The liver and bile ducts 823. Normal adult liver weighs 1400 to 1600 g. It has a dual blood supply, with the portal vein providing 60% to 70% of hepatic blood flow and the hepatic artery supplying them. The contributions of Drs. James Crawford and Neil Thies to this chapter in the last several editions of this book are gratefully acknowledged, remaining 30% to 40%. The portal vein and the hepatic artery enter the inferior aspect of the liver through the hilum, or porta hepatis. Within the liver, the branches of the portal veins, hepatic arteries, and bile ducts travel in parallel within portal tracts. The lobule model provides one useful way to consider the anatomic organization of the liver. Fig. 18.1. In this model, the liver is divided into 1 to 2 hexagonal lobules. 824 Ridpock 18 bill and gallbladder, lobule acinis, gamma delta T cells, but also natural killer NK cells are also present in normal liver, comprising as many as 22% of cells other than hepatocytes. General features of liver disease: portal tract, vessels penetrating, PVH, BD. Figure 18.1 model of liver anatomy. In the hexagonal lobular model, the terminal hepatic vein CV is at the center of a lobule, while the portal tracts are at the periphery. These landmarks serve to identify periportal and pericentral parenchyma. In the center model, on the basis of blood flow, 3 zones can be defined, Zone 1 being the closest to the blood supply and Zone 3 being the farthest. ED, bile duct, HA, hepatic artery, PV, portal vein, that are oriented around the terminal tributaries of the hepatic vein. The veins lie at the center of the lobules and hence are termed central veins, and portal tracts are located at the periphery. Each lobule can be further subdivided into 6 triangular C. The hepatocytes in the vicinity of the central vein are called pericentral and are said to be in Zone 3, while those near the portal tract are periportal and belong to Zone 1. Notably, certain types of hepatic injury preferentially affect hepatocytes, in particular Zone C. Fig. 18.1. These differing sensitivities result from variation in hepatocyte oxygenation, highest in Zone 1, lowest in Zone 3, and metabolic activities from the periphery to the center of the lobule. Within the lobule, hepatocytes are organized into anastomosing sheets or plates extending from portal tracts to the terminal hepatic veins. Between the tracheal plates of hepatocytes are vascular sinusoids. Blood traverses the sinusoids and exits into the terminal hepatic veins through numerous orifices in the vein wall. Hepatocytes are thus bathed on 2 sides by a mixture of portal venous and hepatic arterial blood. The sinusoids are lined by fenestrated endothelium. Beneath the endothelial cells lies the space of descent, into which protrude abundant hepatocyte microvilli. Scattered Kupffer cells of the mononuclear phagocyte system are attached to the luminal face of endothelial cells, and fat-containing hepatic stellate cells are found in the space of descent. Between the budding hepatocytes are biocanaliculæ, which are channels 1 to 2 mm in diameter, formed by grooves in the plasma membranes of facing hepatocytes and separated from the vascular space by tight junctions. These channels drain into the canals of Herring that, in turn, connect to bile ductules. The ductules empty into the interlobular bile ducts within portal tracts. Large numbers of lymphocytes, mostly CV3 zones 2-1. The liver is vulnerable to a wide variety of metabolic, toxic, microbial, circulatory, and neoplastic insults. Hepatic damage also occurs secondary to other diseases, such as heart failure, disseminated cancer, and extrahepatic infections. The enormous functional reserve of the liver masks the clinical impact of mild liver damage, but with progression of diffuse disease or disruption of bile flow, the consequences of deranged liver function may become life-threatening. With the exception of acute liver failure, liver disease is an insidious process in which clinical detection and symptoms of hepatic decompensation may occur weeks, months, or many years after the onset of injury. The ebb and flow of hepatic injury may be imperceptible to the patient and detectable only by abnormal laboratory tests. Table 18.1. Mechanisms of injury and repair. Hepatocyte and parenchymal responses. Injured or dysfunctional hepatocytes in a variety of disorders may demonstrate several potentially reversible morphologic changes. These include accumulation of fat, steatosis, and bilirubin cholestasis, as well as ballooning, a change marked by cell swelling, cytoplasmic clearing, and clumping of intermediate filaments, which when prominent, may form Mallory highline. Balloon hepatocytes are a hallmark of the T18.1 laboratory EVA liver. Test category: serum measurement, hepatocyte integrity, cytosolic hepatocellular enzymes, serum aspartate aminotransferase AST, serum alanine aminotransferase AL, serum lactate dehydrogenase LDH, biliary excretory substances normally secreted in biliary function, serum bilirubin. Total, unconjugated plus conjugated, direct, conjugated only, urine bilirubin, serum bile acids, plasma membrane enzymes from damage to biocanaliculus A, serum alkaline phosphatase, serum gamma-glutamyl transpeptidase GGT, hepatocyte synthetic proteins secreted into the blood function, serum albumin coagulation factors, prothrombin time PT and partial, thromboplastin time PTT, fibrinogen, prothrombin, factors V, Roman 7, Roman 9, and X, hepatocyte metabolism, serum ammonia, aminopurine breath test, hepatic demethylation B, increased in liver disease, B, decreased in liver disease, of liver dysacylation, liver and bile U580 twax, alcohol-induced or non-alcoholic steatohepatitis. See later discussion, but may also occur with ischemic or toxic injury or with cholestasis. When injury is irreversible, hepatocytes may die by necrosis or apoptosis. In hepatocyte necrosis, ion imbalances due to defective plasma membrane transporter function cause water to flow into the cell, which swells and ruptures. Membrane abnormalities also lead to accumulation of intracellular calcium and several events that trigger mitochondrial dysfunction. Even before membrane ruptures, loss of membrane integrity leads to the release of cytoplasmic constituents into the extracellular compartment, including substances that alert innate immune cells to an ongoing threat danger signals. The remnants of the necrotic cells are rapidly phagocytosed by macrophages, which tend to cluster in marked sites of hepatocyte necrosis. Fig. 18.2. This form of injury is the predominant mode of death in ischemic/hypoxic injury and a significant part of hepatic injury in the setting of oxidative stress. Hepatocyte apoptosis is an active form of programmed cell death resulting in hepatocyte shrinkage, nuclear chromatin condensation pycnosis, fragmentation karyorrhexis, and cellular fragmentation into acidophilic apoptotic bodies. These changes are a result of caspase cascades described in detail in Chapter 2. Apoptotic hepatocytes were first clearly described in yellow fever by William Thomas Councilman and therefore have often been referred to as Councilman bodies. While apoptosis occurs in many forms of liver disease, by convention this eponym is restricted to that disease. In the more frequent settings in which apoptotic hepatocytes are seen, for example, acute and chronic hepatitis, the term acidophil bodies is used due to their deeply eosinophilic staining characteristics. Fig. 18.3. If parenchymal injury is widespread, it may lead to confluent necrosis, a zonal loss of contiguous hepatocytes. This may be seen in acute toxic or ischemic injuries or in severe viral or autoimmune hepatitis. Confluent necrosis may begin with hepatocyte dropout in zone 3 near the central vein. The resulting space is filled by cellular debris, macrophages, and remnants of the reticulin meshwork. In bridging necrosis, the area of necrosis may extend from the central. Figure 18.2. Acute hepatitis B. Clusters of macrophages with PAS-positive intracellular material derived from necrotic hepatocytes. Figure 18.3. Foci of lobular hepatitis and chronic hepatitis C showing a apoptotic hepatocyte acidophil body. Arrow in a focus of mononuclear infiltration surrounding a more darkly stained, injured hepatocyte. Double arrows. Veins to the portal tracts, or across adjacent portal tracts, often with an inapparent central vein within the area of injury. In panacenar necrosis, the entire lobule is obliterated. Even in diseases such as viral hepatitis, in which hepatocytes are the principal targets of attack, secondary vascular insults, due to inflammation or thrombosis, may produce large areas of confluent hepatocyte necrosis. This process occurs in many types of liver diseases in which there is extensive hepatocyte loss and collapse of the supporting reticulin framework. The resultant scarring known in the liver as cirrhosis, in which hepatocytes are surrounded by fibrosis with or without a regenerative response, represents a common endpoint for chronic liver disease. In some cases, there is scar regression described in the next section. Replacement of lost hepatocytes occurs primarily by replication of mature hepatocytes adjacent to those that have died, even when there is significant confluent necrosis. Hepatocytes are almost stem cell-like in their ability to continually replicate, even after years of chronic injury, and thus replenishment of parenchyma from tissue stem cells is usually not a significant part of the repair process. Eventually, however, in individuals with chronic disease, the hepatocytes enter into replicative senescence. Once this occurs, stem cell populations may begin to expand and differentiate, an event marked by ductular reactions. These duct-like structures, sometimes without lumens, contain multipotent cells that may contribute significantly to parenchymal restoration. Scar formation and regression. The principal cell type involved in scar deposition in the liver is the hepatic stellate cell. When quiescent, the main function of stellate cells is lipid storage, including vitamin A. However, in several forms of acute and chronic injury, stellate cells become activated and differentiate into highly fibrogenic myofibroblasts. The stimuli for stellate cell activation are varied and include 1. Inflammatory cytokines, such as tumor necrosis factor alpha TNF-alpha, produced by Kupffer cells, macrophages, and other cell types. 2. Alter. 826. Chapter 18. Liver and gallbladder. Interactions with extracellular matrix ECM, and 3. Toxins and reactive oxygen species ROS. Following activation, the conversion of stellate cells into myofibroblasts is stimulated by signals transmitted by platelet-derived growth factor receptor beta and by cytokines, such as transforming growth factor beta TGF-beta and interleukin-17 IL-17, as well as chemokines, which may be released from resident Kupffer cells or recruited macrophages and lymphocytes. The activated stellate cells in turn also release cytokines, growth factors, or in chemotactic and vasoactive factors. If the injury and inflammatory stimuli persist, extracellular matrix deposition and scarring commence, often in the space of descent. There is concurrent loss of sinusoidal endothelial cell fenestration, a change termed sinusoidal capillarization that is a particularly prominent feature in non-alcoholic steatohepatitis and also is a feature of the abnormal sinusoid seen in hepatocellular carcinoma, both described later. Areas of hepatocyte loss in chronic liver disease, perhaps related to vascular compromise, are transformed into dense fibrous septa through collapse of the underlying reticulin framework and deposition of collagen by myofibroblasts. Portal fibroblasts may also play a role in the scarring that accompanies chronic liver injury in some disorders. Eventually, the fibrous septa encircle surviving hepatocytes and give rise to diffuse scarring cirrhosis. In chronic liver disease, Surviving hepatocytes replicate in an effort to restore the parenchyma, forming regenerative nodules that are a predominant feature in most cirrhotic livers. If the chronic injury leading to scar formation is interrupted, for example, clearance of hepatitis virus infection or cessation of alcohol use, then stellate cell activation and scarring ceases and fibrous septi may begin to be broken down by metalloproteinases produced by hepatocytes, leading to partial resolution and an appearance termed incomplete septal cirrhosis. Unfortunately, vascular remodeling and other architectural changes that occur in cirrhosis may not revert to normal, even with extensive scar resorption, which may explain why vascular abnormalities such as portal hypertension fail to improve in some patients. Liver failure. The most severe form of liver disease is liver failure, which may be acute due to sudden and massive hepatic destruction or more commonly chronic, following years of insidious, progressive liver injury. In some cases, individuals with chronic liver disease develop acute on chronic liver failure, in which an unrelated acute injury is superimposed on late-stage chronic disease, or there is a flare of the chronic disease that leads to liver decompensation. Whatever the sequence, 80% to 90% of functional capacity must be lost before hepatic failure appears. When the liver can no longer maintain homeostasis, liver transplantation offers the best hope for survival. Without transplantation, the mortality rate in persons with hepatic failure is about 80%. Acute liver failure. Acute liver failure is defined as an acute liver illness associated with encephalopathy and coagulopathy that occurs within 26 weeks of the initial liver injury in the absence of pre-existing liver disease. Usually the syndrome manifests within 8 weeks of injury. In many patients, progress to coma within only a week. Within this 26-week window, it is useful to know the interval between the onset of symptoms and liver failure, since this may provide helpful clues to the etiology. Very rapid onset acute liver failure is most often induced by drugs or toxins and is typically the result of massive hepatic necrosis. This form of liver failure has been referred to as fulminant liver failure in the past, a term that remains entrenched in the literature and is still used interchangeably. Accidental or deliberate ingestion of acetaminophen Chapter 9 accounts for almost 50% of adult cases in the United States, while autoimmune hepatitis, other drugs/toxins, and acute hepatitis and B infections account for most remaining cases. In Asia, acute hepatitis B and E are the predominant causes. With acetaminophen toxicity, the liver failure occurs within 1 week of the onset of symptoms, whereas failure due to hepatitis viruses takes longer to develop. The mechanism of hepatocellular necrosis may be direct toxic damage as with acetaminophen, but more often is a variable combination of toxicity and immediate hepatocyte destruction, for example, hepatitis virus infection. Rare causes of acute liver failure include abnormalities of blood flow, metabolic disorders, and malignancies, most commonly leukemia or lymphoma 33%, followed by breast cancer 30% and colon cancer 7%. An etiology cannot be established in about 15% of adult and 50% of pediatric cases. Morphology. Acute liver failure usually is associated with massive hepatic necrosis, with broad regions of parenchymal loss surrounding. Islands of preserved or regenerating hepatocytes Fig. 18.4. Affected. Livers are small and shrunken. The prominence of hepatocellular dropout and abductular reactions in these livers depends on the nature and duration of the insult. Toxic injuries, such as acetaminophen overdoses, usually take place within hours to days, too brief a period to allow for scar formation or regeneration. Acute viral infections may cause failure over weeks to a few months, so that although hepatocyte injury continues to outpace repair, regeneration is often evident along with scarring. Rarely, acute liver failure is associated with widespread dysfunction of liver cells without obvious cell death, such as in diffuse microvesicular steatosis related to fatty liver of pregnancy or idiosyncratic reactions to toxins, for example, valproate, tetracycline. In these settings, hepatocyte metabolism is severely affected, usually due to mitochondrial dysfunction, preventing the liver from carrying out its normal functions. In states of immunodeficiency, such as untreated infection with human immunodeficiency virus HIV, post-transplant immunosuppression, and certain lymphoid malignancies, non-hepatotropic viruses, particularly cytomegalovirus, herpes simplex viruses, and adenovirus, can cause acute liver failure. With better treatments for HIV infection, these forms of viral hepatitis are declining in incidence. Clinical features: acute liver failure manifests first with nausea, vomiting, and jaundice, followed by life-threatening encephalopathy and coagulation defects. Typically, serum liver transaminases are markedly elevated. The liver is initially enlarged due to hepatocyte swelling, inflammatory infiltrates, and edema. Liver and bile ducts 827. 8b figure 18.4. Massive necrosis. Cut section of liver. The liver is small 700 G, bile stained, soft, and congested. The hepatocellular necrosis caused by acetaminophen overdose. Confluent necrosis is seen in the perivenular region, zone 3 large arrow. Residual normal tissue is indicated by an asterisk. Courtesy Dr. Matthew Ye, University of Washington, Seattle, Washington. As parenchyma is destroyed, however, the liver shrinks dramatically. Decline of serum transaminases as hepatocytes die often is not, therefore, a sign of improvement, but is rather an indication that there are few viable hepatocytes left. This suspicion is confirmed if there is worsening jaundice, coagulopathy, and encephalopathy. With unabated progression, multi-organ system failure occurs, and, if transplantation is not possible, death ensues. Other manifestations of acute liver failure are as follows. Cholestasis occurs due to alterations of bile formation and flow leading to retention of bilirubin and other solutes normally eliminated in bile. Yellow discoloration of the skin and sclera jaundice and icterus, respectively, occur with bilirubin retention, and there is increased risk of potentially life-threatening bacterial infection. Hepatic encephalopathy is a spectrum of disturbances in consciousness, ranging from subtle behavioral abnormalities to marked confusion and stupor, to deep coma and death. Encephalopathy may progress over days, weeks, or months following acute liver injury. Associated fluctuating neurologic signs include rigidity and hyperreflexia. Asterixis, a particularly characteristic sign, is manifested as non-rhythmic, rapid extension-flexion movements of the head and extremities, best seen when the arms are held in extension with dorsiflex wrists. Hepatic encephalopathy is believed to be caused by elevated ammonia levels, which correlate with impaired neuronal function and cerebral edema. The principal source of the ammonia is the gastrointestinal tract, where it is produced by microorganisms and also by enterocytes during glutamine metabolism. Normally, ammonia is transported in the portal vein to the liver, where it is metabolized in the urea cycle. In severe liver disease, this detoxification mechanism fails. Several non-exclusive mechanisms of CNS toxicity for ammonia have been proposed, including direct effects on neurons and indirect effects mediated through its metabolism in astrocytes to glutamine, which appears to contribute to edema by serving as an osmolyte. Coagulopathy. Hepatocytes are responsible for synthesis of clotting factors Roman 2 prothrombin, V, Roman 7, Roman 9, X, Roman 11, and Roman 12, as well as fibrinogen chapter 4. Thus, with liver failure, factor deficiencies and coagulopathy develops. Easy bruisability is an early sign, which can progress to life-threatening or fatal intracranial bleeding. The liver is also responsible for helping to remove activated coagulation factors from the circulation, and loss of this function in some instances leads to disseminated intravascular coagulation chapter 410, further exacerbating the bleeding tendency. Portal hypertension arises when there is diminished flow through the portal venous system, which may occur because of obstruction at the prehepatic, intrahepatic, or posthepatic level. Although it can occur in acute liver failure, portal hypertension is more commonly seen with chronic liver failure and is described later. In acute liver failure, if portal hypertension develops within days to weeks, obstruction is predominantly intrahepatic and the major clinical consequences are sites. In chronic liver disease, portal hypertension develops over months to years, and its effects are more complex and widespread. Hepatorenal syndrome is a form of renal failure occurring in individuals with liver failure in whom there is no intrinsic morphologic or functional cause for kidney dysfunction. Its onset is marked by a drop in urine output and increasing levels of urea and creatinine in the blood. Its pathophysiology is incompletely understood, but the triggering event is hypothesized to be portal hypertension and secondary increased production of vasodilators such as nitric oxide by endothelial cells in the splanchnic vasculature. This in turn leads to systemic vasodilation and diminished renal perfusion, which is sensed by the kidney, provoking activation of the renin/angiotensin axis. In the setting of portal hypertension and persistent vasodilator production, the principal effect of renin/angiotensin activation is to further diminish renal perfusion and glomerular filtration rate, leading to renal failure. The decline in renal function is reversible if liver function is restored, for example, by liver transplantation. Patients who develop the hepatorenal syndrome usually have portal hypertension due to cirrhosis, severe alcoholic hepatitis, or less often metastatic tumors. However, patients with fulminant hepatic failure from any cause may develop hepatorenal syndrome. 828 Chapter 18 Liver and Gallbladder. Chronic liver failure and cirrhosis. Liver failure and chronic liver disease is most often associated with advanced fibrosis/cirrhosis, a condition marked by diffuse remodeling of the liver into parenchymal nodules, often regenerative, surrounded by fibrous bands, and a variable degree of vascular, often portosystemic shunting. The leading causes of chronic liver failure worldwide are chronic hepatitis B, chronic hepatitis C, non-alcoholic fatty liver disease, and alcoholic liver disease. In the United States, chronic liver disease is the 12th most common cause of mortality and accounts for most liver-related deaths. Although cirrhosis and chronic liver failure are often associated, they are not synonymous. Not all cirrhosis leads inexorably to chronic liver failure, and not all end-stage chronic liver disease is cirrhotic. For example, chronic diseases such as primary biliary cholangitis, primary sclerosing cholangitis, nodular regenerative hyperplasia, chronic schistosomiasis, and fibropolycystic liver disease are often not accompanied by fully established cirrhosis, even at end stage. On the other hand, patients with well-treated autoimmune hepatitis or those with suppressed hepatitis B or cured hepatitis C often do not progress to end-stage liver disease, even if cirrhosis is present. And some diseases that give rise to cirrhosis, such as untreated viral hepatitis, alcoholic liver disease, non-alcoholic fatty liver disease, and metabolic diseases, the morphology and pathophysiology of cirrhosis show some distinctive features described in subsequent sections of this chapter. Thus, while the term cirrhosis implies the presence of severe chronic disease, it is not a specific diagnosis and has variable prognostic implications. There are also some instances in which cirrhosis arises without any clear cause. The term cryptogenic cirrhosis is sometimes applied to such cases. Morphology. Cirrhosis is marked by the presence of parenchymal nodules surrounded by dense bands of fibrosis throughout the liver, converting the normally smooth liver capsule into a bumpy surface with depressed areas of scarring and bulging regenerative nodules. Fig. 18.5. Microscopically, the extent of the fibrosis is highlighted by the use of special stains. For collagen. Fig. 18.6. The size of the nodules, the pattern of scarring linking portal tracts to each other versus linking portal tracts to central veins, the degree of parenchymal collapse, the extent of vascular thrombosis, particularly of the portal vein, all vary between diseases and, to some degree, between individuals with the same disease. Morphologic features of regression include thin and complete scars. See Fig. 18.6b associated with variable cellular reaction and architectural changes. As mentioned earlier, not all end-stage livers are cirrhotic, but all reveal varying degrees of injury, repair, regeneration, and fibrosis. Thus, end-stage liver disease is best viewed as a spectrum of ineffective attempts to repair ongoing, intermittent, or past injury. Clinical features: about 40% of individuals with cirrhosis are asymptomatic until the most advanced stages of the disease. When symptomatic, they present with nonspecific manifestations. Figure 18.5. Cirrhosis resulting from chronic viral hepatitis. Note the depressed areas of dense scars separating bulging regenerative nodules over the liver surface. Anorexia, weight loss, weakness, and an advanced disease. Symptoms and signs of liver failure discussed earlier. The common causes of death are hepatic encephalopathy, bleeding from esophageal varices, bacterial infections resulting from damage to the gut mucosal barrier and Kupffer cell dysfunction, and hepatocellular carcinoma. In addition to jaundice, encephalopathy, and coagulopathy are also seen with acute liver failure. Chronic liver failure is associated with several other significant features. Through unclear mechanisms, persistent cholestasis can lead to pruritus itching, the intensity of which can be profound. Some patients may scratch their skin raw, risking repeated bouts of potentially life-threatening infection. Relief may only be found in liver transplantation. Impaired estrogen metabolism leads to hyperestrogenemia, which has several effects. It produces vascular changes that may lead to palmar erythema, a reflection of local vasodilation, and spider angiomas of the skin. Each angioma is a central, pulsating, dilated arteriole from which small vessels radiate. In males, hyperestrogenemia may also produce hypogonadism and gynecomastia. Hypogonadism can also occur in women due to disruption of hypothalamic pituitary axis function, either through nutritional deficiencies associated with the chronic liver disease or primary hormonal alterations. Portal hypertension. Increased resistance to portal blood flow may develop in a variety of circumstances, which can be divided into prehepatic, intrahepatic, and posthepatic. Table 18.2. The major prehepatic conditions are obstructive thrombosis, narrowing of the portal vein before it ramifies within the liver, or massive splenomegaly with increased splenic vein blood flow. The main posthepatic causes are severe right-sided heart failure, constrictive pericarditis, and hepatic vein outflow obstruction. The dominant intrahepatic cause is cirrhosis, accounting for most cases of portal hypertension. Far less frequent intrahepatic causes are schistosomiasis, massive fatty change, diffuse fibrosing granulomatous disease such as sarcoidosis, and diseases affecting the portal. The liver and bile ducts. 829. A B. Figure 18.6. Alcoholic cirrhosis in an active drinker and after long-term abstinence. B. The thick bands of collagen separate rounded cirrhotic nodules. E. After 1 year of abstinence, most scars are gone. Mass and trichome stain. Courtesy Doctors Humphreys and Isabel Field, Mount Sinai School of Medicine, NY. 18. 2 on causes of portal hypertension. Table. Prehepatic causes obstructive thrombosis of portal vein. Structural abnormalities such as narrowing of the portal vein before it ramifies in the liver. Intrahepatic causes: cirrhosis from any cause, nodular regenerative hyperplasia, primary biliary cholangitis, even in the absence of cirrhosis, schistosomiasis, massive fatty change, diffuse fibrosing granulomatous disease, for example, sarcoid infiltrative malignancy, primary or metastatic focal malignancy with invasion into portal vein, particularly hepatocellular carcinoma, amyloidosis. Posthepatic causes: severe right-sided heart failure, constrictive pericarditis, hepatic vein outflow obstruction. Location: microcirculation such as nodular regenerative hyperplasia, discussed later. The pathophysiology of portal hypertension is complex and involves resistance to portal flow at the level of sinusoids and an increase in portal flow caused by hyperdynamic circulation. Increased resistance to portal flow at the level of the sinusoids is caused by contraction of vascular smooth muscle cells and myofibroblasts, and disruption of blood flow by scarring and the formation of parenchymal nodules. Alterations in sinusoidal endothelial cells that contribute to the intrahepatic vasoconstriction associated with portal hypertension include a decrease in nitric oxide no production and increased release of endothelin-1, angiotensinogen, and icosanoids. Sinusoidal remodeling and anastomosis between the arterial and portal system in the fibrous septa contribute to portal hypertension by imposing arterial pressures on the low-pressure portal venous system. Sinusoidal remodeling and intrahepatic shunts also interfere with the metabolic exchange between sinusoidal blood and hepatocytes. Another major factor in the development of portal hypertension is an increase in portal venous blood flow resulting from a hyperdynamic circulation. This is caused by arterial vasodilation, primarily in the splanchnic circulation. The increased splanchnic arterial blood flow in turn leads to increased venous efflux into the portal venous system. While various mediators such as prostacyclin and TNF have been implicated in the causation of splanchnic arterial vasodilation, NO has emerged as the most significant one. The four major consequences of portal hypertension are: 1. Hepatic encephalopathy described under liver failure, 2. Ascites, 3. The formation of portosystemic venous shunts, and 4. Congestive splenomegaly. These are illustrated in Fig. 18.7 and are described next. Ascites: the accumulation of fluid in the peritoneal cavity is called ascites, which in 85% of cases is caused by cirrhosis. Ascites usually becomes clinically detectable when at least 500 ml have accumulated. The fluid is generally serous, having less than 3 G/dL, a protein largely albumin, and a serum total albumin gradient of 1.1 G/dL. The fluid may contain a scant number of mesothelial cells and mononuclear leukocytes. The presence of neutrophils suggests infection, whereas the presence of red cells points to possible disseminated intra-abdominal cancer. With long-standing ascites, seepage of peritoneal fluid through transdiaphragmatic lymphatics may produce hydrothorax, usually on the right side. The pathogenesis of ascites is complex, involving sinusoidal hypertension, hypoalbuminemia, increased hepatic lymph flow, and splanchnic vasodilation and hyperdynamic circulation. Portosystemic shunts: in the setting of chronic portal hypertension, vascular dilation and remodeling often leads to the development of thin-walled venous shunts between the portal and systemic circulations that bypass the liver. These shunts: 830 Chapter 18, liver and gallbladder. Ascites, cirrhosis, hepatic lymph, hepatic encephalopathy, malnutrition, skin spider angiomatous, esophageal, varices, splenomegaly, portal vein, splenic vein, periumbilical kappa medusae, hemorrhoids, testicular atrophy. Figure 18.7 major clinical consequences of portal hypertension in the setting of cirrhosis, shown for the male. In women, oligomenorrhea, amenorrhea, and sterility as a result of hypogonadism are frequent. Clinically significant findings are in boldface, may appear wherever the systemic and portal circulations share capillary bed. See Fig. 18.7. The principal sites are veins around and within the rectum manifest as hemorrhoids, the esophagogastric junction producing varices, the retroperitoneum, and the falciform ligament of the liver involving periumbilical and abdominal wall collaterals. Abdominal wall collaterals appear as dilated subcutaneous veins extending from the umbilicus toward the rib margins kappa medusae and constitute a clinical hallmark of portal hypertension. Although hemorrhoidal bleeding may occur, it is rarely massive or life-threatening. Much more important are esophagogastric varices, which appear in about 40% of individuals with advanced cirrhosis of the liver and cause massive hematemesis and death in about half of those affected. Each episode of bleeding is associated with till the 30% mortality. Splenomegaly: long-standing portal hypertension may cause congestive splenomegaly. The degree of splenic enlargement varies widely, and the splenic weight may reach as much as 1,000 G5 to 6 times normal, but it is not necessarily correlated with other features of portal hypertension. Splenomegaly may secondarily induce hematologic abnormalities attributable to hypersplenism, particularly thrombocytopenia or even pancytopenia, in large part because of sequestration of blood elements in the expanded splenic red pulp. Pulmonary complications of liver failure and portal hypertension. We conclude this discussion with two pulmonary syndromes that occur in the setting of chronic liver failure and portal hypertension. Hepatopulmonary syndrome is seen in up to till the 30% patients with cirrhosis of the liver and portal hypertension. The syndrome is caused by the dilatation of intrapulmonary capillary and precapillary vessels up to 500 μm in size. Right to left shunting of blood through the dilated vessels produces ventilation-perfusion mismatch and impairs oxygenation of blood, which manifests as hypoxemia. The resulting dyspnea is worse in the upright position rather than in the recumbent position, as gravity exacerbates the ventilation-perfusion mismatch. Patients with this syndrome have a poorer prognosis than patients without hepatopulmonary syndrome. The pathogenesis is unclear, although it has been postulated that the diseased liver may not clear factors such as endothelin-1 that stimulate endothelial cells to produce vasodilators such as nitric oxide. Or pulmonary hypertension refers to pulmonary arterial hypertension arising in liver disease. It also is not well understood, but it seems to depend on concomitant portal hypertension and excessive pulmonary vasoconstriction and vascular remodeling. The most common clinical manifestations are dyspnea on exertion and clubbing of the fingers. Acute on chronic liver failure: some individuals with stable but well-compensated advanced chronic liver disease suddenly develop signs of acute liver failure. In such patients, there is often established cirrhosis with extensive vascular shunting. Thus, large volumes of functioning liver parenchyma have a borderline vascular supply, leaving them highly vulnerable to superimposed insults. The short-term mortality of patients with this form of liver failure is around 50%. Patients with chronic hepatitis B infection who become superinfected with hepatitis D may suddenly decompensate, as may patients with medically suppressed hepatitis B infection in whom viral mutants arise that are resistant to therapy, both due to acute flares of disease. Ascending cholangitis in a patient with primary sclerosing cholangitis or fibropolycystic liver disease described later may also cause rapid decompensation of liver function. Rare patients with non-alcoholic steatohepatitis may develop severe hepatic dysfunction following rapid weight loss or malnutrition. The mechanism of injury in such cases is unknown. Other causes of decompensation are systemic rather than intrahepatic insults. For example, sepsis and its attendant hypotension may undermine hepatic parenchyma with borderline vascular supply. Likewise, Acute cardiac failure or a superimposed drug or toxic injury might tip a well-compensated cirrhotic patient into failure. Finally, the possibility of malignancy, either a primary liver tumor, liver and bile ducts 831, particularly hepatocellular carcinoma or cholangiocarcinoma, or liver metastasis from some other site, for example, colon, should always be kept in mind as a possible cause of acute liver failure and previously well-compensated chronic liver disease. Key concepts: liver failure. Liver failure may follow acute injury or chronic injury, but may also occur as an acute insult superimposed on an otherwise well-compensated chronic liver disease. The mnemonic for causes of acute liver failure is as follows: A. Acetaminophen, hepatitis A, autoimmune hepatitis. B. Hepatitis B, C, hepatitis C, cryptogenic. E. Drugs/toxins, hepatitis D, E, hepatitis E. Esoteric causes, for example, Wilson disease, Budd-Chiari syndrome, lymphoma, carcinoma. F. Fatty change of the microvesicular type, for example, fatty liver. Pregnancy, Valpro, tetracycline, Way syndrome. Serious and sometimes fatal sequelae of liver failure include coagulopathy, encephalopathy, portal hypertension, bleeding, esophageal varices, hepatorenal syndrome, and portopulmonary hypertension. Infectious disorders. Viral hepatitis. The term viral hepatitis is most commonly used in the context of liver involvement by hepatotropic viruses, which include hepatitis A, B, C, D, and E. Non-hepatotropic viruses such as Epstein-Barr virus, Cytomegalovirus virus, herpes simplex virus, adenovirus, and yellow fever virus can also cause hepatitis, often in association with systemic infection. Liver involvement can occur in a wide variety of other systemic viral infections, but it is generally mild and often subclinical. In the sections that follow, we will first discuss individual hepatotropic viruses, and then review certain clinicopathologic syndromes that are common to all. Hepatitis, a virus. Hepatitis, a virus. HAV infection is a self-limited disease and does not lead to chronic hepatitis or a carrier state. It accounts for about 25% of clinically evident acute hepatitis worldwide and is responsible for an estimated 2,000 new cases of viral hepatitis per year in the United States. Epidemiology. HAV is spread by ingestion of contaminated water and foods, and is endemic in countries with poor hygiene and sanitation. In high-income countries, the prevalence of seropositivity indicative of previous exposure increases gradually with age, reaching 50% by 50 years of age in the United States. HAV is shed in the stool for 2 to 3 weeks before and 1 week after the onset of jaundice. Close personal contact with an infected individual or fecal oral contamination during this period accounts for most cases and can result in outbreaks in institutional settings such as schools and nurseries. Waterborne epidemics can occur in places with overcrowded, unsanitary conditions. In high-income countries, sporadic infections may be contracted by the consumption of raw or steamed shellfish, oysters, mussels, clams, which concentrate the virus from seawater contaminated with human sewage. Sexual transmission may occur, but maternal-fetal transmission does not. Since HIV viremia is transient, blood-borne transmission of HIV is rare, and donated blood is not screened for this virus. Pathogenesis discovered in 1973. HIV is a small, non-enveloped, positive strand RNA piconavirus that occupies its own genus, hepatovirus. Ultrastructurally, HIV is an icosahedral capsid that is 27 nm in diameter. The receptor for HIV on hepatocytes is HAVCR1, also known as TIM1, a glycoprotein that is a member of a family of proteins that serve as receptors for several other viruses as well. HIV is not cytopathic, and the hepatocellular injury is inflicted by cytotoxic T lymphocytes and NK cells that recognize and kill hepatocytes infected by the virus. Clinical features. The incubation period for HIV is 2 to 6 weeks. IgM antibody against HIV appears with the onset of symptoms and persists for 3 to 6 months. Fig. 18.8. IgG anti-HIV appear during recovery from the acute infection and persists for years, conferring lifelong immunity against reinfection. Affected individuals have nonspecific symptoms such as fatigue and loss of appetite, and they often develop jaundice. Most patients recover within 3 months, and disease resolution occurs in nearly all patients by 6 months. Acute liver failure occurs in 0.1% to 0.3% of patients, especially those with chronic liver disease due to another etiology. Other incubation period, acute disease, convalescence and recovery, jaundice. Symptoms: total anti-HIV antibody, AG, anti-HIV, fecal have IgM, anti-HIV, 2, 6 weeks, 2 weeks, months. Figure 18.8. Temporal changes in serologic markers in acute hepatitis or infection. HIV, IgM, immunoglobulin M, 832. Chapter 18, liver and gallbladder. Uncommon complications include prolonged cholestasis and relapse of disease within 6 months of the original onset. Extrahepatic manifestations include rash, arthralgia, and immune complex-mediated complications like leukocytoclastic vasculitis, glomerulonephritis, and cryoglobulinemia. HIV vaccine is effective in preventing infection. Hepatitis B virus. Hepatitis B virus HBV infection has varied clinical outcomes, which depend on the age of exposure, comorbid conditions including exposure to other infectious agents, and host immunity. The major clinical presentations include 1. Acute hepatitis followed by recovery and clearance of the virus, 2. Acute hepatic failure with massive liver necrosis, 3. Chronic hepatitis with or without progression to cirrhosis. And 4. An asymptomatic, healthy carrier state Fig. 18.9. Epidemiology. Chronic HBV infection affects 400 million people worldwide, with the highest prevalence 8% in Africa, Asia, and the Western Pacific Rim. The prevalence is also relatively high 2% to 7% in Southern and Eastern Europe, and lower 2% in Western Europe, North America, and Australia. It is estimated that there are 60,000 new cases of HBV infection in the United States every year, and that nearly 2 million people have chronic HBV infection. The virus has a parenteral mode of transmission through unprotected sex, blood transfusion, and sharing of needles and syringes for intravenous drug use. Transfusion-related transmission has been sharply curtailed by screening of donated blood for HBsAg and exclusion of paid blood donors. In high-prevalence regions, transmission during childbirth accounts for 90% of cases. Horizontal transmission can also occur in children through minor breaks in the skin or mucous membranes or with close bodily contact. Pathogenesis. HBV was first linked to hepatitis in the 1960 seconds when Australia antigen, now known as hepatitis B surface antigen, was identified. The virus is a member of the Hepatnaviridae, a family of DNA viruses that cause hepatitis in multiple animal species. The mature virion has an outer surface envelope composed of viral proteins and host-derived lipids that surrounds a core consisting of nucleocapsid proteins, viral polymerase, and viral DNA. The HBV genome is a partially double-stranded circular DNA molecule with several open reading frames encoding the following proteins. Hepatitis B surface antigen HBsAg, which refers to 3 related viral envelope glycoproteins, large, middle, and small HBsAg. Large HBsAg is usually associated with complete virions, while non-infective viral envelope proteins, mainly small HBsAg, are released in large quantities by infected hepatocytes free of viral core elements. Hepatitis B core antigen HBcAg, the nucleocapsid protein, which plays a role in assembly of complete virions, and a longer polypeptide transcript with a precore and core region, designated hepatitis B antigen HBAg. HBV polymerase poly, which exhibits both DNA polymerase and reverse transcriptase activities. Hepatitis B X protein HBX, which is not necessary for virus replication, but may act as a transcriptional transactivator of both viral genes and a subset of host genes. It has been implicated in the pathogenesis of HBV-related hepatocellular carcinoma. Entry of HBV into hepatocytes is enabled by binding of large HBsAg to the bile salt transporter known as sodium taurocholate co-transporting polypeptide NTCP. The viral genome enters the nucleus, where the plus strand is synthesized to form covalently closed circular DNA cccDNA. HBV replication occurs through reverse transcription via an RNA intermediate. The host immune response to the virus is the main determinant of the outcome of the infection. High-level viral replication and high production of viral proteins can produce cytopathic changes in infected cells. However, most hepatocyte injury is caused by an attack of CD8 plus cytotoxic T cells on infected cells. Strong response by virus-specific acute infection. Tilde 65%, tilde 25%, 5%, 10%, subclinical disease, acute hepatitis, chronic hepatitis, 100%, 99%, 1%, 20%, 30%, 2%, 3%. Recovery, fulminant hepatitis, recovery, cirrhosis, and /or hepatocellular carcinoma, death or transplant, death or transplant. Figure 18.9 potential outcomes of hepatitis B infection in adults and their approximate frequencies in the United States. Spontaneous hepatitis B surface antigen clearance occurs during chronic hepatitis B viral infection at an estimated annual incidence of 1% to 2% in Western countries. The liver and bile ducts 833. CD4 plus and CD8 plus interferon IFN gamma, producing cells is associated with resolution of acute infection. Clinical features: HBV has a prolonged incubation period 4 to 26 weeks. The course of the infection is followed by measuring viral antigens and serologic responses in the blood, as shown in Fig. 18.10. A few salient points about these markers is merited. HBsAg appears before the onset of symptoms and peaks in acute, symptomatic disease. In those who clear the infection, it often declines to undetectable levels in 12 weeks, but can be present for as long as 24 weeks. By contrast, HBsAg persists in cases that progress to chronicity. Anti-HBs antibody begins to rise following the resolution of acute disease, generally after the disappearance of HBsAg. See Fig. 18.10a. In some cases, the appearance of anti-HBs antibody is delayed until weeks to months after disappearance of HBsAg. In such instances, the serologic diagnosis can be made by detection of IgM anti-HBc antibody. Anti-HBs antibodies tend to persist for life, conferring protection. This is the basis for current vaccination strategies using non-infectious HBsAg. By contrast, anti-HBs antibodies are not produced in cases that progress to chronic liver disease, which is also associated with variable persistent elevations of serum transaminases in most but not all cases. See Fig. 18.10b. HBAg, HBV DNA, and HBV DNA polymerase are detectable in the serum soon after HBsAg and signify active viral replication. Persistence of HBAg is an important indicator of continued virus replication, infectivity, and probable progression to chronic hepatitis. One caveat is that mutated strains of HBV can emerge that do not produce HB-Ag, but are replication competent and express HBC-Ag. In such patients, the HB-Ag may be low or undetectable despite the presence of serum HBV DNA. Anti-HB antibodies signifies that acute infection has peaked and is on the wane, whereas in cases that progress to chronic infection, anti-HB antibody is not produced or appears only late in the disease course. Acute HBV infection is mild or subclinical in nearly 2/3 of adults, while others have nonspecific constitutional symptoms such as anorexia, fever, jaundice, and upper right quadrant pain. Immune complex mediated phenomena such as glomerulonephritis may occur, as well as other immunologic disorders, such as polyarteritis nodosa chapter 11. Acute liver failure is rare, occurring in approximately 0.1% to 0.5% of acutely infected individuals. In most cases, the infection is self-limited and resolves without treatment. The infection persists and becomes chronic in 5% to 10% of infected individuals. The risk of chronic infection is inversely related to age and is greatest approximately 90% in infants who are exposed to the virus through transmission from their mothers at the time of birth. Individuals who acquire HBV at birth and who subsequently develop chronic hepatitis are also at greatest risk of developing hepatocellular carcinoma Fig. 18.9, which is one of the most common and deadliest cancers in parts of the world such as China where perinatal transmission occurs frequently. Vaccination is highly effective, as it induces a protective anti-HBs antibody response in 95% of infants, children, and adolescents. Although vaccine-induced escape mutants that replicate in the presence of vaccine-induced immunity have been described, these do not appear to be increasing in prevalence. In those with chronic HBV, treatment with interferon and antiviral agents such as reverse transcriptase inhibitors and tenofovir can slow disease progression, reduce liver damage, and lower the risk of cirrhosis and hepatocellular carcinoma, but complete cure is difficult. Incubation period, serum markers, serum transaminases, acute disease, jaundice, symptoms, HB-Ag, HBV DNA, HBs-Ag, anti-HB, convalescence and recovery, total anti-HBC, again, anti-HBC, anti-HBs, incubation period, serum markers, serum transaminases, acute disease, jaundice, symptoms, HB-Ag, HBV DNA, HBs-Ag, again, anti-HBC, chronic disease, total anti-HBC. 4. 26 weeks average 8, 4. 12 weeks 4. 20 weeks years, B 4. 26 weeks average 8, 4. 12 weeks months to years, anti-HB. Figure 18.10 temporal changes in serologic markers in hepatitis B viral infection. Acute infection with resolution, B progression to chronic infection. In some cases of chronic hepatitis B virus, serum transaminases may become normal. 834 Chapter 18 Liver and Gallbladder. Hepatitis C virus, HCV rarely causes symptomatic acute hepatitis, but it is the most common cause of chronic viral hepatitis. Epidemiology: HCV affects approximately 170 million people worldwide, and there are 2.7 million chronic HCV cases in the United States. Screening of donor blood has decreased the annual incidence of infection from 230,000 new infections per year in the mid-1980s to 17,000 new infections per year currently. Mode of transmission is parenteral, intravenous drug abuse, multiple sex partners, needle stick injury, and multiple contacts with an HCV-infected person are the most common risk factors. Transfusion-related transmission has largely disappeared in the United States. Perinatal transmission can occur in children. 1/3 of infected individuals have no identifiable risk factors. An enduring hepatologic mystery. Pathogenesis: HCV, discovered in 1989, is a member of the Flaviviridae family. It is a small, enveloped, single-stranded RNA virus with one open reading frame that codes for a single polyprotein, which is subsequently processed into several functional proteins. These include 2 envelope proteins, EN and ETO, and 5 core proteins, 7, NS4, NS3/4 protease, NS5 a replication complex, and NS5B RNA polymerase. The role of these proteins in the life cycle of HCV is summarized in Fig. 18.11. The inability of the host immune response to eliminate HCV is related to rapid emergence of genetic variants, both within the population and within infected individuals. HCV RNA polymerase has low fidelity, giving rise to variants that fall into 7 genotypes and many subtypes. As the disease progresses, multiple personal genetic variants, known as quasi-species, emerge in infected individuals. Anti-HCV antibodies directed against EPO envelope protein are common and have neutralizing activity, but emerging variants with altered EPO epitopes escape from this host defense. NS3/NS4 protease also impairs the interferon-mediated cellular antiviral response, defeating another potential means of host defense. Clinical features: the incubation period for HCV hepatitis ranges from 4 to 26 weeks, with a mean of 9 weeks. HCV RNA is detectable in blood for 1 to 3 weeks in acute infection and coincides with increase in transaminases. Anti-HCV antibodies emerge 3 to 6 weeks after infection. Spontaneous clearance of the virus after 4 to 6 months is rare, hence persistent detection of HCV RNA after this period is an indicator of chronic HCV infection. Fig. 18.12. Safe for anti-HCV antibodies is used as a screening test for HCV, but it can be negative in early infection and in immunosuppressed individuals. After successful treatment, or in cases with spontaneous viral clearance, anti-HCV antibodies may be detected in the absence of HCV RNA, but can disappear with time. Acute HCV infection is asymptomatic in about 85% of individuals, and severe acute hepatitis is rare, although a few fortunate people clear the acute infection for unclear binding, RNA, lipid envelope nucleocapsid plus RNA, ribosome, polyprotein, translation and protein processing, RNA, synthesis of antisense, RNA template, release, figure 18.11 life cycle of hepatitis C, viral entry, replication, assembly, and budding are shown, emphasizing steps that can be effectively targeted with antiviral drugs. Reason, persistent infection and chronic hepatitis are the usual outcome. In contrast with HBV, chronic disease occurs in 80% to 90% of HCV-infected individuals, and approximately 20% of these individuals progress to cirrhosis over 20 to 30 years. Fluctuating elevations of serum aminotransferases are typically present during the chronic phase of the disease. Even those with normal transaminases are at a risk for pronase inhibitors, pronase, endocytosis, RNA polymerase, receptor, fusion and uncoating, RNA, NS5 inhibitors, NS5A, viral proteins, RNA polymerase inhibitors, RNA replication, viral assembly, hepatocyte, the liver and bile ducts 835, incubation period, acute disease, recovery incubation period, acute disease, chronic disease, jaundice, symptoms, serum marker HCV RNA, serum transaminases anti-HCV, a B2, 6 weeks means 6, 12, 1, 3 weeks months to years 2, 6 weeks, means 6, 12, 1, 3 weeks months to years. Figure 18.12 temporal changes in serologic markers in hepatitis C viral infection. Acute infection with resolution, B progression to chronic infection, developing permanent liver damage, and hence all those with detectable serum HCV RNA levels need treatment and long-term follow-up. Older age, male gender, alcohol use, immunosuppressive drugs, hepatitis B/HIV co-infection, and diseases associated with insulin resistance, including obesity, type 2 diabetes, and metabolic syndrome have been associated with progression. Those who develop cirrhosis are at risk for development of hepatocellular carcinoma. Although the overall risk is small, in the United States, HCV is responsible for about 1/3 of the cases of liver cancer. Fortunately, the treatment of hepatitis C has been revolutionized in the past few years by the availability of highly effective antiviral agents. This remarkable advance has been made possible by understanding the role of viral proteins in the virus life cycle, which in turn has enabled the development of specific drug antagonists Fig. 18.11. As an HIV infection, these drugs are used in combination to overcome resistance and include agents that target the NS3/4 protease, the NS5 replication complex, and the NS5B polymerase. Unlike HIV, HCV does not integrate into the genome where it can lie latent, and as a result, true cures are often achieved. Sustained therapeutic response is defined as undetectable HCV RNA after 12 to 24 weeks of drug therapy. Overall, such sustained responses are obtained in 80% to 90% of cases, with lower response rates in patients infected with genotype 3 HCV. HCV appears to be cured in 99% of patients who achieve a sustained viral response. The major downside of these advances is their very high cost. A curative course of drug therapy costs over $100,000, and it is estimated that treatment of HCV infections in the United States alone may generate expenses of greater than $50 billion over the next 5 years. Hepatitis D virus HDV, or the Delta agent, is a unique RNA virus that is dependent for its life cycle on HBV. Epidemiology, it is estimated that 5% of HBV-infected individuals are co-infected with HDV, which amounts to approximately 15 million people worldwide. The highest prevalence is in the Amazon basin, Central Africa, the Middle East, and the Mediterranean basin. HCV is uncommon in Southeast Asia and China. Disease transmission occurs through a parenteral route, often in association with intravenous drug use and multiple blood transfusions. Pathogenesis HCV, discovered in 1977, is a 35 nm double-shelled particle. The external code antigen of HCV surrounds an internal polypeptide assembly, designated delta antigen HDAG, the only protein produced by the virus. Associated with the virus particle is a small circular molecule of single-stranded RNA, whose length is the shortest of any known animal virus. Replication of the virus is through RNA-directed RNA synthesis by host RNA polymerase. The basis for disease flares associated with HCV superinfection is not well understood. Both cytopathic effects and enhanced cytotoxic host responses have been proposed. Clinical features: infection with HCV arises in 2 settings, each with somewhat different clinical courses. Co-infection occurs following exposure to serum containing both HDV and HBV. Co-infection can result in acute hepatitis that is indistinguishable from acute hepatitis B. It is self-limited and is usually followed by clearance of both viruses. However, There is a higher rate of acute hepatic failure in intravenous drug users. Superinfection occurs when a chronic carrier of HBV is exposed to a new inoculum of HDV. This results in disease 30 to 50 days later, presenting either as severe acute hepatitis in an asymptomatic HBV carrier, or as 836 Chapter 18 liver and gallbladder. An exacerbation of pre-existing chronic hepatitis B infection. Chronic HBV infection occurs in more than 80% of superinfections and may have two phases. An acute phase with active HBV replication and suppression of HBV associated with high transaminase levels, and a chronic phase in which HBV replication decreases, HBV replication increases, and transaminase levels fluctuate. HBV RNA is detectable in the blood and liver just before and in the early days of acute symptomatic disease. IgM anti-HBV antibody is the most reliable indicator of recent HBV exposure, although its appearance is late and frequently short-lived. With chronic delta hepatitis arising from HBV superinfection, HBsAg is present in serum, and anti-HBV antibodies persist for months or longer. Co-infection with HBV and HBV increases the risk of progression to cirrhosis and HCC. Chronic HBV infection is treated with interferon gamma, but clearance of the virus occurs in only a minority of cases. Newer agents targeting viral entry and replication are in clinical trials. Vaccination for HBV also prevents HBV infection. Hepatitis E virus HBV is an enterically transmitted, waterborne infection that occurs primarily in young to middle-aged adults. Epidemiology: HBV is a zoonotic disease with animal reservoirs, such as monkeys, cats, pigs, and dogs. Epidemics have been reported in Asia and the Indian subcontinent, sub-Saharan Africa, the Middle East, China, and Mexico. HBV infection accounts for more than 30% of cases of sporadic acute hepatitis in India, exceeding the frequency of HIV. Sporadic cases can occur in travelers to these regions, and are also seen in high-income nations in association with pig farming or consumption of organ meat. Pathogenesis discovered in 1983. HBV is an unenveloped, positively stranded RNA virus in the hepavirus genus. The RNA genome is 7.3 kb in length and contains 4 open reading frames that encode multiple proteins, including a viral protease and viral RNA polymerase. HBV is not cytopathic, and hepatic damage is thought to stem from the host response to cells infected with virus. Clinical features vary as are shed in stool during the acute illness. An infection is typically by the fecal-oral route. The average incubation period following exposure is 4 to 5 weeks, followed by self-limited acute hepatitis in most cases, with resolution in 2 to 4 weeks. Before the onset of clinical illness, HBV RNA and HBV variants can be detected by PCR in stool and serum. The onset of clinical symptoms, rise of serum aminotransferases, and appearance of IgM anti-HBV are virtually simultaneous. IgM is replaced with persistent Ig anti-HBV antibodies during recovery. Chronic liver disease or persistent viremia in immunocompetent patients is not observed. However, acute HBV infection is associated with a mortality rate approaching 20% among pregnant women. Chronic HBV infection can occur in the setting of immunosuppression, such as in those with AIDS and in transplant recipients. Clinical pathologic syndromes of viral hepatitis may pursue several clinical courses: 1 acute asymptomatic infection with recovery, 2 acute symptomatic hepatitis, icteric or icteric with recovery, 3 acute liver failure with massive to submissive hepatic necrosis, and 4 chronic hepatitis, with or without progression to cirrhosis. Table 18.3 provides a summary of the salient features of infection by various hepatitis viruses. Acute infections by all of the hepatotropic viruses can either be asymptomatic or symptomatic. HAV and HEV in immunocompetent. Table 18.3 virus type of virus. Route of transmission. Viruses hepatitis at ssRNA. Fecal or contaminated food or water. 6 weeks. Mean incubation. Period. Frequency of 10% co-infection. Chronic liver 90% 100% for disease superinfection. Diagnosis: serum IgM and Ig. Antibodies, PCR for HBV RNA, dsDNA, double-stranded DNA, ELISA, enzyme-linked immunosorbent assay, HBsAg, hepatitis B core antigen, HBsAg, hepatitis B surface antigen, HBV, hepatitis B virus, HEV, hepatitis C virus, HAG, hepatitis D antigen, HGV, hepatitis D virus, HEV, hepatitis E virus, Ig, immunoglobulin G, IgM, immunoglobulin M, Roman 4, intravenous, PCR, polymerase chain reaction, ssRNA, single-stranded RNA. From Washington K. Inflammatory and Infectious Diseases of the Liver. And I. O'Donnell, UCA, Montgomery, EA, editors, Gastrointestinal and Liver Pathology, Philadelphia, 2005, Churchill Livingstone, hepatitis. An immunocompromised hosts only, never 5%, 10%. Serum IgM and Ig antibodies, PCR for HEV RNA. ELISA for HCV antibodies, PCR for HCV RNA. Serum IgM antibodies, HBsAg or HBcAg. Antibodies, PCR, for HBV DNA. Hepatitis B partially dsDNA. Parenteral, sexual contact, perinatal. 2 6 weeks. Hepatitis C ssRNA. Parenteral, intranasal cocaine use. 4 26 weeks. Hepatitis D circular defective ssRNA. Parenteral, Same as HBV. Hepatitis E is cis-RNA. Fecal oral. 4. 5 weeks. Liver and bile ducts 837. Hosts do not cause chronic hepatitis, and only a small number of HBV-infected adult patients develop chronic hepatitis. In contrast, HCV is notorious for progressing to chronic infection. Acute liver failure is unusual and is seen primarily with HAV, HBV, or HDV infection, depending on region. HCV can cause acute liver failure in pregnant women. Although HBV and HCV are responsible for most cases of chronic hepatitis, many other disorders have similar clinicopathologic features, especially autoimmune and drug/toxin-induced hepatitis, described later. Therefore, serologic and molecular studies are essential for the diagnosis of viral hepatitis and for distinguishing among the various types. Major features of the main clinicopathologic syndromes associated with hepatropic virus infections are as follows. Acute asymptomatic infection with recovery. Here, infection is identified due to minimally elevated serum transaminases or, after recovery, by the presence of antiviral antibodies. HAV and HBV infection can be subclinical events, verified only by the presence of anti-HAV or anti-HBV antibodies. Acute symptomatic infection with recovery. Symptomatic disease can be divided into 4 phases: 1 incubation period, 2 symptomatic praeteric phase, 3 symptomatic iteric phase, and 4 convalescence. The incubation period for the different viruses is given in Table 18.3. Peak infectivity occurs during the last asymptomatic days of the incubation period and the early days of acute symptoms. Acute liver failure. Viral hepatitis accounts for approximately 10% of cases of acute hepatic failure. Hepatitis and E are the most common causes worldwide, while HBV is more common in Asia and the Mediterranean. The treatment is to provide supportive care and allow for replication of residual hepatocytes to lead to restitution of the liver. Liver transplantation is the only option if the disease does not resolve before secondary infection and failure of other organs develops. Chronic hepatitis. This is defined as symptomatic, biochemical, or serologic evidence of continuing or relapsing hepatic disease for more than 6 months. In some patients, persistent elevation of serum transaminases may be the only clinical evidence of chronicity. Prolongation of the prothrombin time, hyperglobulinemia, hyperbilirubinemia, and mild elevations in alkaline phosphatase level can occur. In symptomatic individuals, the most common finding is fatigue. Less common symptoms are malaise, loss of appetite, and occasional bouts of mild jaundice. Immune complex disease can develop due to circulating antibody-antigen complexes in chronic HBV and HEV infection and can manifest as vasculitis, glomerulonephritis, and cryoglobulinemia. Carrier state. A carrier is an individual who harbors and can transmit an organism, but has no symptoms. For hepatropic viruses, carrier state has been used to describe 2 separate scenarios: 1 individuals who harbor the virus but have no liver disease, and 2 individuals who harbor the virus and have asymptomatic non-progressive liver damage. In both cases, particularly the latter, affected individuals constitute reservoirs of infection. For HBV infection, the term healthy carrier has been used for an individual with HBsAg and anti-HB, but without HBAg. These patients have normal aminotransferases, low or undetectable serum HBV DNA, and lack of significant inflammation or liver injury on biopsy. See Fig. 18.11. For HCV, a state equivalent to the HBV healthy carrier is not recognized. HIV is an important comorbid factor in hepatropic viral infections. Co-infection of HIV and hepatitis viruses is common in the United States, as between 10% and 25% of HIV-infected individuals are also infected with HBV and HCV, respectively. Chronic HBV and HCV infection are leading causes of morbidity and mortality in HIV-infected individuals, although the severity and progression in immunocompetent HIV patients is similar to those who are HIV negative. Untreated HIV infection significantly exacerbates the severity of liver disease caused by HBV or HEV. Morphology. The general morphologic features of viral hepatitis are depicted schematically in Fig. 18.13. The morphologic changes in acute and chronic viral hepatitis due to hepatropic viruses are largely similar and overlap with those associated with autoimmune hepatitis, adverse drug reactions, and Wilson disease. In acute viral hepatitis, the liver may be normal in size, enlarged, due to inflammation, or shrunken in those cases that are associated with acute liver failure and massive liver necrosis. See Fig. 18.4. Microscopically, there is a portal and lobular inflammatory infiltrate comprised predominantly of lymphocytes and variably admixed with plasma cells and eosinophils. The hepatocyte injury may result in necrosis or apoptosis. See Figs. 18.2 and 18.3, often with pigmented macrophages scavenging the dead cell debris. Necrosis of groups of hepatocytes, i.e., confluent necrosis, may be seen in severe cases and can progress to necrosis of the entire lobule, i.e., conlobular or panicynar necrosis, or connect vascular structures, i.e., bridging necrosis. Liver failure can develop with massive hepatic necrosis. The defining histologic feature of chronic viral hepatitis is portal lymphocytic or lymphoplasmacytic inflammation with fibrosis. The inflammatory cells often cross the limiting plate and lead to injury of periportal hepatocytes interface activity. This may be accompanied by a variable degree of lobular inflammation. Fibrosis develops with increasing liver damage, manifesting initially as portal and periportal fibrosis. Fibrocepta develop and lead to portal-portal bridging fibrosis, and eventually, cirrhosis. There are some morphologic features that are distinctive for particular subtypes of chronic viral hepatitis. In chronic hepatitis B, the swollen endoplasmic reticulum of hepatocytes are swollen and filled with HBs ag, leading to a ground glass appearance. Immunostaining for hepatitis B surface and core antigens can confirm the HBV infection. Fig. 18.14. Chronic hepatitis C typically shows prominent lymphoid aggregates or fully formed lymphoid follicles in the portal tracts. Fig. 18.15. Steatosis is common in chronic hepatitis C and can be marked with genotype 3 infection. Bile duct injury can be seen in hepatitis C, mimicking biliary disease, but it is typically a focal finding. Chapter 18, Liver and Gallbladder. Acute hepatitis, chronic hepatitis. Portal tract scant mononuclear infiltrate. Portal tract dense mononuclear infiltrate. Bridging necrosis. Ballooning degeneration. Portal fibrosis. Central vein. Bridging fibrosis. Ductular reaction. Macrophage aggregates. Apoptosis. Cholestasis. Interface hepatitis. Lymphocytes apoptosis. Ground glass cells hepatitis B. Fatty change hepatitis C. Macrophage aggregate. Central vein. Figure 18.13 diagrammatic representation of the morphologic features of acute and chronic hepatitis. Acute hepatitis is characterized by lobular inflammation and hepatocellular injury, and chronic hepatitis shows dense portal inflammation. Bridging necrosis can occur in severe acute hepatitis, and fibrosis is seen in chronic hepatitis. Ductular reaction is often present in areas of fibrosis and chronic hepatitis. Liver biopsy is often performed to confirm the diagnosis of chronic hepatitis and to assess inflammatory activity grade and fibrosis stage. Stage of the disease is used along with other clinical parameters to determine the therapeutic approach. 838. Figure 18.14 ground glass hepatocytes in chronic hepatitis B caused by accumulation of hepatitis B surface antigen in the endoplasmic reticulum. Cytoplasmic inclusions are light pink and finely granular on hematoxylin and eosin staining. Immunostaining insert confirms that they contain hepatitis B surface antigen BRAD. Key concepts: viral hepatitis. Hepatitis that is transmitted through the fecal-oral route causes acute hepatitis and does not lead to chronic liver disease. Hepatitis B is transmitted parenterally, with most infections being subclinical, but can cause acute hepatitis, chronic hepatitis, and cirrhosis. Hepatitis C is most often associated with progression to chronic liver disease 80% or more, while acute infections are almost always subclinical. Hepatitis D is a defective virus, requiring hepatitis B co-infection for replication and infection. Hepatitis E is endemic in equatorial regions and frequently epidemic. It causes acute disease, which can be severe in pregnancy and can lead to chronic hepatitis in immunocompromised individuals. The inflammatory cells in both acute and chronic viral hepatitis are mainly T cells. The morphologic findings overlap with other hepatitic disorders such as autoimmune hepatitis, drug-induced liver injury, and Wilson disease. Biopsy assessment in chronic viral hepatitis provides the extent of fibrosis stage, which can determine the therapeutic course of action. Patients with HBV or HCV are at increased risk for development of HCC, especially in the setting of cirrhosis. The liver and bile ducts. 839. A. Histology shows epithelioid granulomas, with or without necrosis. At sites of involvement, the diagnosis rests on serologic findings, blood cultures, or demonstrating the organisms in liver biopsies. Parasitic and helminthic infections that can involve the liver include malaria, schistosomiasis, strongyloidiasis, cryptosporidiosis, leishmaniasis, echinococcus, amoebiasis, and infections by the liver flukes fasciola hepatica, Opisthochus species, and Clinorchus sinensis. Chapter 8. Schistosomiasis is most commonly found in Asia, Africa, and South America in areas where the water contains numerous freshwater snails as a vector, and it is particularly likely to cause chronic liver disease. Liver fluke infections, most common in Southeast Asia, are notorious for increasing the risk of cholangiocarcinoma, discussed later. Hydatid cysts are usually caused by echinococcal infections. Chapter 8. They often have characteristic calcifications in the cyst walls, which may enable radiologic diagnosis. Hydatid cysts are uncommon in high-income countries. Cystic liver degeneration or abscesses can be caused by ambic and other protozoal and helminthic infections. The incidence of ambic infections is low in high-income countries and is usually found in immigrants from endemic regions. Autoimmune hepatitis B. Figure 18.15 chronic viral hepatitis due to hepatitis C virus. A characteristic portal tract expansion by a lymphoid aggregate. E. Delicate bridging fibrosis, seen later in the disease course. Bacterial, fungal, and parasitic infections. Bacteria, fungi, helminths, and other parasites/protozoa can involve the liver and biliary tree as localized infections or as part of a systemic disease. Examples of bacterial infections include Staphylococcus aureus and toxic shock syndrome, Salmonella typhi and typhoid fever, Treponema pallidum and secondary or tertiary syphilis, and Bartonella henselae and cat scratch disease. Biliary obstruction creates a milieu for bacterial proliferation leading to infection of the biliary tree, often called ascending cholangitis. When severe, this may extend to the liver and produce intrahepatic abscesses. Spread of bacteria through the hematogenous route or direct spread from adjacent infected tissues can also lead to abscess formation. Liver abscesses are associated with fever, right upper quadrant pain, and tender hepatomegaly. Jaundice may result from extrahepatic biliary obstruction. Antibiotic therapy is generally effective, but surgical drainage may be necessary for large lesions. Extrahepatic bacterial infections, particularly intra-abdominal infections, may lead to nonspecific inflammatory changes in the liver. Sepsis can be associated with ductular reaction and cholestasis presenting as bioplugs and ductules, ductular or cholangiolar cholestasis, a typical feature of sepsis. The liver can be involved in disseminated fungal, for example, histoplasmosis and mycobacterial infections. The liver. Autoimmune hepatitis is a chronic, progressive hepatitis associated with genetic predisposition, autoantibodies, and therapeutic response to immunosuppression. There is a female predominance 78%. Pathogenesis. Autoimmune hepatitis has a strong association with specific HLA alleles in Caucasians DR3, Japanese DR4, and in South Americans DR bone. Proposed triggers for the immune reaction include viral infections, drugs/toxins, and vaccination, but the antigens that are the target of autoimmunity are unknown, and as with other autoimmune disorders, that basis for the immune attack on hepatocytes remains obscure. The lymphocytic infiltrate in the liver is composed predominantly of CD4 plus helper T cells with CD8 plus cytotoxic T cells at the interface. CD4 plus cells play an important role in activating B lymphocytes and their differentiation into plasma cells, which are responsible for production of autoantibodies. The mechanism by which the interplay of lymphocytes, autoantibodies, and HLA types lead to liver injury is unclear. A small number of drugs such as minocycline, nitrofurantoin, and alpha-methyl-dopa can trigger the formation of autoantibodies and hepatocellular injury that mimics autoimmune hepatitis. Morphology. The features of autoimmune hepatitis overlap with acute and chronic hepatitis of other etiologies. Extensive inflammation and hepatocellular injury at the interface, as well as in the hepatic parenchyma, is characteristic of autoimmune hepatitis. Numerous plasma cells and clusters are typical. Fig. 18:16. Lymphocytes and plasma cells may be seen within the cytoplasm of hepatocytes. 840. Chapter 18. Liver and gallbladder. Figure 18.16. Autoimmune hepatitis. A focus of lobular hepatitis with prominent plasma cells typical for this disease is shown, often at the interface, a curious phenomenon called emperopulses. Necrosis of groups of hepatocytes. Confluent necrosis can involve the paravenular areas, the entire sinus panicinae necrosis, or connect vascular structures bridging necrosis. The resultant regenerative features can manifest as rosettes, a circular arrangement of hepatocytes around a dilated canaliculus. Most cases have some degree of fibrosis at initial presentation, which increases with disease progression. Cirrhosis with limited inflammatory activity, i.e., burnout cirrhosis, is seen at initial presentation in some cases, the end result of subclinical disease. Simplified. Clinical features. Untreated autoimmune hepatitis leads to death or progresses to cirrhosis in a majority of cases. It has a wide range of presentations ranging from asymptomatic disease detected by elevated transaminases during screening to acute and chronic presentations. Acute presentations may be indistinguishable from acute viral or drug-induced hepatitis and may lead to acute liver failure. More commonly, the presentation is insidious with nonspecific symptoms such as fatigue, anorexia, nausea, and abdominal pain. Patients without symptoms or apparently acute presentations often prove to have fibrosis and even cirrhosis on biopsy, indicating the existence of subclinical disease that went unrecognized. In a small subset of patients, there may be overlapping features with primary biliary cholangitis or primary sclerosing cholangitis, the latter occurring most often in the pediatric setting. The diagnosis of overlap syndromes requires the unequivocal presence of serologic, biochemical, and/or histologic evidence of both diseases. In some instances, the second component of the overlap syndrome becomes evident months or years after treatment of the first component. Autoimmune hepatitis may also be associated with other autoimmune diseases like type 1 diabetes mellitus, thyroiditis, and celiac sprue. Autoimmune hepatitis-like injury induced by drugs is important to recognize because discontinuation of the drug typically leads to clinical recovery. The diagnosis of autoimmune hepatitis is based on the combination of four features: autoantibodies, elevation. Tablet 18. Diagnostic International. Autoimmune hepatitis criteria 0 or 8 offer Group P. Points: ANA or SMA or LKM 182, ANA or SMA or LKM 141, SLA/LP positive 20 units 0, 1, 1, 0. Times normal limit 2, upper normal limit 1. Typical for autoimmune hepatitis 2, compatible with autoimmune hepatitis 1, atypical for autoimmune hepatitis 0. S2 no 0. A definite autoimmune hepatitis AIH, N equals 7. Probable AIH, N equals 6. B typical. 1 interface hepatitis. Lymphocytic/lymphoplasmacytic infiltrates in portal tracts and extending in the lobule. 2 emperopulses, active penetration by one cell into and through larger cell. 3 hepatic rosette formation. Compatible. Chronic hepatitis with lymphocytic infiltration without features considered typical. Atypical. Showing signs of another diagnosis like non-alcoholic fatty liver disease. A. Autoimmune hepatitis. ANA. Antinuclear antibody. SMA. Anti. Smooth muscle acting. IG. Immunoglobulin G. LKM. Anti. liver-kidney microsomal antibodies, LP, liver-pancreas, SLA, soluble liver antigen. Modified from Hans E.M., Zenia M., C. Zaja A.J., et al. Simplified criteria for the diagnosis of autoimmune hepatitis. Hepatology 48-1, 169, 176, 2008. Autoantibodies. Ag or gamma globulins. Liver histology. Absence of viral hepatitis. Of serum Ag. Exclusion of other etiologies, for example, viral hepatitis, drugs, and supportive histologic findings on liver biopsy. These features have been combined to create a scoring scheme, which enables categorization of cases into definite and probable autoimmune hepatitis. Table 18.4. Based on the types of autoantibodies present, autoimmune hepatitis is subclassified as types 1 and 2. Type 1 is more common and is typically characterized by the presence of antinuclear antibodies ANAs and anti-smooth muscle actin SMA antibodies. Antibodies against soluble liver antigen / liver pancreas antigen SLA / LPA, and, less commonly, antimitochondrial antibodies AMA, more typical of primary biliary cholangitis, also may be seen. Type 2 disease is more common in children and is characterized by anti-liver-kidney microsome 1 LKM1 antibodies, which are directed against CYP4D6, and anti-liver cytosol 1 ACL1 antibodies. The other clinical features, natural history, and pathologic findings are similar in the two types. Serum Ag is often elevated in autoimmune hepatitis and may provide another clue to the diagnosis. Autoantibody titers do not correlate well with disease severity or outcome, and may not be present in a small subset of cases, i.e., seronegative autoimmune hepatitis. Autoantibodies also may be present in other disease processes such as steatohepatitis and chronic viral hepatitis, for example, with HBV and HEV. Hence, it is important to make the diagnosis based on overall clinical, serologic, and histologic features. The treatment of choice is immunosuppression with prednisone, with or without azathioprine, leading to remission in 80% to 90% of patients, generally within 12 months of treatment. Other immunosuppressants are used if the side effects of steroids cannot be tolerated. Patients with incomplete responses or with multiple relapses are at higher risk of progression to cirrhosis and also at risk for developing the liver and bile ducts. 841. Hepatocellular carcinoma. Liver transplantation may be necessary for cirrhotic patients. The 10-year survival rate after liver transplant is 75%, with disease recurrence in 20% of patients. Key concepts: autoimmune hepatitis. The diagnosis of autoimmune hepatitis is based on a combination of 4 features: autoantibodies, elevated serum Ag, pathologic findings, and exclusion of viral / drug etiologies. The most common autoantibodies in type 1 autoimmune hepatitis are ANAs and anti-smooth muscle antibodies SMAs, while type 2 autoimmune hepatitis is characterized by anti-LK-MON autoantibodies. Autoimmune hepatitis can have varied presentations: asymptomatic liver enzyme elevation, acute liver failure, chronic hepatitis, and cirrhosis. Typical histologic features of autoimmune hepatitis include a high degree of necroinflammatory activity in numerous plasma cells, drug and toxin-induced liver injury. Drug or toxin-induced liver injury is a major cause of acute liver failure in the United States. Due to its central role in metabolism, the liver is susceptible to injury by a wide array of compounds found in medicines. Table 18.5. Herbal products, dietary supplements, poisonous plants and fungi, for example, Amanita phylloides mushrooms, and household and industrial products, for example, ointments, perfumes, shampoo, cleaning solvents, pesticides. Based on U.S. Drug-Induced Liver Injury Network data, 10% of the patients with drug-induced liver injury die or require liver transplantation, and 17% go on to develop chronic liver disease. Pathogenesis principles of drug and toxic injury are discussed in Chapter 9. Liver injury may develop immediately after exposure to the responsible agent or manifest after weeks or even months. In most instances, the injury is mediated by reactive metabolites generated in the liver. The cytochrome family of enzymes, particularly cytochrome P450, is involved in most of these metabolic reactions. Since these enzymes are more active in the central zone of the lobule, necrosis of perivenular hepatocytes is a typical feature of drug-induced liver injury. Agents that induce the cytochrome system, such as rifampicin, phenytoin, isoniazid, tobacco smoke, and ethanol, may exacerbate the toxicity of other drugs. Drug-induced liver injury can be idiosyncratic unpredictable or dose-dependent predictable. Idiosyncratic reactions are the most common form of drug-induced liver injury and usually occur after 1 to 3 months of exposure. See Table 18.5. In some instances, they appear to stem from a hypersensitivity response to the drug or its metabolite S. It is thought that there is genetic susceptibility in those who have idiosyncratic reactions. For example, the metabolism of isoniazid, an antituberculous agent, is slow in individuals. Amyloid E-iter, AC. 5 toxin-induced IT-HEP patterns. Pattern of injury. Cholestatic hepatitis, hepatocellular necrosis, fatty liver disease, fibrosis and cirrhosis, granulomas, vascular lesions, neoplasms, J of drug, and morphologic findings. Bland hepatocellular cholestasis without inflammation. Cholestasis with lobular necroinflammatory activity may show bile duct destruction. Spotty hepatocyte, necrosis, massive necrosis. Chronic hepatitis, large and small droplet fat, microvesicular. Steatosis, diffuse small droplet fat steatohepatitis with Mallory highline, periportal and paracellular fibrosis. Non-casating epithelial with granulomas, fibrin ring granulomas. Sinusoidal obstruction, syndrome veno-occlusive disease, obliteration of central veins, Budd-Chiari syndrome, pileosis hepatis, blood-filled cavities, not lined by endothelial cells. Hepatocellular adenoma, hepatocellular carcinoma, cholangiocarcinoma, angiosarcoma, or antiretroviral therapy, modified from Washington K. Metabolic and toxic conditions of the liver. Nycabuzzi O'Donnell, UCA, Montgomery EA, editors, Gastrointestinal and Liver Pathology, Philadelphia, 2005. Churchill Livingstone, who have a variant of N-acetyltransferase NAT12 with decreased enzymatic activity, raising drug levels in the liver and leading to susceptibility to isoniazid and hepatotoxicity. Antimicrobial drugs are the most common culprits in idiosyncratic reactions, accounting for nearly 1/2 of cases. Other commonly implicated agents include cardiovascular drugs, central nervous system agents, and neoplastic drugs, and analgesics like non-steroidal anti-inflammatory. 8. Examples of associated agents: contraceptive and anabolic steroids, antibiotics or antibiotics, phenothiazines, statins, methyl-dopa, phenytoin, acetaminophen, alethane isoniazid, ethanol, corticosteroids, methotrexate, total parenteral nutrition, Valpro, tetracycline, aspirin, Ray syndrome, ART, ethanol, amiodarone, irinokin, alcohol, methotrexate, enalapril, vitamin A and other retinoids, sulfonamides, amiodarone, isoniazid, allopurinol, high-dose chemotherapy, Bush teas, oral contraceptives, anabolic steroids, amoxicillin, oral contraceptives, anabolic steroids, alcohol, Thoritress, vinyl, chloride. Chapter 18, liver and gallbladder. Drugs. A wide variety of herbal and nutritional agents also have been implicated in idiosyncratic reactions. Classic, dose-dependent, predictable hepatotic sin is acetaminophen, now the most common cause of acute liver failure necessitating transplantation in the United States. The toxic agent is not acetaminophen itself, but rather a metabolite, an acetylphenylbenzoquinone imine napkin, produced by the cytochrome P450 system. Paracentral zone 3 hepatocytes are most sensitive to napkin, but in severe overdoses the injury affects all parts of the lobules, resulting in acute hepatic failure. While suicide attempts with acetaminophen are common, so are accidental overdoses. This is because the activity of the cytochrome P450 system may be upregulated by other agents taken in combination with acetaminophen, such as alcohol, but where acetaminophen as a hangover prophylactic or codeine and acetaminophen compound tablets. Other examples of direct-acting hepatotic sins that may produce severe liver injury include organic solvents and toxins in mushrooms. Morphology. Drugs can lead to one or more patterns of injury. Hepatocellular injury accounts for almost 1/2 of cases, and the remaining are divided approximately equally between cholestatic and mixed hepatocellular/cholestatic patterns. Idiosyncratic reactions with a hepatocellular pattern of injury show typical features of acute hepatitis dominated by inflammation and varying degrees of necrosis. The picture is similar to viral and autoimmune hepatitis. The centrozoal necrosis is a common feature. Progression to chronic hepatitis, and even cirrhosis, can be seen in a small minority of cases. Injury caused by intrinsic hepatotic sins is dominated by necrosis with minimal inflammation. Injury centered on bile ducts is characterized by varying combinations of cholestasis and ductular reactions, which can progress to chronic cholestasis and duct dropout in a minority of cases. Some agents produce other patterns of injury. Drugs like amiodarone antiarrhythmic, tamoxifen anti-estrogen, irinokin, antineoplastic, and methotrexate immune suppressive can cause steatohepatitis-like pattern of injury. Mitochondrial dysfunction, caused by drugs such as tetracycline antibiotic, valproic acid, anticonvulsant, and zidovudine antiretroviral can result in microvesicular steatosis. Endothelial injury to sinusoids and central veins can be caused by cytotoxic agents azathioprine, oxaliplatin, leading to sinusoidal obstruction syndrome, formerly called veno-occlusive disease. Clinical features: drug-induced liver injury can have a wide variety of presentations and should always be included in the differential diagnosis of liver disease. Since there are no specific clinical or pathologic features, the diagnosis is established based on temporal association of drug or toxin exposure with onset of liver injury. Liver enzyme tests can be used to gauge whether the injury is primarily 1 hepatocellular alanine aminotransferase all 5 times the upper limit of normal, or alt/alkaline phosphatase ALP ratio 5, 2 cholestatic ALP 2 times the upper limit of normal, or alt/ALP ratio 2, or 3 mixed increased alt and ALP with alt/ALP ratio between 2 and 5. Exclusion of other etiologies and disease recovery. In most cases, on withdrawal of the offending agent support the presumptive diagnosis. Recurrence with rechallenge with the drug can be confirmatory but is rarely done in practice for obvious reasons. 842. Key concepts: drug-induced liver injury. There are 2 mechanisms of liver injury: direct hepatotoxicity, a dose-dependent phenomenon of drug or its metabolite, which predictably affects exposed individuals, a typical example being acetaminophen, which is the most common cause of acute liver failure in the United States. Idiosyncratic hypersensitivity response, which is not dose-dependent, accounts for the majority of drug-induced liver injury, but typically occurs in a minority of individuals. Drugs can mimic any clinical or histologic pattern of injury and should be included in the differential diagnosis of liver diseases in diverse clinical settings. Correlation of temporal profile of drug intake and onset of disease is necessary for diagnosis. Fatty liver disease, alcoholic liver disease, and non-alcoholic fatty liver disease share many similarities and are considered together in this section. Alcoholic liver disease. Excessive alcohol ethanol consumption is a major cause of liver disease in most Western countries. It accounts for 5.9% of deaths globally and more often leads to death and disability earlier in life than other forms of chronic liver injury. There are 3 distinctive, albeit overlapping, forms of alcohol-induced liver injury. 1. Steatosis, or fatty change. 2. Alcoholic steatohepatitis. And 3. Fibrosis, which leads to cirrhosis. Pathogenesis, the pharmacokinetics and metabolism of alcohol are described in Chapter 9. Pertinent to this discussion are the detrimental effects of alcohol and its byproducts on hepatocellular function. Short-term ingestion of as little as 80 g of alcohol, 6 beers or 8 ounces of 80-proof liquor over 1 to several days generally produces mild, reversible, hepatic steatosis. The risk of severe hepatic injury becomes significant with intake of 80 g or more of ethanol per day, and daily ingestion of 160 g or more for 10 to 20 years is frequently associated with severe liver injury. However, only 10% to 15% of alcoholics develop cirrhosis. Thus, other factors also influence the development and severity of alcoholic liver disease. These include gender. Although the majority of patients with alcoholic liver disease are men, on a dose-for-dose basis, women are more susceptible to alcohol-induced hepatic injury. Liver and bile ducts. 843. Gender differences in alcohol pharmacokinetics and metabolism may contribute, as well as estrogen-dependent responses of the liver to gut-derived endotoxin lipopolysaccharide LPS. Although exact mechanisms are not known, it appears that estrogen increases gut permeability to endotoxins. These are transported in the portal system to the liver, where they bind the LPS receptor CD14 expressed on Kupffer cells, an event that stimulates toll-like receptor 4. Toll-like receptor signaling triggers the release of cytokines and chemokines, which may contribute to the inflammation that accompanies alcoholic liver disease. Ethnic and genetic differences. In the United States, cirrhosis rates are higher for African Americans than for Caucasian Americans despite similar levels of alcohol consumption. Studies with twins suggest that there is a genetic component in alcohol-induced liver disease, although it remains difficult to separate genetic from environmental influences. Genetic variation in alcohol detoxifying enzymes and cytokine promoters may play significant roles and contribute to differences across populations. Ald*2, a variant of aldehyde dehydrogenase all found in 50% of Asians, has a very low enzyme activity. Individuals homozygous for Ald*2 are unable to oxidize acetaldehyde and are intolerant of alcohol, which produces upper body flushing and variable levels of nausea and lethargy. Comorbid conditions. Iron overload, non-alcoholic steatohepatitis, an infection with HCV and HBV synergize with alcohol to increase the severity of liver disease. Excessive alcohol intake causes steatosis, dysfunction of mitochondria, microtubules and cellular membranes, and oxidative stress, and the resulting injury leads to varying degrees of inflammation and hepatocyte death. Several factors appear to contribute to steatosis. Alcohol metabolism by alcohol dehydrogenase and acetaldehyde dehydrogenase generate large amounts of reduced nicotinamide adenine dinucleotide NAD. This alters the redox balance in hepatocytes and has a plethora of effects that favor lipogenesis, including suppression of fatty acid oxidation and increased expression of enzymes that carry out fatty acid synthesis. The accumulation of intrahepatic lipids may be further exacerbated by impaired lipoprotein assembly and secretion. Alcohol also enhances peripheral catabolism of fat, increasing the circulating pool of lipids that are available for uptake by hepatocytes. The exact mechanisms underlying hepatocyte injury and alcoholic hepatitis are uncertain, but several likely contributory factors have been identified. Acetaldehyde, the product of alcohol dehydrogenase, induces lipid peroxidation and acetaldehyde protein duct formation, disrupting cytoskeleton and membrane function and possibly producing neoantigens. CYP12-EN induction. High levels of alcohol consumption induce liver microsomes that contain CYP12-EN, a component of the cytochrome P450 system. CYP12-EN metabolism of alcohol produces ROS that damage cellular protein, membranes, and mitochondria, effects that may promote apoptosis. Methionine metabolism. Alcohol impairs hepatic metabolism of methionine, which decreases glutathione E levels, thereby sensitizing the liver to oxidative injury and contributes to homocysteine production, which may induce the endoplasmic reticulum stress response. The induction of cytochrome P450 enzymes in the liver by alcohol also enhances the conversion of other drugs, for example, acetaminophen to toxic metabolites. Furthermore, as already mentioned, alcohol has been linked to increased uptake of bacterial endotoxin from the gut, which induces inflammatory responses in the liver. Damage caused by these and other factors lead to inflammation and, with chronicity, liver fibrosis and deranged vascular perfusion summarized in Fig. 18.17. In essence, Alcoholic liver disease can be regarded as a maladaptive state in which cells in the liver respond in an increasingly pathologic manner to a stimulus, alcohol, that originally was only marginally harmful. Morphology characteristic changes in alcoholic liver disease begin in central lobular zone 3 and extend outward toward the portal tracts as the injury increases in severity. Hepatic steatosis, fatty liver, is an early, predictable effect of alcohol consumption. After even moderate intake of alcohol, lipid droplets accumulate in hepatocytes. Lipid accumulation begins as small droplets that coalesce into large droplets, which distend the hepatocyte and push the nucleus. Aside Fig. 18. Macroscopically, the fatty liver of chronic alcoholism is enlarged as heavy as 4 to 6 kilograms, soft, yellow, and greasy. Steatosis may be separated into microvesicular and macrovesicular forms. Macrovesicular steatosis is the predominant form in alcoholic liver disease. An unusual exception is alcoholic foamy degeneration, a form of microvesicular steatosis sometimes seen with chronic heavy alcohol use that is associated with endoplasmic reticulum and mitochondrial damage. In general, fatty change is completely reversible if there is abstention from further intake of alcohol. In a subset of patients with alcoholic liver disease, liver inflammation, alcoholic hepatitis, and fibrosis, see Fig. 18 are prominent features. The morphologic findings in alcoholic hepatitis include the following. Balloon hepatocytes, Fig. 19. These are injured, swollen hepatocytes with cleared out cytoplasm and cytoskeletal damage, which when extensive, results in formation of Mallory hyaline, tangled skeins of intermediate filaments such as keratin 8 and keratin 18 that are partially degraded and ubiquitinated. C. Fig. 19b. Mallory hyaline may reflect a failed attempt to sequester and degrade damaged cytoplasmic proteins. Other balloon hepatocytes lack Mallory hyaline and contain fat droplets instead. While balloon hepatocytes are not entirely specific for alcoholic steatohepatitis, they are essential for this diagnosis. Other conditions with balloon hepatocytes include non-alcoholic steatohepatitis, NASH, Wilson disease, and chronic biliary tract diseases, inflammation, and necrosis. Neutrophils are generally more prominent in alcoholic hepatitis than in NASH and can satellite around balloon hepatocytes, particularly when Mallory hyaline is present. Lobular lymphocytic infiltrates are common, and portal lymphocytic infiltrates also may occur, along with increases in macrophages in both portal tracts and lobular parenchyma. 844, Chapter 18, Liver and Gallbladder. Normal liver exposure, abstinence, severe exposure. Steatosis, fatty change, paravenular fibrosis, abstinence, severe exposure, repeated attacks, hepatitis, liver cell necrosis, inflammation, Mallory bodies, fatty change, continued exposure, cirrhosis, fibrosis, regenerative, nodules. Figure 18.17, alcoholic liver disease. The interrelationships among hepatic steatosis, alcoholic hepatitis, and alcoholic cirrhosis are shown, along with depictions of key morphologic features. It should be noted that some patients present initially with cirrhosis without any of the other forms of alcoholic liver disease. Necrosis/apoptosis is usually spotty, but more prominent hepatocellular injury and confluent necrosis can occur in some cases. Paravenular/paracellular fibrosis. Steatohepatitis is often accompanied by fibrosis. This usually starts in the cinar zone 3 as paracellular or parasinusoidal fibrosis with a chicken wire appearance. See Fig. 18.18. With continued damage, this progresses to portal/paraportal fibrosis, and then to bridging fibrosis and cirrhosis, which in many cases is micronodulolenic cirrhosis. Fig. 18.20. Early stages of scarring can regress with cessation of alcohol use, but with the development of cirrhosis and its vascular derangements related to paravenular fibrosis and fibrous obliteration, termed phlebiosclerosis, and veno-occlusive lesions, the chances of full restoration of normal function diminish. Complete regression of alcoholic cirrhosis, although reported, is rare. Figure 18.18, alcoholic steatosis and fibrosis. A mix of small and large fat droplets seen as clear vacuoles is most prominent around the central vein and extends outward to the portal tracts. Some fibrosis stained blue is present in a characteristic parasinusoidal chicken wire pattern. Mass and trichome stain. Courtesy Dr. Elizabeth Brunk, Washington University, St. Louis, month. Clinical features: hepatic steatosis may cause hepatomegaly, with mild elevation of serum bilirubin and alkaline phosphatase levels. Severe hepatic dysfunction is unusual. Alcohol withdrawal and consumption of an adequate diet are sufficient treatment. In contrast, alcoholic hepatitis tends to appear acutely, usually following a bout of heavy drinking. Typically, there is malaise, anorexia, weight loss, upper abdominal discomfort, and tender hepatomegaly, accompanied by the laboratory findings of hyperbilirubinemia, elevated serum aminotransferases and alkaline phosphatase, and often a neutrophilic leukocytosis. In contrast to other chronic liver diseases, in which serum ALT tends to be higher than serum AST, in alcoholic liver disease serum AST tend to be higher. Liver and bile ducts. 845. A B. Figure 18.19, an alcoholic hepatitis with clustered inflammatory cells marking the site of a necrotic hepatocyte. Mallory hyaline is present in another hepatocyte arrow. The alcoholic hepatitis with many balloon hepatocytes arrowheads. Clusters of inflammatory cells are also present. Inset shows immunostaining for keratins 8 and 18 brown, with most hepatocytes, including those with fat vacuoles, showing normal cytoplasmic staining, but in the balloon cell arrow the ubiquitinated keratins are collapsed into Mallory hyaline, leaving the cytoplasm empty. Courtesy Dr. Elizabeth Brunt, Washington University, St. Louis, month 8. B. Figure 18.20 Alcoholic cirrhosis. The characteristic diffuse nodularity of the surface is induced by the underlying fibrous scarring. The average nodule size is 3 mm in this close-up view, typical of the micronodular cirrhosis of alcoholic liver disease. Greenish tint is caused by cholestasis. B. Microscopically, the cirrhosis is marked by small nodules entrapped in blue staining fibrous tissue. Fatty accumulation is no longer seen in this burned-out stage mass and trichome stain. And serum OUT levels by a ratio of 2, 1 or greater. This finding can be particularly helpful in the setting of acute alcoholism. On the other end of the spectrum, in severe cases, symptoms and laboratory findings may mimic those of acute liver failure. In other instances, an acute cholestatic syndrome picture is seen that resembles large bile duct obstruction. The outlook is unpredictable. Each episode of hepatitis incurs about a 10% to 20% risk of death. With repeated bouts, cirrhosis develops in about 1/3 of patients within a few years. Alcoholic hepatitis also may be superimposed on established cirrhosis. With proper nutrition and total cessation of alcohol consumption, alcoholic hepatitis may clear. However, in some patients, the hepatitis persists despite abstinence, and progression to cirrhosis is seen. The manifestations of alcoholic cirrhosis are similar to those of other forms of cirrhosis. Laboratory findings reflect hepatic dysfunction and include elevated serum aminotransferases, hypobilirubinemia, variable elevation of serum alkaline phosphatase, hypoproteinemia globulins, albumin, and clotting factors, and anemia. In some instances, liver biopsy may be indicated, since in about 10% to 20% of cases of presumed alcoholic cirrhosis, another disease process is found. Finally, cirrhosis may be clinically silent, discovered only at autopsy or when a stress such as infection or trauma tips the balance toward hepatic insufficiency. The long-term outlook for alcoholics with liver disease is variable. The 5-year survival rate approaches 90% in abstainers who are free of jaundice, ascites, or hematemesis. It drops to 50% to 60% in those who continue to imbibe. In advanced disease, common proximate causes of death include 1 hepatic coma, 2 massive gastrointestinal hemorrhage, 3 intercurrent infection to which these patients are predisposed, 4 hepatorenal syndrome often following a bout of alcoholic hepatitis, and 5 hepatocellular carcinoma. The risk of developing this tumor in alcoholic cirrhosis is 1% to 6% annually. 846 Chapter 18 Liver and Gallbladder. Elbatibate M6.81 Health Organization Criteria for the Psilomornius, 1 of diabetes mellitus, or impaired glucose tolerance, or impaired fasting glucose, or insulin resistance, and 2 of blood pressure, 140/90 mmHg, dyslipidemia, triglycerides TG, 1.695, MR/L and high-density lipoprotein cholesterol HDL-C 0.9, MR/L male, 1 MR/L female, central obesity, waist-hip ratio 0.90, male, 0.85, female, or body mass index 30 kg/mPro microalbuminuria, urinary albumin excretion rate of 20 mg/minute or albumin to creatinine ratio 30 mg/g. Key concepts: alcoholic liver disease. Alcoholic liver disease is a chronic disorder that can give rise to steatosis, alcoholic hepatitis, progressive fibrosis, and marked derangement of vascular perfusion leading eventually to cirrhosis. Consumption of 80 g/day of alcohol is considered to be the threshold for development of alcoholic liver disease, but may be lower in women. It may take 10 to 15 years of drinking for development of cirrhosis, which occurs only in a small proportion of chronic alcoholics. The pathologic effects of alcohol on hepatocytes include changes in lipid metabolism related to altered redox potential, injury caused by ROS generated by metabolism of alcohol by the FR150 system, and protein adducts formed by acetaldehyde, a major metabolite of alcohol. Non-alcoholic fatty liver disease (NAFLD). NAFLD is defined as the presence of hepatic steatosis, fatty liver, in individuals who do not consume alcohol or do so in small quantities and who do not have another cause of secondary hepatic fat accumulation, for example, HEV, Wilson disease, medications. NAFLD is associated with obesity, diabetes mellitus type 2, and hyperlipidemia, all components of the metabolic syndrome table 18.6. It has become the most common cause of chronic liver disease in the United States and is projected to exceed 30% prevalence in the adult population by 2030. The term non-alcoholic steatohepatitis, or its common acronym NASH, is reserved for NAFLD patients who demonstrate steatohepatitic injury with histologic features similar to those seen with alcoholic hepatitis. The diagnosis of NASH confers an increased risk of developing advanced fibrotic liver disease, and the rise in NAFLD prevalence is expected to produce a concomitant increase in the incidence of NASH and its serious complications, for example, decompensated cirrhosis, hepatocellular carcinoma. Pathogenesis: the precise mechanisms underlying NAFLD are unknown. The strong association with insulin resistance suggests that this factor is particularly important in disease development. However, even among those with insulin resistance, there is significant variability in the severity of NAFLD, and complex associations with genetic variants, diet, and the intestinal microbiome have also been suggested. As in alcoholic liver disease, There is an established association between increased gut-derived endotoxin production and liver inflammation and injury. High fructose diets have also been associated with increased risk of NAFLD-related fibrosis, and dietary fat, particularly trans fat, may have a role in producing liver injury. Obstructive sleep apnea, usually occurring in the setting of obesity, has been associated with disease progression, possibly related to intermittent hypoxia. Fibrosis may be accelerated when injury from another liver disease, for example, hemochromatosis, is superimposed on NAFLD. In individuals with established insulin resistance and metabolic syndrome, visceral adipose tissue not only increases in mass but also becomes dysfunctional. Resistance to insulin leads to increased release of free fatty acids from adipocytes due to overactivity of lipoprotein lipase, chapter 24. This is associated with reduced production of the hormone adiponectin from adipocytes, which decreases oxidation of free fatty acids by skeletal muscle and increases free fatty acid uptake into hepatocytes, chapter 9, where the fatty acids are stored as triglycerides. The dysfunctional adipocytes also synthesize pro-inflammatory cytokines such as TNF-alpha. At the same time, there is evidence that hepatocytes and NAFLD downregulate lipolysis, an alteration that may further contribute to the accumulation of lipids. Lipolysis occurs through a mechanism called lipophagy that closely resembles macrophagy, which you will recall is the process by which cells remove excessive or dysfunctional cellular components and in times of starvation generate metabolites for energy production. The net effect of these changes is to cause lipid to accumulate in hepatocytes. Fat-laden cells are highly sensitive to lipid peroxidation products generated by oxidative stress, which can damage mitochondrial and plasma membranes, potentially leading to apoptosis or necrosis. These tendencies may be exacerbated by the pro-inflammatory state that accompanies insulin resistance. Once cell injury becomes established, release of cytokines such as TNF-alpha and TGF-beta locally from Kupffer cells leads to the activation of stellate cells, collagen deposition, and scarring. Morphology. NASH shares many morphologic features with alcoholic hepatitis. Steatosis. 5% of hepatocytes, lobular inflammation, and balloon hepatocytes are required for its diagnosis. It is not possible to reliably distinguish alcoholic hepatitis from NASH based on histologic findings, though alcoholic hepatitis has on average less steatosis and more balloon hepatocytes, lobular inflammation, Mallory hyaline, neutrophilic infiltrates, cholestasis, and obliterated central veins. Fig. 18.21. Determination of the extent of fibrosis is important for clinical management. Fibrosis typically develops around the central vein as a fine spider web of pericellular collagen deposition. Also, the liver and bile ducts. 847. Referred to as a chicken wire pattern, which may only be appreciated with a trichome stain. Progression of fibrosis usually manifests as periportal fibrosis, followed by bridging fibrosis and cirrhosis. Cirrhosis is often subclinical for years, and, when established, the steatosis or balloon hepatocytes may be reduced or absent. More than 90% of cases labeled as cryptogenic cirrhosis, i.e., cirrhosis of unknown cause, are thought to be due to NASH, i.e., burned out NASH. Pediatric NAFLD differs significantly from adult NAFLD. Typically, children show more diffuse steatosis and portal rather than central fibrosis, and balloon hepatocytes may not be present. AB. Figure 18.21. Non-alcoholic fatty liver disease. A liver with mixed small and large fat droplets as well as balloon hepatocytes. These steatosis and fibrosis extending along sinusoids in a chicken wire pattern in which individual and clustered hepatocytes are surrounded by thin scars, blue fibers. Note the resemblance to alcoholic hepatitis depicted in Fig. 18.18. Mass and trichome stain. Clinical features. The very clinical course of individuals with NAFLD is summarized in Fig. 18.22. Individuals with only steatosis are generally asymptomatic. Clinical presentation is often related to other signs and symptoms of the metabolic syndrome, in particular insulin resistance or diabetes mellitus. Imaging studies may reveal fat accumulation in the liver. Liver biopsy is required for diagnosis of NASH and aids in assessment of fibrosis. Viral, autoimmune, and other metabolic diseases of the liver must be excluded, and biopsy may be helpful when there is more than one potential etiology for liver injury. Serum AST and ALT are elevated in most patients with NASH. Despite the enzyme elevations, patients may be asymptomatic. Others have nonspecific symptoms, such as fatigue, or complain of right-sided abdominal discomfort caused by hepatomegaly. Because of the association with metabolic syndrome, cardiovascular disease is a frequent cause of death in patients with NASH. NASH also increases the risk of hepatocellular carcinoma, as do other metabolic diseases discussed later. The goal of treating individuals with NASH is to reverse the histologic features of disease and prevent or reverse fibrosis by correcting underlying risk factors, such as obesity and hyperlipidemia, and to treat insulin resistance. Weight loss, diet, and exercise can potentially reverse the histology. Non-alcoholic fatty liver disease NAFLD. 80%, 20%. Isolated fatty liver non-alcoholic steatohepatitis NASH. 1. Not a very minimal progression to cirrhosis. 2. No increased risk of death compared with the general population. 20%. Advanced fibrosis. 3%, 4% per year, 1% per year. Decompensation hepatocellular carcinoma. Figure 18.22. Natural history of non-alcoholic fatty liver disease phenotypes. Isolated fatty liver shows minimal risk for progression to cirrhosis or increased mortality, and non-alcoholic steatohepatitis shows increased overall mortality as well as increased risk for cirrhosis and hepatocellular carcinoma. 848 Chapter 18 Liver and Gallbladder. Abnormalities in NASH. There are numerous ongoing clinical trials aimed at developing pharmacologic approaches for treating NASH and its complications. TD classification. Key concepts: non-alcoholic fatty liver disease. The most common metabolic liver disorder is NAFLD, which is associated with metabolic syndrome, obesity, type 2 diabetes mellitus, and hyperlipidemia. NAFLD may show all the histologic changes associated with alcoholic liver disease, for example, steatosis, steatohepatitis, and steatofibrosis. The diagnosis of NASH requires biopsy, and NASH cannot be reliably distinguished from alcoholic hepatitis without clinical history. Pediatric NAFLD is being increasingly recognized as the obesity epidemic involves pediatric age groups. Its histologic features differ somewhat from those seen in adults. Inherited liver disease. Among inherited metabolic diseases, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency are most prominent and are discussed in the following sections. Hemochromatosis. Hemochromatosis is caused by excessive iron absorption, most of which is deposited in the liver and pancreas, followed by the heart, joints, and endocrine organs. When hemochromatosis results from an inherited disorder, it is referred to as hereditary hemochromatosis. When accumulation occurs as a consequence of parenteral administration of iron, usually in the form of transfusions or other causes, it is called secondary hemochromatosis. The classification of the various causes of iron overload is shown in Table 18.7. Table 18.7 of iron overload I. Hereditary hemochromatosis: mutations of genes encoding HFE, transferrin receptor 2 TFR1, or hepcidin. Mutations of genes encoding HJV hemojuvelin, juvenile hemochromatosis. Roman 2. Hemosiderosis: secondary hemochromatosis. Parenteral iron overload due to red cell transfusions. Severe chronic hemolytic anemias, for example, sickle cell disease. Severe forms of thalassemia, bone marrow failure, for example, aplastic anemia. Conditions associated with increased iron uptake. Beta thalassemia, myelodysplastic syndrome, increased oral intake of iron. African iron overload, bantu siderosis. Congenital atrospheronemia. Chronic liver disease. Alcoholic liver disease. Porphyria cutanea tarda. Neonatal hemochromatosis. A neonatal hemochromatosis develops in utero but does not appear to be a hereditary condition. As discussed in Chapter 14, the total body iron pool ranges from 2 to 6 G in normal adults. About 0.5 G is stored in the liver, 98% of which is in hepatocytes. In severe hemochromatosis, the total body iron pool may exceed 50 G, more than 1/3 of which accumulates in the liver. The following features characterize severe iron overload. Fully developed cases exhibit 1. Micronodular cirrhosis, all patients, 2. Diabetes mellitus, 75% to 80% of patients, and 3. Abnormal skin pigmentation, 75% to 80% of patients. Iron accumulation in hereditary forms is lifelong, but the injury caused by excessive iron is slow and progressive. Hence, symptoms usually first appear in the 4th to 5th decades of life in men and later in women, since menstrual bleeding counterbalances the accumulation until menopause. Because many women do not accumulate clinically relevant amounts of iron within their lifetime, hereditary hemochromatosis affects more males than females, ratio of 5 to 7. 1. Pathogenesis. Because there is no regulated iron excretion from the body, the total body content of iron is tightly regulated by intestinal absorption. In hereditary hemochromatosis, regulation of intestinal absorption of dietary iron is abnormal, leading to net iron accumulation of 0.5 to 1 G/year. The disease typically manifests after 20 G of stored iron has accumulated. Mechanisms of liver injury include 1. Lipid peroxidation via iron-catalyzed free radical reactions, 2. Stimulation of collagen formation by activation of hepatic stellate cells, and 3. Interaction of ROS and iron itself with DNA, leading to lethal cell injury and predisposition to hepatocellular carcinoma. The main regulator of iron absorption is the protein hepcidin, encoded by the HAMP gene and produced and secreted by the liver. Fig. 18.23. Transcription of HAMP is increased by inflammatory cytokines and iron, and decreased by iron deficiency, hypoxia, and erythropoietin, a hormone produced by marrow erythroblasts. These inputs are integrated to regulate the synthesis and plasma levels of hepcidin. See Chapter 14. Hepcidin binds to the cellular iron efflux channel ferroportin, causing its internalization and proteolysis, thereby inhibiting the release of iron from intestinal cells and macrophages. Due to these activities, an increase in hepcidin lowers plasma iron levels. Conversely, an abnormal deficiency of hepcidin causes iron overload. Other proteins involved in iron metabolism do so by regulating hepcidin levels. Decreased hepcidin synthesis or activity may be caused by loss of function mutations in the genes HAMP, HJV, TFR1, and HFE, all of which are associated with hereditary forms of hemochromatosis. Deficiencies of hepcidin also occur when erythropoietin levels are chronically elevated, as occurs in disorders marked by infective hematopoiesis, such as beta thalassemia and myelodysplastic syndrome. The adult form of hereditary hemochromatosis is usually caused by mutations of HFE. Mutation of TFR1 is a rare cause. Mutations in HAMP and HJV genes are much less common and give rise to juvenile forms of hereditary hemochromatosis. HFE encodes in HLA class I, like molecule that governs intestinal absorption of dietary iron by regulating the liver and bile ducts. 849. A. Normal iron absorption. TFR-TFRone enterocyte iron, HJV, HFE, hepcidin synthesis, hepcidin, DM-tone, ferritin, hepatocyte, B. Hemochromatosis, TFR-TFRone, HJV, reduced hepcidin synthesis, HFE, ferritin, hepatocyte. Figure 18.23 normal iron metabolism and altered iron metabolism in hereditary hemochromatosis. In normal state, HFE, HJV, and TFR will regulate hepcidin synthesis by hepatocytes maintaining normal circulating hepcidin levels. Hepcidin binds to ferroportin on enterocytes, leading to internalization of the complex and ferroportin degradation. This in turn reduces efflux of iron from enterocytes. Through these regulatory interactions, normal iron absorption is maintained. B. In hereditary hemochromatosis, HFE, HJV, or TFR gene mutations reduce hepcidin synthesis, diminishing circulating hepcidin levels. Due to decreased hepcidin-ferroportin interaction, ferroportin activity and iron efflux from enterocytes increases, giving rise to systemic iron overload. Hepcidin synthesis. The most common HFE mutation produces an inactivating cysteine to tyrosine substitution at amino acid 282C1282Y and is present in 70% or more of patients diagnosed with hereditary hemochromatosis. The other common disease-associated HFE mutation results in a H63D histidine at position 63 to aspartate substitution. The C1282Y mutation of HFE is largely confined to Caucasian populations of European origin, while the H63D mutation has a worldwide distribution. The frequency of C1282Y homozygosity is 0, 45% 1 in 220 persons, and the heterozygous frequency is 11%, making hereditary hemochromatosis one of the most common genetic disorders in humans. The penetrance of the disorder is low in patients with the homozygous C1282Y mutation, and is even lower in homozygous H63D and C1282Y/H63D compound heterozygous individuals. Morphology. Severe hemochromatosis, hereditary or secondary, is characterized by one deposition of hemosiderin in the following organs: in hepcidin, enterocyte, iron overload, DM-tone, ferroportin. Iron. Figure 18.24 hereditary hemochromatosis. In this Prussian blue stained section, hepatocellular iron appears blue. The parenchymal architecture is normal. Decreasing order of severity: liver, pancreas, myocardium, pituitary gland, adrenal gland, thyroid and parathyroid glands, joints, and skin. 2. Cirrhosis. And 3. Pancreatic fibrosis. In the liver, iron becomes evident first as golden yellow hemosiderin granules in the cytoplasm of periportal hepatocytes that stain with Prussian blue. Fig. 18.24. With increasing iron load, there is progressive deposition in the rest of the lobule, along with bile duct epithelium and Kupffer cells. Iron is a direct hepatotoxin, and inflammation is characteristically absent. In early stages of disease, the liver is typically slightly larger than normal, dense, and chocolate brown. Fibrous septa develop slowly, leading ultimately to a small, shrunken liver with a micronodular pattern of cirrhosis. The liver parenchyma in later stages is often dark brown to nearly black due to extensive iron accumulation. Other organs that are particularly susceptible to the toxic effects of iron also show morphologic changes. The pancreas becomes intensely pigmented and may undergo parenchymal atrophy associated with interstitial fibrosis. The heart is often enlarged and exhibits hemosiderosis, producing a striking brown coloration. Both organs may develop fibrosis. Skin pigmentation predominantly results from increased epidermal melanin production, the mechanism of which is unknown. The combination of these pigments imparts a characteristic slate gray color to the skin. With hemosiderin deposition in joint linings, an acute synovitis may develop. Excessive deposition of calcium pyrophosphate damages the articular cartilage, producing a disabling polyarthritis referred to as pseudogout. The testes may be small and atrophic, secondary to pituitary involvement and reduced gonadotropin and testosterone levels. Clinical features. The principal manifestations of hemochromatosis include hepatomegaly, abdominal pain, abnormal skin pigmentation particularly in sun-exposed areas, deranged glucose homeostasis or diabetes mellitus due to destruction of pancreatic islets, cardiac dysfunction or arrhythmias, cardiomyopathy, and atypical arthritis. In some patients, the presenting complaint is hypogonadism, for example, menorrhea in the female, impotence and loss of libido in the male. It is more often a disease of males, for reasons described earlier. 850 Chapter 18 Liver and gallbladder, and rarely becomes evident before 40 years of age. The classic tetrad of cirrhosis with hepatomegaly, abnormal skin pigmentation, diabetes mellitus, and cardiac dysfunction may not develop until late in the course. Death may result from cirrhosis or cardiac disease. Another significant cause of death is hepatocellular carcinoma. The risk is 200-fold greater than in the general population. Treatment that reduces iron overload does not fully remove the cancer risk, presumably because DNA damage occurs prior to diagnosis and treatment initiation. Fortunately, hemochromatosis is often diagnosed before irreversible tissue damage has occurred. Currently, most patients with hemochromatosis are identified in the subclinical, pre-cirrhotic stage due to routine serum iron measurements as part of other diagnostic workups, and the diagnosis is confirmed by DNA sequencing and detection of causative mutations, usually in HFE. Further evaluation includes exclusion of secondary causes of iron overload. A liver biopsy may also provide useful information, for example, about the presence of fibrosis, but is not done routinely, as genetic testing and imaging have negated the need for quantitative assessment of tissue iron content. Screening of the family members of probands is important, as identification of asymptomatic carriers can prevent disease development. Prevention of the development or progression of disease in patients with adult onset hereditary is remarkably simple, as regular phlebotomy steadily depletes tissue iron stores. With treatment, life expectancy is normal. The most common causes of secondary or acquired hemochromatosis are disorders associated with infective erythropoiesis, such as thalassemia chapter 14 and myelodysplastic syndrome chapter 13. In these disorders, the excess iron results not only from transfusions, but also from increased absorption. Erythrophorone released from an expanded population of erythroid progenitors in the bone marrow suppress hepcidin production by the liver, leading to increased iron absorption. Transfusions alone, when given repeatedly over a period of years, for example, in patients with chronic hemolytic anemias, can also lead to systemic hemosiderosis and parenchymal injury, independent of infective hematopoiesis. Finally, other forms of cirrhosis may also diminish hepcidin production due to loss of hepatocyte mass, leading again to increased iron uptake from the gut and increased tissue levels of iron. Wilson disease. Wilson disease is an autosomal recessive disorder caused by mutation of the AT7B gene, resulting in impaired copper excretion into bile and a failure to incorporate copper into ceruloplasmin. This disorder is marked by the accumulation of toxic levels of copper in many tissues and organs, principally the liver, brain, and eye. Free copper is taken up by hepatocytes and incorporated into a post-ceruloplasmin to form ceruloplasmin, which is secreted into the blood. Ceruloplasmin accounts for 90% to 95% of plasma copper. Excess copper within hepatocytes that is not incorporated into ceruloplasmin is sequestered in lysosomes and transported into the bile, from which it is eventually excreted in the feces. Pathogenesis. Wilson disease results from loss of function mutations in the AT7B gene, which encodes a transmembrane copper transporting ATPase, expressed on the hepatocyte canalicular membrane. More than 300 sequence variants in the AT7B gene have been identified, but not all cause the disease. The overwhelming majority of patients are compound heterozygotes containing different mutations on each AT7B allele. The overall frequency of mutated alleles is 110-0, and the prevalence of the disease is approximately 130, 0 to 150, 0 approximately 9,000 patients in the United States. Deficiency of AT7B decreases copper transport into bile, impairs its incorporation into ceruloplasmin, and inhibits ceruloplasmin secretion into the blood. These defects lead to a decrease in circulating ceruloplasmin accompanied by the accumulation of copper in hepatocytes. Total serum copper may be lower than normal due to the deficiency in ceruloplasmin, particularly early in the disease course. Excess hepatic copper causes toxic injury by 3 mechanisms: 1. Promoting the formation of free radicals by the Fendon reaction chapter 2, 2. Binding to sulfhydryl groups of cellular proteins, and 3. Displacing other metals from hepatic metal enzymes. Hepatocyte injury causes non-ceruloplasmin-bound copper to be spilled into the blood and accumulate in certain tissues, particularly the basal ganglia of the brain and the cornea. Concomitantly, urinary excretion of copper markedly increases, but not to levels sufficient to prevent deposition of copper in tissues. Morphology. The liver often bears the brunt of injury, but the disease may also present as a neurologic disorder. The hepatic changes are variable, ranging from relatively minor to massive damage, and mimic many other disease processes. Fatty chain steatosis may be present with focal hepatocyte necrosis. Acute liver failure can mimic acute viral hepatitis. Chronic hepatitis in Wilson disease typically exhibits moderate to severe portal inflammation and hepatocyte necrosis, and mixed with fatty change and features of steatohepatitis, i.e., balloon hepatocytes, prominent Mallory highline, and parasinusoidal fibrosis. Eventually, cirrhosis supervenes. Histochemical copper staining is not sensitive or specific for diagnosis of Wilson disease. Toxic brain injury primarily involves the basal ganglia, and nearly all patients with neurologic involvement develop eye lesions called Kayser-Fleischer rings, green to brown deposits of copper in disemic membrane in the limbus of the cornea. Clinical features. The age at onset of Wilson disease ranges from 6 to 40 years of age. Average age is 11.4 years. Its clinical presentation is extremely variable. Some patients present with acute or chronic liver disease. Neurologic involvement may lead to movement disorders, tremor, poor coordination, chorea or choreoathetosis or rigid dystonia, spastic dystonia, mask-like faces, rigidity, and gait disturbances. Patients may also have psychiatric symptoms. Hemolytic anemia may occur due to red cell membrane damage caused by oxidants. The liver and bile ducts. 851. Produced by free copper. The biochemical diagnosis of Wilson disease is usually based on the presence of decreased serum ceruloplasmin, increased hepatic copper content, the most sensitive and accurate test, and increased urinary excretion of copper, the most specific test. Sequencing of the AT7B gene is now available for cases in which results of biochemical tests are indeterminate. Such problems may arise in the setting of liver injury, which may cause serum ceruloplasmin levels to rise into the normal range. Demonstration of Kayser-Fleischer rings by slit examination also is diagnostically helpful. Early recognition and long-term copper chelation therapy with deep penicillamine or trientine or zinc-based therapy which blocks uptake of dietary copper in the gut is effective. Individuals with hepatitis or unmanageable cirrhosis require liver transplantation, which can be curative. Alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is an autosomal recessive disorder of protein folding marked by very low levels of circulating alpha-1 antitrypsin alpha-1. The major function of this protein is the inhibition of proteases, particularly neutrophil elastase, cathepsin G, and proteinase 3, which are normally released from neutrophils at sites of inflammation. Alpha-1 deficiency leads to the development of pulmonary emphysema because the activity of neutrophil elastases is not inhibited. Chapter 15. It also causes liver disease as a consequence of hepatocellular accumulation of the misfolded protein, an example of a toxic gain-of-function mutation. Alpha-1 is a small 394 amino acid plasma glycoprotein synthesized predominantly by hepatocytes. It is a member of the serine protease inhibitor serpin family. The gene is very polymorphic, and at least 75 forms of alpha-1 have been identified, denoted alphabetically by their relative migration in an isoelectric gel. The general notation is pi for protease inhibitor and an alphabetic letter for the position in the gel. 2 letters denote the genotype of an individual's 2 alleles. The most common genotype is pi MM, occurring in 90% of individuals, the wild type. The most common clinically significant mutation is pi Z. Homozygous for the pi ZZ protein have circulating alpha-1 at levels that are only 10% of normal. These individuals are at high risk for developing clinical disease. Expression of alleles is autosomal codominant, and, consequently, pi MZ heterozygous have intermediate plasma levels of alpha-1. Among people of Northern European descent, the pi ZZ state affects 1 in 1,800 live births. Because of its early presentation with liver disease, alpha-1 deficiency is the most commonly diagnosed inherited hepatic disorder in infants and children. Pathogenesis disease-associated variants show a selective defect in transport of the protein from the endoplasmic reticulum to the Golgi apparatus. This is particularly characteristic of the pi Z polypeptide, resulting from the substitution of lysine for glutamine at amino acid position 342. The mutant polypeptide alpha-1 at Z misfolds and aggregates, creating endoplasmic reticulum stress and triggering the unfolded protein response, a signaling cascade that may lead to apoptosis. Chapter 2. All individuals with the pi ZZ genotype accumulate alpha-1 at Z in the endoplasmic reticulum of hepatocytes, but only a small subset develops overt liver disease. Other genetic factors or environmental factors are thus posited to play a role in the development of liver disease. B. Morphology. Alpha-1 deficiency is characterized by the presence of round to oval cytoplasmic globular inclusions in hepatocytes, which are strongly periodic acid, SCIF PAS positive and diastase resistant. Fig. 18.25. The inclusions appear first in periportal hepatocytes, in early and mild forms of the disease, and with progression appear in central hepatocytes in more severe disease, such as that associated with the pi ZZ variant. However, the number of globular-containing hepatocytes is not tightly correlated with disease severity, and patients may present with neonatal hepatitis prior to the appearance of the globules, generally 12 weeks of age or older, for pi ZZ-associated disease. A figure 18.25 alpha-1 antitrypsin deficiency, a periodic acid, SCIF stain after diastase digestion of the liver, highlighting the characteristic magenta cytoplasmic granules. The electron micrograph showing endoplasmic reticulum dilated by aggregates of misfolded protein. Chapter 18. Liver and gallbladder. Clinical features. The clinical findings and course are quite variable. Unusual neonatal presentations tend to be associated with severe disease and rapid progression to cirrhosis. Other patients present in adulthood with chronic hepatitis, cirrhosis, or hepatocellular carcinoma, which develops in 2% to 3% of pi ZZ adults, usually but not always in the setting of cirrhosis. Liver transplantation is curative of hepatic disease, but it has no effect on the development and course of pulmonary disease. Chapter 15. Key concepts. Inherited liver disease. Hereditary hemochromatosis is most commonly caused by loss of function mutations in the HFE gene, whose product regulates intestinal iron uptake by increasing hepcidin synthesis by the liver. It is characterized by increased absorption of dietary iron and accumulation of iron in the liver and pancreas. Injury to these organs results in cirrhosis and diabetes. Wilson disease is caused by mutations that abolish the function of the metal ion transporter at 7B, which results in accumulation of copper in the liver, brain, particularly basal ganglia, and eyes. Case of Fleischer rings. Alpha-1 antitrypsin deficiency is a disease of protein misfolding that results in impaired secretion of alpha-1 antitrypsin into the serum and creates endoplasmic reticulum stress, leading to hepatocyte injury through the unfolded protein response pathway. The main consequence of alpha-1 antitrypsin deficiency is pulmonary emphysema because of unchecked elastase activity. Senescent erythrocytes, bilirubin glucuronides, biocanaliculus, heme, hepatocyte, 1 biliverdin, 2 bilirubin, albumin complex, 3-4 mononuclear phagocytic cell, hemoxygenase, biliverdin reductase, blood, liver, bile ducts, duodenum, 5, urobilinogen, cholestatic disease, bile formation and secretion. Bile plays a critical role in elimination of bilirubin, excess cholesterol, xenobiotics, and trace metals such as copper, arsenic, selenium, and zinc, and its detergent action emulsifies dietary fat in the intestinal lumen, enabling its absorption by the gut. The major components of bile are bilirubin, bile salts, cholesterol, and phospholipids, mainly phosphatidylcholine. Bilirubin is a toxic end product of heme degradation that is processed by the liver and excreted in the bile. Fig. 18.26. Hepatic handling of bilirubin involves uptake from the circulation, intracellular stores, conjugation with glucuronic acid, and excretion into bile. The majority of the bilirubin produced daily 0.2 to 0.3 g. 85% is derived from breakdown of senescent red cells by macrophages in the spleen, liver, and bone marrow. The remaining bilirubin is produced by the turnover of hepatic proteins containing heme groups, for example, P450 cytochrome. Heme is converted to bilirubin by the action of several phagocyte enzymes and released into the blood, where it binds albumin, a necessary step for transport, as bilirubin is insoluble at physiologic pH. Uptake by hepatocytes at the sinusoidal membrane is followed by conjugation of bilirubin with one or two molecules of Figure 18.26 bilirubin metabolism and elimination. One normal bilirubin production from heme 0.2 to 0.3 g/day is derived primarily from the breakdown of senescent circulating erythrocytes. 2 extrahepatic bilirubin is bound to serum albumin and delivered to the liver. 3 hepatocellular uptake and 4 glucuronidation in the endoplasmic reticulum generates bilirubin monoglucuronides and diglucuronides, which are water-soluble and readily excreted into bile. 5 gut bacteria deconjugate the bilirubin and degrade it to colorless urobilinogens. The urobilinogens and the residue of intact pigments are excreted in the feces, with some reabsorption and excretion into urine. Glucuronic acid in the endoplasmic reticulum and excretion of the water-soluble, non-toxic bilirubin glucuronides into bile. Most bilirubin glucuronides are deconjugated in the gut lumen by bacterial beta-glucuronidases and degraded to colorless urobilinogens. The urobilinogens and the residue of intact pigment are largely excreted in feces. Approximately 20% of the urobilinogens formed are reabsorbed in the ileum and colon, returned to the liver, and re-excreted into bile. A small amount of reabsorbed urobilinogen is excreted in the urine, 852, liver and bile ducts, 853. Bile salts are formed by the conjugation of bile acids with taurine or glycine. The predominant bile acids in humans are cholic acid and chenodeoxycholic acid, both of which are highly effective detergents. Bile acids combine with cholesterol and phospholipids to form micelles that solubilize cholesterol and reduce the toxic effect of bile acids on biliary epithelium. Most of the secreted bile acids, conjugated or unconjugated, are reabsorbed from the intestine and recirculate to the liver enterohepatic circulation, where they are taken up by hepatocytes, thus helping to maintain the endogenous pool of bile acids. The constituents of bile are ferried across the canalicular membrane of hepatocytes by a variety of transporter proteins. Some of the important ones are Mr. P12 multidrug-resistant protein 2 for conjugated bilirubin, bile salt export pump B-set for bile salts, MDR3 multi-drug resistance 3 for phosphatidylcholine, and sterolins 1 and 2 for cholesterol. Pathophysiology of hyperbilirubinemia. Serum bilirubin levels in the normal adult vary between 0.3 and 1.2 mg/dl, and the rate of bilirubin production is equal to the rate of hepatic uptake, conjugation, and biliary excretion. Jaundice becomes evident when the serum bilirubin levels rise above 2 to 2.5 mg/dl. Depending on the underlying etiology summarized in Table 18.8, the elevation can predominantly involve unconjugated indirect or conjugated direct bilirubin. Testing for conjugated and unconjugated plasma bilirubin helps determine the cause of hyperbilirubinemia. Excess bilirubin production, for example, due to hemolytic anemia or ineffective erythropoiesis or defective conjugation due to immaturity or hereditary causes, leads to the accumulation of unconjugated bilirubin. This form is largely insoluble and cannot be excreted in the urine. Although most unconjugated bilirubin is tightly bound to albumin in the blood, at excessive levels the unbound fraction rises and may diffuse into tissues, particularly the brain in infants, and produce neurologic damage kernicterus. Conjugated hyperbilirubinemia most often results from hepatocellular disease, bile duct injury, and biliary obstruction. Since this form is water-soluble and loosely bound to serum albumin, it can be excreted in the urine. With this as an overview, we next discuss hepatobiliary disorders that lead to hyperbilirubinemia. Many of these are characterized by cholestasis, which refers to the retention of bilirubin and other solutes eliminated in bile due to impaired bile formation or obstruction of flow. Before delving into specific entities, we will briefly review the morphologic and clinical features of cholestasis that are common to all. LBT, the 8.81 Sessler C4 J, predominantly unconjugated hyperbilirubinemia, excess production of bilirubin. Hemolytic anemias, resorption of blood from internal hemorrhage, for example, alimentary tract bleeding, hematoma, infective erythropoiesis, for example, pernicious anemia, thalassemia. Reduced hepatic uptake, drug interference with membrane carrier systems, some cases of Gilbert's syndrome, impaired bilirubin conjugation, physiologic jaundice of the newborn, decreased UG-tone AION activity, decreased excretion, breast milk jaundice, beta-glucuronidases in milk, genetic deficiency of UG-tone AION activity, Crigler-Najjar syndrome, type Psi and Roman 2, some cases of Gilbert's syndrome, predominantly conjugated hyperbilirubinemia, deficiency of canalicular membrane transporters, Dubin-Johnson syndrome, Reuter's syndrome, hepatocellular disease, for example, viral or drug-induced hepatitis, cirrhosis, impaired bile flow from duct obstruction or autoimmune, Chalanger-opathies. Eugetone-AN, uridine diphosphate glucuronyltransferase family, peptide AN. Clinical features: elevated bilirubin becomes clinically evident as yellow discoloration of the skin, jaundice, and sclera icterus. Other manifestations include pruritus, skin xanthomas, focal accumulation of cholesterol, with symptoms related to intestinal malabsorption, including deficiencies of fat-soluble vitamins A, D, and K. Elevated serum alkaline phosphatase and gamma-glutamyl transpeptidase GGT, enzymes present on the apical canalicular membranes of hepatocytes and bile duct epithelial cells, are characteristic laboratory findings of cholestatic disease. Physiologic jaundice of the newborn. In physiologic jaundice of the newborn, levels of eugetone-AN uridine diphosphate glucuronyltransferase family, peptide AN, the enzyme that is responsible for bilirubin glucuronidation, are low at birth and do not reach adult levels until 3 to 4 months of age. Hence, transient and mild unconjugated hypobilirubinemia is nearly universal in the first week. Breastfeeding may exacerbate unconjugated hypobilirubinemia, possibly because of the presence of bilirubin conjugating enzymes in breast milk. In most infants, phototherapy with blue light, which converts bilirubin to a soluble isomer that is readily excreted in the urine, is sufficient to keep the levels of unconjugated bilirubin within a safe range until the hepatic machinery for conjugation matures sufficiently. Morphology: hereditary hypobilirubinemia. The hallmark of cholestasis is accumulation of green-brown plugs of bile pigment in hepatocytes and dilated canaliculi. Fig. 18.27. Rupture of canaliculi can lead to extravasation of bile, which is phagocytosed by Kupffer cells. Accumulation of bile salts in hepatocytes results in a swollen, foamy appearance of the cytoplasm, feathery degeneration. Genetic mutations can result in impaired uptake, conjugation, or secretion of bilirubin. Crigler-Najjar syndrome type 1 is caused by severe eugetone-AN deficiency and is fatal around birth. In Crigler-Najjar type 2 and Gilbert syndrome, there is some eugetone-AN activity, leading to a milder phenotype. In contrast, Dubin-Johnson syndrome and Roller syndrome lead. Chapter 18: Liver and gallbladder. Anormal. Bile hepatocytes, canaliculi, parenchyma, cholestasis. 2-1. Kupffer cells. 4-3. Apoptosis. Large bile duct obstruction. Obstruction of the large bile ducts has diverse causes. In adults, the common causes are stones, cholecystectosis, malignant neoplasms of the biliary tree or head of pancreas, usually adenocarcinoma, and strictures resulting from previous surgical procedures or ischemic injury. Primary sclerosing cholangitis described later may lead to an obstructive picture due to inflammatory injury to the large intrahepatic or extrahepatic bile ducts. In the pediatric setting, the common culprits are biliary atresia, cystic fibrosis, and cold arterial cysts. The resulting cholestatic changes are reversible if the obstruction is corrected early in the disease course, but persistent obstruction can lead to fibrosis and so-called biliary cirrhosis. Biliary obstruction also predisposes to ascending cholangitis, a bacterial infection of the biliary tree most commonly caused by enteric organisms such as coliforms and enterococci. Cholangitis usually presents with fever, chills, abdominal pain, and jaundice. Severe cases can result in abscess formation, sepsis, and death. Morphology. The obstruction of extrahepatic or large intrahepatic bile ducts leads to proximal duct dilation. The hallmark on liver biopsies is portal expansion due to edema, prominent ductular reaction at the portal parenchymal interface, and infiltrating neutrophils associated with ductular pericholangitis. Fig. 18.28. In ascending cholangitis, the neutrophils also involve the bile duct epithelium and lumens. Fig. 18.29. Persistent obstruction leads to fibrosis, which can eventually proceed to biliary cirrhosis. Fig. 18.30. Swelling of periportal hepatocytes, feathery degeneration, bile pigment, and Mallory hyaline is seen in periportal hepatocytes in advanced disease. Superimposed ascending cholangitis in advanced disease can precipitate acute on chronic liver failure. 854. See Figure 18.27. Cholestasis. The morphologic features of cholestasis right in comparison with normal liver left. Cholestatic hepatocytes 1 are enlarged with dilated canalicular spaces. 2. Apoptotic cells 3 may be seen, and Kupffer cells 4 frequently contain regurgitated bile pigments. The intracellular cholestasis showing the bile pigments in the cytoplasm. See bile plug arrows showing the expansion of bile canaliculus by bile. To conjugated hypobilirubinemia. Both are autosomal recessive disorders and clinically innocuous. Dubin-Johnson syndrome is caused by mutation in the Mr. P4G multidrug resistant protein 2, which is required for transport of non-bile salt organic anions at the canalicular membranes. Deposition of brown-black melanin-like pigment in the hepatocytes is a striking feature in this disease and can lead to blackening of the liver. Figure 18.28. Acute large duct obstruction. There is marked edema of the portal tract stromal white spaces and a ductular reaction with mixed neutrophils at the interface between portal tract and hepatocellular parenchyma. Liver and bile ducts. 855. Figure 18.29. Ascending cholangitis. Individuals with large bile duct obstruction are at risk for bacterial infections within the biliary tree. Neutrophils are seen within the bile duct epithelial lining and within the lumen. Figure 18.31. Ductular cholestasis of sepsis. Large, dark bile concretions within markedly dilated canals of Herring and ductules at the portal parenchymal interface. Courtesy Dr. J. Lefkowitz, Columbia University College of Physicians and Surgeons, NY. Cholestasis of sepsis. Sepsis may affect the liver by several mechanisms, 1 through direct effects of intrahepatic bacterial infection, for example, abscess formation or bacterial cholangitis. 2. Ischemia relating to hypotension caused by sepsis, particularly when the liver is cirrhotic. Or 3. In response to circulating microbial products. The latter effect is most likely to lead to the cholestasis of sepsis, particularly when the systemic infection is caused by gram-negative organisms. Characteristic morphologic findings in the setting of severe sepsis include canalicular cholestasis and bile plugs within dilated canals of Herring and bioductules at the portal parenchymal interface, ductular or cholangiolar cholestasis. Fig. 18.31. Inflammation and hepatocellular injury is typically mild. A primary hepatolithiasis, at one time called recurrent pyogenic cholangitis. Hepatolithiasis refers to stones in the intrahepatic bile ducts that can lead to repeated bouts of ascending cholangitis and progressive inflammatory destruction of hepatic parenchyma. The disease is highly prevalent in East Asia, but is rare in other parts of the world. Its cause is uncertain. Congenital duct abnormalities, diet, and chronic infection with bacteria or parasites have all been suggested as possible etiologies. Chronic inflammatory injury associated with hepatolithiasis is a risk factor for cholangiocarcinoma, particularly in Taiwan and to a lesser extent in Japan. Morphology. Figure 18.30. Biliary cirrhosis. A sagittal section through the liver demonstrates the nodularity most prominent at the right and bile staining of end-stage biliary cirrhosis. Unlike other forms of cirrhosis, nodules of liver cells in biliary cirrhosis are often not round but irregular, like jigsaw puzzle shapes. Pigmented calcium bilirubinate stones are present in distended intrahepatic bile ducts. Fig. 18.32. The ducts show chronic inflammation, neurofibrosis, and parabiliary gland hyperplasia. Obstruction of extrahepatic ducts is not present. Repeated bouts of inflammation, parenchymal collapse, and fibrosis can lead to a mass-like lesion, which can mimic a tumor on imaging. 856. Chapter 18. Liver and gallbladder. Figure 18.32. Hepatolithiasis. A resected, atrophic right hepatic lobe with characteristic findings including markedly dilated and distorted bile ducts containing large pigment stones and broad areas of collapsed liver parenchyma. Courtesy Dr. Wilson M.S. Tsui, Caritas Medical Center, Hong Kong. Neonatal cholestasis. Physiologic jaundice of the newborn discussed earlier resolves by 2 weeks, and infants who have jaundice beyond 14 to 21 days after birth must be evaluated for neonatal cholestasis. The major causes can be grouped under the 2 broad categories: 1. Obstructive biliary disease such as biliary atresia, and 2. Non-obstructive etiologies that include paucity of bile ducts, infectious/metabolic diseases, bile transporter defects, and idiopathic neonatal hepatitis. Extrahepatic biliary atresia. Extrahepatic biliary atresia is characterized by complete or partial obstruction of the extrahepatic biliary tree within the first 3 months of life. It accounts for 1/3 of neonatal cholestasis cases and for 50% to 60% of children referred for liver transplantation. In its most common perinatal form, 80% of cases, the biliary tree is normally formed and the disease onset is after birth. Infections, toxic agents, and autoimmune injury have been invoked, but the causes are known. The less common fetal form likely results from aberrant development of the extrahepatic biliary tree. Infants with extrahepatic biliary atresia present with jaundice, dark urine, light or cholic stools, and hepatomegaly. Morphology. Inflammation and fibrosis of the hepatic or common bile ducts is the hallmark of the disease and can extend to involve the intrahepatic ducts. Typical features of biliary obstruction are seen on liver biopsy, including portal edema, ductular reaction, and neutrophil infiltrates. If left uncorrected, cirrhosis can develop by 3 to 6 months of age. Clinical features: since extrahepatic biliary atresia requires surgical intervention, poor tonderostomy or Kasai procedure, its differentiation from non-obstructive neonatal cholestasis is critical. Other etiologies of obstructive biliary diseases like cystic fibrosis also must be excluded. The combination of clinical presentation, imaging, ultrasound, and hepatospecific aminoacidic acid HETA scans, and biopsy can confirm the diagnosis in a vast majority of cases. Ultrasound findings of a small or absent gallbladder and fibrosis at the porta hepatis support the diagnosis of extrahepatic biliary atresia, as do HETA scans with technetium 99 meters 99 mTc, which is excreted in bile. In extrahepatic biliary atresia, there is total lack of secretion of 99 mTc into the bile, and the biliary tree is not visualized. Involvement of ducts proximal to the porta hepatis, intrahepatic progression of disease, and ascending cholangitis are impediments to successful surgical therapy. Liver transplantation is the only option when surgical intervention is not feasible. Non-obstructive neonatal cholestasis. A diverse group of disorders are associated with non-obstructive neonatal cholestasis. These can be divided into those in which cholestasis appears as part of a syndrome or as an isolated liver abnormality. Alago syndrome is an autosomal dominant disorder that is associated with cholestasis and paucity of bile ducts as well as other abnormalities such as dysmorphic facies, butterfly-shaped vertebra, light defects, and cardiac defects. It is caused by loss of function mutations in the Notch pathway involving either the genes encoding the ligand JAGON or the receptor NOTCH, both of which are required for normal development of the biliary tree. Certain inborn errors of metabolism, particularly galactosemia chapter 10 and Niemann-Pick disease chapter 5, can present with non-obstructive cholestasis. Non-syndromic causes of non-obstructive cholestasis include alpha-1 antitrypsin deficiency discussed earlier in diverse disorders of bile acid synthesis and bile transport. With recent advances, the underlying etiology can be determined in 85% to 90% of cases summarized in Table 18.9, Table of Major. 189 causes of neonatal cholestasis. Obstructive biliary disease, extrahepatic biliary atresia, neonatal infection, cytomegalovirus, bacterial sepsis, urinary tract infection, syphilis, genetic disorders, metabolic diseases, tyrosinemia, galactosemia, lipid storage diseases, Niemann-Pick disease, biosynthesis defects, bile transport abnormalities, progressive, intrahepatic cholestasis, bile acid synthesis defects, cystic fibrosis, alpha-1 antitrypsin deficiency, Alago syndrome, syndromic paucity of bile ducts, miscellaneous, shock/hypoperfusion, drugs, total parenteral nutrition, hypopituitarism, idiopathic neonatal hepatitis, the liver and bile ducts. 857. Morphology. Decreased numbers of bile ducts within portal regions profiles is the most characteristic and constant feature. The biliary insufficiency often is associated with hepatitis, characterized by inflammation and hepatocellular apoptosis/necrosis. The most striking features are hepatocanalicular cholestasis and giant cell or syncytial cell change with multinucleated hepatocytes. Fig. 18.33. Reactive Kupffer cells and extramedullary hematopoiesis are usually present. Autoimmune cholangiopathys. This section discusses the two main autoimmune disorders of bile ducts, primary biliary cholangitis and primary sclerosing cholangitis. The features of these two conditions are contrasted in Table 18.10. Primary biliary cholangitis (PBC). PBC is an autoimmune disease characterized by inflammatory destruction of small and medium-sized intrahepatic bile ducts. Large intrahepatic ducts and the extrahepatic biliary tree are not involved. Most patients are diagnosed in the early stages of disease, and hence the former name primary biliary cirrhosis is no longer used. PBC has a striking female predilection of 9.1, with a peak incidence between 40 and 50 years of age. The disease is most common in the United States and Northern Europe, and the incidence is low in Africa and the Indian subcontinent. Family members of PBC patients have an increased risk for development of the disease. Pathogenesis. PBC is thought to be an autoimmune disorder resulting from a T lymphocyte-mediated attack on small interlobular bile ducts. The trigger for the attack is not known, but may involve exposure to environmental factors like infections and toxic chemicals in genetically susceptible individuals. This may lead to expression of autoantigens on bile duct. Features of Persozero on sate, Ionamary, Nea, Splogia and primary scleron T, primary biliary, parameter cholangitis. Age median age 50 years, gender 90% female, associated Sjogren's syndrome, conditions 70%, thyroid disease, scleroderma, serology 95% AMA positive, 40%, 50% ANA positive, 65% ANCA positive, ANA variable, AMA typically negative, 6% ANA positive. Radiology normal strictures and beating of large bile ducts, pruning of smaller ducts, duct lesion, florid duct lesions, inflammatory destruction, loss of small ducts of extrahepatic and large intrahepatic ducts, fibrotic obliteration of medium and small intrahepatic ducts, ductular reaction in smaller portal tracts, endomitochondrial antibody, antinuclear antibody, antineutrophil cytoplasmic antibody, epithelial cells and the resulting destruction by T lymphocytes. A retention of bile salts due to bile duct injury leads to secondary hepatocellular injury in PBC, which can eventually produce a cirrhotic picture. Antimitochondrial antibodies directed against the EPO component of the pyruvate dehydrogenase complex PDC-EPO are the most characteristic finding in PBC. PDC-EPO specific T cells are present in PBC, further supporting the notion of an immune-mediated process. The role of antimitochondrial antibodies in the pathogenesis of PBC is unclear, as 5% of patients with otherwise typical PBC are antimitochondrial antibody AMA negative. Moreover, antibody titers do not correlate with disease severity or disease progression, and they are not predictive of response to therapy discussed later. Other autoantibodies against nuclear pore proteins and centromeric proteins may also be present. Main, biliary cholangitis, primary sclerosing cholangitis. Median age 30 years, 70% male. Inflammatory bowel disease 70%. Morphology. The hallmark of PBC is lymphocytic infiltration and epithelial injury involving the small interlobular bile ducts. Poorly formed epithelioid granulomas are often present in the portal tracts and can be centered on bile ducts. The histologic picture of lymphocytic and /or granulomatous bile duct destruction florid duct lesion is highly characteristic of PBC. Fig. 18.34. Portal lymphoplasmacytic inflammation and ductular reaction are often present. The bile duct involvement has a patchy distribution, with involvement of a minority of portal tracts being a common feature in early disease. Disease progression leads to loss of small intrahepatic bile ducts, ductopenia. Unlike obstructive, drug-induced, or sepsis-associated cholestasis, the bile. Figure 18.33 Neonatal hepatitis. Note the multinucleated giant hepatocytes. Chapter 18 Liver and gallbladder. Figure 18.34 Primary biliary cholangitis. A portal tract is markedly expanded by an infiltrate of lymphocytes and plasma cells surrounding a destructive granulomatous reaction centered on a bile duct florid duct lesion. Accumulation in PBC is not centrozinal, what is seen in periportal/paraseptal regions. Stasis of bile salts leads to swelling of periportal hepatocytes, which have clear cytoplasm with granular strands, feathery degeneration, and may develop Mallory hyaline. These periportal changes are referred to as chalate stasis and can be seen in any chronic biliary disease. End-stage disease culminates in cirrhosis. Like other biliary diseases, cirrhotic nodules in PBC tend to be elongated garland shape in contrast to the round nodules in hepatitic diseases. Some patients develop portal hypertension due to regenerative nodules without fibrosis, a feature called nodular regenerative hyperplasia. The basis of this phenomenon in PBC is not known. 858. Clinical features: symptomatic PBC usually presents with fatigue and pruritus, which increase slowly over time. Hypercholesterolemia is common. Splenomegaly and jaundice are seen in advanced disease. Other features that may be seen include skin hyperpigmentation, xanthelasmus, steatorrhea, and vitamin D malabsorption, related osteomalacia or osteoporosis. Other autoimmune diseases, such as Sjogren's syndrome, systemic sclerosis, thyroiditis, rheumatoid arthritis, Raynaud phenomenon, and celiac disease, may also be present in affected patients. An increasing number of cases are being detected in asymptomatic patients with elevated serum alkaline phosphatase levels. Antimitochondrial antibodies are present in 90% to 95% of patients at all stages of the disease process and are highly characteristic. For uncertain reasons, many patients also have elevated serum levels of IgM antibody. Antimitochondrial antibodies can be detected by indirect immunofluorescence or enzyme-linked immunosorbent ELISA. The latter has higher sensitivity and specificity as it selectively detects antibodies directed against the EP or subunit of the pyruvate dehydrogenase complex. The diagnosis can be established if two of the following are present: elevated alkaline phosphatase for more than 6 months, positive test for antimitochondrial antibodies, and characteristic histologic findings. The AMA negative form of the disease has only 2 of these findings and is sometimes termed autoimmune cholangiopathie or autoimmune cholangitis. Its clinical presentation, pathology, and natural history are otherwise similar. PBC is a slowly progressive disease, and progression to end-stage liver disease occurs in 20% to 25% of patients over 15 to 20 years. Treatment with oral ursodeoxycholic acid, a naturally occurring bile acid, slows disease progression in most patients, but the response is inadequate in up to 40% of those affected. Other medical therapies, such as with obeticholic acid or synthetic bile acid, are being evaluated in such patients. In those in whom medical treatment fails, liver transplantation yields excellent results, with survival of more than 70% at 7 years. Like many chronic forms of hepatic injury, PBC is associated with an increased risk of hepatocellular carcinoma. Primary sclerosing cholangitis (PSC) is characterized by inflammation and obliterative fibrosis of extrahepatic and large intrahepatic ducts and dilation of preserved segments. PSC tends to occur in the 3rd through 5th decades and has a 2:1 male predominance. Pathogenesis: the presence of circulating autoantibodies and T lymphocytes in the periductal stroma, and associations with HLA-beta and other MHC antigens and ulcerative colitis, all support the idea that PSC is an immunologically mediated process. A combination of environmental and genetic factors is thought to trigger the inflammatory injury of bile ducts. First-degree relatives of patients with PSC have an increased risk of developing the disease, suggesting a genetic component. It has been proposed that T cells, activated in the damaged mucosa of patients with ulcerative colitis, migrate to the liver, where they recognize a cross-reacting bile duct antigen. Infections or changes in the intestinal microbiome have also been postulated to lead to alterations in cholangiocytes that incite inflammatory injury. Unlike PBC, the autoantibody profile in PSC is not characteristic, but atypical perinuclear antineutrophil cytoplasmic antibodies P-ANCA targeting a nuclear envelope protein are found in approximately 65% of patients. Morphology: the large intrahepatic bile ducts and extrahepatic ducts show epithelial injury and neutrophilic infiltrates superimposed on chronic inflammation. Edema and inflammation cause narrowing of the lumen, leading to fibrosis and strictures. Lithosis can develop in the dilated ducts. The inflammatory injury can result in circumferential onion skin fibrosis, periductal fibrosis/sclerosis around an increasingly atrophic duct lumen fig. 1835, eventually leading to obliteration by a tombstone scar. Smaller intrahepatic bile ducts, which are more commonly sampled on biopsy, are not directly involved by inflammation, but may exhibit mild injury and prominent ductular reaction due to cholestasis. Progression of cholestasis and fibrosis culminates in biliary cirrhosis. Biliary intraepithelial neoplasia can develop and eventually lead to cholangiocarcinoma, a dreaded complication of PSC. The liver and bile ducts 859, 1 cm, a B, figure 18.35, primary sclerosing cholangitis. A degenerating bile duct is entrapped in a dense, onion skin concentric scar. Clinical features: the most common presenting symptoms are fatigue, pruritus, and jaundice. Nearly 1/2 of the patients are asymptomatic at presentation and come to attention because of persistent elevation of serum alkaline phosphatase, particularly in ulcerative colitis patients who are routinely screened. Ascending cholangitis can also be the initial presentation. Chronic pancreatitis and chronic cholecystitis, from involvement of pancreatic ducts and gallbladder, are also seen. Fibrosis and eventually cirrhosis can occur. The gold standard for diagnosis of PSC is the characteristic beating seen in the large intrahepatic and extrahepatic biliary tree by endoscopic/magnetic retrograde cholangiopin-creatocography ERB/MRCP, involving attributable to irregular biliary strictures and dilations. Fig. 18.36. Inflammatory bowel disease, particularly ulcerative colitis, affects approximately 70% of individuals with PSC, whereas 8% of inflammatory bowel disease patients develop PSC. In a small subset of cases, mostly in association with inflammatory bowel disease, there is involvement of smaller bile ducts only and the ERB/MRCP examination is normal. This is referred to as small duct PSC and can progress to typical large duct PSC. Classic PSC needs to be distinguished from cholangitis that occurs in e.g. sclerosing disease chapter 6, which is steroid responsive and often associated with pancreatitis. In 5% to 10% of cases, autoimmune hepatitis is present along with PSC. The disease typically follows a protracted course leading to cirrhosis over 10 to 15 years. The lifetime risk of developing cholangiocarcinoma is 20%. There is no established medical therapy for PSC. Clinical trials of ursodeoxycholic acid are ongoing. Cholestyramine, a bile acid, binding resin, is used to alleviate pruritus, and endoscopic dilation or stenting is used to relieve biliary obstruction. Liver transplantation is the treatment of choice for end-stage liver disease. Key concepts: cholestatic diseases. Cholestasis occurs with impaired bile flow, leading to accumulation of bile pigment in the hepatic parenchyma. Hepatic etiologies. Figure 18.36 imaging studies of a patient with primary sclerosing cholangitis. A magnetic resonance cholangiography shows focal dilation in some bile ducts, bright, broad areas, and strictures in others thinning or absence. The endoscopic retrograde cholangiography of the same patient shows nearly identical features as in A. The endoscope is visible, giving a sense of scale. Courtesy Dr. M. Edwin Harrison, M.D., Mayo Clinic, Scottsdale. Errors include metabolic defects in bile formation or secretion and inflammatory injury to bile ducts, while posthepatic etiologies include mechanical obstruction or inflammatory destruction of the extrahepatic bile ducts. Large bile duct obstruction is most commonly associated with gallstones and carcinomas involving the head of the pancreas. Ascending cholangitis may develop. Chronic obstruction can lead to cirrhosis. Cholestasis and sepsis may result from direct effects of intrahepatic bacterial infection, circulating microbial products, or ischemia. Relating to hypotension. Primary hepatolithiasis is a disorder of intrahepatic gallstone formation that is most common in East Asia and leads to repeated bouts of ascending cholangitis and inflammatory parenchymal destruction. It predisposes to cholangiocarcinoma. PBC is an autoimmune disease with inflammatory and often granulomatous destruction of small to medium-sized intrahepatic bile ducts. It occurs most often in middle-aged women and is typically associated with antimitochondrial antibodies and with other autoimmune diseases, for example, Sjogren's syndrome and Hashimoto thyroiditis. PSC is an autoimmune disease that is more common in males and is strongly associated with inflammatory bowel disease, particularly ulcerative colitis. The diagnosis is established by visualization of the biliary tree. Histologically, the typical features are inflammation, fibrosis, and strictures involving large intrahepatic and extrahepatic bile ducts. Patients are at risk for developing cholangiocarcinoma. Structural anomalies of the biliary tree. Cold-arterial cysts are congenital dilations of the common bile duct. They present most often in children before age 10 as jaundice and / or recurrent abdominal pain. Symptoms. Chapter 18 liver and gallbladder that are typical of biliary colic. Approximately 20% of cases become symptomatic only in adulthood. In some cases, cold-arterial cysts occur in conjunction with cystic dilation of the intrahepatic biliary tree. Caroli disease, described later. The female to male ratio is 3:1 to 4:1. These uncommon cysts may take the form of segmental or cylindric dilation of the common bile duct, diverticula of the extrahepatic ducts, or colichosos, which are cystic lesions that protrude into the duodenal lumen. Cold-arterial cysts predispose to stone formation, stenosis and stricture, pancreatitis, and obstructive biliary complications within the liver. There also is an increased risk of developing bile duct carcinoma due to ascending cholangitis. Multifocal cystic dilation of the large intrahepatic bile ducts is referred to as Caroli disease. When the cystic dilation of the biliary tree occurs along with congenital hepatic fibrosis, the term Caroli syndrome is applied. Fig. 18.38. Ducts may be cystically dilated, but true cysts are also present. These may be intrahepatic cysts or cold-arterial cysts, as described earlier. Congenital hepatic fibrosis is characterized by portal tracts enlarged by broad bands of collagenous tissue-forming septa that divide the liver into irregular islands. Fig. 18.39. Variable numbers of abnormally shaped bile ducts are embedded in the fibrous tissue, although they remain in continuity with the biliary tree. As with cirrhosis, individuals with congenital hepatic fibrosis are at risk for developing portal hypertension and its complications, particularly bleeding varices. 860. Fibropolycystic disease. Fibropolycystic disease of the liver is a heterogeneous group of lesions in which the primary abnormality is congenital malformation of the biliary tree. Lesions may be found incidentally during radiographic studies, surgery, or autopsy. The most severe forms may manifest as hepatosplenomegaly or portal hypertension in the absence of hepatic dysfunction, starting in late childhood or adolescence. These lesions are part of the spectrum of developmental ductal plate malformations, which result from persistence of the fetal paraportal ductal plates. The caliber of involved portal tracts determines the size, morphology, and distributions of the lesions. Fibropolycystic liver disease often occurs in association with autosomal recessive polycystic renal disease, Chapter 20. Persons with fibropolycystic liver disease are at increased risk for cholangiocarcinoma. 3 sets of pathologic findings may be seen with polyfibrocystic disease, sometimes overlapping with each other. Von Meyenberg complexes are small bile duct hematomas, Fig. 18:37. Occasional von Meyenberg complexes are common in otherwise normal individuals. When they are diffuse, they signal the presence of underlying, clinically important fibropolycystic disease. Single or multiple intrahepatic or extrahepatic biliary cysts. When present in isolation, these may be symptomatic. Figure 18.38 congenital hepatic fibrosis with multiple biliary cysts. Figure 18.37 von Meyenberg complex bile duct hematoma. Dilated irregular bile ducts with curvilinear outlines thought to represent ductal plate formation. Figure 18.39 congenital hepatic fibrosis. Broad bands of fibrosis with dilated remnants of ductal plates. The intervening parenchyma is relatively normal mass and trichome stain. The liver and bile ducts. 861. Circulatory disorders. Given the large volume of blood that flows through the liver, it is not surprising that circulatory disturbances have considerable impact on the organ. In most instances, however, clinically significant liver function abnormalities do not develop, but hepatic morphology may be strikingly affected. These disorders can be grouped according to whether blood flow into, through, or from the liver is impaired. Fig. 18.40. Impaired blood flow into the liver. Hepatic artery compromised. The liver's dual blood supply mitigates against infarction. However, obstruction of an intrahepatic branch of the hepatic artery by emboli, thrombi, or compression may result in a localized infarct that is either pale and anemic or hemorrhagic if there is suffusion with portal blood. Fig. 18.41. Underlying causes may include neoplasia, polyarteritis nodosa, Chapter 11, or sepsis. Interruption of blood flow through the main hepatic artery does not always produce ischemic necrosis of the organ, particularly if the liver is otherwise normal, as retrograde arterial flow through accessory vessels, when coupled with the portal venous supply, is usually sufficient to sustain the liver parenchyma. Several conditions increase the vulnerability of the liver to infarction in the setting of hepatic artery obstruction. Hepatic artery thrombosis in a transplanted liver generally leads to infarction of the major ducts of the biliary tree, since their blood supply is entirely arterial, and may also lead to hepatic injury and regenerative changes. Large infarcts may occur with combined portal vein and hepatic artery thrombosis, which eventually result in subcapsular scarring. Forms manifestations. Impaired blood inflow. Portal vein obstruction, intrahepatic or extrahepatic. Thrombosis. Esophageal varices, splenomegaly, intestinal congestion. Ascites cirrhosis, esophageal varices, cirrhosis, hepatomegaly, elevated amintransferases. Impaired intrahepatic blood flow. Cirrhosis, sinusoid occlusion. Hepatic vein outflow obstruction. Hepatic vein thrombosis. Budd-Chiari syndrome. Sinusoidal obstruction. Syndrome. Ascites, hepatomegaly, abdominal pain, elevated amintransferases, jaundice. Figure 18.40 forms and clinical manifestations of hepatic circulatory disorders. Figure 18.41 liver infarct. A thrombus is lodged in a peripheral branch of the hepatic artery arrow and compresses the adjacent portal vein. The distal necrotic infarcted tissue has pale margins and multifocal areas of hemorrhage. Portal vein obstruction and thrombosis, blockage of the portal vein and its tributaries may be insidious and well tolerated, or may be a catastrophic, potentially lethal event. Most cases fall somewhere in between. Occlusive disease of the portal vein or its major branches typically produces abdominal pain and, in most instances, manifestations of portal hypertension, principally esophageal varices that are prone to rupture. The obstruction may occur at the level of the extrahepatic portal vein, intrahepatic portal vein radicals, or small portal vein branches. Extrahepatic portal vein obstruction may be idiopathic, approximately 1/3 of cases, or may arise from the following conditions. Neonatal umbilical sepsis or umbilical vein catheterization, often producing subclinical occlusion of the portal vein that presents as variceal bleeding and ascites years later. Intra-abdominal infection caused by acute diverticulitis or appendicitis, leading to pylophlebitis in the splanchnic circulation. Inherited or acquired hypercoagulable states, including myeloproliferative neoplasms, such as polycythemia vera, Chapter 13, in which platelet abnormalities predispose to portal vein thrombosis. Trauma, surgical or otherwise. Pancreatitis and pancreatic cancer. Associated splenic vein thrombosis, which propagates into the portal vein. Invasion of the portal vein by hepatocellular carcinoma. Cirrhosis, which is associated with portal vein thrombosis in about 25% of patients. Many such patients have an underlying thrombophilic genotype, for example, factor V latent, Chapter 4. Intrahepatic portal vein radicals are most likely to be obstructed by acute thrombosis, often in the setting of a malignancy or some other hypercoagulable state. By contrast, small portal vein branch obstruction may be seen in a variety of pathogenically distinct conditions characterized by non-cirrhotic portal hypertension, as follows. 862 Chapter 18 Liver and gallbladder. The most common cause of small portal vein branch obstruction is schistosomiasis. The eggs of the parasites and the associated granulomatous inflammatory response obstruct the smallest portal vein branches. Other diseases associated with obstruction of small portal vein branches are collectively referred to as idiopathic non-cirrhotic portal hypertension. The pathogenesis is unknown. Associations with prothrombotic states, infections for example, HIV, drugs, toxins, immune deficiencies, chronic biliary obstruction, and autoimmune diseases have been noted. Geographic variation in the incidence of non-cirrhotic portal fibrosis and hypertension has been reported. It is particularly common in India, although the incidence appears to be declining. Patients often present with upper gastrointestinal bleeding. In East Asia, particularly Japan, there is a female predominance in patients present with splenomegaly, often in association with rheumatologic diseases. The disease is seen in untreated HIV disease and in those being treated with antiretroviral therapy, in whom it may represent a complication of treatment. Liver transplantation may be necessary to avoid fatal sequelae of portal hypertension in all these settings. Impaired blood flow through the liver. The most common intrahepatic cause of blood flow impairment is cirrhosis, as described earlier. In addition, physical occlusion of sinusoidal blood flow occurs in a small group of diseases, including the following. Sickle cell disease Fig. 1842, due to obstruction by sickled red cells. Disseminated intravascular coagulation, due to myriad small thrombi. Eclampsia discussed later. Diffuse intrasinusoidal metastatic tumor, due to physical obstruction by plugs of tumor, sometimes with superimposed thrombosis. In all of these scenarios, obstruction of blood flow may lead to massive necrosis of hepatocytes and acute liver failure. Peliosis hepatis is a peculiar form of sinusoidal dilation that occurs in any condition in which efflux of hepatic blood is impeded. The liver contains blood-filled cystic spaces, either unlined or lined with sinusoidal endothelial cells. The pathogenesis is unknown. Bartonella species have been seen in the sinusoidal endothelial cells in AIDS-associated peliosis, but peliosis is also seen in cancer and with other infections, such as tuberculosis. Sex hormone administration, for example, anabolic steroids, oral contraceptives, danazol sometimes causes peliosis as well. While clinical signs are generally absent, potentially fatal intra-abdominal hemorrhage or hepatic failure may occur. Lesions usually disappear after correction of the underlying cause. Hepatic venous outflow obstruction. Hepatic vein thrombosis. The obstruction of major hepatic veins produces liver enlargement, pain, and ascites, a condition known as Budd-Chiari syndrome. Obstruction of a single main hepatic vein by thrombosis is clinically silent. Hepatic damage is the consequence of increased intrahepatic blood pressure. Hepatic vein thrombosis is associated with myeloproliferative neoplasms such as polycythemia vera chapter 13, inherited disorders of coagulation chapter 4, antiphospholipid antibody syndrome, paroxysmal nocturnal hemoglobinuria chapter 14, and intra-abdominal cancers, particularly hepatocellular carcinoma. In pregnancy or with oral contraceptive use, it occurs through interaction with an underlying thrombophilic disorder. Morphology. In Budd-Chiari syndrome, the liver is swollen and red-purple and has a tense capsule Fig. 18.43. There may be areas of hemorrhagic collapse alternating with preserved or regenerating parenchyma, with the patterns being dependent on which small and large hepatic veins are obstructed. Microscopically, the affected hepatic parenchyma reveals severe centralobular congestion and necrosis. Paracentral/sinusoidal fibrosis develops in instances in which thrombosis develops more slowly. The major veins contain thrombi showing various degrees of organization. Clinical features. The mortality of untreated acute hepatic vein thrombosis is high. Prompt surgery to create a portosystemic venous. Figure 18.42 Sickle cell crisis in liver. The photomicrograph shows several sinusoids containing sickled red cells. Arrow. Figure 18.43 Budd-Chiari syndrome. Thrombosis of the major hepatic veins has caused hemorrhagic liver necrosis. Liver and bile ducts 863. Shunt permits reverse flow through the portal vein and improves the prognosis. The chronic form is far less lethal, and more than 2/3 of patients are alive after 5 years. Sinusoidal obstruction syndrome, originally described in Jamaican drinkers of pyrrolizidine alkaloid, containing bush tea and named veno-occlusive disease. Sinusoidal obstruction syndrome now occurs primarily in 2 settings. 1 following allogeneic or less commonly, autologous hematopoietic stem cell transplantation, usually within the first 3 weeks, though changes in conditioning regimens have lowered the incidence. And 2 in cancer patients receiving certain forms of chemotherapy. The mortality rate is up to 80% in severe disease. Pathogenesis. Sinusoidal obstruction syndrome arises from toxic injury to the sinusoidal endothelium. Injured, sloughed endothelium obstructs sinusoidal blood flow, and associated debris accumulates in the terminal hepatic vein. Red cells enter the space of Dissay in the disrupted sinusoids, and the cessation of blood flow often leads to necrosis of paravenular hepatocytes. Morphology. Sinusoidal obstruction syndrome is characterized by obliteration of the terminal hepatic venules by swollen or necrotic endothelium, edema, and eventual collagen deposition. In acute disease, there is centralobular congestion, hepatocellular necrosis, and accumulation of hemosiderin-laden macrophages. In advanced lesions, the obliterated lumens of venules can be highlighted by special stains for connective tissue. Fig. 18.44. In chronic or healed sinusoidal obstruction syndrome, complete fibrous obliteration of the venule may follow. Clinical features. Although histology is the gold standard for diagnosis, liver biopsy is often risky in these patients. As a result, the diagnosis is typically made on clinical grounds based on the findings of tender hepatomegaly, ascites, weight gain, and jaundice, as well as reversed or attenuated hepatic venous flow on Doppler ultrasonography. Early results suggest that treatment with anticoagulants and ursodeoxycholate may lower the incidence and severity of sinusoidal obstruction syndrome in patients undergoing hematopoietic stem cell transplantation, passive congestion, and centrilobular necrosis. These hepatic manifestations of systemic circulatory compromise, passive congestion, and centrilobular necrosis are considered together because they represent a morphologic continuum. Both changes are commonly seen at autopsy because there is an element of preterminal circulatory failure in virtually every non-traumatic death. Morphology. Right-sided cardiac decompensation leads to passive congestion of the liver. The liver is slightly enlarged, tense, and cyanotic with rounded edges. Microscopically, there is congestion of dilated centrilobular sinusoids. With time, centrilobular hepatocytes become atrophic, resulting in markedly attenuated liver cell plates. Left-sided cardiac failure or shock may lead to hepatic hypoperfusion and hypoxia of hepatocytes around central veins. The combination of hypoperfusion and retrograde congestion acts synergistically to cause centrilobular hemorrhagic necrosis. The liver takes on a variegated mottled appearance, reflecting hemorrhage and necrosis in the centrilobular regions. Fig. 18:45a. This finding is known as nutmeg liver due to its resemblance to the cut surface of a nutmeg. In most instances, the only clinical evidence of centrilobular necrosis or its variants is transient elevation of serum aminotransferases, but the parenchymal damage may be sufficient to induce mild to moderate jaundice. By microscopy, there is a sharp demarcation of viable periportal and necrotic or atrophic pericentral hepatocytes, with suffusion of blood through the centrilobular region. See Fig. 18:45b. With sustained chronic severe congestive heart failure, cardiac sclerosis develops with centrilobular pericellular fibrosis, sometimes with bridging fibrous septum. Key concepts: circulatory disorders. Circulatory disorders of the liver can be caused by impaired blood inflow, defects in intrahepatic blood flow, and obstruction of blood outflow. Portal vein obstruction by intrahepatic or extrahepatic thrombosis may cause portal hypertension, esophageal varices, and ascites. The most common cause of impaired intrahepatic blood flow is cirrhosis. Figure 18.44 Sinusoidal obstruction syndrome. Collagen stain reveals marked sinusoidal congestion, hepatocyte atrophy and loss, and organizing thrombus within the vein lumen arrow. Actin-trichome stain. Chapter 18 Liver and gallbladder. Abnormal liver tests occur in 3% to 5% of pregnancies, but in most cases these are of no clinical importance. In a very small subgroup of pregnant women, 0.1%, more serious hepatic complications develop. These disorders include preeclampsia and eclampsia, acute fatty liver of pregnancy, and intrahepatic cholestasis of pregnancy. In extreme cases, eclampsia and acute fatty liver of pregnancy may be fatal. Preeclampsia and eclampsia. A. Preeclampsia affects up to 10% of pregnancies and is characterized by maternal hypertension, proteinuria, peripheral edema, and coagulation abnormalities. See Chapter 22 for detailed discussion. When hyperreflexia and convulsions occur, the condition is called eclampsia and may be life-threatening. Alternatively, subclinical hepatic disease may be the primary manifestation of preeclampsia, as part of a syndrome of hemolysis, elevated liver enzymes, and low platelets, dubbed the HELP syndrome. Here we focus on the hepatic pathology of these entities. Morphology. B. In preeclampsia, periportal sinusoids contain fibrin deposits associated with hemorrhage into the space of descent, leading to periportal hepatocellular coagulative necrosis. Blood under pressure may coalesce and expand to form a hepatic hematoma. Dissection of blood under glycine capsule may lead to catastrophic hepatic rupture and eclampsia. Fig. 18:46. Figure 18.45 Acute passive congestion nutmeg liver. The cut surface of the liver has a variegated mottled red appearance, representing congestion and hemorrhage in the centrilobular regions of the parenchyma. On microscopic examination, the centrilobular region is suffused with red blood cells, and atrophied hepatocytes are not easily seen. Portal tracts and the periportal parenchyma are intact. Clinical features: patients with hepatic involvement in preeclampsia may show modest to severe elevation of serum aminotransferases and mild elevation of serum bilirubin. Hepatic dysfunction sufficient to cause a coagulopathy signifies advanced and potentially lethal disease. Mild cases may be managed conservatively. Termination of pregnancy is required in severe cases. Women who survive mild or severe preeclampsia recover without sequelae. 864. Obstructions of blood outflow include hepatic vein thrombosis, Budd-Chiari syndrome, and sinusoidal obstruction syndrome, previously known as veno-occlusive disease, hepatic disease associated with pregnancy. Some forms of hepatic disease may be exacerbated by pregnancy. Viral hepatitis, HAV, HBV, HCV, or HBV plus HEV is the most common cause of jaundice in pregnancy. While these women require careful clinical management, pregnancy does not specifically alter the course of viral hepatitis, with exception of HEV infection, which, for unknown reasons, runs a more severe course and has a fatality rate approaching 20% in pregnant patients. The liver may also be secondarily involved by other infections during pregnancy. These include hepatitis caused by herpes simplex virus, a rare cause of acute liver failure in pregnancy, and liver abscess caused by Listeria monocytogenes, an organism that thrives in placental tissue, from where it may seed the liver. Figure 18.46 Eclampsia. Subcapsular hematoma dissecting under glycine capsule in a fatal case. Courtesy Dr. Brian Blackburn, Office of the Medical Examiner, San Diego, Calif. The liver and bile ducts 865. Acute fatty liver of pregnancy. Acute fatty liver of pregnancy presents with a spectrum of disease ranging from subclinical or modest hepatic dysfunction evidenced by elevated serum aminotransferase levels to hepatic failure, coma, and death. It is a rare disease affecting approximately 1 in 16,000 pregnant women. Pathogenesis. The pathogenesis of this disease in some cases may involve an inherited disorder of metabolism. In a subset of patients, both mother and father carry a heterozygous deficiency in mitochondrial long-chain 3-hydroxyacetylcoenzyme coenzyme dehydrogenase. The homozygous deficient fetuses and placenta fare well during pregnancy but cause hepatic dysfunction in the mother because long-chain 3-hydroxylacyl metabolites produced by the fetus or placenta enter the maternal circulation and cause hepatic toxicity. Thus, this may be a rare instance of the fetus causing metabolic disease in the mother. Morphology. The diagnosis of acute fatty liver of pregnancy rests on biopsy identification of characteristic diffuse microvesicular steatosis and hepatocytes. In severe cases, there may be lobular disarray with hepatocyte dropout, reticulin collapse, and portal tract inflammation, making distinction from viral hepatitis difficult. Cholestasis may also be present. Clinical features. While this condition most commonly runs a mild course, women with acute fatty liver of pregnancy can progress within days to hepatic failure and death. The primary treatment is termination of pregnancy. Affected women present in the latter half of pregnancy, usually in the third trimester. Symptoms are directly attributable to incipient hepatic failure, including bleeding, nausea and vomiting, jaundice, and coma. In 20% to 40% of cases, the presenting symptoms may be those of coexistent preeclampsia. Intrahepatic cholestasis of pregnancy. The onset of pruritus in the second or third trimester, followed in some cases 10% to 25% by darkening of the urine and occasionally light stools and jaundice, heralds the development of this enigmatic syndrome, which resolves within 2 to 3 weeks of delivery. Serum bilirubin, mostly conjugated, rarely exceeds 5 mg/dl. Alkaline phosphatase may be slightly elevated. The level of bile salts is increased greatly. The altered hormonal state of pregnancy likely combines with environmental factors and transporter protein defects to engender canalicular cholestasis. There is a modest risk of fetal loss, and the condition may recur in subsequent pregnancies. The pruritus resulting from retention of bile salts can be extremely distressing for the pregnant mother. Nodules and tumors. Hepatic mass lesions include non-neoplastic processes like focal nodular hyperplasia, regenerative nodules, an abscess or another infectious process. Neoplastic mass lesions include benign hepatocellular nodules such as hepatocellular adenoma, malignant primary liver epithelial neoplasms, such as hepatocellular carcinoma or intrahepatic cholangiocarcinoma, and non-epithelial neoplasms, such as angiosarcoma and metastatic tumors. Non-neoplastic mass lesions. Focal nodular hyperplasia. Focal nodular hyperplasia (FNH) is a benign, non-neoplastic lesion that is most common in adult women. Pathogenesis. FNH is thought to result from altered blood flow that leads to hyperplastic changes in hepatocytes. FNH-like nodules can occur adjacent to other tumors and in vascular conditions, such as hemangiomas and Budd-Chiari syndrome. Multifocal FNH can occur in association with hepatic or extrahepatic hemangioma, vascular malformations, or curiously brain tumors, such as meningioma and astrocytoma. Morphology. FNH is well circumscribed, typically lacks a capsule, and has a central stellate scar in up to 80% of cases. Fig. 1847. Most lesions are 5 cm or less in diameter. Microscopically, fibrous septa radiate from the central scar dividing the hepatic parenchyma into nodules. The fibrous septa and central scar contain thick-walled arteries with intimal and fibromuscular hyperplasia and poorly formed elastic lamina. Fig. 1847b. Prominent ductular reaction is often present, but interlobular bile ducts are absent. The hepatocytes and the nodules are arranged in 1 to 2 so thick plates. Cytologic and architectural atypia is not present. Immunohistochemistry for glutamine synthetase GS, an enzyme normally present in centrosomal hepatocytes, is very useful for diagnosis. In FNH, a highly characteristic map-like pattern of strong cytoplasmic GS staining is seen within anastomosing groups of hepatocytes. Clinical features. Most cases are asymptomatic and come to clinical attention during imaging or surgery. The presence of a central scar is a highly characteristic finding and helps in establishing the diagnosis on imaging. FNH is a benign lesion and does not need any treatment. Resection is performed for large symptomatic lesions. Other non-neoplastic mass lesions. Non-neoplastic mass-forming lesions like abscesses, granulomas, and inflammatory pseudotumors can mimic true neoplasms. Large regenerative nodules can occur in non-cirrhotic liver and vascular conditions, such as Budd-Chiari, 866 Chapter 18 liver and gallbladder. Benign neoplasms. 8. The figure 18.47 focal nodular hyperplasia, a resected specimen showing lobulated contours and a central stellate scar. The low-power micrograph showing a broad fibrous scar with thick-walled arteries and ductular reaction, but no interlobular bile ducts. Syndrome, hemangioma, and vascular malformations. In some conditions, the entire liver becomes nodular without significant fibrosis, a condition referred to as nodular regenerative hyperplasia (NRH). NRH can lead to portal hypertension and mimic cirrhosis on imaging. Benign biliary proliferations include bile duct adenoma and biliary hamartoma von Mayenberg complex, described earlier. Both are asymptomatic and generally less than 2 cm. These lesions come to clinical attention as tiny nodules or cysts on imaging, or as small subcapsular lesions observed during abdominal surgery when they can be mistaken for metastatic disease. Both lesions show haphazard bile ducts in a fibrous stroma and lack atypical cytologic or architectural features. The ductular profiles in bile duct adenoma tend to be round and non-dilated, while those in biliary hematoma are dilated, curvilinear, and often show inspissated bile or secretions. The latter are thought to be a remnant of ductal plate malformation. The recent identification of pathogenic acquired BRAF mutations in the majority of bile duct adenomas indicates that this is a benign neoplasm, settling a long-standing debate. Cavernous hemangioma. Cavernous hemangioma is the most common benign liver tumor. It appears as a discrete red-blue, soft nodule, usually less than 2 cm in diameter, generally in a subcapsular location. Histologically, the tumor consists of dilated thin-walled vascular channels. Fig. 1848. Most are asymptomatic and are detected incidentally by imaging. Hepatocellular adenoma. Hepatocellular adenoma is a benign neoplasm that typically occurs in young women and is strongly associated with use of oral contraceptives and anabolic steroids. The incidence has increased in the past decade, presumably related to obesity and metabolic syndrome. Multiple hepatocellular adenomas, termed hepatic adenomatosis, when 10 or more tumors are present, can occur both in familial and acquired settings. Pathogenesis. 3 molecular subtypes have been defined, each associated with distinct clinicopathologic features and varying risk of transformation into hepatocellular carcinoma. Hepatocyte nuclear factor 1 alpha HN4 alpha inactivated hepatocellular adenoma. All of these tumors by definition have loss of function mutations in the HN4 alpha gene, which encodes a transcription factor that regulates many genes in hepatocytes and in pancreatic islets. Heterozygous germline mutations are responsible for autosomal dominant maturity onset diabetes of the young, type 3, and are also associated with 10% of HN4 alpha inactivated hepatocellular adenomas. This subtype accounts for 40% to 50% of cases, has a strong female predilection, and is associated with minimal risk of transformation to hepatocellular carcinoma. Inflammatory hepatocellular adenoma is a subtype that results from acquired activating mutations in GPO130, a co-receptor for IL-6, that lead to constitutive activation of JK-STAT signaling. This subtype accounts for 40% to 50% of cases. Figure 18.48. Cavernous hemangioma. Blood-filled vascular channels separated by a dense fibrous stroma. Liver and bile ducts. 867. Is more common in women and is associated with obesity and metabolic syndrome. Beta-catenin activating mutations also are present in 10% of inflammatory hepatocellular adenomas, and these tumors have a higher risk of malignant transformation. Beta-catenin activated hepatocellular adenoma is defined by activating mutations in the beta-catenin gene CTN in bone or in other components of the WNT pathways such as APC. These tumors are at high risk for malignant transformation to hepatocellular carcinoma and are associated with oral contraceptive and anabolic steroid use. Nearly 40% occur in men. Morphology. Hepatocellular adenomas appear as discrete masses, sometimes with associated hemorrhage, composed of hepatocytes arranged in 1 to 2 cell-thick plates. Fig. 18.49. Large arteries are present within a small amount of fibrous stroma, while interlobular bile ducts and normal portal tracts are absent. HN4 alpha mutated tumors typically show prominent fat in the lesional hepatocytes, and by immunohistochemistry, liver fatty acid binding protein LFAP, a protein regulated by HN4 alpha, is absent. Fig. 1858. Beta-catenin mutated tumors often show atypical cytologic or architectural features, and areas showing overt transformation to hepatocellular carcinoma may be present. Due to beta-catenin mutations or other mutations that activate WNT signaling, strong nuclear localization of beta-catenin is seen within at least a subset of the tumor cells. See Fig. 1850b. Inflammatory tumors typically show sinusoidal dilation and may have features mimicking focal nodular hyperplasia, such as fibroceptor and ductular reaction. Because of hyperactive JK-STAT signaling, these tumors overexpress acute phase reactants, such as C-reactive protein and serum amyloid. A C Fig. 1850c. Clinical features. Hepatocellular adenoma may be detected incidentally by imaging or come to attention due to symptoms related to abdominal pain or hemorrhagic necrosis. Rupture of hepatocellular adenomas can cause massive abdominal bleeding and represents a surgical emergency. Resection is recommended for beta-catenin activated tumors as well as tumors 5 cm or larger due to the risk of hemorrhage and malignant transformation. For smaller tumors without beta-catenin activation, close follow-up and cessation of exposure to oral contraceptive or anabolic steroids may suffice. Primary malignant neoplasms. 8. Malignant tumors in the liver can be primary or metastatic. Among primary epithelial tumors, the most common are hepatocellular carcinoma and intrahepatic cholangiocarcinoma. Hepatoblastoma is a rare hepatocellular tumor that occurs in the pediatric setting. Non-epithelial tumors, such as angiosarcoma, are exceedingly rare. Hepatoblastoma is the most common liver tumor of early childhood. It rarely occurs over the age of 3 years, and its incidence is increasing. Activation of the WNT signaling pathway is characteristic of hepatoblastoma, leading to nuclear beta-catenin and increased expression of WNT target genes such as glutamine synthetase in nearly all cases. These tumors are associated with several syndromes, including familial adenomatous polyposis caused by germline loss-of-function mutations in APC, Chapter 17, and Beckwith-Wiedemann syndrome. The latter is a disorder associated with congenital growth abnormalities caused by abnormal epigenetic imprinting of a region of chromosome 11 that leads to overexpression of insulin-like growth factor 2 and loss of expression of CDK9C. The tumor suppresses a gene that encodes the cyclin-dependent kinase inhibitor 57. Morphology. Figure 18.49 hepatocellular adenoma, a resected specimen showing a well-defined tan mass in the liver. B microscopic view showing thin cords of hepatocytes, with an arteriovascular supply arrow and no portal tracts. There are a variety of histologic subtypes of hepatoblastoma, which can be broadly grouped into two categories. One epithelial type, composed of small polygonal fetal cells or smaller embryonal cells forming tracheally, acini, tubules, or papillary structures, vaguely recapitulating the developing liver Fig. 1851, and 2. Mixed epithelial and mesenchymal type, which contains additional foci of mesenchymal differentiation that may consist of primitive mesenchyme, osteoid, cartilage, or striated muscle. 868 Chapter 18 Liver and Gallbladder. BC Figure 18.50 Molecular subtypes of hepatocellular adenoma. HN-alpha inactivated hepatocellular adenoma. Liver fatty acid, binding protein LFAB, expression of which depends on HN-alpha is absent in the tumor by immunostaining and is present in adjacent normal hepatocytes lower left. The hepatocellular adenoma with beta-catenin activation. Note nuclear immunostaining in some neoplastic hepatocytes compared to other tumor hepatocytes that maintain normal membranous staining. C. Inflammatory hepatocellular adenoma. There is marked upregulation of C-reactive protein in neoplastic hepatocytes compared to the highly variable and low-level expression in adjacent hepatic parenchyma. Immunostained with DAB Brown and hematoxylin counterstain. A. Courtesy Dr. Valerie Paradis, Ojan Hospital, Paris, France. Figure 18.51 Hepatoblastoma. The tumor cells are arranged in sheets and resemble embryonal and fetal hepatocytes. Clinical features. Hepatoblastoma usually comes to clinical attention due to abdominal swelling in an asymptomatic infant or child. Symptoms related to liver dysfunction, jaundice, pruritus are seen in a subset of patients, and about 20% of tumors will have metastasized to the lungs by the time of diagnosis. The tumor is treated with surgical resection and chemotherapy, which has improved outcomes. The overall 5-year survival rate is approximately 80%. Hepatocellular carcinoma HCC accounts for approximately 4% of all cancers worldwide and is one of the most common cancers in geographic regions with high rates of hepatitis B infection. More than 85% of cases occur in countries in Asia, Southeast China, Korea, Taiwan, and Sub-Saharan Africa, where chronic HBV infection is common. The peak incidence of HCC in these areas is in young adults between 20 and 40 years of age who acquired hepatitis B virus by maternal fetal transmission. Encouragingly, the incidence of HCC is decreasing in Asia due to hepatitis B vaccination, but at the same time the incidence is increasing in the Western countries owing to rising rates of hepatitis C infection and metabolic syndrome. For unclear reasons, there is a pronounced male predominance, as high as 8.1 in high incidence areas. Pathogenesis. Most HCCs occur in the setting of chronic liver disease with cirrhosis, while 15% to 20% arise in non-cirrhotic livers. Fig. 18.52. Most common underlying diseases are chronic viral hepatitis B and C, metabolic diseases, the liver and bile ducts. 869. 60% of tumors, and inactivating mutations in T53 up to 60% of tumors. One unusual histologic subtype that often occurs in adolescents and young adults in the absence of pre-existing liver disease, fibrolamellar HCC, is strongly associated with a fusion gene that leads to aberrant activity of protein kinase A, an enzyme that participates in a signaling pathway regulated by cAMP. Morphology. Several precursor lesions for HCC have been described. As discussed earlier, in non-cirrhotic liver, HCC can arise in hepatocellular adenoma, especially those with beta-catenin activating mutations. In chronic liver disease, the earliest morphologic alterations that appear to correlate with the presence of at-risk hepatocytes are called large cell change and small cell change. Fig. 18.53. Large cell change refers to hepatocytes that are larger than normal and often have enlarged, multiple, polymorphic nuclei, without an increase in nuclear to cytoplasmic ratio. See Fig. 18.53a. In small cell change, the hepatocytes have a high nuclear to cytoplasmic ratio and mild nuclear hyperchromasia and / polymorphism. See Fig. 18.53b. More ominous are nodular lesions. Figure 18.52 Hepatocellular carcinoma. A liver removed at autopsy showing a unifocal neoplasm replacing most of the right hepatic lobe. B. Malignant hepatocytes growing in distorted versions of normal architecture, including large pseudoacinar spaces malformed, dilated bile canaliculi, and thickened hepatocyte tracheally. A. Such as hereditary hemochromatosis and alpha-1 antitrypsin deficiency, and alcoholic liver disease. Non-alcoholic fatty liver disease also increases the risk of HCC, even in the absence of cirrhosis. Although details are not clearly worked out, it is believed that the chronic injury inflammation, and hepatocyte regeneration that are seen in these disorders contribute to the acquisition of driver mutations that lead to HCC development described later. Part of the risk in Africa and Asia appears to be related to contamination of crops by aflatoxin, a mycotoxin produced by Aspergillus species that acts synergistically with alcohol and hepatitis B. The risk for HCC and cirrhosis related to other etiologies, like Wilson disease and chronic biliary diseases, is somewhat lower but still elevated above the population average. As with other cancers, HCC is associated with complementary sets of driver mutations that lead to the acquisition of cancer hallmarks. Chapter 7. Among the most common are activating mutations in the beta-catenin gene 40% of tumors, mutations in the TER telomerase transcriptase gene promoter that upregulate telomerase activity 50% too. Figure 18.53 promalignant changes in hepatocytes. A large cell change. Large hepatocytes with large, often atypical nuclei are scattered among normal-sized hepatocytes with round, typical nuclei. Small cell change. The abnormal cells have a high nuclear to cytoplasmic ratio and are separated by thickened plates. Normal-appearing hepatocytes are in the lower right corner. Courtesy Dr. Young Nyan Park, Yonsei Medical College, Seoul, South Korea. 870 Chapter 18 Liver and Gallbladder. In cirrhotic liver referred to as dysplastic nodules Fig. 1854, which are often associated with small cell change. Dysplastic nodules differ from adjacent cirrhotic nodules in size, color, and vascularization, show varying degrees of dysplasia, and have clonal aberrations associated with full-blown HCC. Small areas of HCC may sometimes be seen in high-grade dysplastic nodules. Nodule and nodule appearance see Fig. 1854b. HCC may form a single mass or multiple discrete masses, or it may diffusely infiltrate the liver. They may be pale and yellow due to fatty change or green due to cholestasis. Tumors larger than 2 cm are more likely to be associated with vascular invasion and intrahepatic metastasis. Invasion of veins with extension into the portal vein, inferior vena cava, and even the right side of the heart may occur. B. Figure 18.55 Fibrolamellar carcinoma. A resected specimen showing a well-demarcated nodule. B. Microscopic view showing nests and cords of malignant appearing, oncocytic hepatocytes separated by dense bundles of collagen. A. Microscopically, well and moderately differentiated HCC are composed of cells that resemble normal hepatocytes, while poorly differentiated tumors show marked cytologic atypia. The tumor cells grow in thick plates or trabeculae, pseudoglandular structures with bioplugs, or sheets. See Fig. 1852b. The distinctive fibrolamellar variant shows a characteristic triad of features: large polygonal cells with granular oncocytic cytoplasm due to abundant mitochondria, vesicular nuclei with a prominent nucleolus, and parallel lamellae of dense collagen bundles. Fig. 18.55. B. Figure 18.54 A hepatitis C. Related cirrhosis with a distinctively large nodule arrows. Nodule and nodule growth suggests an evolving cancer. B. Histologically, the region within the box in it shows a well-differentiated hepatocellular carcinoma HCC right side and a subnodule of moderately differentiated HCC within its center, left. Courtesy Dr. Masamichi Kajiro, Kurum University, Kurum, Japan. Clinical features: the clinical manifestations of HCC are nonspecific and include abdominal pain, malaise, fatigue, weight loss, and hepatomegaly. Features of underlying chronic liver disease can be present. Elevated levels of serum alpha-fett protein is a frequent finding in advanced disease, but it is not sensitive as a screening test for early tumors and is not associated with the fibrolamellar variant. Ultrasonography is used for screening high-risk patients, such as those with cirrhosis. Computed tomography and magnetic resonance imaging with contrast studies yield highly characteristic findings. Early enhancement of the tumor due to contrast uptake in the arterial phase, followed by rapid venous washout, is considered diagnostic of HCC. Surgical resection, when possible, is the treatment of choice for tumors in non-cirrhotic livers and in cirrhotic livers with the liver and bile ducts. 871. Adequate function. Liver transplantation is considered for HCC in the setting of advanced cirrhosis. Image-guided tumor ablation with alcohol or radiofrequency waves can be done for unresectable tumors or those that do not meet criteria for transplantation. Hematogenous metastases, especially to the lung, tend to occur late in the disease. Lymph node metastases occur in 5% of cases. Overall outcomes in HCC are poor due to underlying liver disease and the intrinsic resistance of HCC to conventional chemotherapy. The overall 5-year survival rate is 30% for tumor confined to the liver and only 5% to 10% for cases with extrahepatic spread. Outcomes are better for the unusual fibrolamellar variant, with up to 40% of patients surviving 10 years or longer. This is in large part because, in the absence of underlying liver disease, extensive surgical resection is possible thanks to the regenerative capacity of the remaining liver. Malignant biliary tumors, adenocarcinomas arising from the intrahepatic biliary tree, are referred to as intrahepatic cholangiocarcinoma, while similar tumor arising from the extrahepatic bile ducts are referred to as biliary adenocarcinoma. Intrahepatic cholangiocarcinoma is the most common primary malignant tumor of the liver after HCC. Its incidence is rising in the United States. It accounts for 6% of cancer deaths worldwide and 3% of cancer deaths in the United States. It is very common in Southeast Asian countries such as Thailand, Laos, and Cambodia, where liver fluke infestation is endemic. Pathogenesis: developmental disorders, like fibropolycystic liver disease, and chronic inflammatory conditions involving the bile ducts, including primary sclerosing cholangitis, infestation by liver flukes, particularly Opisthochus and Clenorchis species, and hepatolithiasis are risk factors for biliary tract neoplasms. Chronic liver diseases that predispose to HCC, such as hepatitis B, hepatitis C, and non-alcoholic fatty liver disease, also increase the risk for intrahepatic cholangiocarcinoma. As with HCC, chronic injury, inflammation, and regeneration of biliary epithelium in these conditions may set the stage for acquisition of driver mutations leading to cancer. Driver mutations in intrahepatic cholangiocarcinoma and extrahepatic biliary adenocarcinoma only partially overlap. Cross mutations are common in both tumors. In addition, subsets of intrahepatic cholangiocarcinoma have distinctive driver mutations in IDHONE and IDHO isotrate dehydrogenase that generate oncometabolites chapter 7, and in chromatin modifier genes like BA-PON and PPR-MON. Fusion genes involving FGFR fibroblast growth factor receptor 2 are also common. By contrast, in addition to cross mutations, extrahepatic biliary adenocarcinomas are most likely to have mutations in T53 and SMAD4, genetic features that are similar to those of pancreatic adenocarcinoma. AB. See Figure 18.56 cholangiocarcinoma, a multifocal cholangiocarcinoma in a liver from a patient with infestation by the liver fluke Clenorchis sinuses. The invasive malignant glands in a reactive sclerotic stroma. See perineural invasion by malignant glands, forming a wreath-like pattern around the central tract nerve. A. Courtesy Dr. Wilson M.S. Sui, Caritas Medical Center, Hong Kong. Morphology intrahepatic cholangiocarcinoma usually occurs in the non-cirrhotic liver Fig. 1856 and typically forms a firm gray-white mass. Extrahepatic biliary adenocarcinomas include perihilar tumors, known as Claskin tumors, which are located at the junction of the right and left hepatic ducts. These tumors comprise 60% to 70% of extrahepatic biliary adenocarcinomas, while the remaining 30% to 40% involve the common bile duct. Extrahepatic biliary adenocarcinomas are generally small at diagnosis, as they are detected early due to obstructive features. These tumors may. Chapter 18 Liver and Gallbladder. Primary hepatic lymphoma is a rare type of liver malignancy. The most common subtype is diffuse large B-cell lymphoma, a form of non-Hodgkin lymphoma that frequently occurs at extranatal sites. Chapter 13. Another rare subtype is hepatosplenic T-cell lymphoma, most common in young adult males, which has a predilection for growth within the sinusoids of the liver, spleen, and bone marrow. Form a firm nodule in the bile duct wall, may be diffusely infiltrative, or may form papillary lesions. Microscopically, both intrahepatic and extrahepatic tumors show features of adenocarcinomas. Most are well to moderately differentiated and are arranged in clearly defined glandular/tubular structures lined by malignant epithelial cells embedded in an abundant fibrous stroma. See Fig. 1856b. Lymphovascular and perineural invasion. See Fig. 1856c are common. These tumors are thought to usually arise from premalignant lesions termed biliary intraepithelial neoplasia. Other less common precursor lesions are mucinous cystic neoplasms and intraductal papillary neoplasms. Metastasis involvement of the liver by metastatic malignancy is far more common than primary hepatic neoplasia. Although the most common primary sources are the colon, breast, lung, and pancreas, virtually any may spread to the liver. Typically, multiple nodular metastases are found that often cause striking hepatomegaly and replace much of the normal liver parenchyma. The liver weight can exceed several kilograms. Metastasis may also appear as a single nodule, in which case it may be resected surgically. Always surprising is the extent of metastatic involvement that may be present in the absence of clinical or laboratory evidence of hepatic insufficiency. Often the only telltale sign is hepatomegaly. However, with massive destruction of hepatocytes or direct obstruction of major bile ducts, jaundice and other evidence of liver dysfunction inevitably appears. Clinical features intrahepatic cholangiocarcinoma may be detected incidentally on imaging or may present with a cholestatic picture or symptomatic liver mass, whereas extrahepatic adenocarcinoma typically presents with symptoms related to biliary obstruction. Tumor resection with negative margins and absence of lymph node involvement are favorable factors. Lymph node metastasis is present in 50% to 60% of patients at presentation. Adjuvant chemotherapy is commonly given after resection, but tumor responses are usually transient. The overall prognosis is poor, as recurrences are common, and the 5-year survival rate is 20% to 40% after surgical resection. Key concepts: liver tumors. The liver is the most common site of metastatic cancers from primary tumors of the colon, lung, and breast. Hepatocellular adenomas are benign tumors of neoplastic hepatocytes, which can be subclassified on the basis of different sets of driver mutations. HCC is the most common primary hepatic malignant neoplasm, often occurring in the setting of cirrhosis related to chronic liver disease such as chronic hepatitis B and C, autoimmune hepatitis, alcoholic/non-alcoholic fatty liver disease, and hemochromatosis. Intrahepatic cholangiocarcinoma and extrahepatic biliary adenocarcinoma show similar histologic features and share risk factors, like primary sclerosing cholangitis and infestation by liver flukes, such as Opisthochus and Clenorchis. These tumors have a poor prognosis. Other primary hepatic malignant tumors, a number of other cancers may arise within the liver. Among the most common or pathogenically interesting are the following. Combined hepatocellular cholangiocarcinoma is composed of cells resembling both HCC and intrahepatic cholangiocarcinoma. These tumors have the same risk factors as HCC. Angiosarcoma is a malignant vascular tumor that is historically associated with exposure to vinyl chloride, arsenic, or the imaging agent thorotrash chapters 9 and 11. This tumor has become rare with reduced exposures to these agents. Epithelioid hemangioendothelioma is another vascular tumor with intermediate malignant potential and a somewhat better prognosis than angiosarcoma, which is almost uniformly fatal. Gallbladder. As much as 1 L of bile is secreted by the liver per day. Between meals, bile is stored in the gallbladder, where it is concentrated. The adult gallbladder has a capacity of about 50 ml. The organ is not essential for biliary function, since humans do not suffer from indigestion or malabsorption of fat after cholecystectomy. Congenital anomalies. The gallbladder may be congenitally absent, or there may be gallbladder duplication with conjoined or independent cystic ducts. A longitudinal or transverse septum may create a bilobed gallbladder. Barren locations of the gallbladder occur in 5% to 10% of the population, most commonly with partial or complete embedding in the liver substance. A folded fundus is the most common anomaly, creating a Phrygian cap Fig. 18.57. Agenesis of all or any portion of the hepatic or common bile ducts and hypoplastic narrowing of biliary channels. True biliary atresia may also occur. Cold arterial cysts, described earlier, may be isolated findings in the gallbladder or associated with other cysts in the extrahepatic biliary tree or with fibropolycystic disease. 872. Gallbladder 873, figure 18.57. Phrygian cap of the gallbladder. The fundus is folded inward. Cholelithiasis gallstones. More than 95% of biliary tract disease is attributable to gallstones. Gallstones afflict 10% to 20% of adult populations in high-income countries. It is estimated that more than 20 million persons in the United States have gallstones, totaling some 25 to 50 tons in weight, leading to more than 700,000 cholecystectomies performed annually at a cost of approximately $6 billion. Epidemiology. There are two general classes of gallstones: cholesterol stones, containing more than 50% of crystalline cholesterol monohydrate, and pigment stones composed predominantly of bilirubin calcium salts, each with different risk factors. Cholesterol gallstones are more prevalent in the United States and Western Europe, 90%, and uncommon in low-income countries. The prevalence rates of cholesterol gallstones approach 75% in Native Americans of the Pima, Hopi, and Navajo groups, while pigment stones are rare in these populations. Pigment gallstones, the predominant type of gallstone in non-Western populations, arise primarily in the setting of bacterial infections or parasitic infestations of the biliary tree, and as well as in individuals with diseases that lead to chronic red cell hemolysis. The major risk factors associated with the development of gallstones are listed in Table 18.11 and are briefly described here. Age and sex. The prevalence of cholesterol gallstones increases throughout life, but they predominantly affect individuals of middle to older age. Prevalence is higher in females in any region or ethnicity. In Caucasian women, it is about twice as high as in men. Hypersecretion of biliary cholesterol seems to play the major role in both age and gender differences. Significant associations are also seen with metabolic syndrome and obesity. Environmental factors. Estrogen exposure, including through oral contraceptive use and during pregnancy, increases expression of hepatic lipoprotein receptors and stimulates hepatic HMG-CoA reductase activity, enhancing both cholesterol uptake and biosynthesis, respectively. The net result is excess biliary secretion of cholesterol. Obesity and rapid weight loss are also strongly associated with increased biliary cholesterol secretion. Acquired disorders. Gallbladder stasis, either neurogenic or hormonal, fosters a local environment that is favorable for both cholesterol and pigment gallstone formation. Hereditary factors. Genes encoding hepatocyte proteins that transport biliary lipids, known as ATP-binding cassette ABC transporters, have associations with gallstone formation. In particular, a common variant of the sterol transporter encoded by the ABCJ gene is associated with an increased risk of cholesterol gallstones. Pathogenesis of cholesterol stones. Cholesterol is rendered soluble in bile by forming micelles with bile salts and lecithins, both of which act as detergents. When cholesterol concentrations exceed the solubilizing capacity of bile supersaturation, cholesterol can no longer remain dispersed and nucleates into solid cholesterol monohydrate crystals. 4 conditions appear to contribute to formation of cholesterol gallstones: 1. Supersaturation of bile with cholesterol, 2. Hypomotility of the gallbladder, 3. Accelerated cholesterol crystal nucleation, and 4. Hypersecretion of mucus in the gallbladder, which traps the nucleated crystals, leading to accretion of more cholesterol and the appearance of macroscopic stones. Pathogenesis of pigment stones. Pigment gallstones are complex mixtures of insoluble calcium salts of unconjugated bilirubin and inorganic calcium salts. Disorders that are associated with elevated levels of unconjugated bilirubin and bile increase the risk of developing pigment stones. These include chronic hemolytic anemia, severe ileal dysfunction or bypass, and bacterial contamination of the biliary tree. Unconjugated bilirubin is normally a minor component of bile, but it increases when infection of the biliary tract leads to release of microbial beta-glucuronidases, which hydrolyze bilirubin glucuronides. Thus, infection of the biliary tract with Escherichia coli, Ascaris lumbricoides, or the liver fluke C. Sinuses increases the. Table 18. 11G risk factors for all stones. Cholesterol stones demography. Northern Europeans, North and South Americans, Native Americans, Mexican Americans, advancing age, female sex hormones, female gender, oral contraceptives, pregnancy, obesity and metabolic syndrome, rapid weight reduction, gallbladder stasis, inborn disorders of bile acid metabolism, hyperlipidemia syndromes, pigment stones. Demography. Asians more than Westerners, rural more than urban. Chronic hemolytic anemias, biliary infection, gastrointestinal disorders, ileal disease for example, Crohn's disease, ileal, resection or bypass, cystic fibrosis with pancreatic insufficiency. Chapter 18 Liver and Gallbladder. Figure 18.5 8 Cholesterol gallstones. The wall of the gallbladder is thickened and fibrotic due to chronic cholecystitis. Figure 18.5 9 Cholesterolosis. Gallbladder mucosa demonstrates lamina propria distended by foamy macrophages. Likelihood of pigment stone formation. In hemolytic anemias, the secretion of conjugated bilirubin into bile increases. About 1% of bilirubin glucuronides are deconjugated in the biliary tree, and in the setting of chronically increased secretion of conjugated bilirubin, a sufficiently large amount of deconjugated bilirubin is generated to allow pigment stones to form. 874. Morphology. Cholesterol stones arise exclusively in the gallbladder and range from 100% pure, which is rare, down to around 50% cholesterol. Pure cholesterol stones are pale yellow, round to ovoid, and have a finely granular, hard external surface. Fig. 1858, which on trisection reveals a glistening, radiating crystalline palisade. With increasing proportions of calcium carbonate, phosphates, and bilirubin, the stones take on a gray-white to black color and may be lamellated. Multiple stones are usually present that range up to several centimeters in diameter. Rarely, a very large stone may virtually fill the fundus. Surfaces of stones may be rounded or faceted because of tight opposition to adjacent stones. Stones composed largely of cholesterol are radiolucent. Sufficient calcium carbonate is found in 10% to 20% of cholesterol stones to render them radiopaque. Supersaturated cholesterol in bile that forms cholesterol stones may also diffuse into the mucosa and manifest as cholesterolosis. Fig. 1859. Pigment gallstones are brown to black. In general, black pigment stones are found in sterile gallbladder bile, and brown stones are found in infected large bile ducts. Black stones contain oxidized polymers of calcium salts of unconjugated bilirubin, small amounts of calcium carbonate, calcium phosphate, mucin glycoprotein, and some cholesterol monohydrate crystals. Brown stones contain similar compounds along with some cholesterol and calcium salts of palmitate and stearate. Black stones are rarely greater than 1.5 cm in diameter, are almost invariably present in great number with an inverse relationship between size and number. Fig. 1860, and are quite free of black. Their contours are usually spiculated and molded. Brown stones tend to be laminated and soft and may have a soap-like or greasy consistency. Approximately 50% to 75% of black stones are radiopaque due to calcium salts, while brown stones, which contain calcium soaps, are radiolucent. Mucin glycoproteins constitute the scaffolding and interparticle cement of all types of stones. Clinical features: gallstones may be present for decades before symptoms develop, and 70% to 80% of patients remain asymptomatic throughout their lives. Asymptomatic individuals convert to being symptomatic at an average rate of up to 4% per year, although the risk diminishes with time. Symptomatic patients with biliary colic experience excruciating pain, although this name is a misnomer, as the pain is usually constant, not colicky. Pain often follows a fatty meal that induces gallbladder contraction, which presses a stone against the gallbladder outlet, leading to increased pressure and eventually pain. The pain is localized to right upper quadrant. Figure 18.60 Pigment gallstones. Several faceted black gallstones are present in this otherwise unremarkable gallbladder from a patient with a mechanical mitral valve prosthesis, leading to chronic intravascular hemolysis. 875, or epigastrium, and may radiate to the right shoulder or the back. Inflammation of the gallbladder, cholecystitis, discussed later in association with stones, also generates pain. More severe complications include empyema, perforation, fistula, inflammation of the biliary tree, cholangitis, obstructive cholestasis, and pancreatitis. The larger the calculi, the less likely they are to enter the cystic or common ducts to produce obstruction. It is very small stones, or gravel, that are most dangerous. Occasionally a large stone may erode directly into an adjacent loop of small bowel, generating intestinal obstruction, gallstone ileus, or Bouverie syndrome. Gallstones also are associated with an increased risk of gallbladder carcinoma, discussed later. Cholecystitis. Inflammation of the gallbladder may be acute, chronic, or acute superimposed on chronic. It almost always occurs in association with gallstones. In the United States, cholecystitis is one of the most common indications for abdominal surgery. Its epidemiology closely parallels that of gallstones. Acute cholecystitis. Acute cholecystitis is precipitated in 90% of cases by obstruction of the neck of the gallbladder or the cystic duct by a stone. Acute calculous cholecystitis is the primary complication of gallstones and the most common reason for emergency cholecystectomy. Cholecystitis without gallstones or calculous cholecystitis may also occur in severely ill patients and accounts for the remaining 10% of cases. Pathogenesis: acute calculous cholecystitis results from chemical irritation and inflammation of a gallbladder obstructed by stones. The action of mucosal phospholipases hydrolyzes lumiноlecithins to toxic lysolecithins. The normally protective glycoprotein mucus layer is disrupted, exposing the mucosal epithelium to the direct detergent action of bile salts. Prostaglandins released within the wall of the distended gallbladder contribute to mucosal and mural inflammation. Distension and increased intraluminal pressure compromise blood flow to the mucosa. These events initially occur in the absence of bacterial infection, but later in the course bacterial infection may be superimposed and exacerbate the inflammatory process. Acute calculous cholecystitis is particularly common in diabetic patients who have symptomatic gallstones. Acute calculous cholecystitis is thought to result from ischemia. The cystic artery is an end artery without a collateral circulation. Contributing factors may include inflammation and edema of the wall, compromising blood flow and gallbladder stasis due to accumulation of microcrystals of cholesterol, biliary sludge, viscous bile, and mucus, causing cystic duct obstruction in the absence of stones. Usually occurs in acutely ill patients who are hospitalized for unrelated conditions. Risk factors for acute calculous cholecystitis include 1. Sepsis with hypotension and multisystem organ failure, 2. Immunosuppression, 3. Major trauma and burns, 4. Diabetes mellitus, and 5. Infections, gallbladder. Morphology in acute cholecystitis. The gallbladder is usually enlarged and tense, and it may assume a bright red or blotchy, violaceous to green-black discoloration imparted by subserosal hemorrhages. Serosa is frequently covered by a fibrinous exudate that may be fibrinopurulin in severe cases. There are no specific morphologic differences between acute calculous and calculous cholecystitis, save the absence of stones in their calculous form. In calculous cholecystitis, an obstructing stone is usually present in the neck of the gallbladder or the cystic duct. The gallbladder lumen contains one or more stones and is filled with cloudy or turbid bile mixed with fibrin, pus, and hemorrhage. When the exudate is virtually pure pus, the condition is referred to as gallbladder empyema. In mild cases, the gallbladder wall is thickened, edematous, and hyperemic. In more severe cases, it is transformed into a green-black necrotic organ, termed gangrenous cholecystitis, with small to large perforations. The invasion of gas-forming organisms, notably Clostridia and coliforms, may cause an acute emphysematous cholecystitis. Histologically, early changes of acute cholecystitis include edema, congestion, and mucosal erosion. Neutrophils are typically sparse, unless there is superimposed infection. Clinical features: individuals with acute calculous cholecystitis usually but not always have experienced previous episodes of pain related to the gallbladder. An attack begins with progressive right upper quadrant or epigastric pain that lasts for more than 6 hours. It is frequently associated with mild fever, anorexia, tachycardia, sweating, nausea, and vomiting. Most patients are free of jaundice. The presence of hyperbilirubinemia suggests obstruction of the common bile duct. Mild to moderate leukocytosis may be accompanied by modestly elevated serum alkaline phosphatase. Acute calculous cholecystitis may appear with remarkable suddenness and constitute an acute surgical emergency, or it may present with mild symptoms that resolve without medical intervention. In the absence of medical attention, the attack usually subsides in 7 to 10 days and frequently within 24 hours. However, as many as 25% of patients develop progressively more severe symptoms and require immediate surgical intervention. Recurrence is common in patients who recover without surgery. Clinical symptoms of acute calculous cholecystitis tend to be more insidious, since they are obscured by the underlying conditions precipitating the attack. A high proportion of patients have no symptoms referable to the gallbladder. Diagnosis therefore rests on a high index of suspicion. In the severely ill patient, early recognition of the condition is crucial, since failure to do so almost ensures a fatal outcome. As a result of either delay in diagnosis or the disease itself, the incidence of gangrene and perforation is much higher in calculous cholecystitis than in calculous cholecystitis. In rare instances, primary bacterial infection by agents such as S. typhi and Staphylococcus can give rise to acute calculous cholecystitis. A more indolent form of acute calculous cholecystitis may occur in the setting of systemic vasculitis, severe atherosclerotic ischemic disease in the elderly, AIDS usually related to cryptosporidium infection, or ascending biliary tract infection. 876 Chapter 18 Liver and Gallbladder. Chronic cholecystitis. Chronic cholecystitis may be a sequel to repeated bouts of mild to severe acute cholecystitis, but in many instances it develops in the apparent absence of antecedent attacks. Since it is associated with cholelithiasis in more than 90% of cases, the at-risk patient population is the same as that for gallstones. The evolution of chronic cholecystitis is obscure. It is not clear that gallstones play a direct role in the initiation of inflammation or the development of pain, particularly since chronic calculous cholecystitis shows symptoms in histology similar to those of the calculous form. Rather, supersaturation of bile predisposes to both chronic inflammation and, in most instances, stone formation. Microorganisms, usually E. coli and Enterococci, are cultured from the bile in about 1/3 of cases. Unlike acute calculous cholecystitis, obstruction of gallbladder outflow is not a prerequisite. Morphology. The morphologic changes in chronic cholecystitis are extremely variable and sometimes minimal. The serosa is usually smooth and glistening, but may be dulled by subserosal fibrosis. Dense fibrous adhesions may be present that represent the sequelae of prior acute inflammation. On sectioning, the wall is variably thickened and has an opaque gray-white appearance. In uncomplicated cases, the lumen contains grain-yellow, mucoid bile and usually stones. The mucosa itself is generally preserved. On histologic examination, The degree of inflammation is variable. In the mildest cases, only scattered lymphocytes, plasma cells, and macrophages are found in the mucosa and in the subserosal fibrous tissue. Fig. 1861a. In more advanced cases, there is marked subepithelial and subserosal fibrosis, accompanied by mononuclear cell infiltration. Reactive proliferation of the mucosa and fusion of the mucosal folds may give rise to buried crypts of epithelium within the gallbladder wall. Outpouchings of the mucosal epithelium through the wall Rokitansky-Aschoff sinuses may be quite prominent. See Fig. 1861b. In rare instances, there is extensive dystrophic calcification of the gallbladder wall porcelain gallbladder. More often, there is complete replacement of the gallbladder wall and mucosa by dense fibrosis hyalinizing cholecystitis, with or without calcification. This change is notable for being associated with an increased incidence of gallbladder carcinoma discussed later. In xanthogranulomatous cholecystitis, the gallbladder has a massively thickened wall and is shrunken, nodular, and chronically inflamed with foci of necrosis and hemorrhage. It is triggered by rupture of Rokitansky-Aschoff sinuses into the wall of the gallbladder, followed by an accumulation of macrophages that have ingested biliary phospholipids. Such lipid-containing cells with foamy cytoplasm are called xanthoma cells, hence the name of this condition. Finally, an atrophic, chronically obstructed, often dilated gallbladder may contain only clear secretions, a condition known as hydrops of the gallbladder. Other rare forms of chronic cholecystitis include IgG4-related sclerosing cholecystitis, another manifestation of IgG4-related fibrosing disease. Clinical features: chronic cholecystitis does not have the striking manifestations of the acute forms and is usually characterized by Figure 18.61. Chronic cholecystitis of the gallbladder mucosa is infiltrated by inflammatory cells. The outpouching of the mucosa through the wall forms Rokitansky-Aschoff sinus contains bile. Recurrent attacks of either steady epigastric or right upper quadrant pain, nausea, vomiting, and intolerance for fatty foods are frequent accompaniments. Diagnosis of both acute and chronic cholecystitis is important because of the following complications: bacterial superinfection with cholangitis or sepsis, gallbladder perforation and local abscess formation, gallbladder rupture with diffuse peritonitis, biliary enteric chocyst enteric fistula, with drainage of bile into adjacent organs, entry of air and bacteria into the biliary tree, and potentially gallstone-induced intestinal obstruction ileus. Aggravation of pre-existing medical illness with cardiac, pulmonary, renal, or liver decompensation. Gallbladder carcinoma. Carcinoma of the gallbladder is the most common malignancy of the extrahepatic biliary tract. Approximately 6,000 new cases of gallbladder cancer are diagnosed each year in the United States. There are wide variations in the incidence of gallbladder cancer worldwide, with regions 877, such as Chile, Bolivia, and northern India harboring the highest numbers of cases. Even within the United States, areas with large Native American or Hispanic populations, such as the Southwest, have a higher incidence of gallbladder cancer than the rest of the country. Gallbladder cancer is at least twice as common in women as in men. This gender disparity can be several-fold greater in regions of highest incidence. The overwhelming majority of patients are diagnosed at an advanced, surgically unresectable stage, and the mean 5-year survival rate for affected patients is less than 10%. Pathogenesis: the most important risk factor for gallbladder cancer besides gender and ethnicity is gallstones, which are present in 95% of cases. However, it should be noted that only 1% to 2% of patients with gallstones develop gallbladder cancer. In Asia, chronic bacterial or parasitic infections have been implicated as risk factors, and the coexistence of gallstones with gallbladder cancer is much lower. Nonetheless, the common thread that ties gallstones or chronic infections together with gallbladder cancer is chronic inflammation. Relatively common driver mutations include gain-of-function aberrations affecting members of the EGF receptor gene family, including HER2 genes enacting downstream signaling components such as ORAS, and loss-of-function mutations in the T53 tumor suppressor gene, which are present in up to 1/2 of tumors. As is typical of T53 mutated cancers, most gallbladder carcinomas exhibit aneuploidy, gallbladder, morphology. Several precursor lesions of gallbladder carcinoma have been described, indicating that, as is typical of carcinoma, generally full-blown cancer likely arises from a lengthy stepwise process. These precursors include flattened cytologies with varying degrees of dysplasia, mass-forming adenoma-like lesions termed intracholcystic papillary tubular neoplasm, and intestinal metaplasia. Gallbladder cancers are mainly adenocarcinomas and are most often detected in the fundus. Fig. 1862. They may produce a firm, poorly circumscribed mass or may diffusely infiltrate the wall of gallbladder, simulating the gross appearance of chronic cholecystitis. Microscopically, they are usually characterized by the presence of glands embedded in desmoplastic stroma, but in some cases cytologic atypia and stromal response are minimal. In these instances, identification of perineural and vascular invasion help establish the diagnosis. With progression, direct extension into other organs, fistula formation, peritoneal and biliary spread, and metastases to the liver and portohepatic lymph nodes occur. Rarely, other types of malignant tumors arise primarily within the gallbladder, including neuroendocrine tumors, squamous cell carcinoma, and sarcomas. Clinical features: preoperative diagnosis of carcinoma of the gallbladder is the exception rather than the rule, occurring in fewer than 20% of patients. Presenting symptoms are insidious and typically indistinguishable from those associated with cholelithiasis, including abdominal pain, jaundice, and rexia. 8B figure 18.62 gallbladder adenocarcinoma. The open gallbladder contains a large, exophytic tumor that virtually fills the lumen. B malignant glands are seen infiltrating a densely fibrotic gallbladder wall. And nausea and vomiting. If the tumor is detected prior to invasion and spread, such as when carcinoma is an incidental finding during surgery for symptomatic gallstones or acute cholecystitis, cure by surgical resection is possible. However, most patients have advanced disease at diagnosis, and the overall prognosis for such patients is poor, even with apparently complete resection of evident tumor. Adjuvant chemotherapy is often offered to such patients but is not curative, and most patients eventually succumb to their disease. Key concepts: diseases of the gallbladder. Gallbladder diseases include cholelithiasis, acute and chronic cholecystitis, and gallbladder cancer. Gallstones are common in Western countries. The great majority are cholesterol stones. Pigmented stones containing bilirubin and calcium are most common in Asian countries. Risk factors for the development of cholesterol stones are advancing age, female gender, estrogen use, obesity, and heredity. Cholecystitis almost always occurs in association with cholelithiasis, although in about 10% of cases it occurs in the absence of gallstones. Gallstones are also a risk factor for gallbladder cancer. Chapter 18: Liver and gallbladder. Acute calculus cholecystitis is the most common reason for emergency cholecystectomy. Gallbladder cancers are associated with gallstones in the vast majority of cases. Typically, they are detected late because of non-specific symptoms and hence carry a poor prognosis. 878. Suggested readings: mechanisms of liver injury and repair. Gout ASW, Clauston AD, Thies ND. Ductular reactions in human livers, diversity at the interface, Pathology 54, 1853, 2011. Review of ductular reactions, the stem cell response of human livers in all liver diseases that are related to mechanisms of regeneration, fibrogenesis, and neoplasia. Akabe P. Friedman et al. Cellular basis of hepatic fibrosis and its role in inflammation and cancer. Front bio Sci-Scal ed 521-7, 2013. Interweaving what is known about hepatic stellate cells and other myofibroblastic cells of the liver with inflammatory, fibrosing, and neoplastic disease processes. Koyama Y. Brenner D.A. Liver inflammation and fibrosis. J. Klin Invest 127-1, 55, 64, 2017. doi. 10-1172/JCEID 8881. EPUB 2017 January 3. PubMed PMed 28,045,404. PubMed Central PMKit 5,199,698. Review: a recent review of the complex interplay between the immune system and hepatic fibrosis. Quaglia A. Alves V.A. Alabor C. et al. International Liver Pathology Study Group. Role of etiology in the progression, regression, and parenchymal remodeling of liver disease. Implications for liver biopsy interpretation. Histopathology 68-7, 953, 96-7, 2016. Or 10-1111/His 12,957. EPUB 2016 April 28. PubMed PMed 26,918,878. Review: this paper challenges pathologists to evolve past use of the term cirrhosis to communicate more useful information about fibrosis in relation to disease etiology. Thies ND. Saxena R. Portman B.C. et al. The canals of Hering and hepatic stem cells in humans. Hepatology 36, 1425, 1433, 1999. PubMed PMed 10,573,521. The meticulous histopathologic identification of a stem cell niche in liver. Wellness IR. Nakashima E. Sherman M. Regression of human cirrhosis. Morphologic features and the genesis of incomplete septal cirrhosis. Arch Patholab Med 12 for 5099, 2000. A revolutionary paper that began the reassessment of whether fibrosis/cirrhosis could regress. Take a look also, in the same volume of the journal, at the critiques by the original reviewers of the paper published despite their objections and the author's response to these. Pathology history happening before your eyes. Acute on chronic liver failure. Bernal W. 1 and J. Acute liver failure. In Engel J. Med 36 92525, 2013. An excellent clinical review. Berzagati A. Sajo S. Reverter E. et al. Assessing portal hypertension and liver diseases. Expert Reverend Gastroenterol Hepatos 749, 2013. Evolving definitions and methodologies for evaluating portal hypertension are at the leading edge of advances in hepatology. Chun L.J. Tong M.J. Ustil R.W. et al. Acetaminophen hepatotoxicity and acute liver failure. J. Klin Gastroenterol 4334, 2009. About the most common cause of acute liver failure leading to transplantation. Hyder P. Over D.C. Alves V. Beyond Cirrhosis, a proposal from the International Liver Pathology Study Group, and J. Klin Patho 137, 5, 2012. New understandings of diverse cirrhosis and a new look at the old concept of cirrhosis and advanced stage liver disease. Kunger V. Cordet F. Hepatic encephalopathy. Klin Liver Dis 1631, 2012. Good overview of one of the most ominous sequelae of all forms of liver failure. Lehman W., Burbick L., Mearsman P. Acute on chronic liver failure. Current concepts on definition, pathogenesis, clinical manifestations, and potential therapeutic interventions. Expert Reverend Gastroenterol Hepatol 552-3, 2011. EWM, Squires or H. Jr., Nyberg S.L. et al., Acute liver failure. Summary of a workshop. Hepatology 47-4, 1401, 1415, 2008. doi. 10-1002/Hep. 22,177. PubMed PMed, 18,318,440. PubMed Central PMedKit, 3,381,946. A discussion of findings from the Acute Liver Failure Study Group. Left College JH, The Pathology of Acute Liver Failure, Av Annett Patho 23-3, 144, 158, 2016. Or 10-1097/PAP, 112. PubMed PMed, 27,058,243. Review. An excellent review of the pathology of acute liver failure. Van Leeuwen DJ. Alves V. Alabor C. et al. Acute on chronic liver failure 2018. The need for urgent liver biopsy. Expert Reverend Gastroenterol Hepatol 12-6, 565, 573, 2018. Recent review of terminology and clinicopathologic considerations around acute on chronic liver failure. Viral hepatitis Chung or T, Omer TF, curing chronic hepatitis C. The Arc of Medical Triumph, in Engel J. Med 37-1576, 2014. An excellent perspective on why and how hepatitis C can be cured. European Association for the Study of the Liver, ESO Recommendations on Treatment of Hepatitis C 2018, J. Hepatol 69-2, 461, 511, 2018. Review of Diagnosis, Screening and Treatment Guidelines for Hepatitis C. Joyce May, Tyrrell D.L., The Cell Biology of Hepatitis C Virus, Microbes Infect 12-26-3, 2010. What we understand and do not understand about hepatitis C virus and the cells it infects. Amategni R.J., Ag S., Bouchard M.J., Hepatitis B virus molecular biology and pathogenesis, Hepatoma Res 216-3, 186, 2016. Review of hepatitis B virus infection. Engineer D. Weber A. Clinicopathologic features and pathologic diagnosis of hepatitis E. Humpatho 2019. doi. 10-1016/J. Humpath 2019-10-003. PI. S46 8177 1930,179-0. Keep ahead of print. Review of hepatitis E virus infection. Autoimmune liver diseases CZAJ AJ. Examining pathogenic concepts of autoimmune hepatitis for cues to future investigations and interventions. World J. Gastroenterol 2545. 6579. 6606. 2019. Review of pathogenesis of AIH. Eisenman de Torres B. and members of the International Autoimmune Hepatitis Group. Simplified criteria for the diagnosis of autoimmune hepatitis. Hepatology 4869, 2008. Still relevant set of criteria for diagnosing autoimmune hepatitis. European Association for the Study of the Liver. ESO Clinical Practice Guidelines. The diagnosis and management of patients with primary biliary cholangitis. J. Hepatol 67-1, 145, 172, 2017. Review of diagnosis and treatment guidelines for PBC. Carlson T.H., Falsraz T., Thorburn D., et al. Primary sclerosing cholangitis. A comprehensive review. J. Hepatol 67-6, 1298, 1323, 2017. Review of all aspects of PSC. Drug and toxin-induced liver injury. Crawford J.M. Histologic findings in alcoholic liver disease. Clin Liver Dis 1669-9, 2012. Thorough look at the morphologic changes in alcoholic liver disease and the underlying mechanisms that produce them. Gunno and B. Kaplovitz N. Clinical Perspectives on Xenobiotic-Induced Hepatotoxicity. Drug Medab Reverend 3631, 2004. Comprehensive and current review. Planer D. Drug-induced liver injury. The hepatic pathologist's approach. Gastroenterol Clint North and 46-2, 273, 296, 2017. Review of the manner in which morphologic changes are evaluated in the setting of suspected drug-induced liver injury. Fatty liver disease. Alpert L. Hart J. The Pathology of Alcoholic Liver Disease. Clin Liver Dis 23, 47-3, 489, 2016. Recent review of the pathology of alcoholic liver disease. Planer D. 1EM. Non-alcoholic fatty liver disease. Pathologic patterns in biopsy evaluation and clinical research. Semin Liver Dis 32, 3, 2012. As authoritative as one can be on the topic. Inherited liver diseases. Promoter D.H. Silverman G.A. Hepatic fibrosis and carcinogenesis and alpha-1 antitrypsin deficiency. A prototype for chronic tissue damage and gain of function disorders. Cole Springhard Perspect BL1, 3, 2011. Readings 879, benign and malignant liver tumors, Charlie W.T. ACRS, atypical hepatocellular neoplasms, review of clinical, morphologic, immunohistochemical, molecular, and cytogenetic features. Anet Patho 25-4, 25, 262, 2018, review of pathologic and molecular aspects of adenomas and atypical tumors with borderline HEC features. International Consensus Group for Hepatocellular Neoplasia. Pathologic diagnosis of early hepatocellular carcinoma, Hepatology 4965-8, 2009. Good example of how change comes to medicine, individual efforts combining, over years, to achieve a new consensus. Massaway N.N., El Sereg H.B. Epidemiology of hepatocellular carcinoma and intrahepatic cholangiocarcinoma, Cancer Control 24-3, 1,273,274,817,729,245, 2017. View of epidemiology at trends in hepatocellular carcinoma and cholangiocarcinoma. Rizvi S. Kansar, Alamaya C.L. et al., cholangiocarcinoma, Evolving Concepts and Therapeutic Strategies, Net Reverend Clint Onco 15-2, 95, 111, 2018. View of epidemiology, pathogenesis, and management of cholangiocarcinoma. Semper C. Chang C. Gao et al., benign hepatocellular nodules. What have we learned using the pathomolecular classification? Clin Res Hepatal Gastroenterol 37-4, 322, 327, 2013. From the team largely responsible for the new molecular simplifications of hepatocellular adenomas. Vogel A. Cervantes A. Shaw et al., ESMO Guidelines Committee. Hepatocellular carcinoma, ESMO Clinical Practice Guidelines for Diagnosis, Treatment and Follow-up, and OnCall 29 Supple 4, IF 138, IF 155, 2018. View off guidelines for diagnosis and management of HCC. WHO Classification of Tumors Editorial Board. Digestive System Tumors, Lyon, France, 2019, International Agency for Research on Cancer. WHO Classification of Tumors Series, in 5, Volume 1, suggested a broader perspective on some chronic hereditary diseases using alpha-1 antitrypsin as the paradigmatic example. Pietrangelo A. Genetics, Genetic Testing, and Management of Hemochromatosis, 15 years since Hepcidin, Gastroenterology 149-5, 1240, 1251, 2015. Comprehensive Review of Genetics of Hemochromatosis with emphasis on hepcidin and mechanism of disease. Rosenkrantz R. Shosky M. Wilson Disease, Pathogenesis and Clinical Considerations in Diagnosis and Treatment, Semin Liver Disc 31-24, 2011. Review of Mechanisms of Copper-Induced Liver Injury and Wilson Disease with a useful summary of diagnosis and treatment considerations. Cholestatic Syndromes Desmond V.J. Congenital Diseases of Intrahepatic Bile Ducts. Variations on the theme Ductal Plate Malformation, Hepatology 16-1069, 1992. Classic paper in liver pathology. Hirschfield G.M., Heathcote E.J., Gershwin Me. Pathogenesis of Cholestatic Liver Disease and Therapeutic Approaches, Gastroenterology 39-1481, 2010. Thorough overview of the most common features of liver disease. Baumgartner G. Biliary Physiology and Disease, Reflections of a Physician-Scientist, Hepatology 51-1095, 2010. How benchtop work comes to exert an impact on clinical medicine, sometimes slowly over decades. Sui W.M., Lam P.W., Lee W.K., Primary Hepatolithiasis, Recurrent Pyogenic Cholangitis, and Oriental Cholangiohepatitis. The Tale of Three Countries, Anet Patho 1831-8, 2011. A review that reveals much about the diseases discussed as well as the variable histories of medical understanding in different regions of the globe. Circulatory Disorders Guido M. Alves VAF. Alabos C. et al. Histology of portal vascular changes associated with idiopathic non-cirrhotic portal hypertension. Nomenclature and definition. Histopathology 74-2, 219, 2-6, 2019. Provides a review of the spectrum of histologic changes and a unified nomenclature. See targeted therapy available online at www.studentconsole.com. CHAPTE, or the pancreas, the 19, Anubin Matra. Chapter contents. Congenital anomalies 881, pancreatitis 882, acute pancreatitis 882, chronic pancreatitis 886, non-neoplastic cysts 888, congenital cysts 888, pseudocysts 888, neoplasms 888, cystic neoplasms 888, pancreatic carcinoma 890, precursors to pancreatic cancer 890, acinar cell carcinoma 893, pancreatoblastoma 894. Adult pancreas is a transversely oriented retroperitoneal organ extending from the C-loop of the duodenum to the hilum of the spleen. Fig. 19.1. Although the organ gets its name from the Greek pancreas, all flesh, it is in fact a complex lobulated organ with distinct exocrine and endocrine components. The exocrine pancreas constitutes 80% to 85% of the organ and is composed of acinar cells. These pyramidally shaped epithelial cells contain membrane-bound granules rich in proenzyme zymogens, including trypsinogen, chymotrypsinogen, procarboxypeptidase, prolistase, kallikreinogen, and prophospholipases and B, all of which contribute to digestion. Upon secretion, these proenzymes and enzymes are carried by a series of ductules and ducts to the duodenum, where they are activated by proteolytic cleavage described later. The endocrine pancreas is composed of about 1 million endocrine cell clusters, the islets of Langerhans, that are scattered throughout the gland. Islet cells secrete insulin, glucagon, somatostatin, and pancreatic polypeptide. Although they constitute only 1% to 2% of the organ mass, the hormones released by the islet cells are essential regulators of systemic metabolism. Diseases of the endocrine pancreas are described in detail in Chapter 24. Congenital anomalies. The complex process by which the dorsal and ventral pancreatic primordia fuse during pancreatic development is imperfect, giving rise to variation in pancreatic anatomy. The pancreas normally arises from the fusion of dorsal and I am grateful for the immense contributions of Ralph H. Rubin and Christine A. Icabuzzi-O'Donoghue, who authored this chapter in the prior edition of this book. Many of the photomicrographs used in this chapter are contributed by Dr. Rubin. 881. Ventral outpouchings of the foregut, the body, the tail, and the superior/anterior aspect of the head of the pancreas, as well as the accessory duct of Santorini, are derived from the dorsal primordium. Typically, the ventral primordium gives rise to the posterior/inferior part of the head of the pancreas and drains through the main pancreatic duct into the papilla of Vater. Pancreas divisum. Pancreas divisum is the most common congenital anomaly of the pancreas with an incidence of 3% to 10%. In most individuals, the main pancreatic duct, the duct of Wersen, joins the common bile duct just proximal to the papilla of Vater, and the accessory pancreatic duct, the duct of Santorini, drains into the duodenum through a separate minor papilla. See Fig. 19. 1a. Pancreas divisum is caused by a failure of fusion of the fetal duct systems of the dorsal and ventral pancreatic primordium. As a result, in this anatomic variant, the bulk of the pancreas formed by the dorsal pancreatic primordium drains into the duodenum through the small caliber minor papilla. Fig. 19. 1b. While the duct of Wersen drains only a small portion of the head of the gland through the papilla of Vater. Although controversial, it has been suggested that inadequate drainage of the pancreatic secretions through the minor papilla, especially when combined with genetic defects that also increase susceptibility to pancreatitis described later, predisposes individuals with pancreatic divisum to chronic pancreatitis. Annular pancreas. Annular pancreas is a band-like ring of normal pancreatic tissue that completely encircles the second portion of the duodenum. Annular pancreas can produce duodenal obstruction. Ectopic pancreas. Pancreatic tissue that is aberrantly situated, or ectopic, is found in about 2% of careful routine post-mortem examinations. The favored sites for ectopia are 82 and 9 are once pancreate CHNPT, the duct of Santorini, minor sphincter, bile-duct duodenum, papilla of Vater, bile-duct duodenum, minor sphincter, papilla of Vater. Figure 19.1 Pancreatic ductal anatomy. A normal ductal anatomy. B. Ductal anatomy in pancreatic divisum. Modified from Greg J. A. et al. Pancreas divisum. Results of surgical intervention. And J. Circ 14-48-8. 492. 1983. A. Normal duct of Wersen. B. Pancreas divisum. Acinar and ductal cells secrete trypsin inhibitors, including serine protease inhibitor Caslo type L spin cone, which further limit intrapancreatic trypsin activity. Pancreatitis occurs when these protective mechanisms are disrupted or overwhelmed. Acute attacks may range from mild and self-limited to life-threatening events. Recurrent or persistent pancreatitis may lead to permanent loss of pancreatic function. Acute pancreatitis. Acute pancreatitis is characterized by reversible pancreatic parenchymal injury and inflammation and has many causes, including toxic exposures, for example, alcohol, pancreatic duct obstruction, for example, biliary calculi, inherited genetic defects, vascular injury, and infections. Acute pancreatitis is relatively common with an annual incidence in Western countries of 10 to 20 cases per 100,000 people. Biliary tract disease and alcoholism account for approximately 80% of these cases. Table 19.1. The proportion of cases caused by excessive alcohol intake varies from 65% in the United States to 20% in Sweden to 5% or less in southern France and the United Kingdom. The male to female ratio is 6:1 in those with alcoholism and 1:3 in patients with biliary tract disease. Gallstones are present in 35% to 60% of acute pancreatitis cases and cause gallstone pancreatitis in about 5% of patients with gallstones. Pathogenesis. Acute pancreatitis results from inappropriate release and activation of pancreatic enzymes that, in turn, destroy the stomach and duodenum, followed by the jejunum, macrodiverticula, and ileum. Although usually incidental findings, these embryologic rests, composed of normal-appearing pancreatic acini, glands, and sometimes islets of Langerhans, may cause pain from localized inflammation or may incite mucosal bleeding. Agenesis. Very rarely the pancreas fails to develop agenesis. Some cases of agenesis are caused by homozygous germline mutations involving PD-zone, a gene encoding a homeobux transcription factor that is critical for pancreatic development. Pancreatitis. Pancreatitis is divided into two forms, acute and chronic, each with its own characteristic pathologic and clinical features. Both are initiated by injuries that lead to autodigestion of the pancreas by its own enzymes. Under normal circumstances, several factors protect the pancreas from autodigestion. Most digestive enzymes are synthesized as inactive proenzymes, zymogens, and packaged within secretory granules. Proenzymes are typically activated by trypsin, which itself is activated by dual-no-enteroxidase enterokinase in the small bowel. As a result, intrapancreatic activation of proenzymes is normally minimal. Etiology. 1 factors in acute pancreatitis. 1 table. Metabolic. Alcoholism, hyperlipoproteinemia, hypercalcemia. Drugs, for example, azathioprine, statins, GLP-1 agonists, DPP-4 inhibitors. Genetic. Mutations in genes encoding trypsin PRS-SOM, trypsin regulators SPINCONE, or proteins that regulate calcium metabolism. Cast cystic fibrosis CFTR. Mechanical. Gallstones, a trauma, iatrogenic injury, operative injury, endoscopic procedures with dye injection, for example, or vascular. Shock catherombolism, vasculitis, for example, polyarteritis nodosa. Infectious mumps, Coxsackie virus, are most common etiologies in the United States. DPP-4, dieptidylpeptidase 4, ERK, endoscopic retrograde cholangiopin-creatinography, GLP-1, glucagon-like peptide 1, pancreatitis 83, pancreatic tissue and elicit an acute inflammatory reaction. Inappropriate trypsin activation within the pancreas can activate other proenzymes such as prophospholipase and prolestase, which degrade fat cells and damage the elastic fibers of blood vessels, respectively. Once tissue damage commences, trypsin can also directly or indirectly activate factors found in the blood, including components of the coagulation, complement, kallikrein, and fibrinolytic pathways. Chapters 3 and 4. The resulting inflammation and small vessel thrombosis causes further damage to acinar cells, amplifying intrapancreatic enzyme activation. The triggers that cause intrapancreatic enzyme activation in sporadic acute pancreatitis remain a topic of investigation, but there is evidence for at least 3 major initiating events. Fig. 19.2. Pancreatic duct obstruction is most commonly caused by gallstones and biliary sludge, but can also stem from periampullary neoplasms, for example, pancreatic cancer, cholelithiosal congenital cystic dilation of the common bile duct, parasites, particularly Ascaris lumbricoides and Clenorchis sinensis, and possibly pancreas divison. Obstruction raises intrapancreatic ductal pressure and leads to accumulation of enzyme-rich fluid within the interstitium. Unlike other pancreatic enzymes, lipase is secreted in an active form and has the potential to cause local fat necrosis. The death of adipocytes is hypothesized to produce danger signals locally that are sensed by pancreatic stellate cells and leukocytes, which release pro-inflammatory mediators that promote microvascular leak and development of interstitial edema. Edema may further compromise local blood flow, causing vascular insufficiency and ischemic injury to acinar cells. Primary acinar cell injury leads to release of digestive enzymes, inflammation, and tissue autodigestion. Acinar cells can be damaged by a variety of endogenous, exogenous, and iatrogenic insults. Many of these result in oxidative stress and generation of intracellular free radicals that lead to membrane lipid oxidation and transcription factor activation. The latter include APON and NF-kappa B, which induce expression of chemokines that attract mononuclear cells. Increased calcium flux is another important trigger for inappropriate enzyme activation. Calcium has a key role in trypsin regulation. When calcium levels are low, trypsin tends to cleave and inactivate itself. But this autoinhibition is abrogated and trypsin autoactivation is favored when calcium levels are increased. Any factor causing increased calcium within acinar cells may therefore trigger excessive trypsin activation. Examples include inherited abnormalities that affect calcium levels. Table 19.2. Duct obstruction, acinar cell injury, defective intracellular transport, cholelithiasis, ampullary obstruction, chronic alcoholism, ductal concretions, alcohol, drugs, trauma, ischemia, viruses, hypercalcemia. Metabolic injury, alcohol, duct obstruction, interstitial edema, impaired blood flow, release of intracellular proenzymes and lysosomal hydrolases, delivery of proenzymes to lysosomal compartment. Ischemia, enzyme activation, intra or extracellular, intracellular enzyme activation, acinar cell injury, activated enzymes, interstitial inflammation and edema plus proteolysis plus fat necrosis plus damage to vessel walls, hemorrhage, acute pancreatitis. Figure 19.23. Proposed pathways in the pathogenesis of acute pancreatitis. 884. Chapter 19. The pancreas. Table 19.2. Predisposition to pancreatitis. Gene chromosome location. CFTR 731. Protein product. Cystic fibrosis transmembrane conductance regulator. PRS-SOM 734. Serine protease 1 trypsinogen 1. SPINCONE 532. Serine peptidase inhibitor. Casl type 1. Cas313 calcium sensing receptor. CTRC 136 TPAN 732. Chymotrypsin C caldicrine. Carboxypeptidase AN. Function epithelial anion channel. Loss of function mutations alter fluid pressure and limit bicarbonate secretion, leading to inspissation of secreted fluids and duct obstruction. Cationic trypsin. Gain of function mutations prevent self-inactivation of trypsin. Inhibitor of trypsin. Mutations cause loss of function, increasing trypsin activity. Membrane-bound receptor that senses extracellular calcium levels and controls luminal calcium levels. Mutations may alter calcium concentrations and activate trypsin. Degrades trypsin, Protects the pancreas from trypsin-related injury. Exopeptidase involved in regulating zymogen activation inherited. Defective intracellular transport of enzymes within acinar cells. Normal acinar cells. Digestive enzymes and lysosomal hydrolases are transported via separate pathways. In animal models of acinar injury, pancreatic proenzymes, of which the cathepsin family of hydrolases is most important, are aberrantly delivered to lysosomes. The hydrolases then activate pancreatic proenzymes that disrupt lysosomal membranes, ultimately leading to release of activated enzymes. It is not clear if this mechanism is relevant to human acute pancreatitis. Two factors have been proposed to contribute to alcohol-induced pancreatitis: duct obstruction and acinar cell damage. Alcohol consumption transiently increases contraction of the sphincter of Oddi, the muscle at the papilla vator, and chronic alcohol ingestion results in the secretion of protein-rich pancreatic fluid that is prone to form inspissated protein plugs that obstruct small pancreatic ducts. Within acinar cells, alcohol-induced oxidative stress may generate free radicals, leading to membrane lipid oxidation and activation of the pro-inflammatory transcription factors APON and NF-kappa B. Oxidative stress also may promote fusion of lysosomes and zymogen granules and increase intracellular calcium levels, possibly through mitochondrial damage, thereby promoting the intracellular activation of trypsin and other digestive enzymes. Nevertheless, it should be noted that most alcoholics never develop pancreatitis, and those who do usually do so after many years of alcohol abuse. Thus, key aspects of the pathophysiology of alcohol-induced pancreatitis remain obscure. Other proven or suspected triggers of acute pancreatitis in sporadic cases include see Table 19.1. Metabolic disorders such as hypertriglyceridemia and hypocalcemic states, as in hypoparathyroidism. Genetic lesions, as described below. Medications. Hundreds of drugs have been anecdotally linked to acute pancreatitis, but only about 50 have a definite association. The latter include azathioprine, angiotensin-converting enzyme AC inhibitors, statins, and antidiabetic drugs such as glucagon-like peptide-1 GLP-1 agonists and dipeptidase 4 DPP-4 inhibitors. Traumatic acinar cell injury, by either blunt abdominal trauma or iatrogenic injury during surgery or endoscopic retrograde cholangiopancreatography. Ischemic acinar cell injury due to shock, vascular thrombosis, embolism, or vasculitis. Infections, including mumps, can lead to acute pancreatitis through direct acinar cell injury. Hereditary factors are increasingly recognized as causes of pancreatitis. Affected individuals have recurrent attacks of severe acute pancreatitis, which often begin in childhood and can ultimately lead to chronic pancreatitis. A feature shared by most forms of hereditary pancreatitis is a defect that increases or sustains the activity of trypsin. See Table 19.2. 3 genes implicated in hereditary pancreatitis deserve special note: PRS-SON, SPINCON, and CFTR. Most hereditary cases are due to gain-of-function mutations in the trypsinogen gene known as PRS-SON. Some of these PRS-SON gene mutations make trypsin resistant to self-inactivation, abrogating an important negative feedback mechanism. Other mutations make trypsinogen more prone to proteolytic activation. Hereditary pancreatitis associated with trypsinogen mutation has an autosomal dominant mode of inheritance, as is typically true of disorders associated with gain-of-function mutations. Hereditary pancreatitis can also be caused by loss-of-function mutations in SPINCON, a gene encoding a trypsin inhibitor. Because one functional copy of SPINCON produces sufficient inhibitor to maintain adequate trypsin control, this form of hereditary pancreatitis has an autosomal recessive mode of inheritance. As discussed in detail in Chapter 10, cystic fibrosis is caused by mutations in the cystic fibrosis transmembrane conductance regulator CFTR gene that encodes an apical chloride channel. Loss of CFTR leads to abnormal secretions that promote protein plugging, duct obstruction, and the development of pancreatitis. Disease can occur in those with homozygous and even heterozygous CFTR gene mutations, particularly in patients who also have SPINCON mutations. Of note, patients with PRS-SON-associated hereditary pancreatitis have a 40% lifetime risk of developing pancreatic cancer. Yet another example of the nefarious association between neoplasia and chronic tissue injury and inflammation. Pancreatitis 885, morphology. The morphology of acute pancreatitis ranges from limited inflammation and edema to extensive necrosis and hemorrhage. The basic alterations are 1 microvascular leak and edema, 2 fat necrosis, 3 acute inflammation, 4 damage, including autodigestion, of pancreatic parenchyma, and 5 blood vessel destruction with interstitial hemorrhage. The extent of each of these depends on the duration and severity of disease. In more limited forms of acute interstitial pancreatitis, histologic alterations are limited to mild inflammation, interstitial edema, and focal fat necrosis within the pancreas and the parapancreatic fat Fig. 19.3. Fat necrosis, triggered by lipase activity, leads to saponification, a process in which fatty acids combine with calcium to form insoluble calcium soaps that impart a granular blue microscopic appearance to surviving fat cells. Chapter 2. In acute necrotizing pancreatitis, acini, ducts, and even islets undergo necrosis. In the most severe form, hemorrhagic pancreatitis, extensive parenchymal necrosis is accompanied by intraparenchymal hemorrhage due to vascular injury. This imparts a red-black color with interspersed foci of yellow-white, chalky. Fat necrosis Fig. 19.4. Fat necrosis may also occur in the omentum and the mesentery of the bowel adjacent to the pancreas and beyond the abdominal cavity, such as in the subcutaneous fat. As a result of systemic lipase release, the peritoneal cavity typically contains a serous, slightly turbid, brown-tinged fluid with fat globules that reflect digestion of adipose tissue. Clinical features: abdominal pain is the cardinal manifestation of acute pancreatitis. Characteristically, the pain is constant, intense, and referred to the upper or mid-back and, occasionally, the left shoulder. The severity ranges from mild discomfort to incapacitating pain. Anorexia, nausea, and vomiting are common. Elevated plasma levels of amylase and lipase support the diagnosis of acute pancreatitis, as does the exclusion of other causes of abdominal pain. Severe acute pancreatitis is a medical emergency. Patients usually present with an acute abdomen and systemic findings caused by the release of toxic enzymes, cytokines, and other mediators into the circulation. These activate a systemic. Figure 19.4. The pancreas has been sectioned longitudinally to reveal dark areas of hemorrhage in the head of the pancreas and a focal area of pale fat necrosis in the peripancreatic fat upper left. Inflammatory response, resulting in leukocytosis, disseminated intravascular coagulation, edema, and acute respiratory distress syndrome. Shock, due to the systemic inflammatory response syndrome chapter 4, and acute renal tubular necrosis may occur. Laboratory findings include elevation of serum amylase and lipase levels during the first 4 to 12 hours following the onset of pain. Serum lipase is the most specific and sensitive marker of acute pancreatitis, as serum amylase has a short half-life and may return to normal in 3 to 5 days, whereas lipase levels remain elevated for 8 to 14 days. Glycosuria occurs in 10% of cases, and hypocalcemia may result from saponification of necrotic fat. Direct visualization of the enlarged inflamed pancreas by computed tomography CT scanning is useful in the diagnosis of pancreatitis. Treatment centers on resting the pancreas by total elimination of oral intake and supportive therapy with intravenous fluids and analgesia. Most individuals with acute pancreatitis recover fully, but about 5% with severe acute pancreatitis die in the first week of illness. Acute respiratory distress syndrome and acute renal failure are ominous complications. Possible sequelae include sterile pancreatic abscesses and pancreatic pseudocysts. In 40% to 60% of patients with acute necrotizing pancreatitis, their cellular debris becomes infected, usually by gram-negative organisms from the gut, further complicating the clinical course. Systemic organ failure and pancreatic necrosis are both adverse prognostic indicators. Key concepts: acute pancreatitis. Acute pancreatitis is a form of reversible pancreatic parenchymal injury associated with inflammation. Acute pancreatitis may be caused by excessive alcohol intake, pancreatic duct obstruction, for example, gallstones, genetic factors, for example, PRS-SOM, SPINCOM, CFTR, traumatic injuries, medications, infections, for example, mumps or Coxsackie virus, metabolic disorders leading to hypercalcemia, ischemia. Figure 19.3. The microscopic field shows a region of fat necrosis on the right and focal pancreatic parenchymal necrosis center. 886. Chapter 19. The pancreas. The key feature common to all these causes is that they promote inappropriate activation of digestive enzymes within the pancreas. Clinical features include acute abdominal pain, systemic inflammatory response syndrome, and elevated serum lipase and amylase levels. Chronic pancreatitis. Chronic pancreatitis is defined as prolonged inflammation of the pancreas associated with irreversible destruction of exocrine parenchyma, fibrosis, and, in the late stages, loss of endocrine parenchyma. The prevalence of chronic pancreatitis is between 0.4% and 5%. Most affected patients are middle-aged males. The most common cause of chronic pancreatitis is long-term alcohol use. In addition to alcohol, chronic pancreatitis has been associated with the following conditions: long-standing obstruction of the pancreatic duct by calculi or neoplasms, autoimmune injury, hereditary factors, as discussed above. Up to 25% of chronic pancreatitis has a genetic basis. Pathogenesis: chronic pancreatitis often follows repeated episodes of acute pancreatitis. It has been proposed that acute pancreatitis initiates a sequence of perilobular fibrosis, duct distortion, and altered secretions that, as a result of recurrent injury, leads to loss of exocrine parenchyma and fibrosis. Chronic pancreatic injury of any cause leads to local production of inflammatory mediators that promote fibrosis and acinar cell loss. While there is overlap between the cytokines released during chronic and acute pancreatitis, fibrogenic factors tend to predominate in chronic pancreatitis. These fibrogenic cytokines, including transforming growth factor beta TGF-beta and platelet-derived growth factor PDGF, induce activation and proliferation of pancreatic stellate cells, periacinar myofibroblasts, collagen deposition, and fibrosis. Fig. 19.5. Autoimmune pancreatitis is a pathogenically distinct form of chronic pancreatitis that comes in two distinct forms, each with its own characteristic histopathology. Autoimmune pancreatitis type 1 is associated with the presence of immunoglobulin G4, IgG4, secreting plasma cells in the pancreas, and is one manifestation of a systemic IgG-related disease, chapter 6. In contrast, autoimmune pancreatitis type 2 is restricted to the pancreas with the exception of a subset of patients with ulcerative colitis. Both variants of autoimmune pancreatitis may mimic pancreatic carcinoma, including presentation as a mass lesion in the pancreatic head on imaging. Autoimmune pancreatitis, which responds to steroid therapy, is therefore important to distinguish from neoplasia. Morphology. Chronic pancreatitis is characterized by parenchymal fibrosis, acinar atrophy and dropout, and variable ductal dilation. Fig. 19. 6a. Grossly, the gland is whole, sometimes with visibly dilated ducts containing calcified concretions. These changes are typically accompanied by histologically evident chronic inflammatory infiltrate that surrounds lobules and ducts. Acinar loss is a constant feature, but there is usually relative sparing of the islets of Langerhans, which become embedded in the sclerotic tissue and may fuse and appear enlarged. Ductal epithelium may. Pancreatitis acute. Pancreatitis pancreatic chronic. Activation of inflammatory mediators. Activation of digestive enzymes. Ethanol oxidative stress injury. Collagen secretion ECM remodeling. Proliferation of stellate cells. Inflammation. Vascular injury. Acinar cell injury. Inflammation TGF-beta PDGF. Resolution of pancreatitis. Fibrosis acinar cell loss. Figure 19.5 Comparison of the mediators in acute and chronic pancreatitis. In acute pancreatitis, acinar injury results in release of digestive enzymes, leading to a cascade of events including activation of the clotting cascade, acute and chronic inflammation, vascular injury, and edema. In most patients, complete resolution of the acute injury occurs with restoration of acinar cell mass. In chronic pancreatitis, repeated episodes of acinar cell injury lead to the production of profibrogenic cytokines such as transforming growth factor beta TGF-beta and platelet-derived growth factor PDGF, resulting in myofibroblast proliferation, collagen synthesis, and extracellular matrix ECM remodeling. Repeated injury leads to irreversible loss of acinar cell mass, fibrosis, and exocrine pancreatic insufficiency. 887, a BC figure 19.6 Chronic pancreatitis. Extensive fibrosis and atrophy has left only residual islets top and ducts bottom, with a sprinkling of chronic inflammatory cells and a few islands of acinar tissue. A higher power view demonstrating dilated ducts with inspissated eosinophilic ductal concretions in a person with alcoholic chronic pancreatitis. See example of autoimmune pancreatitis with extensive lymphoplasmacytic infiltrates and storiform fibrotic stroma. In this case, an AG4 stain confirmed abundant AG4 expressing plasma cells. C. Photomicrograph courtesy out of D. Shanghai, University of Pittsburgh Medical Center, Pittsburgh, PA. Eutrophic, hyperplastic, or metaplastic squamous. Chronic pancreatitis caused by alcohol abuse is characterized by ductal dilation and intraluminal protein plugs and calcifications. Fig. 19. 6b. Autoimmune pancreatitis type 1 typically displays swirling or storiform fibrosis, obliterative inflammation of the veins phlebitis, and a dense lymphoplasmacytic inflammation that is enriched in AG4 secreting plasma cells. Fig. 19. 6c. The last mentioned may also be seen in other organs. In contrast, autoimmune pancreatitis type 2 is characterized by neutrophilic infiltrates within the epithelium and lumen of medium-sized pancreatic ducts granulocytic epithelial lesions. While lymphoplasmacytic infiltrates are seen in both variants, type 2 autoimmune pancreatitis lacks the abundant AG4 secreting plasma cells that characterize type 1. Clinical features. Chronic pancreatitis may follow multiple bouts of acute pancreatitis with repeated attacks of mild to moderately severe abdominal pain or persistent abdominal and back pain. Attacks may be precipitated by excessive alcohol consumption, overeating which increases demand on the pancreas, or use of opiates and other drugs that increase sphincter of Auditone. In other patients, the disease may be entirely silent until pancreatic insufficiency and diabetes mellitus develop due to destruction of the exocrine and endocrine pancreas. Diagnosis of chronic pancreatitis requires a high degree of suspicion. During an attack, there may be mild fever and mild to moderate elevations of serum amylase. In chronic disease, however, acinar cell dropout may be so great that this diagnostic clue is absent. Gallstone-induced obstruction may present with jaundice or elevated serum alkaline phosphatase. Visualization of calcifications within the pancreas by CT and ultrasonography can be very helpful. Weight loss due to pancreatic exocrine insufficiency and malabsorption and edema secondary to hypoalbuminemia may also support the diagnosis. Chronic pancreatitis is usually not an immediately life-threatening condition, but the long-term outlook is poor, with a 20 to 25-year mortality rate of 50%. Pancreatic exocrine insufficiency, chronic malabsorption, and diabetes mellitus all can lead to significant morbidity and contribute to mortality. In other patients, severe, chronic pain is a dominant problem. Pancreatic pseudocysts described later develop in about 10% of patients. Patients with hereditary pancreatitis associated with PRS1 mutations have a 40% lifetime risk of developing pancreatic cancer. The risk of pancreatic cancer is only modestly elevated with other forms of chronic pancreatitis. Key concepts. Chronic pancreatitis. Chronic pancreatitis is characterized by irreversible injury of the pancreas leading to fibrosis, loss of pancreatic parenchyma, loss of exocrine and endocrine function, and pseudocyst development. Chronic pancreatitis is most often caused by repeated bouts of acute pancreatitis, chronic alcohol use, germline mutations in genes such as CFTR, the gene encoding the transporter that is defective in cystic fibrosis, particularly when combined with environmental stresses. Pancreatitis. 888 Chapter 19 The pancreas. Chronic pancreatitis may be the manifestation of a systemic or localized autoimmune etiology. Clinical features include intermittent or persistent abdominal pain, intestinal malabsorption, and diabetes. Non-neoplastic cysts. A variety of cysts can arise in the pancreas. Most are non-neoplastic pseudocysts, but congenital cysts and neoplastic cysts also occur. Congenital cysts. Congenital cysts are unilocular, thin-walled cysts that likely result from anomalous pancreatic duct development. They range in size from microscopic to 5 cm in diameter and are lined by a uniform cuboidal epithelium, or, if intracystic pressure is high, flattened and attenuated epithelial cells. Thin, fibrous capsule filled by clear serous fluid typifies congenital cysts that may be sporadic or part of inherited conditions, such as autosomal dominant polycystic kidney disease Chapter 20 and von Hippel, Landau disease Chapter 28. Cysts in the kidney, liver, and pancreas frequently coexist in polycystic kidney disease. In von Hippel, Landau disease vascular neoplasms are found in the retina and cerebellum or brainstem in association with congenital cysts and also neoplasms in the pancreas, liver, and kidney. Pseudocysts. Pseudocysts are formed when areas of intrapancreatic or peripancreatic hemorrhagic fat necrosis are walled off by fibrosis and granulation tissue. These lesions, which account for 75% of all pancreatic cysts, are referred to as pseudocysts because they lack an epithelial lining. Pseudocysts typically arise following a bout of acute pancreatitis, particularly one superimposed on chronic alcoholic pancreatitis. Traumatic injury to the pancreas can also give rise to pseudocysts. While many pseudocysts resolve spontaneously, they may also become secondarily infected, and larger pseudocysts may compress or even perforate into adjacent structures. Morphology. Pseudocysts are usually solitary and may be situated within the pancreas or, more commonly, in the lesser omental sac or in the retroperitoneum between the stomach and transverse colon or between the stomach and liver. They can even be subdiaphragmatic. Fig. 19. 7. Pseudocysts are lined by fibrous tissue and granulation tissue. Fig. 19. 7b and range in size from 2 to 30 cm in diameter. Neoplasms. A broad spectrum of exocrine neoplasms arises in the pancreas. These neoplasms may be cystic or solid. Some are benign, while others are among the most lethal of all. 8b figure 19.7 pancreatic pseudocyst. A cross-section revealing a poorly defined cyst with a necrotic brown-black wall. B. The cyst lacks a true epithelial lining and instead is lined by fibrin and granulation tissue. Malignancies. Endocrine tumors also occur in the pancreas and are discussed in Chapter 24. Cystic neoplasms. Cystic neoplasms are diverse tumors that range from harmless benign cysts to lesions that are precursors to invasive, potentially lethal, cancers. Only 5% to 15% of all pancreatic cysts are neoplastic. Conversely, fewer than 5% of all pancreatic neoplasms are cystic. Sericystic neoplasms are almost always benign, whereas others, such as intraductal papillary mucinous neoplasms and mucinous cystic neoplasms, are precancerous. The genomic landscape of each type of cystic neoplasm is distinct, underscoring differences in pathogenesis and natural history. Sericystic neoplasms usually occur in the tail of the pancreas. Cysts are small 1 to 3 mm and can be solitary, multiple, or present as a honeycomb of microcystic lesions. Sericysts are lined by glycogen-rich cuboidal cells and contain clear, thin, straw-colored fluid. Fig. 19.8. They account for 15% to 25% of all cystic neoplasms of the pancreas and are twice as common in women. Sericystic neoplasms typically present in the 6th to 7th decade of life with nonspecific symptoms such as abdominal pain, but many are detected incidentally during imaging for another indication. Surgical resection is curative in the vast majority of patients. Inactivation of the VHL tumor suppressor gene. Neoplasms 889. 88b figure 19.8 sericystic neoplasms. Sericystadenoma. Cross-section through a microcystic sericystic neoplasm. Only a thin rim of normal pancreatic parenchyma remains. The cysts are relatively small and contain clear, straw-colored fluid. The cysts are lined by cuboidal epithelium without atypium. On chromosome 3 is the most common genetic abnormality in sericystic neoplasms. Close to 95% of mucinous cystic neoplasms arise in women and, in contrast to sericystic neoplasms, they are precursors to invasive carcinomas. These neoplasms usually arise in the tail of the pancreas and present as painless, slow-growing masses. The cystic cavities are larger than those in sericystic neoplasms and are filled with thick, tenacious mucin. The columnar mucin-producing epithelium that lines the cyst is associated with a dense stroma similar to ovarian stroma. Fig. 19.9. The latter frequently expresses estrogen and progesterone receptors as well as other markers of the ovarian stroma, such as inhibin. Surgical resection is curative for non-invasive mucinous cystic neoplasms, but up to 1/3 harbor an invasive adenocarcinoma. Up to 50% of patients with an invasive adenocarcinoma arising in a mucinous cystic neoplasm will succumb to their disease within 5 years. Therefore, early detection and treatment before invasive cancer develops is critical. Mucinous cystic neoplasms harbor oncogenic CRAS mutations in approximately half of cases, while mutations of T53 and SMAD4 are typically observed in invasive neoplasms arising from these cysts. Recently, loss-of-function mutations of RNF43, which encodes an F3 ubiquitin ligase that normally, figure 19.9 pancreatic mucinous cystic neoplasm with low-grade dysplasia. Cross-section through a mucinous multiloculated cyst in the tail of the pancreas. The cysts are large and filled with tenacious mucin. B. The cysts are lined by columnar mucinous epithelium with a dense ovarian stroma. Regulates W&T signaling, have been described in up to 1/3 of mucinous cystic neoplasms. Similar RNF43 mutations also occur in colorectal cancers. Introductal papillary mucinous neoplasms. IPMs are mucin-producing neoplasms that involve the larger ducts of the pancreas. In contrast to mucinous cystic neoplasms, IPM arise more frequently and may and tend to involve the head of the pancreas. Up to 20% are multifocal. Two features are useful in distinguishing IPM from mucinous cystic neoplasms. One, absence of the dense ovarian stroma seen in mucinous cystic neoplasms, and two, involvement of a pancreatic duct. Fig. 19.10. Just as with mucinous cystic neoplasms, IPM can progress to an invasive cancer. Early detection and treatment before progression to invasive cancer is thus critical. Similar to mucinous cystic neoplasms, introductal mucinous papillary neoplasms harbor oncogenic CRAS mutations in approximately 80% of tumors and loss of function RNF43 mutations in up to 50%. P53 and SMA-D4 mutations typically occur only with transition to invasive cancer. Notably, oncogenic mutations of NAS, which encodes the alpha subunit of the stimulatory G protein. 890 Chapter 19 The Pancreas. Pancreatic carcinoma. 8b. Figure 19.10 Introductal papillary mucinous neoplasm. A cross-section through the head of the pancreas showing a prominent papillary neoplasm distending the main pancreatic duct. The neoplasm involves the main pancreatic duct left and extends down into the smaller ducts and ductules right. GS alpha are present in approximately 2/3 of IPM but are not found in other pancreatic cysts. The uncommon solid pseudopapillary neoplasm occurs mainly in young women and due to its large size often presents with abdominal discomfort. As implied by the name, these well-circumscribed neoplasms have solid and cystic components, with the latter filled with hemorrhagic debris. The neoplastic cells grow in solid sheets or, as the name suggests, as pseudopapillary projections and often appear to be poorly cohesive. Activating mutations of CTN and bone beta-catenin are present in nearly all of these tumors, while mutations of CRAS, RNF43, NAS, or VHL characteristic of other pancreatic cystic neoplasms are not observed. Surgical resection is the treatment of choice and proves curative in most patients. Infiltrating ductal adenocarcinoma of the pancreas, more commonly known as pancreatic cancer, is the third leading cause of cancer deaths in the United States, trailing only lung and colon cancers, and has one of the highest mortality rates of any cancer. It was estimated that in 2020 pancreatic cancer would strike approximately 5,760 Americans, virtually all of whom would die of their disease. The 5-year survival rate is a dismal 10%. Precursors to pancreatic cancer. Invasive pancreatic cancers arise from non-invasive precursor lesions referred to as pancreatic intraepithelial neoplasia PAN in Fig. 19.11. These lesions develop in small ducts and are often microscopic, although some, such as the two variants of cystic mucinous neoplasms described above, can be detected macroscopically. Overall, it is thought that greater than 90% of pancreatic cancers arise from PAN, with the remainder arising from cystic lesions. This conclusion is supported by the following observations. The genetic and epigenetic alterations identified in PAN are similar to those found in invasive cancers described later. PAN is often found in pancreatic parenchyma adjacent to infiltrating carcinoma. Corollary of this observation is that while isolated low-grade PAN lesions can be observed in the pancreata of elderly individuals, high-grade PAN, also known as carcinoma in situ, is almost never observed in the absence of an invasive cancer. PAN precedes the development of invasive cancer in genetically engineered mouse models of pancreatic cancer. Isolated case reports have documented individuals with PAN who later developed an invasive pancreatic cancer. The epithelial cells in PAN show dramatic telomere shortening, which may predispose these lesions to accumulate chromosomal abnormalities and progress to invasive carcinoma. Chapter 7. As previously mentioned, PAN is separated into low-grade and high-grade based on key concepts. Cystic neoplasms. Virtually all serous cystic neoplasms are benign. Non-invasive introductal papillary mucinous neoplasms and mucinous cystic neoplasms are almost always curable, but both may progress to invasive, potentially lethal carcinomas. Each of the major cystic neoplasms has a relatively specific mutational profile. Figure 19.11 High-grade pancreatic intraepithelial neoplasia involving a small pancreatic duct. Neoplasms. 891 Morphologic features, which also tend to correlate with the stepwise accumulation of genetic abnormalities. Fig. 19.12 Pathogenesis. As with other carcinomas, pancreatic cancer is the product of complementary mutations and epigenetic alterations that alter the expression of oncogenes and tumor suppressor genes. Most common molecular alterations in pancreatic carcinogenesis are summarized in Table 19.3 and include the following. CRAS chromosome 12 IP is the most frequently altered oncogene in pancreatic cancer, with activating point mutations present in greater than 90% of cases. These result in constitutive activation of RAS, a small, guanosine triphosphate GTP, binding protein enzyme that normally participates in signaling events downstream of growth factor receptors with intrinsic tyrosine kinase activity. Chapters 1 and 7. RAS signaling activates several downstream pathways that augment cell growth and survival, most notably the mitogen-activated protein kinase MAC and P3K/AKT pathways. Chapter 7. CDKN12 chromosome 9 IP is inactivated in 30% of pancreatic cancers through point mutations or homozygous deletions. This complex locus encodes two tumor suppressor proteins chapter 7, 16/K4, a cyclin-dependent kinase inhibitor that antagonizes cell cycle progression, and ARF, a protein that augments the function of the 53 tumor suppressor protein. SMA-D4 chromosome 18 is inactivated in 55% of pancreatic cancers. SMA-D4 encodes a tumor suppressor that plays an important role in signal transduction from the TGF-beta family of cell surface receptors. SMA-D4 is only rarely inactivated in other cancer types. T53 chromosome 17 is inactivated in 70% to 75% of pancreatic cancers. This gene encodes the tumor suppressor 53, a nuclear DNA-binding protein that can respond to DNA damage by arresting cell growth, inducing cell death or apoptosis, or causing cellular senescence chapter 7. Also seen are less common mutations that affect genes involved in DNA repair or regulation of chromatin structure. Table 19.3. In addition, other work has identified pathogenic epigenetic changes, which together with the aforementioned genetic changes produce several distinct molecular subtypes of pancreatic cancer. DNA methylation epigenetic abnormalities. DNA methylation abnormalities are widespread in pancreatic cancer. For example, promoter hypermethylation causes transcriptional silencing of tumor suppressor genes including CDKN12A. Inversely, promoter hypomethylation leads to overexpression of oncogenes such as JTS6 and BRD4. Transcriptomic profiles in pancreatic cancer subtypes. Global analyzers of gene expression have identified two distinct pancreatic cancer subtypes, termed basal-like and classical. Basal-like pancreatic cancers are highly aggressive, whereas the classical subtype has a somewhat more favorable prognosis. How these subtypes respond differentially to specific therapies is an area of active investigation. Epidemiology and inheritance. Pancreatic cancer is primarily a disease of older adults, with 80% of cases occurring after age 60. The incidence is increased in African Americans, Japanese Americans, Native Hawaiian Islanders, and Ashkenazi Jews. The strongest environmental influence is cigarette smoking, which doubles the risk of pancreatic cancer. Chronic pancreatitis is an additional risk factor that may reflect the association between chronic inflammation, tissue repair, and neoplasia. Pancreatic cancer risk is also greater in those with visceral obesity and high body mass index. Diabetes mellitus is also a modest risk factor. Conversely, new-onset diabetes mellitus may be the first indication of an occult pancreatic cancer in older patients. Abnormal glucose tolerance or frank diabetes is present in as many as half of pancreatic cancer patients up to 3 years before clinical signs of cancer appear. Thus, the appearance of diabetes may present an opportunity for early diagnosis of pancreatic cancer. Approximately 10% of patients with pancreatic cancer have a deleterious germline mutation in a cancer predisposition gene, table 19, or report one or more first-degree relatives with pancreatic cancer. BRCA1 mutations are the normal low-grade, high-grade invasive carcinoma, telomere shortening activating CRAS mutations, inactivation of CDKN12, inactivation of T53, SMA-D4, BRCA1, figure 19.12 model for the progression from normal ducts far left through low, and high-grade pancreatic intraepithelial neoplasia center to invasive carcinoma far right. Telomere shortening and mutations of the oncogene CRAS are the earliest discernible alterations in multi-step progression, followed by inactivation of the CDKN12 tumor suppressor gene that encodes the cell cycle regulator 16. Inactivation of the T53, SMA-D4, and BRCA1 tumor suppressor genes occurs in high-grade pancreatic intraepithelial neoplasia that precedes invasive cancer. It is important to note that while there is a general temporal sequence of changes, the accumulation of multiple mutations is more important than their occurrence in a specific order. 892 Chapter 19 The Pancreas. Somatic molecular alterations in pancreatitis inrited 19 ductal adenosinoto. Percentage of cases with genetic alteration. Oncogenes frequency includes point mutations and amplifications. CRAS 12-IP 90% GTP binding enzyme in. Growth factor signal transducer. AKT4 19 6% growth factor. Signal transducer. MYC8 5% transcription. Factor. GT6 18 9% transcription. Factor. FGFR 8 5% growth factor. Receptor. BRAF7 3% serine threonine. Kinase. Regulates. ACT signaling. Tumor suppressor genes frequency includes point mutations and homozygous deletions. 16/9 of 30% negative cell cycle. CDKN12 regulator. T53 17 75% response to DNA damage. SMA-D4 18 55% TGF-beta pathway. BRCA1 13 4% DNA damage. Response. ATM 11 5% DNA damage. Response. ARI done 1 6% chromatin. Regulator. MLL3/7 4% chromatin. AMT12C regulator. KDM6XP 3% chromatin. Regulator. A frequency of alterations abstracted from the Cancer Genome Atlas Research Network. Integrated molecular characterization of pancreatic ductal adenocarcinoma. Cancer cell 32-2. 185. 203. E13. 2017. GTP. Guanosine triphosphate. MAP. Mitogen activated protein kinase. TGF-beta. Transforming growth factor beta gene function. Chromosomal region gene. Most common known cause of familial pancreatic cancer. Germline mutations and other genes that are linked to hereditary breast and ovarian cancer BRCA and CALB12, ATM are also associated with a 4 to 10-fold elevated risk. With the availability of therapeutic agents that specifically target cancers with DNA repair defects, most commonly BRCA1 or BRCA1 mutations, germline testing is now recommended for all patients with pancreatic cancer. Patients with defects in DNA mismatch repair genes who have hereditary non-polyposis colorectal cancer are also at increased risk for pancreatic cancer. Identification of microsatellite instability. The molecular signature of DNA mismatch repair in Table 193. 4. Disorder Peutz-Jeghers syndrome, hereditary pancreatitis. Familial atypical multiple mole melanoma syndrome, strong family, history 3 or more relatives, with pancreatic cancer, hereditary breast and ovarian cancer, hereditary non-polyposis colorectal cancer. Pancreatic cancer is also therapeutically important, as such cancers are more likely to respond to immune checkpoint therapy. Morphology. Approximately 60% of pancreatic cancers arise in the head, 15% in the body, and 5% in the tail. In 20% of cases, the entire pancreas is involved. The vast majority of pancreatic neoplasms are adenocarcinomas that recapitulate normal ductal epithelium by forming glands and secreting mucin. Two features are characteristic. One, these cancers are highly invasive, often extending into parapancreatic tissues. And two, they elicit an intense desmoplastic response that results in the deposition of dense collagen. As a result of these characteristics, most pancreatic cancers are hard, stellate, gray-white, poorly defined masses Fig. 19, 13. Most carcinomas of the head of the pancreas obstruct the style common bile duct, resulting in distension of the biliary tree in about 50% of patients. In contrast, carcinomas of the pancreatic body and tail do not impinge on the biliary tract and may be large and widely disseminated at diagnosis. Pancreatic cancers tend to grow along nerves and invade into blood vessels in the retroperitoneum. The spleen, adrenals, transverse colon, and stomach are often involved by direct invasion, and parapancreatic, gastric, mesenteric, omental, and portohepatic lymph nodes are frequently involved. Perineural, lymphatic, and large vessel invasion are common. Distant metastases are principally to the liver and lungs. Microscopically, carcinomas of the head, body, and tail of the pancreas are indistinguishable. They form abortive tubular structures or cell clusters with an aggressive, deeply infiltrative growth pattern. Predisposition: pancreatic cancer table. Increased risk of pancreatic cancer. Gene fold. SD Kelvin 130. Risk of pancreatic cancer by age 70%, 30, 60. PRS zone, spin cone 50, 80, 25, 40, 20, 35, 10, 17. CDKN12A, unknown 410, 32, 8, 16, 4, 10, 5, multiple, including BRCAN, BRCA1, PAL-B12, 810, multiple, including ML-home, MSH-RO, PMS-RO, 8, 10, 4, neoplasms 893, 8B figure 19.13 carcinoma of the pancreas. Cross-section through the tail of the pancreas showing normal pancreatic parenchyma and a normal pancreatic duct left and a pale mass centered on the duct right. The poorly formed glands composed of malignant epithelial cells are dispersed within densely fibrotic stroma. Some inflammatory cells are also present. Fig. 1913b. The poorly formed malignant glands are lined by pleomorphic cuboidal to columnar epithelial cells. It can, however, occasionally be difficult to discriminate between well-differentiated carcinomas and benign glands with epithelial atypia and stromal fibrosis that are common in chronic pancreatitis. Intense desmoplasia elicited by pancreatic cancers can also interfere with diagnostic interpretation of needle biopsies, regardless of tumor differentiation, as much of the tumor mass is non-neoplastic. Less common morphologic variants of pancreatic cancer include adenosquamous carcinomas, colloid carcinoma, hepatoid carcinoma, medullary carcinoma, signet ring cell carcinoma, undifferentiated carcinoma, and undifferentiated carcinoma with osteoclast-like giant cells. Clinical features: carcinomas of the pancreas typically remain silent until they cause obstruction or invade into adjacent structures. Pain is usually the first symptom, but by the time pain appears, these cancers are usually beyond cure. Obstructive jaundice is associated with most cases involving the pancreatic head, as these tend to block the common bile duct. This is exemplified by the Courvoisier sign, a palpably enlarged, non-tender gallbladder with mild painless jaundice. Weight loss, anorexia, and generalized malaise and weakness are often signs of advanced disease. Migratory thrombophlebitis, known as the Trousseau sign, occurs in about 10% of patients and is attributable to the elaboration of platelet activating factors and procoagulants from the carcinoma or its necrotic products. Chapter 4. Sadly, Armand Trousseau 1801, 1867, physician at Hotel Dieu, Paris, for whom this sign is named, correctly suspected that he had carcinoma when he developed spontaneously appearing and disappearing migratory thrombosis. Survival after diagnosis of advanced pancreatic carcinoma is typically short. Greater than 80% of pancreatic cancers are unresectable at the time of diagnosis due to invasion of vessels and other structures or distant metastasis. In contrast, patients who undergo successful resection are increasingly surviving longer, some greater than 5 years, underscoring the critical importance of early detection. To facilitate diagnosis when pancreatic cancers are resectable, many have sought tests that could be used for early detection. Although serum levels of several antigens, for example, Carcinoma bronic antigen and C-adenine antigen are often elevated in individuals with pancreatic cancer and can be useful in following individual patients' response to treatment. These markers lack the specificity and sensitivity needed for tests applied to larger populations. Although imaging techniques such as endoscopic ultrasonography and CT can be used to establish the diagnosis, they are not useful as screening tests. Thus, the U.S. Screening and Prevention Task Force (USP) does not currently recommend screening the general population for pancreatic cancer due to the overarching concern for false positives and potential harm. Screening is, however, recommended for individuals who harbor deleterious germline mutations, Table 19, that place them at increased risk for pancreatic cancer. Key concepts: pancreatic carcinoma. Pancreatic cancer is one of the most aggressive of the solid cancers. Cigarette smoking is a significant cause of pancreatic cancer. Cancer-causing germline mutations are present in 10% of patients. Invasive pancreatic cancer arises from histologically well-defined precursor lesions, the most common of which is pancreatic intraepithelial neoplasia (PAN-N). Ductal adenocarcinomas are highly invasive and elicit an intense desmoplastic response. The genes most frequently mutated or otherwise altered in pancreatic cancer include CRAS, 16/CDKN12A, T53, and SMAD4. Transcriptional profiles can be used to define the highly aggressive, basal-like and somewhat less aggressive classical subtypes. Patients often present with abdominal pain and weight loss, sometimes accompanied by jaundice and deep vein thrombosis. No-onset diabetes is detected in up to half of cases. Acinar cell carcinoma. Like normal acinar cells, acinar cell carcinomas form zymogen granules and produce exocrine enzymes such as trypsin and lipase. Up to 15% of those with acinar cell carcinoma develop metastatic fat necrosis syndrome due to lipase release. Chapter 19: The pancreas. Into the circulation. Acinar cell carcinomas demonstrate aberrant W&T pathway activation due to either loss-of-function mutations of the APC tumor suppressor gene or activating point mutations of CTNN bone, which encodes beta-catenin. Pancreatoblastoma. Pancreatoblastomas are rare neoplasms that occur primarily in children 1 to 15 years of age. They have a distinct microscopic appearance consisting of squamous islands admixed with acinar cells. They are malignant, but survival is better than with pancreatic ductal adenocarcinomas. Like acinar cell carcinoma, pancreatoblastomas frequently harbor mutations that activate the W&T signaling pathway. Suggested readings: congenital anomalies, Standard BZ, Hebrock M, control of cell identity in pancreas development and regeneration, gastroenterology 410 for 1170. 1179, 2013. Review of the normal development of the pancreas and how development explains anomalies. Acute pancreatitis for Smart C, Veach SS, Wilcox CM, acute pancreatitis, in Angle J, Med 37, 1972, 1981, 2017. Clinically oriented authoritative overview of acute pancreatitis, especially guidelines for classification and management. Kangar, Lassie Mount, ZHJ et al. Cell death and dampen acute pancreatitis, Med 2046-6, 477, 2014. Mechanistic review of acute pancreatitis highlighting how local tissue damage translates into the systemic inflammatory response that is characteristic of severe disease. Bankish PG, Apt-M, Banks PA, acute pancreatitis, Lancet 38-685, 96, 2015. Another clinically oriented review of acute pancreatitis, this time with more of an international focus. Mauser R, Wickham DC, Genetics of Acute and Chronic Pancreatitis, Kerr-Op and Gastroenterol 2954, 551, 2013. Review of genetic factors that predispose to acute pancreatitis and recurrent acute pancreatitis leading to chronic pancreatitis from one of the leading experts in this area. Chronic pancreatitis, Hart PA, ZNY, Shari Saint, Recent Advances in Autoimmune Pancreatitis, Gastroenterology 4939, 51, 2015. Review of this uncommon entity including the two subtypes autoimmune pancreatitis, clinical and imaging features, and management. EGE, Scientoth M, Genetic Risk in Chronic Pancreatitis, the trypsin-dependent pathway, Big Dis size 62-6092, 1701, 2017. Mechanistic review that ties together how mutations in genes responsible for trypsin homeostasis lead to chronic pancreatitis. Leave J, Wickham DC, Shimoskawa T et al., Chronic Pancreatitis, Nat Reverend Dis Primers 31760, 2017. The Primer series is wonderful for a quick one-stop shop overview of any entity, for example, chronic pancreatitis. All the authors are world-renowned experts in this area. Maginder S., Shari Saint, Chronic Pancreatitis, Lancet 38-7-1957, 1966, 2016. Excellent treatise on pathophysiology, mechanisms, and management of chronic pancreatitis, 894. Pseudocysts Corpel G. Pseudocysts and other non-neoplastic cysts of the pancreas, Semen Die in Pathos 17, 7, 15, 2000. Discussion of pseudocysts by a leading expert in pancreatic pathology. Cystic neoplasms Basterco, Hong SM, Wood LD et al., a revised classification system and recommendations from the Baltimore Consensus Meeting for Neoplastic Precursor Lesions in the Pancreas, and J. Patho 39 1730, 1741, 2015. Guidelines defining the diagnostic criteria and dysplasia grading in the common precursor lesions of pancreatic cancer. Singhai A.D., McGrath K., Brandry et al. Preoperative next-generation sequencing of pancreatic cyst fluid is highly accurate in cyst classification and detection of advanced neoplasia. Gut 2017. Outstanding example of how molecular pathology is integrated into the diagnostic algorithm of the management of pancreatic cysts to differentiate conservative management versus surgery. Springer S. Maskett D.L. Dalmolin M. et al. A multimodality test to guide the management of patients with a pancreatic cyst. Sci-Trans Med 11, GF 1772, 2019. Real-world application of molecular assays in pancreatic cyst fluid to classify the underlying cyst type in the pancreas. Tanaka M., Fernandez del Castillo C., Kamisawa T. et al. Revisions of International Consensus Fukuoka Guidelines for the Management of IPM of the Pancreas. Pancreatology 1773, 753, 2017. Guidelines on the clinical management of cysts. Wu J. Jio Y. Dalmolin M. et al. Whole exome sequencing of neoplastic cysts of the pancreas reveals recurrent mutations and components of ubiquitin-dependent pathways. Procnatal Cat Sci USA 10-821-188, 21193, 2011. Sequencing the exomes of the most common cystic neoplasms of the pancreas reveals a mutation profile specific for each type of cyst. Pancreatic Carcinoma Cancer Genome Atlas Research Network. Integrated Genomic Characterization of Pancreatic Ductal Adenocarcinoma. Cancer Cell 32 18th, 203, 2017. Definitive article on molecular characterization of pancreatic cancer using multiple platforms and integrative data analysis. Shari Saint, Kelly K., Hollingsworth M. et al. Early Detection of Pancreatic Cancer. A summative review. Pancreas 4469-3. 712, 2015. Roadmap for early detection approaches in pancreatic cancer that also highlights the importance of new-onset diabetes as an avenue for enriching for patients at risk for this cancer. UC, Hartnesen, Holly C. et al. Association between inherited germline mutations and cancer predisposition genes and risk of pancreatic cancer. JAMA 1924, 2409, 2018. Largest case control series on identifying deleterious germline mutations that correlate with risk of pancreatic cancer. Cleve J. Cork M. App M. et al. Pancreatic cancer. Nat Reverend Disprim 21622, 2016. A relatively comprehensive review on pathology, genetics, clinical features, and treatment of pancreatic cancer. Neil Palimos J.P., Cleve J., Mitchell P. et al. Therapeutic developments in pancreatic cancer. Current and future perspectives. Nat Reverend Gastroenteral Hepatol 1533-3. 348, 2018. Clinically oriented review on recent advances in treatment options for localized and metastatic pancreatic cancer and emerging therapies like immunotherapies. Ing H. P. Gao W. et al. Genetics and Biology of Pancreatic Ductal Adenocarcinoma. Genes Dev 3035, 385, 2016. Exhaustive review of molecular aberrations in pancreatic cancer, both genomic and non-genomic, and potential translational implications. See targeted therapy available online at www.studentconsult.com. CHA-PTE, or The Kidney Chapter, 20. Anthony Chang's Olden G. Last Psychite 195. Contents. Clinical manifestations of renal diseases 896, glomerular diseases 897, structure of the glomerulus 898, pathologic responses of the glomerulus to injury 900, hypercellularity 900, basement membrane thickening 900, hyalinosis and sclerosis 900, pathogenesis of glomerular injury 901, diseases caused by in situ formation of immune complexes 901, disease caused by antibodies directed against normal components of the glomerular basement membrane 901, glomerulonephritis resulting from deposition of circulating immune complexes 903, mechanisms of glomerular injury following immune complex formation 903, cell-mediated immunity and glomerulonephritis 904, activation of alternative complement pathway 904, mediators of glomerular injury 904, epithelial cell injury 905, mechanisms of progression in glomerular diseases 905, tubular injury and interstitial fibrosis 906, nephritic syndrome 906, acute proliferative post-infectious and infection-associated glomerulonephritis 906, chronic rapidly progressive glomerulonephritis 909, nephrotic syndrome 911, membranous nephropathy 912, minimal change disease 914, focal segmental glomerulosclerosis 914, HIV-associated nephropathy 917, membranoproliferative glomerulonephritis 917. Secondary membranoproliferative glomerulonephritis 918, dense deposit disease 918, fibrillary glomerulonephritis 920, other glomerular diseases 920, IgA nephropathy, Burgett disease 920, hereditary nephritis 922, Alport syndrome 922, thin basement membrane nephropathy, benign familial hematuria 922, glomerular lesions associated with systemic diseases 923, lupus nephritis 923, Henoch-Schönlein purpura 923, diabetic nephropathy 923, other systemic disorders 923, 923 tubular and interstitial diseases, 924 acute tubular injury/necrosis, 924 tubular interstitial nephritis, 926 pyelonephritis and urinary tract infection, 927 acute pyelonephritis, 928 chronic pyelonephritis and reflux nephropathy, 930 tubular interstitial nephritis induced by drugs and toxins, 931 acute drug-induced interstitial nephritis, 932 other tubular interstitial diseases, 933 urate nephropathy, 933 hypocalcemia and nephrocalcinosis, 933 autosomal dominant tubular interstitial kidney disease, 934 light chain cast nephropathy, myeloma kidney, 934 bile cast nephropathy, 935 vascular diseases, 935 nephrosclerosis, 935 renal artery stenosis, 936 thrombotic myocardiopathies, 937 typical epidemic, classic, diarrhea positive hemolytic uremic syndrome, 938 atypical non-epidemic, diarrhea negative hemolytic uremic syndrome, 938 thrombotic thrombocytopenic purpura, 939 other vascular disorders, 939 atherosclerotic ischemic renal disease, 939 atherombotic renal disease, 939 sickle cell nephropathy, 940 renal infarcts, 940 congenital and developmental anomalies, 940 cystic diseases of the kidney, 941 autosomal dominant adult polycystic kidney disease, 941 autosomal recessive childhood polycystic kidney disease, 943 cystic diseases of the renal medulla, 944 medullary sponge kidney, 944 nephronophthises, 944 multicystic renal dysplasia, 944 acquired cystic disease, 945 simple cysts, 945 urinary tract obstruction, obstructive uropathy, 945 urolithiasis, renal calculi, stones, 947 neoplasms of the kidney, 948 benign neoplasms, 948 renal papillary adenoma, 948 angiomyolipoma, 948 oncocytoma, 948 malignant neoplasms, 948 renal cell carcinoma, 948 urothelial carcinoma of the renal pelvis, 951 869 twintyroid K-chap iden. What is a human but an ingenious machine designed to turn, with infinite artfulness, the red wine of Shiraz into urine? So said the storyteller in Isaac Dyson's 7 Gothic Tales. More accurately but less poetically, human kidneys serve to convert more than 1,700 L of blood per day into about 1 L of a highly concentrated fluid called urine. In so doing, the kidney excretes the waste products of metabolism, precisely regulates the body's concentration of water, salt, calcium, phosphorus, and other anions and cations, and maintains the appropriate acid-base balance of plasma. The kidney also serves as an endocrine organ, secreting such hormones as erythropoietin, renin, and prostaglandins, and regulating vitamin D metabolism. Physiologic mechanisms that the kidney has developed to carry out these functions require a high degree of structural complexity. Renal diseases are responsible for a great deal of morbidity and mortality. According to the 2015 U.S. Renal Data System Annual Data Report, more than 66,000 Americans had end-stage renal disease (SID), of whom 2/3 are maintained on dialysis, at a cost of approximately $72,000 per person annually. The one-year mortality rate of SID, when the enhanced risk for cardiovascular disease conferred by SID is considered, exceeds that of most newly diagnosed cancers. Acute kidney injury occurs in more than 2 million people worldwide, and it is a major risk factor for the development of chronic kidney disease and SID. In addition, millions of people are affected annually by non-fatal kidney diseases, most notably infections of the kidney or lower urinary tract, kidney stones, and urinary obstruction. The availability of dialysis and the success of renal transplantation have improved the outlook for patients. The study of kidney diseases is facilitated by dividing them into those that affect the 4 basic morphologic components: glomeruli, tubules, interstitium, and blood vessels. This approach is useful because the early manifestations of disease affecting each of these components tend to be distinct. Further, some components seem to be more vulnerable to specific forms of renal injury. For example, most glomerular diseases are immunologically mediated, whereas tubular and interstitial disorders are frequently caused by toxic or infectious agents. However, some disorders affect more than one structure, and the anatomic and functional interdependence of the components of the kidney means that damage to one usually secondarily affects the others. Primary disorders of the blood vessels, for example, inevitably affect all structures that be these vessels. Severe glomerular damage impairs the flow through the peritubular vascular system. Conversely, tubular destruction, by increasing intraglomerular pressure, induces glomerular injury. Thus, whatever the origin, all forms of chronic kidney disease ultimately damage all 4 components of the kidney, culminating in what are called end-stage kidneys. The functional reserve of the kidney is large, and much damage may occur before there is evident functional impairment. For these reasons, recognizing the early signs and symptoms is of particular clinical importance. Clinical manifestations of renal diseases. The clinical manifestations of renal disease can be grouped into reasonably well-defined syndromes. Some are uniquely glomerular diseases, and others are present in diseases that affect any one of the components. Azotemia is a biochemical abnormality that refers to an elevation of blood urea nitrogen BUN and creatinine levels, and is related largely to a decreased glomerular filtration rate GFR. Azotemia is a consequence of many renal disorders, but it also arises from extrarenal disorders. It is a typical feature of both acute and chronic kidney injury. Prerenal azotemia is encountered when there is hypoperfusion of the kidneys that impairs renal function in the absence of parenchymal damage. It may be caused by hypotension, excessive fluid losses from any cause, or if the effective intravascular volume is decreased due to shock, volume depletion, congestive heart failure, or cirrhosis of the liver. Postrenal azotemia is seen whenever urine flow is obstructed distal to the kidney. Relief of the obstruction is followed by correction of the azotemia. When azotemia leads to clinical signs and symptoms associated with biochemical abnormalities, it is termed uremia. Uremia is characterized not only by failure of renal excretory function but also by a host of metabolic and endocrine alterations resulting from renal damage. Uremic patients frequently manifest secondary involvement of the gastrointestinal system, for example, uremic gastroenteritis, peripheral nerves, for example, peripheral neuropathy, and heart, for example, uremic fibrinous pericarditis. Nephritic syndrome is a clinical entity caused by inflammatory glomerular disease and is dominated by the acute onset of either grossly visible hematuria, red blood cells in urine, or microscopic hematuria with dysmorphic red cells and red cell casts on urinalysis, diminished GFR, mild to moderate proteinuria, and hypertension. It is the classic presentation of acute post-streptococcal glomerulonephritis. Rapidly progressive glomerulonephritis, or PGN, is a form of nephritic syndrome in which there is rapid decline in GFR within hours to days. Nephrotic syndrome, also due to glomerular disease, is characterized by heavy proteinuria more than 3.5 g/day, hypoalbuminemia, severe edema, hypolipidemia, and lipoduria, lipid in the urine. The clinical features of nephritis and the nephrotic syndrome are discussed in more detail later. Asymptomatic hematuria or proteinuria, or a combination of these two, is usually a manifestation of subtle or mild glomerular abnormalities. Acute kidney injury, previously called acute renal failure, is characterized by rapid decline in GFR within hours to days with concurrent dysregulation of fluid and electrolyte balance, and retention of metabolic waste products normally excreted by the kidney, including urea and creatinine. In its most severe forms, it is manifested by oliguria or anuria, reduced or no urine flow. It can result from glomerular, interstitial, vascular, or acute tubular injury, ATI. Chronic kidney disease, previously called chronic renal failure, is defined as the presence of a diminished GFR that is persistently less than 60 ml/minute/173 m12 for at least 3 months, from any cause, and / or persistent albuminuria. It may present with a clinically silent decline in renal excretory function in milder forms or with prolonged symptoms and signs of uremia in more severe cases. It is the end result of all chronic renal parenchymal diseases. In end-stage renal disease, the GFR is less than 5% of normal. This is the terminal stage of uremia. Renal tubular defects are dominated by polyuria, excessive urine formation, nocturia, and electrolyte disorders, for example, metabolic acidosis. They are the result of diseases that either directly affect tubular structures, for example, the nephronophthises, or cause defects in specific tubular functions. The latter can be inherited, for example, familial nephrogenic diabetes, cystinuria, renal tubular acidosis, or acquired, for example, lead nephropathy. Urinary tract obstruction and renal tumors have very clinical manifestations based on the specific anatomic location and nature of the lesion. Urinary tract infection is characterized by bacteriuria, impuria, bacteria, and leukocytes in the urine. The infection may be symptomatic or asymptomatic, and it may affect the kidney pyelonephritis or the bladder cystitis. Nephrolithiasis, renal stones, is manifested by spasms of severe pain, renal colic, and hematuria, often with recurrent stone formation. Chronic kidney disease is estimated to affect 11% of all adults in the United States, with a particular predominance among older adults. It is the end result of a variety of renal diseases, but most commonly diabetes and hypertension, and the major cause of death from renal disease. The evolution from normal renal function to symptomatic chronic kidney injury progresses through a series of stages that are defined by measures of serum creatinine, from which estimates of reduction in GFR are derived. Chronic kidney disease causes significant systemic abnormalities, which are listed in Table 20.1. 20. 1-Drony-D-kinase principal systemic manifestations of CH table. 197 Cs and E or A. Fluid and electrolytes. Dehydration, edema, hyperkalemia, metabolic acidosis. Calcium phosphate and bone. Hypophosphatemia, hypocalcemia, secondary hyperparathyroidism, renal osteodystrophy. Hemorrhagic, anemia, bleeding, diaphysis. Cardiopulmonary. Hypertension, congestive heart failure, cardiomyopathy, pulmonary edema, uremic pericarditis. Gastrointestinal. Nausea and vomiting, bleeding, esophagitis, gastritis, colitis. Neuromuscular. Myopathy, peripheral neuropathy, encephalopathy. Dermatologic. Sallow color, pruritus, dermatitis. Key concepts: clinical manifestations of renal diseases. Azotemia is the biochemical manifestation of acute or chronic kidney injury and is characterized by elevated BUN or alternately by an elevated serum creatinine. It reflects a reduction in GFR. Kidney injury that results in azotemia can be either acute or chronic. Acute kidney injury can be reversible or progress to chronic kidney disease, which is generally irreversible. One major manifestation of kidney injury is the nephrotic syndrome, in which injury to the glomerulus results in abnormal filtration, leading to heavy proteinuria, edema, and metabolic disturbances. Nephritic syndromes are those in which hematuria, azotemia, hypertension, and subnephrotic proteinuria are the major manifestations. Diseases involving the tubules and interstitium may have clinical manifestations of the nephritic syndrome or of specific defects in tubular function or of acute or chronic kidney disease without more specific defining features. Glomerular diseases. Glomerular diseases constitute some of the major problems in nephrology. Glomeruli may be injured by a variety of factors, and in the course of several systemic diseases. Systemic immunologic diseases such as systemic lupus erythematosus SLE, vascular disorders such as hypertension, metabolic diseases such as diabetes mellitus, and some hereditary conditions such as Fabry disease often affect the glomerulus. These are termed secondary glomerular diseases. Disorders in which the kidney is the only or predominant organ involved constitute the various types of primary glomerulonephritis or, because some do not have a cellular inflammatory component, primary glomerulopathy. However, both the clinical manifestations and glomerular histologic changes in primary and secondary forms can be similar. In the following sections, we discuss the normal glomerulus and mechanisms of glomerular injury, and then the various types of primary glomerulopathies. We briefly review the secondary forms covered in other parts of this book. Table 20.2 lists the most common forms of glomerulonephritis that have reasonably well-defined morphologic and clinical characteristics. The clinical manifestations of glomerular disease are clustered into the 5 major glomerular syndromes summarized in Table 20.3. Both the primary glomerulopathies and the systemic diseases affecting the glomerulus can result in these syndromes. Because glomerular diseases are often associated with systemic disorders, mainly diabetes mellitus, SLE, vasculitis, and amyloidosis, in any. Chapter 20, the kidney. 22's table Ditwell table F3 S898. Primary glomerulopathies. Acute proliferative glomerulonephritis. Post-infectious. Other rapidly progressive crescentic glomerulonephritis. Membranous nephropathy. Minimal change disease. Focal segmental glomerulosclerosis. Membranoproliferative glomerulonephritis. Dense deposit disease. Nephropathy. Systemic diseases with glomerular involvement. Systemic lupus erythematosus, diabetes mellitus, amyloidosis, Goodpasture syndrome, microscopic polyarteritis/polyangiitis, granulomatosis with polyangiitis, Henoch-Schönlein purpur. Hereditary disorders. Alport syndrome, thin basement membrane nephropathy, Fabry disease. Patient with manifestations of glomerular disease, it is essential to consider these systemic conditions. Structure of the glomerulus. Many clinical manifestations of glomerular diseases result from perturbations of specific components of the glomerular tuft. So before discussing these diseases, we describe the key anatomic structures of glomeruli. The glomerulus consists of an anastomosing network of capillaries lined by fenestrated endothelium invested by 2 layers of epithelial cells. Fig. 20.1. The visceral epithelial cells, commonly referred to as podocytes, are incorporated into and become an intrinsic part of the capillary wall, separated from endothelial cells by a basement membrane. The parietal epithelium, situated on the Bowman capsule, lines the urinary space, the cavity in which plasma filtrate first collects. The glomerular capillary wall is the filtering membrane and consists of the following structures. Fig. 20.2. There is a thin layer of fenestrated endothelial cells, with each fenestra being about 70 to 100 nm in diameter. Manifestations of glomerular diglomerular. Manifestations: hematuria, azotemia, variable proteinuria, oliguria, edema, and hypertension. Acute nephritis, proteinuria, and acute renal failure. 3-5. D/day proteinuria, hypoalbuminemia, hypolipidemia, lipoduria. Azotemia, uremia progressing from months to years. Glomerular hematuria and / or subnephrotic proteinuria clinical. Xerocesis. A. Syndrome, nephritic syndrome, rapidly progressive glomerulonephritis, nephrotic syndrome, chronic kidney disease, isolated urinary abnormalities. Glomerular basement membrane GBM with a thick electron-dense central layer, the lamina densa, and thinner electron-lucent peripheral layers, the lamina rara interna and lamina rara externa. The GBM consists of collagen, mostly type Roman 4, laminin, polyanionic protoglycans, mostly heparin sulfate, fibronectin, intactin, and several other glycoproteins. Type Roman 4 collagen forms a network superstructure to which other glycoproteins attach. The building block monomer of this network is a triple helical molecule composed of one or more of 6 types of alpha chains, alpha 1 to alpha 6, or COL4A and a COL4A6. Each molecule consists of a 7s domain at the N terminus, a triple helical domain in the middle, and a globular non-collagenous N-cone domain at the C terminus. The N-cone domain is important for helix formation and for assembly of collagen monomers into the basement membrane superstructure. Glycoproteins laminin, intactin, and protoglycans heparin sulfate, prolicin attached to the collagenous superstructure. The biochemical properties of these structural components are critical to understanding glomerular diseases. For example, antigens in the N-cone domain are the targets of antibodies in anti-GBM nephritis. Genetic defects in the alpha chains underlie some forms of hereditary nephritis, and the protoglycan content of the GBM may contribute to its permeability characteristics. Visceral epithelial cells, podocytes, possess interdigitating processes embedded in and adherent to the lamina rara externa of the basement membrane. See Fig. 20.1. Adjacent foot processes are separated by 20 to 30 nm wide filtration slits, which are bridged by a thin diaphragm. See Fig. 22. The entire glomerular tuft is supported by the mesangium, the tissue that lies between the capillaries and is composed of basement membrane, like mesangial matrix that forms a meshwork in which the mesangial cells are embedded. See Fig. 20.1. These cells, of mesenchymal origin, are contractile, phagocytic, and capable of proliferation, of laying down both matrix and collagen, and of secreting several biologically active mediators. Biologically, they are most akin to vascular smooth muscle cells and parasites. They are important in many forms of glomerulonephritis. The normal glomerulus is highly permeable to water in small solutes because of the fenestrated nature of the endothelium, and it is impermeable to proteins of the size of albumin tilde 3. 6 nm radius, 70 kilodaltons kd molecular weight or larger. The permeability characteristics of the glomerular filtration barrier allow discrimination among various protein molecules, depending on their size. The larger, the less permeable and charged, the more cationic, the more permeable. The size and charge-dependent barrier function is accounted for by the structure of the capillary wall. The charge-dependent restriction is important in the virtually complete exclusion of albumin from the filtrate because albumin is an anionic molecule. The visceral epithelial cell is important for the maintenance of glomerular barrier function. Its slit diaphragm presents a size-selective distal diffusion barrier to the filtration of proteins, and this cell type is largely responsible, under normal circumstances, for synthesis of GBM components. Proteins located in the slit diaphragm are present in assemblies of molecules within visceral epithelial cells. Disease is 899. A. Glomerulus, capillary loops. Urinary space mesangium, red cell proximal tubule, urinary space, parietal epithelium, mesangial cell mesangial matrix, fenestrian endothelium, capillary lumen parietal epithelium, basement membrane, visceral epithelium. B. Foot processes basement endothelium, membrane red blood cell, foot processes. Figure 20.1 a low-power electron micrograph of renal glomerulus. CL, capillary lumen, visceral epithelial cells with foot processes, and endothelium, mesangium. These schematic representation of a glomerular lobe. 8. Courtesy Dr. Vicky Kelly, Brigham and Women's Hospital, Boston, Mass. Glomerular, 900 Chapter 20 The kidney. Pathologic responses of the glomerulus to injury. Figure 20.2 glomerular filter consisting from bottom to top of fenestrated endothelium, basement membrane, and foot processes of epithelial cells. Note the filtration slits, arrows, and diaphragm between the foot processes. Note also that the basement membrane consists of a central lamina densa, sandwiched between two looser layers, the lamina rara interna and lamina rara externa. Courtesy Dr. Helmut Brandt, Brigham and Women's Hospital, Boston, Mass. That are attached to the slit diaphragm are illustrated in Fig. 20.3. Nephrin is a transmembrane protein with a large extracellular portion made up of immunoglobulin egg-like domains. Nephrin molecules extend toward each other from neighboring foot processes and dimerize across the slit diaphragm. Within the cytoplasm of the foot processes, nephrin forms molecular connections with podosin, CD12-associated protein, and ultimately the actin cytoskeleton of the visceral epithelial cells. More slit diaphragm proteins continue to be identified, and comprehensive descriptions of their structure and interactions have been published. The importance of the slit diaphragm proteins in maintaining glomerular permeability is demonstrated by the observation that mutations in the genes encoding them give rise to defects in permeability and the nephrotic syndrome discussed later. Podocyte foot processes, actin filaments, CD12 nephrin molecules, filtration, slit podosin, basement membrane, endothelium fenestrated. Figure 20.3 is simplified schematic diagram of some of the best studied proteins of the glomerular slit diaphragm. CD12-associated protein. Various types of glomerulopathies are characterized by one or more of four basic tissue reactions. Hypercellularity. Some inflammatory diseases of the glomerulus are characterized by an increase in the number of cells in the glomerular tufts. This hypercellularity results from one or more of the following: proliferation of mesangial or endothelial cells, infiltration of leukocytes, including neutrophils, monocytes, and, in some diseases, lymphocytes. The combination of infiltration of leukocytes and swelling and proliferation of mesangial and or endothelial cells is often referred to as endocapillary proliferation. Formation of crescents. These are accumulations of cells composed of proliferating glomerular epithelial cells and infiltrating leukocytes. The epithelial cell proliferation that characterizes crescent formation occurs following an immune/inflammatory injury involving the capillary walls. Plasma proteins leak into the urinary space, where it is believed that exposure to procoagulants such as tissue factor leads to fibrin deposition. Activation of coagulation factors such as thrombin is suspected of being a trigger for crescent formation, but the actual mechanisms are still poorly understood. Molecules that have been implicated in recruitment of leukocytes into crescents include multiple pro-inflammatory cytokines, basement membrane thickening by light microscopy. This change appears as thickening of the capillary walls, best seen in sections stained with periodic acid, SCIF-PAS. By electron microscopy, such thickening takes one of three forms: deposition of amorphous electron-dense material, most often immune complexes, on the endothelial or epithelial side of the basement membrane or within the GBM itself. Fibrin, amyloid, cryoglobulins, and abnormal fibrillary proteins may also deposit in the GBM. Increased synthesis of the protein components of the basement membrane, as occurs in diabetic glomerulosclerosis. Formation of additional layers of basement membrane matrices, which most often occupy subendothelial locations and may range from poorly organized matrix to fully duplicated lamina densa, as occurs in membranoproliferative glomerulonephrititis and PGN. Hyalinosis and sclerosis. Hyalinosis, as applied to the glomerulus, denotes the accumulation of material that is homogeneous and eosinophilic by light microscopy. Hyalin is an extracellular, amorphous material composed of plasma proteins that have exudated from the circulation into glomerular structures. When extensive, these deposits may obliterate the capillary lumens of the glomerular tuft. Hyalinosis is usually a consequence of endothelial or capillary wall injury and typically the end result of various forms of glomerular damage. Sclerosis is characterized by deposition of extracellular collagenous matrix. It may be confined to mesangial areas, as is often the case in diabetic glomerulosclerosis. Involved. Disease is 901. The capillary loops, or both. The sclerosing process may also result in obliteration of some or all of the capillary lumens in affected glomeruli. Many primary glomerulopathies are classified by their histology, as seen in Table 20.2. The histologic changes can be further subdivided by their distribution into the following categories: diffuse, involving all of the glomeruli in the kidney; global, involving the entirety of individual glomeruli; focal, involving only a fraction of the glomeruli in the kidney; segmental, affecting a part of each glomerulus; and capillary loop or mesangial, affecting predominantly capillary or mesangial regions. Key concepts: injury of glomerular structures. The GBM is composed of type Roman 4 collagen molecules and other matrix proteins. These proteins can be the target of antibodies in some types of glomerulonephrititis. Genetic abnormalities in their composition are the basis for some forms of hereditary nephritis. Visceral epithelial cells, podocytes, are a critical component of the glomerular filtration barrier, and their injury leads to protein leakage into the urinary space, proteinuria. The acute glomerular response to injury includes hypercellularity, with proliferation of mesangial and / or endothelial cells, influx of leukocytes, and, when severe, formation of crescents. Chronic glomerular responses to injury include basement membrane thickening, hyalinosis, and sclerosis. Pathogenesis of glomerular injury. Although much remains unknown about etiologic agents and triggering events, it is clear that immune mechanisms underlie most forms of primary glomerulopathy and many secondary glomerular disorders. Table 20.4. Glomerulonephritis can be induced experimentally by antigen-antibody reactions. Furthermore, glomerular deposits of immunoglobulins, often with components of complement, are found in the majority of individuals with glomerulonephritis. 24. Glomerular immune mechanisms of glomerular injury. Table. Antibody-mediated injury in situ immune complex deposition fixed intrinsic tissue antigens. Incone domain of type Roman 4 collagen antigen anti-GBM nephritis. PL-APO antigen membranous glomerulopathy mesangial antigens. Others, planet antigens, exogenous infectious agents, drugs, endogenous DNA, nuclear proteins, immunoglobulins, immune complexes, IGA, circulating immune complex deposition. Endogenous antigens, for example, DNA, tumor antigens, exogenous antigens, for example, infectious products. Cell-mediated immune injury, activation of alternative complement pathway, GBM, glomerular basement membrane. Cell-mediated immune reactions also may play a role, usually in concert with antibody-mediated events. We begin this discussion with a review of antibody-instigated injury. Two forms of antibody-associated injury have been established. One, injury by antibodies reacting in situ within the glomerulus, either binding to insoluble fixed intrinsic glomerular antigens or extrinsic molecules planted within the glomerulus. And two, injury resulting from deposition of circulating antigen-antibody complexes in the glomerulus. It is clear that the major cause of glomerulonephritis resulting from formation of antigen-antibody complexes is the consequence of in situ immune complex formation and not deposition of circulating complexes as was once thought. Disease is caused by in situ formation of immune complexes. In this form of injury, immune complexes are formed locally by antibodies that react with intrinsic tissue antigens or with extrinsic antigens planted in the glomerulus from the circulation. Membranous nephropathy is the classic example of glomerular injury resulting from local formation of immune complexes by antibodies reactive with endogenous antigens. The pattern of immune deposition by immunofluorescence microscopy is granular, reflecting the very localized antigen-antibody interaction. On electron microscopy, the glomerulopathy is characterized by the presence of numerous discrete subepithelial electron-dense deposits made up of immune reactants. These subepithelial complexes, with resultant host responses, can result in a thickened basement membrane appearance by light microscopy, hence the term membranous nephropathy. Antibodies can react in situ with antigens that are not normally present in the glomerulus but are planted there. Such antigens may localize in the kidney by interacting with various intrinsic components of the glomerulus. Planted antigens include cationic molecules that bind to anionic components of the glomerulus, DNA, nucleosomes, and other nucleoproteins, which have an affinity for GBM components, bacterial products, large aggregated proteins, for example, aggregated immunoglobulins, which deposit in the mesangium because of their size, and immune complexes themselves, because they continue to have reactive sites for further interactions with free antibody, free antigen, or complement. There is no dearth of other possible planted antigens, including viral, bacterial, and parasitic products and drugs. Disease caused by antibodies directed against normal components of the glomerular basement membrane. An anti-GBM antibody, Induce glomerulonephritis. Antibodies bind to intrinsic antigens homogeneously distributed along the entire length of the GBM, resulting in a diffuse linear pattern of staining for the antibodies by immunofluorescence techniques Fig. 24b and E. This contrasts with the granular pattern of immunofluorescence staining corresponding to the discrete immune complexes seen in membranous nephropathy, or other glomerular diseases in which large complexes of antigens and antibodies form in situ. Although anti-GBM antibody-induced glomerulonephritis accounts for less than 5% of cases of human glomerulonephritis, it causes severe necrotizing and crescentic glomerular damage and the clinical syndrome of RPGN. Chapter 20. The kidney. Circulating immune complex deposition. Epithelial cell foot processes endothelium, anti-GBM, in situ Hayman, basement membrane, endothelium, circulating complex, subendothelial deposit, antigen, antibody, a BCDE. Figure 20.4. Antibody-mediated glomerular injury can result either from the deposition of circulating immune complexes or, more commonly, from in situ formation of complexes exemplified by anti-glomerular basement membrane anti-GBM disease B or Hayman nephritis C. E and E2 patterns of deposition of immune complexes as seen by immunofluorescence microscopy, granular, characteristic of circulating and in situ immune complex nephritis D, and linear, characteristic of classic anti-GBM disease E. E. Courtesy Dr. J. Kowalska, Department of Pathology, University of Washington, Seattle, Washington. E. From Kumar V. Abbas A.K., Pastor J.C., Robbins Basic Pathology, Ed 10, Philadelphia, 2018, Elsevier, 902. Diseases 903. Glomerulonephritis resulting from deposition of circulating immune complexes. In this type of nephritis, glomerular injury is caused by the trapping of circulating antigen-antibody complexes within glomeruli. The antibodies have no immunologic specificity for glomerular constituents, and the complex is localized within the glomeruli because of their physicochemical properties and the hemodynamic factors peculiar to the glomerulus see Fig. 24a. Antigens that trigger the formation of circulating immune complexes may be of endogenous origin, as in the glomerulonephritis associated with SLE or Inigo nephropathy, or they may be exogenous, as may occur in the glomerulonephritis that follow certain infections. Microbial antigens that are implicated include bacterial products, streptococcal proteins, the surface antigen of hepatitis B virus, hepatitis C virus antigens, and antigens of Treponema pallidum, Plasmodium falciparum, and several viruses. Some tumor antigens are also thought to cause immune complex-mediated nephritis. In many cases, the inciting antigen is unknown. Mechanisms of glomerular injury following immune complex formation. The pathogenesis of immune complex diseases is discussed in Chapter 6. Here we briefly review the salient features that relate to glomerular injury. Whatever the antigen may be, antigen-antibody complexes formed or deposited in the glomeruli may elicit a local inflammatory reaction that produces injury. The antibodies may activate complement and engage Fc receptors on leukocytes and perhaps glomerular mesangial or other cells, leading to inflammation. The glomerular lesions may exhibit leukocytic infiltration and proliferation of mesangial and endothelial cells. Electron microscopy reveals electron-dense deposits, presumably containing immune complexes, that may lie in the mesangium, between the endothelial cells and the GBM subendothelial deposits, or between the outer surface of the GBM and the podocyte subepithelial deposits. Deposits may be located at more than one site in a given case. By immunofluorescence microscopy, the immune complexes are seen as granular deposits along the basement membrane see Fig. 24d, in the mesangium, or in both locations. Once deposited in the kidney, immune complexes may eventually be degraded, mostly by infiltrating neutrophils and monocytes/macrophages, mesangial cells, and endogenous proteases, and the inflammatory reaction may then subside. Such a course occurs when the exposure to the inciting antigen is short-lived and limited, as in most cases of post-streptococcal glomerulonephritis. However, if immune complexes are deposited repeatedly for prolonged periods, as may be seen in SLE or viral hepatitis, many cycles of injury may occur, leading to a more chronic membranous or membranoproliferative type of glomerulonephritis. Several factors affect glomerular localization of antigen, antibody, or immune complexes. The molecular charge and size of these reactants are clearly important. Highly cationic antigens tend to cross the GBM, and the resulting complexes eventually reside in a subepithelial location. Highly anionic macromolecules are excluded from the GBM and are trapped subendothelially or are not nephrogenic at all. Molecules of neutral charge and immune complexes containing these molecules tend to accumulate in the mesangium. Large circulating complexes are not usually nephrogenic because they are cleared by the mononuclear phagocyte system and do not enter the GBM in significant quantities. The pattern of localization is also affected by changes in glomerular hemodynamics, mesangial function, and integrity of the charge-selective barrier in the glomerulus. These influences may underlie the variable pattern of immune reactant deposition in various forms of glomerulonephritis Fig. 25. In turn, the distinct patterns of localization of immune complexes is a key determinant of the injury response and the histologic features that subsequently develop. Immune complex is located in subendothelial portions of capillaries and in mesangial regions are accessible to the circulation and more likely to be involved in inflammatory processes that require interaction and activation of circulating leukocytes. Diseases in which immune complexes are confined to the subepithelial locations and for which the capillary basement membranes may be a barrier to interaction with circulating leukocytes, as in the case of membranous nephropathy, typically have a non-inflammatory pathology. In summary, most cases of immune complex mediated glomerulonephritis are a consequence of deposition of discrete immune complexes, which give rise to granular immunofluorescence staining along the basement membranes or in the mesangium. However, it may be difficult to determine whether the deposition has occurred in situ, by circulating complexes, or by both mechanisms. 213 MMMC and GBM4 LRI and GBM at. Figure 20.5 Localization of immune complexes in the glomerulus, 1 subepithelial humps, as in acute glomerulonephritis, 2 membranous deposits, as in membranous nephropathy and Hayman nephritis, 3 subendothelial deposits, as in lupus nephritis and membranoproliferative glomerulonephritis, 4 mesangial deposits, as in IgA nephropathy, and endothelium, epithelium, GBM, glomerular basement membrane, LD, lamina densa, LRE, lamina rara externa, LRI, lamina rara interna, MC, mesangial cell, MM, mesangial matrix, modified from Council WG, mediation of immune glomerular injury, JM Soc Nephro 11, 13, 29, 1990, glomerular, Chapter 20 The kidney, because, as discussed earlier, trapping of circulating immune complexes can initiate further in situ complex formation. Single etiologic agents, such as hepatitis B and C viruses, can cause either a membranous pattern of glomerulonephritis with subepithelial in situ deposition of antigens or a membranoproliferative pattern, more indicative of subendothelial deposition of antigens or deposition of circulating complexes. It is best then to consider that antigen-antibody deposition in the glomerulus is a major pathway of glomerular injury and that in situ immune reactions, trapping of circulating complexes, interactions between these two events, and local hemodynamic and structural determinants in the glomerulus all contribute to the diverse morphologic and functional alterations in glomerulonephritis. Cell-mediated immunity in glomerulonephritis. Although antibody-mediated mechanisms may initiate most forms of glomerulonephritis, there is evidence that sensitized T cells cause glomerular injury and are involved in the progression of some glomerulonephritides. Clues to the role of cellular immunity include the presence of activated macrophages and T cells and their products in the glomerulus in some forms of human and experimental glomerulonephritis. In vitro and in vivo evidence of lymphocyte activation on exposure to antigen in human and experimental glomerulonephritis. Abrogation of glomerular injury by lymphocyte depletion. And experiments in which glomerular injury may be induced by transfer of T cells from nephritic animals to normal recipients. The evidence is most compelling for certain types of experimental crescentic glomerulonephritis in which antibodies to GBM initiate glomerular injury and activated T lymphocytes propagate the inflammation. Despite this body of suggestive evidence, proof of glomerulonephritis in humans resulting primarily from T cell activation remains lacking. Activation of alternative complement pathway. Alternative complement pathway activation occurs in the clinicopathologic entity called dense deposit disease, until recently referred to as membranoproliferative glomerulonephritis MPGN type Roman II, and in C3 glomerulopathies. This is discussed later in the sections describing these diseases. Mediators of glomerular injury. Once immune reactants or sensitized T cells have localized in the glomerulus, how does the glomerular damage ensue? The mediators, both cells and molecules, are the usual suspects involved in acute and chronic inflammation, described in Chapter 3, and only a few are highlighted here. Fig. 20.6. Cells. Neutrophils and monocytes infiltrate glomeruli in certain types of glomerulonephritis, largely as a result of activation of complement, resulting in generation of chemotactic agents mainly C5, but also by Fc receptor-mediated activation. Neutrophils release proteases, which cause GBM degradation, oxygen-derived free radicals, which cause cell damage, and arachidonic acid metabolites, which contribute to the reductions in GFR. Macrophages and T lymphocytes, which infiltrate glomeruli and antibody and cell-mediated reactions, when activated, release a vast number of biologically active molecules. Platelets may aggregate in glomeruli during immunomediate injury. Their release of eicosanoids, growth factors, and other mediators may contribute to vascular injury and proliferation of glomerular cells. Antiplatelet agents have beneficial effects in both human and experimental glomerulonephritis. Resident glomerular cells, particularly mesangial cells, can be stimulated to produce inflammatory mediators, including reactive oxygen species ROS, cytokines, chemokines, 904. Antibody deposition. T cell immune reaction. Immune complexes. Complement activation. Platelets, macrophages, mesangial cells, T cells, NK cells. Cytotoxic T, NK. C5 of 9, C5, neutrophils, epithelial, endothelial, mesangial, oxidant cytokines, chemokines, proteases, growth factors, eicosanoids, nitric oxide, others. Figure 20.6 Mediators of immune glomerular injury. Glomerular disease is 905, growth factors, eicosanoids, nitric oxide, and endothelin. They may initiate inflammatory responses in glomeruli, even in the absence of leukocytic infiltration. Soluble mediators. Virtually all the known inflammatory chemical mediators, Chapter 3, have been implicated in glomerular injury. Complement activation leads to the generation of chemotactic products that induce leukocyte influx, complement neutrophil dependent injury, and the formation of C5, C9, the membrane attack complex. C5, C9 causes cell lysis, but, in addition, it may stimulate mesangial cells to produce oxidants, proteases, and other mediators. Thus, even in the absence of neutrophils, C5, C9 can cause proteinuria, as has been demonstrated in experimental membranous glomerulopathy. In some diseases, collectively called C3 glomerulopathies, there is evidence of complement activation resulting not from antibody or immune complex deposition but from defective regulation of the complement system. As expected, because antibodies are not involved, in these disorders complement activation is by the alternative pathway. The end result is the same as in classical pathway activation. Glycosaminoglycanols, nitric oxide, angiotensin, and endothelin are involved in the hemodynamic changes. Cytokines, particularly IL-1 and TNF, which may be produced by infiltrating leukocytes and resident glomerular cells, induce leukocyte adhesion and a variety of other effects. Chemokines such as monocyte chemoattractant protein 1 promote monocyte and lymphocyte influx. Growth factors such as platelet-derived growth factor PDGF are involved in mesangial cell proliferation. TGF-beta, connective tissue growth factor, and fibroblast growth factor seem to be critical in the ECM deposition and hyalinization leading to glomerulosclerosis and chronic injury. Vascular endothelial growth factor VEGF seems to maintain endothelial integrity and may help regulate capillary permeability. The coagulation system is also a mediator of glomerular damage. Fibrin is frequently present in the glomeruli and Bowman space in glomerulonephritis, indicative of coagulation cascade activation, and activated coagulation factors, particularly thrombin, may be a stimulus for crescent formation. Epithelial cell injury. Podocyte injuries common to both primary and secondary glomerular diseases of both immune and non-immune etiologies. The term podocytopathy has been applied to diseases with disparate etiologies whose principal manifestation is injury to podocytes. This can be induced by antibodies to podocyte antigens, by toxins, as in an experimental model of proteinuria induced by puromycin aminonucleoside, conceivably by certain cytokines, by certain viral infections such as human immunodeficiency virus HIV, or by incompletely characterized circulating factors, postulating minimal change disease in focal segmental glomerulosclerosis FSGS. Such injury is reflected by morphologic changes in podocytes, which include effacement of foot processes, vacuolization, and retraction and detachment of cells from the GBM, and functionally by proteinuria Fig. 20.7. Loss of podocytes, which have only a very limited capacity for replication and repair, may be a feature of multiple types of glomerular injury, including FSGS and diabetic nephropathy. Such loss typically cannot be recognized in pathologic specimens unless morphometric techniques are applied. In most forms of glomerular injury, loss of normal slit diaphragms is a key event in the development of proteinuria. See Fig. 20.7. Functional abnormalities of the slit diaphragm may also result from mutations in its components, such as nephrin and podocin, without actual inflammatory damage to the glomerulus. Such mutations are the cause of rare hereditary forms of the nephrotic syndrome. Mechanisms of progression in glomerular diseases. Thus far, the immunologic mechanisms and mediators that initiate glomerular injury have been discussed. The outcome of such injury depends on several factors, including the severity of renal damage, the nature and persistence of the antigens, and the immune status, age, and genetic predisposition of the host. It has long been known that once any renal disease, glomerular or otherwise, destroys functioning nephrons, normal epithelial cell foot process, effacement and detachment, filtration slit, epithelial, foot processes, effacement, antibody cytokine, adhesion toxin molecule endothelium, basement membrane, Figure 20.7 epithelial cell injury. The postulated sequence is a consequence of antibodies specific to epithelial cell antigens, toxins, cytokines, or other factors causing injury. This results in foot process effacement and sometimes detachment of epithelial cells and protein leakage through defective glomerular basement membrane and filtration slits. Chapter 20. The kidney. And reduces the GFR to about 30% to 50% of normal. Progression to end-stage renal failure proceeds at a steady rate, independent of the original insult or activity of the underlying disease. Secondary factors that lead to progression are of great clinical interest because they can be targets of therapy that delays or even prevents the inexorable journey to dialysis or transplantation. The two major histologic characteristics of such progressive renal damage are glomerulosclerosis and tubulointerstitial fibrosis. Glomerulosclerosis. Sclerosis involving portions of some glomeruli, also referred to as secondary FSGS, develops after many types of renal injury and can lead to proteinuria and increasing functional impairment. Glomerular sclerosis may be seen even in cases in which the primary disease was non-glomerular. The mechanisms of glomerulosclerosis in this setting are described in the discussion of FSGS later in this chapter. Tubular injury and interstitial fibrosis. Tubulointerstitial injury, manifested by tubular damage and interstitial inflammation, is a component of many acute and chronic glomerulonephritis. Tubular interstitial fibrosis contributes to progression in both immune and non-immune glomerular diseases, for example, diabetic nephropathy. Indeed, there is often a much better correlation of decline in renal function with the extent of tubular interstitial damage than with the severity of glomerular injury. Many factors may lead to such tubular interstitial injury, including ischemia of tubular segments downstream from sclerotic glomeruli, acute and chronic inflammation in the adjacent interstitium, and damage or loss of the peritubular capillary blood supply. It appears that proteinuria also can cause direct injury to inactivation of tubular cells. Activated tubular cells in turn express adhesion molecules and elaborate pro-inflammatory cytokines, chemokines, and growth factors that contribute to interstitial fibrosis. Filter proteins that may produce these tubular effects include cytokines, complement products, the iron and hemoglobin, immunoglobulins, lipid moieties, and oxidatively modified plasma proteins. Key concepts: pathogenesis of glomerular injury and progression of glomerular disease. Antibody-mediated injury is an important mechanism of glomerular damage, mainly via complement and leukocyte-mediated pathways. Antibodies may also be directly cytotoxic to glomerular cells. The most common forms of antibody-mediated glomerulonephritis are caused by the formation of immune complexes, which may involve either endogenous antigens, for example, PL-ATWA, and membranous nephropathy, or exogenous antigens, for example, microbial. Immune complexes show a granular pattern of deposition by immunofluorescence. Autoantibodies against components of the GBM are the cause of anti-GBM antibody-mediated disease, often associated with severe injury. The immunofluorescence pattern of antibody deposition is linear. Activation of the alternative complement pathway is an important mechanism of injury in C3 glomerulopathies that include dense deposit disease and C3 glomerulonephritis. Soluble inflammatory mediators, such as cytokines, chemokines, growth factors, glycosanoids, nitric oxide, and activated coagulation factors also contribute to the glomerular injury. Epithelial cell podocyte injury induced by antibodies, toxins, cytokines, infections, and poorly characterized circulating factors is a common manifestation of various forms of glomerular diseases. Progressive glomerular injury can be the result of either primary or secondary glomerular injuries, of diseases that are either renal limited or systemic, and of diseases that initially involve renal structures other than glomeruli. Progressive injury ensues from a cycle of glomerular and nephron loss, compensatory changes that lead to further glomerular injury and glomerulosclerosis, and eventually acid. Progressive glomerular injury is accompanied by chronic injuries to other renal structures, typically manifest as tubular interstitial fibrosis. 906. Having discussed the factors involved in the initiation and progression of glomerular injury, we now turn to a discussion of individual glomerular diseases. Table 20.5 summarizes the main clinical and pathologic features of the major forms of primary glomerulopathies. Nephritic syndrome. Glomerular diseases presenting with the nephritic syndrome are characterized by inflammation in the glomeruli. Main clinical features of nephritic syndrome include the following: hematuria, red blood cells, and red cell casts in urine. Proteinuria, usually subnephrotic range with or without edema. Azotemia, hypertension. Nephritic syndrome is the typical clinical presentation of most proliferative types of GN, such as post-infectious GN, crescentic GN, and proliferative lupus GN. The lesions that cause the nephritic syndrome have in common proliferation of the cells within the glomeruli, often accompanied by an inflammatory leukocytic infiltrate. This inflammatory reaction severely injures the capillary walls, permitting blood to pass into the urine and inducing hemodynamic changes that lead to a reduction in GFR. A reduced GFR is manifested clinically by oliguria, fluid retention, and azotemia. Hypertension probably is a result of both the fluid retention and renin release from the ischemic kidneys. Acute proliferative post-infectious and infection-associated glomerulonephritis. As the name implies, this cluster of diseases is characterized histologically by diffuse proliferation of glomerular cells associated with influx exudation of leukocytes, typically caused by immune complexes. The inciting antigen may be exogenous or endogenous. The prototypic exogenous antigen-induced disease pattern is post-infectious. Glomerular disease is 907. Table 20.5 disease. Post-infectious glomerulonephritis. Crescentic rapidly. Progressive. Glomerulonephritis. Membranous nephropathy. Of major primary glomerulonephritides, most frequent clinical presentation: pathogenesis, glomerular pathology. Fluorescence. Light microscopy. Nephritic immune complex, diffuse endocapillary granular Ig and C3 and syndrome-mediated proliferation, GBM and mesangium, circulating or leukocytic infiltration, granular Ig and some planted antigen cases. Linear Ig and C3 and anti-GBM antibody-mediated GN, granular Ig, other Igs, and /or complement and immune complex-mediated GN, or no deposits in anchor-mediated GN. Granular Ig and C3, diffuse, extracapillary proliferation with crescents, necrosis, anti-GBM antibody-mediated, immune, complex-mediated, anchor-mediated, and unknown. Nephritic syndrome, rapid progression. Nephrotic syndrome, in situ immune, complex PL-ATWA antigen in most cases of primary disease. Unknown, loss of glomerular polyanion, podocyte injury. Unknown ablation, nephropathy, plasma factor, podocyte injury. Immune complex mesangial proliferative or member not proliferative patterns of proliferation, GBM. Thickening, splitting. Mesangial proliferative or member not proliferative patterns of proliferation, GBM thickening, splitting. Focal mesangial proliferative glomerulonephritids, mesangial widening. Anchor, antineutrophil cytoplasmic antibodies, GBM, glomerular basement membrane, summary. Diffuse capillary wall thickening, normal. Lipid and tubules negative. Minimal change, disease, nephrotic. Syndrome, focal, again plus C3 in many cases. Focal and segmental, sclerosis and hyalinosis. Focal segmental, glomerulosclerosis. Nephrotic, syndrome, non-nephrotic. Proteinuria, Ag++ C3, connect ++ C4. Nephritic/nephrotic, syndrome, member not proliferative glomerulonephritis and PGN type I. C3, no connect or C4, acquired or genetic. Dysregulation of the alternative complement pathway, unknown. Hematuria, chronic renal failure. Dense deposit disease, MPGN type Roman 2. Ig plus or minus Ig, Ig-M, and C3 in mesangium. Ig nephropathy recurrent. Hematuria or proteinuria. Electron microscopy. Primarily subepithelial humps. Subendothelial deposits in early disease stages. No deposits in anti-GBM and ANCA-mediated GN. Immune complexes at various locations in immune complex-mediated GN. Subepithelial deposits. Effacement of foot processes. No deposits. Effacement of foot processes. Epithelial denudation. Subendothelial deposits. Dense deposits. Mesangial and paramesangial dense deposits. Glomerulonephritis, whereas an example of an endogenous antigen-induced disease is the nephritis of SLE, described in Chapter 6. The most common underlying infections are streptococcal, but the disorder may also be associated with other infections. Post-streptococcal GN is decreasing in frequency in the United States but continues to be a fairly common disorder worldwide. It usually appears 1 to 4 weeks after a streptococcal infection of the pharynx or skin and pedicle. Skin infections are commonly associated with overcrowding and poor hygiene. Post-streptococcal glomerulonephritis occurs most frequently in children 6 to 10 years of age, but children and adults of any age can also be affected. Pathogenesis post-streptococcal GN is caused by immune complexes containing streptococcal antigens and specific antibodies. Only certain strains of group of beta hemolytic streptococci are nephrogenic, more than 90% of cases being traced to types 12, 4, and 1, which can be identified by typing of the M protein of the bacterial cell walls. Many lines of evidence support an immunologic basis for post-streptococcal glomerulonephritis. The latent period between infection and onset of nephritis is compatible with the time required for the production of antibodies and the formation of immune complexes. Elevated titers of antibodies. 908 Chapter 20 The kidney. Against one or more streptococcal antigens are present in a great majority of patients. Serum complement levels are low, compatible with activation of the complement system and consumption of complement components. There are granular immune deposits in the glomeruli, indicative of an immune complex-mediated mechanism. The streptococcal antigenic component responsible for the immune reaction had long eluded identification, but the preponderance of evidence identifies streptococcal pyogenic exotics and BSPB as the principal antigenic determinant in most but not all cases of post-streptococcal glomerulonephritis. This protein can directly activate complement, is commonly secreted by nephrogenic strains of streptococci, and has been localized to the hump-like deposits characteristic of this disease described later. At the outset, the inciting antigens are exogenously planted from the circulation and subendothelial locations in glomerular capillary walls, leading to in situ formation of immune complexes, where they elicit an inflammatory response. Subsequently, through mechanisms that are not well understood, the antigen-antibody complexes dissociate, migrate across the GBM, and reform on the subepithelial side of the GBM. Deposition of circulating immune complexes also may contribute to the lesions. A similar form of glomerulonephritis occurs sporadically in association with other infections, including those of bacterial, for example, staphylococcal endocarditis, pneumococcal pneumonia, and meningococcemia. Viral, for example, hepatitis B, hepatitis C, mumps, HIV infection, varicella, and infectious mononucleosis, and parasitic malaria, toxoplasmosis origin. In these settings, granular immunofluorescent deposits and subepithelial humps characteristic of immune complex nephritis are also present. Morphology. The classic histologic picture is one of enlarged, hypercellular glomeruli Fig. 28b. The hypercellularity is caused by 1. Infiltration by leukocytes, both neutrophils and monocytes, 2. Proliferation of endothelial and mesangial cells, and 3. In severe cases by crescent formation. The proliferation and leukocyte infiltration are typically global and diffuse, that is, involving all lobules of glomeruli. There is also swelling of endothelial cells, and the combination of proliferation, swelling, and leukocyte. BD. Figure 20.8 Acute proliferative glomerulonephritis. The normal glomerulus. B. Glomerular hypercellularity is due to intracapillary leukocytes and proliferation of intrinsic glomerular cells. D. Typical electron-dense subepithelial hump in a neutrophil and the lumen. D. Immunofluorescent stain demonstrates discrete, coarsely granular deposits of complement protein C3 stain for Ig was similar, corresponding to humps illustrated in Part C. A C. Courtesy Dr. H. Rank, Brigham and Women's Hospital, Boston, Mass. D. Courtesy D.J. Kowalski, Cedars-Sinai Medical Center, Los Angeles, California. Glomerular disease is 909. Infiltration obliterates the capillary lumens. There may be interstitial edema and inflammation, and the tubules often contain red cell casts. By immunofluorescence microscopy, there are granular deposits of Ig and C3, and sometimes Ig-M in the mesangium, and along the GBM Fig. 28D. Although immune complex deposits are almost universally present, they are often focal and sparse. The characteristic electron microscopic findings are discrete, amorphous, electron-dense deposits on the epithelial side of the membrane, often having the appearance of humps Fig. 28C, presumably representing the antigen-antibody complexes at the subepithelial cell surface. Subendothelial deposits are also commonly seen, typically early in the disease course, and mesangial and intramembranous deposits may be present. Glomerulomphritis. Clinical features in the typical case: the young child abruptly develops malaise, fever, nausea, oliguria, and hematuria, smoky or cola colored urine 1 to 2 weeks after recovery from a sore throat. The patients have dysmorphic red cells or red cell casts in the urine, mild proteinuria usually less than on G/day, periorbital edema, and mild to moderate hypertension. In adults, the onset is more likely to be atypical, such as the sudden appearance of hypertension or edema, frequently with elevation of BUN. The glomerulonephritis is subclinical in some infected individual, and is discovered only on screening for microscopic hematuria carried out during epidemic outbreaks. Important laboratory findings include elevations of antistreptococcal antibody titers and a decline in the serum concentration of C3 and other components of the complement cascade. More than 95% of affected children eventually recover renal function with conservative therapy aimed at maintaining sodium and water balance. A small minority of children, perhaps less than 1%, do not improve, become severely oliguric, and develop a rapidly progressive form of glomerulonephritis described later. Some of the remaining patients may undergo slow progression to chronic glomerulonephritis with or without recurrence of an active nephritic picture. Prolonged and persistent heavy proteinuria in abnormal GFR mark patients with an unfavorable prognosis. In adults, the disease is less benign, although the overall prognosis in epidemics is good, and only about 60% of sporadic cases do the patients recover promptly. In the remainder, the glomerular lesions fail to resolve quickly, as manifested by persistent proteinuria, hematuria, and hypertension. In some of these patients, the lesions eventually clear, but others develop chronic glomerulonephritis or even RPGN. Ascendic rapidly progressive glomerulonephritis (RPGN) is a clinical syndrome associated with severe glomerular injury, but it does not denote a specific etiology. It is characterized by relatively rapid and progressive loss of renal function associated with severe oliguria and signs of nephritic syndrome. If untreated, death from renal failure may occur within weeks to months. The most common histologic picture is the presence of crescents in most of the glomeruli, hence the name crescentic glomerulonephritis. As discussed earlier, these are produced predominantly by the proliferation of the epithelial cells lining the Bowman capsule and by the infiltration of monocytes and macrophages. Pathogenesis crescentic GN may be a manifestation of a number of different diseases, some restricted to the kidney and others systemic. Although no single mechanism can explain all cases, there is little doubt that in most cases the glomerular injury is immunologically mediated. A practical classification divides crescentic GN into 3 groups on the basis of immunologic findings, table 26, which have been described as follows. Anti-GBM antibody mediated disease, characterized by linear deposits of Ig in many cases, C3 in the GBM. In some of these patients, the anti-GBM antibodies cross-react with pulmonary alveolar basement membranes to produce the clinical picture of pulmonary hemorrhage associated with renal failure Goodpasture syndrome. Plasmapheresis to remove the pathogenic circulating antibodies is usually part of the treatment, which also includes therapy to suppress the underlying immune response. The antigen common to the alveoli and GBM is a peptide within the non-collagenous portion of the alpha-3 chain of collagen type Roman 4. What triggers the formation of these autoantibodies is unclear in most patients. Exposure to viruses or hydrocarbon solvents found in paints and dyes has been implicated in some patients, as have various drugs and cancers. There is a high prevalence of certain HLA alleles, for example, HLA-DR in affected patients, a finding consistent with the genetic predisposition to autoimmunity. Disease is caused by immune complex deposition, with granular deposits of antibodies and complement by immunofluorescence. Crescentic GN can be a complication of any of the immune complex nephritis, including post-infectious glomerulonephritis, lupus nephritis, IgA nephropathy, and Henoch-Schönlein purpura. These patients usually cannot be helped by plasmapheresis, and they require treatment for the underlying disease. Pulsi-immune crescentic GN, defined by the lack of detectable anti-GBM antibodies or immune complexes by immunofluorescence and electron microscopy. Most patients with this type of RPGN have circulating antineutrophil cytoplasmic crescentic oversive tablet P20, 6 or R-pily, type I anti-GBM antibody, renal-limited Goodpasture syndrome, type Roman 2 immune complex, idiopathic post-infectious glomerulonephritis, lupus nephritis, Henoch-Schönlein purpura, IgA nephropathy, others. Type Roman 3 pulsi-immune, ANCA-associated idiopathic granulomatosis with polyangiitis, formerly Wegener granulomatosis, microscopic polyangiitis, ANCA, antineutrophil cytoplasmic antibodies, GBM, glomerular basement membrane. Chapter 20, the kidney. Antibodies anchors that produce a cytoplasmic C anchor or perinuclear P anchor staining pattern and are known to play a role in some vasculitides. Chapter 11. This type of RPGN may be a component of a systemic vasculitis such as granulomatosis with polyangiitis, formerly called Wegener granulomatosis or microscopic polyangiitis. In many cases, however, pulsi-immune crescentic glomerulonephritis is limited to the kidneys and hence idiopathic. More than 90% of such idiopathic cases have C anchor, now called PR3 anchor, because the antibodies are specific for neutrophil granuloprotein proteinase 3 or P anchor, now called MPO anchor, indicating reactivity with neutrophil myeloperoxidase in the serum. The presence of circulating anchor in both idiopathic crescentic glomerulonephritis and cases of crescentic glomerulonephritis that occur as a component of systemic vasculitis, and the similar pathologic features in both settings, have led to the idea that these disorders are pathogenetically related. According to this concept, all cases of crescentic glomerulonephritis of the pulse-immune type are manifestations of small vessel vasculitis or polyangiitis, which is limited to glomerular and perhaps peritubular capillaries. In cases of idiopathic crescentic glomerulonephritis, anchor have proved to be invaluable as a highly sensitive diagnostic marker for pulsi-immune crescentic glomerulonephritis, but proof of their role as a direct cause of this glomerulonephritis has been elusive. Recent evidence of their pathogenic potential has been obtained by studies in mice showing that transferring antibodies against myeloperoxidase, the target antigen of most P anchors, induces a form of RPGN. To summarize, about 1/5 of patients with RPGN have anti-GBM antibody-mediated glomerulonephritis without lung involvement, another 1/4 have immune complex-mediated crescentic glomerulonephritis, and the remainder are of the pulsi-immune type. Figure 20.9 Crescentic glomerulonephritis periodic acid. Skiff stain. Note the compressed glomerular tufts and the crescent-shaped mass of proliferating epithelial cells and leukocytes within the Bowman capsule. Courtesy Dr. M.A. Venkatachalam, University of Texas Health Sciences Center, San Antonio, Tex. Show ruptures in the GBM, a severe injury that allows leukocytes, plasma proteins such as coagulation factors and complement, and inflammatory mediators to reach the urinary space where they trigger crescent formation. Fig. 20.10. In time, most crescents undergo organization in foci of segmental necrosis resolve as segmental scars, a type of segmental sclerosis, but restoration of normal glomerular architecture may be achieved with early aggressive therapy. 910. Clinical features. The renal manifestations of all forms of crescentic glomerulonephritis include hematuria with red blood cell casts in the urine, moderate proteinuria occasionally reaching the morphology. The kidneys are enlarged and pale, often with petechial hemorrhages on the cortical surfaces. Depending on the underlying cause, the glomeruli often show focal and segmental necrosis, invariably show diffuse or focal endothelial proliferation and mesangial proliferation. Segmental glomerular necrosis and distinctive crescents. Fig. 20. 9 Adjacent to glomerular segments uninvolved by inflammatory or proliferative changes is the feature most typical of pulsi-immune RPGN. Crescents are formed by proliferation of glomerular epithelial cells and by migration of monocytes and macrophages into the urinary space. Neutrophils and lymphocytes may be present. The crescents may obliterate the urinary space and compress the glomerular tuft. Fibrin strands are frequently prominent between the cellular layers in the crescents. Indeed, as discussed earlier, the escape of procoagulant factors, fibrin, and cytokines into Bowman space may contribute to crescent formation. By immunofluorescence microscopy, immune complex-mediated cases show granular immune deposits. Goodpasture syndrome cases show linear GBM fluorescence for Ig and complement, and pulsi-immune cases have little or no deposition of immune reactants. Electron microscopy discloses deposits in those cases due to immune complex deposition. Regardless of type, electron microscopy may. Figure 20.10 Crescentic glomerulonephritis. Electron micrograph showing characteristic wrinkling of glomerular basement membrane with focal disruptions. Arrows. Diseases 911. Nephrotic range and variable hypertension and edema. In Goodpasture syndrome, the course may be dominated by recurrent hemoptysis or even life-threatening pulmonary hemorrhage. Serum analyzes for anti-GBM antibodies, antinuclear antibodies, and ANC lymphatic gnosis of specific subtypes. Although milder forms of glomerular injury may subside, the renal involvement is usually progressive over a matter of weeks and culminates in severe oliguria. Recovery of renal function may follow early intensive plasmapheresis plasma exchange combined with steroids and cytotoxic agents in Goodpasture syndrome. This therapy can reverse both pulmonary hemorrhage and renal failure. Other forms of RPGN also respond well to steroids and cytotoxic agents. However, despite therapy, many patients eventually require chronic dialysis or transplantation, particularly if the disease is discovered at a late stage. Key concepts. The nephritic syndrome. The nephritic syndrome is characterized by hematuria, oliguria with azotemia, proteinuria, and hypertension. The most common causes are immunologically mediated glomerular injury. Lesions are characterized by proliferative changes and leukocyte infiltration. Acute post-infectious glomerulonephritis typically occurs after streptococcal infection in children and young adults but may occur following infection with many other organisms. It is caused by deposition of immune complexes, mainly in the subepithelial spaces with abundant neutrophils and proliferation of glomerular cells. Most affected children recover. the prognosis is worse in adults. RPGN is a clinical entity with features of the nephrotic syndrome and rapid loss of renal function. RPGN is commonly associated with severe glomerular injury, with necrosis and GBM breaks and subsequent proliferation. Parietal epithelial cells forming crescents, also called crescentic GN. Crescentic GN may be antibody-mediated, caused by antibodies to the GBM, or as a result of immune complex deposition. It can also occur in the absence of significant antibody deposition. Most patients with this type of RPGN have circulating anger. Nephrotic syndrome. Certain glomerular diseases virtually always produce the nephrotic syndrome. In addition, many other forms of primary and secondary glomerulopathies discussed in this chapter may underlie the syndrome. Before the major diseases associated with nephrotic syndrome are presented, the causes and pathophysiology of this clinical complex are briefly discussed. Pathophysiology. Nephrotic syndrome is caused by a derangement in glomerular capillary walls resulting in increased permeability to plasma proteins. The manifestations of the syndrome include the following. Acid proteinuria, with a daily loss of 3.5 g or more of protein less in children. Glomerular hypoalbuminemia, with plasma albumin levels less than 3 g/dl. Generalized edema, hypolipidemia, and lipoduria. The various components of nephrotic syndrome bear a logical relationship to one another. The glomerular capillary wall, with its endothelium, GBM, and visceral epithelial cells, acts as a size and charge barrier through which the plasma filtrate passes. Increased permeability resulting from either structural or physicochemical alterations in this barrier allows proteins to escape from the plasma into the urinary space, resulting in proteinuria. Heavy proteinuria depletes serum albumin levels at a rate beyond the compensatory synthetic capacity of the liver, resulting in hypoalbuminemia. Increased renal catabolism of filtered albumin also contributes to the hypoalbuminemia. The generalized edema is a direct consequence of decreased intravascular colloid osmotic pressure. There is also sodium and water retention, which aggravates the edema. Chapter 4. This seems to be due to several factors, including compensatory secretion of aldosterone, mediated by the hypovolemia-enhanced renin secretion, stimulation of the sympathetic system, and a reduction in the secretion of natriuretic factors such as atrial peptides. Edema is characteristically soft and pitting, and it is most marked in the periorbital regions and dependent portions of the body. If severe, it may also lead to pleural effusions and ascites. The largest proportion of protein lost in the urine is albumin, but globulins are also excreted in some diseases. The ratio of low to high molecular weight proteins in the urine in various cases of nephrotic syndrome is a manifestation of the selectivity of proteinuria. Highly selective proteinuria consists mostly of low molecular weight proteins. Albumin, 70 kD, transferrin, 76 kD molecular weight, whereas a poorly selective proteinuria consists of high molecular weight globulins in addition to albumin. The genesis of the hypolipidemia is complex. Most patients with nephrotic syndrome have increased blood levels of cholesterol, triglyceride, very low density lipoprotein, lipoprotein, and apoprotein, and there is a decrease in high density lipoprotein concentration in some patients. These defects seem to be due to a combination of increased synthesis of lipoproteins in the liver, abnormal transport of circulating lipid particles, and decreased lipid catabolism. Lipiduria follows the hypolipidemia because lipoproteins also leak across the glomerular capillary wall. The lipid appears in the urine either as free fat or as oval fat bodies, representing lipoprotein resorbed by tubular epithelial cells and then shed along with injured tubular cells that have detached from the basement membrane. Nephrotic patients are particularly vulnerable to infection, especially staphylococcal and pneumococcal infections, probably due to loss of immunoglobulins in the urine. Thrombotic and thromboembolic complications are also common in nephrotic syndrome, due in part to loss of endogenous anticoagulants, for example, antithrombin Roman 3 in the urine. Renal vein thrombosis, once thought to be a cause of nephrotic syndrome, is most often a consequence of this hypercoagulable state, particularly in patients with membranous nephropathy. See later. 912 Chapter 20 The kidney. Pathogenesis. The incidences of the several causes of the nephrotic syndrome vary according to age and geography. In children younger than 17 years of age in North America, for example, nephrotic syndrome is almost always caused by a lesion primary to the kidney. Among adults, in contrast, it is often associated with a systemic disease. Table 20.7 represents a composite derived from several studies of the causes of the nephrotic syndrome and is therefore only approximate. The most frequent systemic causes of the nephrotic syndrome are diabetes, amyloidosis, and sleep. The most important of the primary glomerular lesions are minimal change disease, membranous nephropathy, and FSGS. The first is most common in children in North America. The second is most common in older adults, and FSGS occurs at all ages. These three lesions are discussed individually in the following sections. Other less common causes of nephrotic syndrome include the various proliferative glomerulonephritides, such as MPGN and IgA nephropathy. Membranous nephropathy. Membranous nephropathy is characterized by diffuse thickening of the glomerular capillary wall due to the accumulation of deposits containing IgA along the subepithelial side of the basement membrane. Approximately 75% of cases of membranous nephropathy are primary. The remaining cases occur in association with other systemic diseases and have identifiable etiologic agents, and hence are referred to as secondary membranous nephropathy. The most notable of these associations are as follows. Drugs: penicillamine, Topical, goal, non-steroidal anti-inflammatory drugs NSAIDs, from 1% to 7% of nephrotic syndrome 7, 2 tell, approximate prevalence percent A, causes children and adults, primary glomerular disease, membranous nephropathy, minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephrititis and dense deposit disease, other proliferative glomerulonephrititis focal, pure mesangial, nephropathy B. Systemic diseases. Diabetes mellitus amyloidosis, systemic lupus erythematosus, drugs, non-steroidal anti-inflammatory, penicillamine, heroin infections, malaria, syphilis, hepatitis B and C, HIV, malignant disease, carcinoma, lymphoma, miscellaneous B, sting allergy, hereditary nephritis. Approximate prevalence of primary disease equals 95% of nephrotic syndrome in children, 60% in adults. Approximate prevalence of systemic disease equals 5% in children, 40% in adults. Membranoproliferative and other proliferative glomerulonephritides may result in mixed nephrotic/nephritic syndromes. Cause 375-1010, 3835-10, 217. Patients with rheumatoid arthritis treated with penicillamine or gold drugs now used infrequently for this disease develop membranous nephropathy. Underlying malignant tumors, particularly carcinomas of the lung and colon, and melanoma. According to some studies, these are present in as many as 5% to 10% of adults with membranous nephropathy. SLE, about 10% to 15% of glomerulonephritis and SLE is of the membranous type. Infections, chronic hepatitis B, hepatitis C, syphilis, schistosomiasis, malaria. Other autoimmune disorders such as thyroiditis can be associated with secondary membranous nephropathy. Pathogenesis. Membranous nephropathy is a form of chronic immune complex mediated disease. In secondary membranous nephropathy, the inciting antigens can sometimes be identified in the immune complexes. The antigens may be endogenous or exogenous. The endogenous antigens may be renal or non-renal, described later. Membranous nephropathy and SLE is associated with deposition of complexes of self-nuclear proteins and autoantibodies. Exogenous antigens include those derived from hepatitis B virus and Treponema pallidum in patients infected with these microbes. Primary formerly idiopathic membranous nephropathy is an autoimmune disease caused in most cases by antibodies to a renal autoantigen. A major recent advance came from the identification of the M-type phospholipase APO receptor PL-APO-R as the antigen that underlies 60% to 70% of human membranous nephropathy. Autoantibody binding to PL-APO-R, a membrane protein at the basal surface of the glomerular epithelial cell, is followed by complement activation and then shedding of the immune aggregates from the cell surface to form characteristic deposits of immune complexes along the subepithelial aspect of the basement membrane. See Fig. 24c. Less often, the target antigen is thrombosponin type 1 domain, containing 7-THSD7 or neutral endopeptidase CD10, a membrane protein recognized by placentally transferred maternal antibodies in cases of neonatal membranous nephropathy. The lesions bear a striking resemblance to those of experimental Hayman nephritis, which is induced by antibodies to the megalin antigenic complex present in the rat podocyte, the antigenic counterpart of the human PL-APO-R. How does the glomerular capillary wall become leaky in membranous nephropathy? There is a paucity of neutrophils, monocytes, or platelets in glomeruli. Virtually uniform presence of complement and corroborating experimental work suggests that the complement C5, C9 membrane attack complex has an important role. It is postulated that C5, C9 activates glomerular epithelial and mesangial cells, inducing them to liberate proteases and oxidants, which cause capillary wall injury and increase protein leakage. Subclass of IgG, IgG4, which differs from other IgG subclasses in being a poor activator of the classical complement pathway, is the principal immunoglobulin deposited in most cases of membranous nephropathy. How IgG4 may activate the complement system is not clear. Disease is 913. Morphology. Time. These spikes thicken to produce dome-like protrusions and eventually close over the immune deposits, burying them within a markedly thickened, irregular membrane. Immunofluorescence microscopy demonstrates that the granular deposits contain both immunoglobulins and complement. Fig. 20.11c. Immunostains also reveal PL-APO-R or THSD7 glomerular positivity in the majority of patients. However, a significant proportion of patients with secondary membranous nephropathy can also be positive. As the disease advances, segmental sclerosis may occur. In the course of time, glomeruli may become totally sclerosed. The epithelial cells of the proximal tubules contain protein resorption droplets, and there may be considerable interstitial mononuclear cell inflammation. Glomerular. By light microscopy, the glomeruli either appear normal in the early stages of the disease or exhibit uniform, diffuse thickening of the glomerular capillary wall. Fig. 20.11a. By electron microscopy, the thickening is seen to be caused by irregular electron-dense deposits containing immune complexes between the basement membrane and the overlying epithelial cells, with effacement of podocyte foot processes. Fig. 20.11b and d. Basement membrane material is laid down between these deposits, appearing as irregular spikes protruding from the GBM. These spikes are best seen by silver stains, which color the basement membrane, but not the deposits. Black. NUS, EPUS, B, NUS, a BCL, epithelium with effaced foot processes. thickened basement membrane, subepithelial, deposits. CD, figure 20.11 membranous nephropathy. Silver methenamine stain. Note the marked diffuse thickening of the capillary walls without an increase in the number of cells. There are prominent spikes of silver staining matrix arrow projecting from the basement membrane lamina densa toward the urinary space, which separate and surround deposited immune complexes that lack affinity for the silver stain. The electron micrograph showing electronense deposits arrow along the epithelial side of the basement membrane B. Note the effacement of foot processes overlying deposits. C. Characteristic granular immunofluorescent deposits of Ig along the glomerular basement membrane. D. Diagrammatic representation of membranous nephropathy. CL. Capillary lumen. N. Endothelium. Epithelium. US. Urinary space. A. Courtesy Dr. Charles Lassman, UCLA School of Medicine, Los Angeles, Calif. 914 Chapter 20 The kidney. Clinical features. This disorder usually presents with the insidious onset of the nephrotic syndrome or in 15% of patients with non-nephrotic proteinuria. Hematuria and mild hypertension are present in 15% to 35% of cases. It is necessary in any patient to first rule out the secondary causes described earlier because treatment of the underlying condition, malignant neoplasm, infection, or SLE or discontinuance of the offending drug can reverse or ameliorate the injury. The course of the disease is variable but generally indolent. In contrast to minimal change disease, described later, the proteinuria is not selective and usually does not respond well to corticosteroid therapy. Complete or partial remissions may occur in up to 40% of patients, even in some patients without therapy. Progression is associated with increasing sclerosis of glomeruli, rising serum creatinine reflecting renal insufficiency, and development of hypertension. Although proteinuria persists in more than 60% of patients, only about 10% die or progress to renal failure within 10 years, and no more than 40% eventually develop severe chronic kidney disease or SID. The disease recurs in up to 40% of patients who undergo transplantation for SID. Spontaneous remissions and a relatively benign outcome occur more commonly in women and in those with proteinuria in the non-nephrotic range. Because of the variable course of the disease, it has been difficult to evaluate the overall effectiveness of corticosteroids or other immunosuppressive therapy in controlling the proteinuria or progression. It is thought that circulating antibodies to PL-ATWA or and THSD7 may be useful biomarkers of disease activity and thereby aid in the diagnosis and management of membranous nephropathy. Minimal change disease. This relatively benign disorder is characterized by diffuse effacement of foot processes of visceral epithelial cells podocytes, detectable only by electron microscopy, and glomeruli that appear normal by light microscopy. It is the most frequent cause of nephrotic syndrome in children, but it is less common in adults. See Table 27. The peak incidence is between 2 and 6 years of age. The disease sometimes follows a respiratory infection or routine prophylactic immunization. Pathogenesis. Although the absence of immune deposits in the glomerulus excludes immune complex-mediated injury, several features of the disease point to an immunologic basis, including 1. The clinical association with respiratory infections and prophylactic immunization, 2. The response to corticosteroids and or other immunosuppressive therapy, 3. The association with other atopic disorders, for example, eczema, rhinitis, 4. The increased prevalence of certain HLA haplotypes in cases associated with atopy suggesting a genetic predisposition, and 5. The increased incidence of minimal change disease in patients with Hodgkin lymphoma, in whom defects in T-cell mediated immunity are well recognized. The current leading hypothesis is that minimal change disease involves some immune dysfunction that results in the elaboration of factors that damage visceral epithelial cells and cause proteinuria. Candidate pathogenic factors, such as angiopoietin and LIT4, have been identified in animal models, but none of these factors have been proven to cause the human disease. The ultrastructural changes point to a primary visceral epithelial cell injury podocytopathy, and studies in animal models suggest the loss of glomerular polyanions. Thus, defects in the charge barrier may contribute to the proteinuria. The actual route by which protein traverses the epithelial cell portion of the capillary wall remains an enigma. Possibilities include transcellular passage through epithelial cells, passage through residual spaces between remaining but damaged foot processes, or through abnormal spaces developing underneath the portion of the foot process that directly abuts the basement membrane, or leakage through foci in which the epithelial cells have become detached from the basement. Morphology. The glomeruli are normal by light microscopy. Fig. 2012. By electron microscopy, the GBM appears normal, and no electronense material is deposited. The principal lesion is in the visceral epithelial cells, which show a uniform and diffuse effacement of foot processes, these being reduced to a rim of cytoplasm with loss of recognizable intervening slit diaphragms. Fig. 2012b. This change, often incorrectly termed fusion of foot processes, actually represents simplification of the epithelial cell architecture with flattening, retraction, and swelling of foot processes. Foot process effacement is also present in other proteinuric states, for example, membranous glomerulopathy, diabetic nephropathy. It is only when effacement is associated with normal glomeruli by light microscopy that the diagnosis of minimal change disease can be made. Visceral epithelial changes are completely reversible after corticosteroid therapy, concomitant with remission of the proteinuria. The cells of the proximal tubules are often laden with lipid and protein, reflecting tubular reabsorption of lipoproteins passing through diseased glomeruli, thus the historical name lipoid nephrosis for this disease. Immunofluorescence. Studies show no Ig or complement deposits. Clinical features: despite massive proteinuria, renal function remains good, and there is commonly no hypertension or hematuria. The proteinuria usually is highly selective, most of the protein being albumin. A characteristic feature is its usually dramatic response to corticosteroid therapy. Most children, 90% with minimal change disease, respond rapidly to this treatment. However, proteinuria may recur in a significant proportion of patients, and some patients may become steroid dependent or resistant. Nevertheless, the long-term prognosis for patients is excellent, and even steroid-dependent disease usually resolves when children reach puberty. Although adults are slower to respond, their long-term prognosis is also excellent. As has been noted, minimal change disease in adults can be associated with Hodgkin lymphoma and, less frequently, other lymphomas and leukemias. In addition, secondary minimal change disease may follow NSAID therapy, usually in association with acute interstitial nephritis, to be described later in this chapter. Focal segmental glomerulosclerosis, primary FSGS, is the most common cause of nephrotic syndrome in adults in the United States. It is sometimes glomerular disease is 915. B. Figure 20.12. Minimal change disease. A glomerular stain with periodic acid, SCIF, no normal basement membranes, and absence of proliferation. The ultrastructural characteristics of minimal change disease include effacement of foot processes, arrows, and absence of deposits. CL, capillary lumen. M, mesangium. P, podocyte cell body. Considered to be a primary disorder of podocytes, like minimal change disease. As the name implies, this lesion is characterized by sclerosis of some, but not all, glomeruli. Thus, it is focal, and in the affected glomeruli, only a portion of the capillary tuft is involved. Thus, it is segmental. FSGS is frequently manifest clinically by the acute or subacute onset of nephrotic syndrome or non-nephrotic proteinuria. Hypertension, microscopic hematuria, and some degree of azotemia are commonly present when the disease is first clinically recognized. Classification and types. FSGS occurs in the following settings: as a primary disease, idiopathic FSGS, in association with other known conditions, such as HIV infection, HIV-associated nephropathy, heroin addiction, heroin nephropathy, sickle cell disease, and morbid obesity. As a secondary event, reflecting scarring of previously active necrotizing lesions in cases of focal glomerulonephritis, for example, IgA nephropathy. As a component of the adaptive response to loss of renal tissue, renal ablation, described earlier, whether from congenital anomalies, for example, unilateral renal agenesis, or renal dysplasia, or acquired causes, for example, reflux nephropathy, or in advanced stages of other renal disorders, such as hypertensive nephropathy. In uncommon inherited forms of nephrotic syndrome where the disease may be caused by mutations in genes that encode proteins localized to the slit diaphragm, for example, Hodgkin, alpha-actinin 4, and TRPC6 transient receptor potential calcium channel 6. Idiopathic FSGS accounts for 10% and 35% of cases of nephrotic syndrome in children and adults, respectively. FSGS, both primary and secondary forms, has increased in incidence and is now the most common cause of nephrotic syndrome in adults in the United States, particularly in Hispanic and African American patients. The clinical signs differ from those of minimal change disease in the following respects. 1. There is a higher incidence of hematuria, reduced GFR, and hypertension. 2. Proteinuria is more often non-selective. 3. There is poor response to corticosteroid therapy. And 4. There is progression to chronic kidney disease, with at least 50% developing SID within 10 years. Pathogenesis. The characteristic degeneration and focal disruption of visceral epithelial cells with effacement of foot processes resemble the diffuse epithelial cell change typical of minimal change disease and other podocytopathies. This epithelial damage is the ultrastructural hallmark of FSGS. Multiple different mechanisms can cause such epithelial damage, including circulating factors and genetically determined defects affecting components of the slit diaphragm complex. The hyalinosis and sclerosis stem from entrapment of plasma proteins in extremely hyperpermeable foci and increased ECM deposition. The recurrence of proteinuria after transplantation, sometimes within 24 hours, with subsequent progression to overt lesions of FSGS, suggests that an unknown circulating factor is the cause of the epithelial damage in some patients. The discovery of a genetic basis for some cases of FSGS and other causes of the nephrotic syndrome has improved the understanding of the pathogenesis of proteinuria in the nephrotic syndrome and has provided new methods for diagnosis and prognosis. Inherited forms of FSGS may be associated with the following. The first relevant gene to be identified, MPH-SOM, maps to chromosome 1913 and encodes the protein nephrin. Nephrin is a key component of the slit diaphragm. See Fig. 23, the structure that controls glomerular permeability. Several mutations of the MPHS gene have been identified that give rise to congenital nephrotic syndrome of the Finnish type, producing a minimal change disease, like glomerulopathy with extensive foot process effacement. A distinctive pattern of autosomal recessive FSGS results from mutations in the MPHS2 gene, which maps to chromosome 125, Q31, and encodes the protein product. Chapter 20. The kidney. Podocin. Podocin has also been localized to the slit diaphragm. Mutations in MPHS2 result in a syndrome of steroid-resistant nephrotic syndrome of childhood onset. Mutations in the gene encoding the podocyte actin binding protein alpha-actin 4 underlies some cases of autosomal dominant FSGS, which can be insidious in onset but has a high rate of progression to renal insufficiency. Mutations in the gene encoding TRPC6 have been found in some kindreds with adult-onset FSGS. This protein is widely expressed, including in podocytes, and the pathogenic mutations may perturb podocyte function by increasing calcium flux in these cells. What these proteins have in common is their localization to the slit diaphragm and to adjacent podocyte cytoskeletal structures. Their specific functions and interactions are incompletely understood, but it is clear that the integrity of each is necessary to maintain the normal glomerular filtration barrier. Recently, 2 sequence variants GON/G12 risk alleles in the apolipoprotein lone gene EPO-lone on chromosome 22 have been strongly associated with an increased risk of FSGS and renal failure in individuals of African descent, although the mechanisms underlying this association are not yet known. These sequence variants are particularly remarkable because the selective pressures for their conservation in people of African descent is a result of resistance to trypanosome infection conferred by these polymorphisms. Renal ablation FSGS, a secondary form of FSGS, occurs as a complication of glomerular and non-glomerular diseases causing reduction in functioning renal tissue. Particularly striking examples in which this occurs are reflux nephropathy and unilateral agenesis. These may lead to progressive glomerulosclerosis and renal failure. Glomerulosclerosis seems to be initiated by the adaptive change that occurs in the relatively unaffected glomeruli of diseased kidneys. Such a mechanism is suggested by experiments in rats subjected to subtotal nephrectomy. Compensatory hypertrophy of the remaining glomeruli initially maintains renal function in these animals, but proteinuria and segmental glomerulosclerosis soon develop, leading eventually to total glomerular sclerosis and uremia. Glomerular hypertrophy is associated with hemodynamic changes, including increases in glomerular blood flow, filtration, and transcapillary pressure, glomerular hypertension, and often with systemic hypertension. The sequence of events Fig. 2013 that is thought to lead to sclerosis in this setting entails endothelial and visceral epithelial cell injury, visceral epithelial cell loss leading to segments of GBM denuded of overlying foot processes and consequent increased glomerular permeability to proteins, and accumulation of proteins in the mesangial matrix. This is followed by proliferation of mesangial cells, infiltration by macrophages, increased accumulation of extracellular matrix ECM, and segmental and eventually global sclerosis of glomeruli. With increasing reductions in nephron mass and ongoing compensatory changes, a vicious cycle of continuing glomerulosclerosis sets in. Most of the mediators of chronic inflammation and fibrosis, particularly TGF-beta, play a role in the development of sclerosis. Currently, the most successful interventions to interrupt these mechanisms of progressive glomerulosclerosis involve treatment with inhibitors of the renin-angiotensin system, which not only systemic hypertension, mesangial cell hyperplasia/ECM, deposition, reductions in renal mass, intraglomerular hypertension, intraglomerular coagulation, glomerulosclerosis. Figure 20.13 focal segmental glomerulosclerosis associated with loss of renal mass. The adaptive changes in glomerular hypertrophy and glomerular capillary hypertension, as well as systemic hypertension, cause epithelial and endothelial injury and result in proteinuria. Mesangial response, involving mesangial cell proliferation and extracellular matrix production, together with intraglomerular coagulation, causes glomerulosclerosis. This results in further loss of functioning nephrons and a vicious circle of progressive glomerulosclerosis. Reduce intraglomerular hypertension, but also have direct effects on each of the mechanisms identified earlier. Importantly, these agents have been shown to ameliorate progression of sclerosis in both animal and human studies. Morphology. By light microscopy, the focal and segmental lesions may involve only a minority of the glomeruli and may be missed. If the biopsy specimen contains an insufficient number of glomeruli, Fig. 2014, in the sclerotic segments, there is collapse of capillary loops, increase in matrix, and segmental deposition of plasma. Proteins along the capillary wall hyalinosis, which may become so pronounced as to include capillary lumens, lipid droplets, and foam cells are often present. Fig. 2014b. Glomeruli that do not show segmental lesions usually appear normal on light microscopy, but may show increased mesangial matrix on electron microscopy. Both sclerotic and non-sclerotic areas show diffuse effacement of foot processes, and there may also be focal detachment of the epithelial cells and denudation of the underlying GBM. Immunofluorescence microscopy, IgM and C3 may be present in the sclerotic areas and or in the mesangium. In addition to the focal sclerosis, there may be pronounced hyalinosis and thickening of afferent arterioles. With progression of the disease, increase numbers of glomeruli become involved, and sclerosis spreads within each glomerulus. In time, this leads to total i.e. global sclerosis of glomeruli with pronounced tubular atrophy and interstitial fibrosis. A morphologic variant of FSGS, called collapsing glomerulopathy, is characterized by retraction and or collapse of the entire glomerular tuft, with or without additional FSGS lesions of the type described earlier. Fig. 2015. A characteristic feature is proliferation and hypertrophy of glomerular visceral epithelial cells. Collapsing glomerulopathy may be idiopathic, but it also has been associated with some drug toxicities, for example, pamidronate, and it is the most characteristic lesion of HIV-associated nephropathy. Collapsing glomerulopathy is typically associated with prominent tubular injury with formation of microcysts and prominent interstitial inflammation. It has a particularly poor prognosis. 916. Glomerular hypertrophy, epithelial/endothelial, injury, proteinuria. Disease is 917. A B figure 20.14 focal segmental glomerulosclerosis, periodic acid, skiff stain. Segmental sclerosis involves the upper half of both glomeruli. The high power view showing hyaline and sudation arrow and lipid small vacuoles in sclerotic area. Clinical features: there is little tendency for spontaneous remission in idiopathic FSGS, and responses to corticosteroid therapy are variable. In general, children have a better prognosis than adults do. Progression to renal failure occurs at variable rates. About 20% of patients follow an unusually rapid course, with intractable massive proteinuria ending in renal failure within 2 years. Factors associated with rapid progression include the degree of proteinuria, the degree of renal insufficiency at diagnosis, and histologic subtype. The collapsing variant has an unfavorable course. The tip variant has a relatively good prognosis. Occurrences are seen in 25% to 50% of patients receiving allografts. Figure 20.15 collapsing glomerulopathy. Visible or retraction of the glomerular tuft arrows, narrowing of capillary lumens, proliferation and swelling of visceral epithelial cells double arrows, and prominent accumulation of intracellular protein absorption droplets in the visceral epithelial cells arrowheads. Silver methenamine stain. Courtesy Dr. Jelena Kowalska, Cedars-Sinai Medical Center, Los Angeles, California. Glomerular HIV-associated nephropathy. HIV infection can directly or indirectly cause several renal complications, including acute renal failure or acute interstitial nephritis induced by drugs or infection, thrombotic myocardiopathies, post-infectious glomerulonephritis, and most commonly, a severe form of the collapsing variant of FSGS, termed HIV-associated nephropathy. The latter has been reported in 5% to 10% of HIV-infected individuals in some older series, more frequently in blacks than in whites. With the advent of antiretroviral therapy for HIV infection, the incidence of this lesion has been much reduced. The morphologic features of HIV-associated nephropathy are a high frequency of the collapsing variant of FSGS Fig. 2015, a striking focal cystic dilation of tubule segments, which are filled with proteinaceous material, and inflammation and fibrosis. The presence of large numbers of tubuloarticular inclusions within endothelial cells, detected by electron microscopy. Such inclusions, also present in SLE, have been shown to be modifications of endoplasmic reticulum induced by circulating interferon alpha. They are not usually present in idiopathic FSGS and therefore may have diagnostic value in a biopsy specimen. The pathogenesis of HIV-associated FSGS is unclear, but may be primarily due to the presence of the GON/G12 risk alleles for EPO alone. There is some data to suggest that HIV can infect tubular epithelial cells and podocytes, but much remains to be known. Membranoproliferative glomerulonephritis (MPGN) is best considered a pattern of immune-mediated injury rather than a specific disease. An emerging consensus on classification separates MPGN into 2 groups. One type are characterized by deposition of immune complexes containing Ig and complement, and a second type, Roman II, now called dense deposit disease, in which activation of complement appears to be the most important factor. The latter belong to a group of disorders called C3 glomerulopathies. The criteria that define this group are still evolving. Chapter 20, the kidney. MPGN is characterized histologically by alterations in the GBM, accumulation of mesangial matrix, proliferation of glomerular cells, leukocyte infiltration, and the presence of deposits in mesangial regions and glomerular capillary walls. As we will describe later, these deposits are made up of immune complexes in type I MPGN and some unknown material in type Roman II MPGN. In type Roman II, C3 is present on the GBM but not in the dense deposits. This difference is important and suggests that although morphologically similar, types I and Roman II MPGN are pathogenically distinct. In both types, because the proliferation is predominantly in the mesangium but also may involve the capillary loops, an older synonym is mesangiocapillary glomerulonephritis. MPGN accounts for up to 10% of cases of nephrotic syndrome in children and young adults. Some patients present only with hematuria or proteinuria in the non-nephrotic range, but many others have a combined nephrotic-nephritic picture. MPGN is increasingly recognized to be associated with other systemic disorders and known etiologic agents secondary MPGN, but there is still a residue of cases of unknown etiology primary MPGN. Figure 20.16 membranoproliferative glomerulonephritis, showing mesangial cell proliferation, increased mesangial matrix staining black with silver stain, basement membrane thickening with segmental splitting, accentuation of lobular architecture, swelling of cells lining peripheral capillaries, and influx of leukocytes endocapillary proliferation. Pathogenesis in most cases of type I MPGN. There is evidence of immune complexes in the glomerulus and activation of both classical and alternative complement pathways. The antigens involved in idiopathic MPGN are unknown. In many cases, they are believed to be proteins derived from infectious agents such as hepatitis C and B viruses, which presumably behave either as planted antigens after first binding to or becoming trapped within glomerular structures or are contained in preformed immune complexes deposited from the circulation. Clinical features: most patients with primary MPGN present in adolescence or as young adults with nephrotic syndrome and a nephritic component manifested by hematuria or, more insidiously, as mild proteinuria. Few remissions occur spontaneously in either type, and the disease follows a slowly progressive but unremitting course. Some patients develop numerous crescents and a clinical picture of RPGN. About 50% develop chronic renal failure within 10 years. Treatments with steroids, immunosuppressive agents, and antiplatelet drugs have not proven to be of any benefit. Morphology: secondary membrane-non-proliferative glomerulonephritis. Secondary MPGN invariably type I is more common in adults and arises in the following settings. Chronic immune complex disorders, such as SLE, hepatitis B infection, hepatitis C infection, usually with cryoglobulinemia, endocarditis, infected ventriculotracheal shunts, chronic visceral abscesses, HIV infection, and schistosomiasis. Alpha-1 antitrypsin deficiency. Malignant diseases, particularly lymphoid tumors such as chronic lymphocytic leukemia, which are commonly complicated by development of autoantibodies. The glomeruli are large and hypercellular. The hypercellularity is produced both by proliferation of cells in the mesangium and so-called endocapillary proliferation involving capillary endothelium and infiltrating leukocytes. The glomeruli have an accentuated lobular appearance due to the proliferating mesangial cells and increased mesangial matrix Fig. 20:16. The GBM is thickened and often shows a double contour or Trantrek appearance, especially evident in silver or PAS stains. This is caused by duplication of the basement membrane, also commonly referred to as splitting, usually as the result of new basement membrane synthesis in response to subendothelial deposits of immune complexes. Between the duplicated basement membranes, there is inclusion or interposition of cellular elements, which can be of mesangial, endothelial, or leukocytic origin. Such interposition also gives rise to the appearance of split basement membranes. Fig. 20:17. Crescents are present in many cases. Type I MPGN is characterized by the presence of discrete subendothelial electron-dense deposits, mesangial and occasional subepithelial deposits may also be present. See Fig. 20:17. By immunofluorescence, EG and C3 are deposited in a granular pattern, and early complement components connecting C4 are often also present, indicative of an immune complex. Pathogenesis: 918. Dense deposit disease. Most patients with dense deposit disease, formerly called type Roman II MPGN, have abnormalities resulting in excessive activation of the alternative complement pathway. These patients have a consistently decreased serum C3 but normal colon and C4, the early components of complement. They also have diminished serum levels of factor B and properdin, components of the alternative complement pathway. The glomeruli contain deposits of C3 and properdin, but not EG. Recall that in the alternative complement pathway, C3 is directly cleaved to C3. Fig. 20:18. See also Chapter 3. Disease is 919. MCL. CL, a B type I. Subendothelial. Deposit. Interposed mesangial cell process. Intramembranous. Deposit. Type Roman II. See Figure 20.17. A membrane-non-proliferative glomerulonephritis. Type I. No discrete electron-dense deposits. Arrows incorporated into the glomerular capillary wall between duplicated split basement membranes. Double arrows. And in mesangial regions. M. B dense deposit disease. Type Roman II. Membrane-non-proliferative glomerulonephritis. There are dense homogeneous deposits within the basement membrane. In both, mesangial interposition gives the appearance of split basement membranes when viewed in a light microscope. See schematic representation of patterns in the two types of membrane-non-proliferative glomerulonephritis. In type I, there are subendothelial deposits. Type Roman II is characterized by intramembranous dense deposits. Dense deposit disease. In both, the basement membranes appear split when viewed in a light microscope. CL, capillary lumen. A. Courtesy Dr. Jelena Kowalska. Cedars-Sinai Medical Center, Los Angeles, Calif. Glomerular. Fig. 3:12. The reaction depends on the initial activation of C3 by such substances as bacterial polysaccharides, endotoxin, and aggregates of IgA via a pathway involving factors B and D. This leads to the generation of C3BB, the alternative pathway C3 convertase. Normally, this C3 convertase is labile, but more than 70% of patients with dense deposit disease have a circulating autoantibody termed C3 nephritic factor C3nef that binds the alternative pathway C3 convertase and protects it from inactivation. See Fig. 20.18. This favors persistent C3 activation in hypocomplementemia. There is also decreased C3 synthesis by the liver, further contributing to the profound hypocomplementemia. 920. Chapter 20. The kidney. Properdin C3nef, polysaccharide, endotoxin, IgA aggregates, C3BD, MgPro+, C3BB, alternative pathway C3 convertase, stabilize, degrade, C3C3, Figure 20.18. The alternative complement pathway in C3 glomerulopathy and atypical hemolytic uremic syndrome. Note that C3nef, an antibody present in the serum of individuals with membrane-non-proliferative glomerulonephritis, acts at the same step as properdin, serving to stabilize the alternative pathway C3 convertase, thus enhancing C3 activation and consumption, causing hypocomplementemia. The precise nature of the dense deposits is unknown. Mutations in components of the alternate pathways such as factor H have also been associated with dense deposit disease. Morphology. While some cases of dense deposit disease share histologic features with MPGN, there is a wider spectrum of histologic alterations in dense deposit disease. Many cases have a predominantly mesangial proliferative pattern of injury, while others have an inflammatory and focally crescentic appearance. In some cases, dense deposits of a cellular material can be seen permeating the GBMs in histologic sections. The defining feature is revealed by electron microscopy, which demonstrates permeation of the lamina densa of the GBM by ribbon-like, homogeneous, extremely electron-dense material of unknown composition. See Fig. 20. 17b. Immunofluorescence. C3 is present in irregular granular or linear foci in the basement membranes on either side but not within the dense deposits. C3 is also present in the mesangium in characteristic circular aggregates mesangial rings. G is usually absent, as are components of the classical pathway of complement activation such as connect and C4. C3 glomerulopathies other than dense deposit disease can have a similar distribution, with mesangial and capillary wall involvement, but lack the extremely electron-dense deposits that define dense deposit disease. Clinical features. Dense deposit disease affects primarily children and young adults. The clinical presentation of nephritic syndrome with hematuria and / or nephrotic syndrome with proteinuria overlaps with that of MPGN. The prognosis is poor, with over one-half of patients progressing to acid. There is a high incidence of recurrence in transplant recipients. Dense deposits recur in 90% of such patients. Fibrillary glomerulonephritis. Fibrillary glomerulonephritis is a rare disease characterized by fibrillary deposits in the mesangium and glomerular capillary walls that resemble amyloid fibrils superficially. IH. But differ ultrastructurally and do not stain with Congo red. The glomerular lesions usually show mesangial-proliferative or membranous-proliferative patterns by light microscopy. Immunofluorescence microscopy. There is selective deposition of polyclonal Ig, often of the Ig4 subclass, complement C3, in a cap and a glandular light chains. Clinically, patients develop nephrotic syndrome, hematuria, and progressive renal insufficiency. The disease recurs in kidney transplants. The pathogenesis is unknown, but DNAG-B9, a co-chaperone for heat shock protein 70 seconds, recently has been identified as a highly sensitive and specific marker for fibrillary GN. Key concepts. The nephrotic syndrome. Membranous nephropathy is caused by an autoimmune response, most often directed against the PL-ATWA or on podocytes. It is characterized by granular subepithelial deposits of antibodies with GBM thickening and loss of foot processes but little or no inflammation. The disease is often resistant to steroid therapy. The nephrotic syndrome is characterized by proteinuria, which results in hypoalbuminemia and edema. Podocyte injury is an underlying mechanism of proteinuria, and may be the result of non-immune causes as in minimal change disease and FSGS or immune mechanisms as in membranous nephropathy. Minimal change disease is the most frequent cause of nephrotic syndrome in children. It is manifested by proteinuria and effacement of glomerular foot processes without antibody deposits. The pathogenesis is unknown. Secondary forms can be triggered by infections, immunization, drugs, and certain neoplastic lesions. The disease responds well to steroid therapy. FSGS may be primary podocyte injury by unknown mechanisms or secondary, for example, as a consequence of prior glomerulonephritis, hypertension, or infections such as HIV. Glomeruli show focal and segmental obliteration of capillary lumens and loss of foot processes. The disease is often resistant to therapy and may progress to acid. MPGN in most cases is the result of immune complex deposition in both mesangial regions and capillary walls. It may be associated with systemic infections. Dense deposit disease, formerly type Roman II MPGN, defined by a unique permeation of GBMs by electron-dense material, primarily affects children and young adults. It is associated with acquired or genetic dysregulation of the alternate pathway of complement. Fibrillary glomerulonephritis is a rare disease characterized by Congo red-negative fibrillary glomerular deposits of unknown etiology. Other glomerular diseases. IgA nephropathy. Berger disease. IgA nephropathy, characterized by the presence of prominent IgA deposits in the mesangial regions and recurrent hematuria, is the most common type of glomerulonephritis worldwide. The disease can be suspected by light microscopic examination, but the diagnosis is made only by the detection of glomerular IgA deposition. Fig. 20.19. Mild proteinuria is usually present in the nephrotic syndrome. Glomerular disease is 921. 8b. Figure 20.19. IgA nephropathy. A light microscopy showing mesangial proliferation and matrix increase. The characteristic deposition of IgA, principally in mesangial regions, detected by immunofluorescence, may occasionally develop. Rarely, patients may present with crescentic GN. Whereas IgA nephropathy is typically an isolated renal disease, similar IgA deposits are present in a systemic disorder of children, Henoch-Schönlein purpura, to be discussed later, which has many overlapping features with IgA nephropathy. In addition, secondary IgA nephropathy occurs in patients with liver and intestinal diseases, as discussed later. Pathogenesis. Current evidence favors a multi-hit etiology for this disorder involving several steps. IgA, the main IgA mucosal secretions, is present in plasma at low concentrations, mostly in monomeric form, the polymeric forms being catabolized in the liver. In patients with IgA nephropathy, levels of plasma polymeric IgA are increased, but increased production is not sufficient to cause this disease. The clue comes from the observation that in IgA nephropathy, the glomerular deposits consist predominantly of polymeric IgA molecules with aberrant glycosylation. It is believed that a key facet of IgA nephropathy is a hereditary or acquired defect in the normal formation or attachment of galactose-containing sugar chains called O-linked glycans to the hinge region of the IgA molecule, particularly to those of the IgA subclass prior to their secretion by B cells. This aberrantly glycosylated IgA is either deposited by itself in glomeruli, or it elicits an autoimmune response and forms immune complexes in the circulation with IgG autoantibodies directed against the abnormal IgA molecules. Immune complexes are deposited in the mesangium. Alternatively, the abnormal IgA is deposited in the mesangium with subsequent formation of immune complexes in situ. The mesangial immune deposits then activate mesangial cells to proliferate, produce increased amounts of ECM, and secrete numerous cytokines and growth factors. These secreted mediators may not only participate in further mesangial cell activation but may also recruit inflammatory cells into the glomeruli. The recruited leukocytes contribute to glomerular injury and also to a reparative response, which can include opsonization and removal of the immune complexes. The deposited IgA and IgA-containing immune complexes activate the complement system via the alternate pathway, and hence the presence of C3 and the absence of Connect and C4 in glomeruli are typical of this disorder. Genetic influence is suggested by the occurrence of this condition in families and in HLA identical siblings, the increased frequency of certain HLA and complement genotypes in some populations, and the findings of genome-wide association studies linking specific MHC class Roman II loci to disease susceptibility. Epidemiologic features of this disorder indicate that the increased synthesis of abnormal IgA may occur in response to respiratory or gastrointestinal exposure to environmental agents, for example, viruses, bacteria, food proteins. The specific initiating antigens are unknown, and several infectious agents and food products have been implicated. IgA nephropathy occurs with increased frequency in individuals with gluten enteropathy, celiac disease, in whom intestinal mucosal defects are well defined, and in liver disease, in which there is defective hepatobiliary clearance of IgA complexes, secondary IgA nephropathy. Morphology. On histologic examination, the lesions vary considerably. The glomeruli may be normal or may show mesangial widening and endocapillary proliferation. Mesangial-proliferative glomerulonephritisis Fig. 2019. Segmental proliferation confined to some glomeruli. Focal proliferative glomerulonephritisis, or rarely, overt crescentic glomerulonephritisis. The presence of leukocytes within glomerular capillaries is a variable feature. The mesangial widening may be the result of cell proliferation, accumulation of matrix, immune deposits, or some combination of these abnormalities. Healing of the focal proliferative lesion may lead to secondary focal segmental sclerosis. The characteristic immunofluorescent picture is of mesangial deposition of IgA Fig. 2019b, often with C3 and property and lesser amounts of IgG or IgM. Early complement components are usually absent. Electron microscopy confirms the presence of electron-dense deposits predominantly in the mesangium. Capillary wall deposits, if present, are usually sparse. Clinical features: the disease affects people of any age, most commonly older children and young adults. Many patients present with gross hematuria after an infection of the respiratory or, less commonly, gastrointestinal or urinary tract. 30% to 40% have only microscopic hematuria, with or without proteinuria. Chapter 20. The kidney. And 5% to 10% develop acute nephritic syndrome, including some with RPGN. The hematuria typically lasts for several days and then subsides, only to return every few months. The subsequent course is highly variable. Many patients maintain normal renal function for decades. Slow progression to chronic renal failure occurs in 15% to 40% of cases over a period of 20 years. Onset in old age, heavy proteinuria, hypertension, and the extent of glomerulosclerosis on biopsy are clues to an increased risk of progression. Recurrence of IgA deposits in transplanted kidneys is frequent, and in approximately 15% of those with recurrent IgA deposits, the disease runs the same slowly progressive course as that of primary IgA nephropathy. Hereditary nephritis. Hereditary nephritis refers to a group of heterogeneous familial renal diseases associated with mutations in collagen genes that manifest primarily with glomerular injury. Two deserve discussion. Alport syndrome, because the lesions and genetic defects have been well studied, and thin basement membrane nephropathy, the most common cause of benign familial hematuria. Alport syndrome is caused by mutations affecting type Roman IV collagen that result in hematuria with progression to chronic renal failure, accompanied by nerve deafness and various eye disorders, including lens dislocation, posterior cataracts, and corneal dystrophy. The disease is inherited as an X-linked trait in approximately 85% of cases. In the X-linked form, males express the full syndrome, while female heterozygotes typically present with hematuria. Approximately 90% of affected males progress to SID before 40 years of age. Autosomal recessive and autosomal dominant pedigrees also exist, in which males and females are equally susceptible to the full syndrome. Pathogenesis. The disease manifestations are due to mutations in one of several genes coding for subunits of the collagen Roman IV molecule. More than 500 mutations resulting in disease have been identified, all of which interfere with assembly of type Roman IV collagen, which is crucial for function of the GBM, the lens of the eye, and the cochlea. Because the GBM consists of networks of trimeric collagen Roman IV molecules composed of alpha-3, alpha-4, In alpha-5 chains, mutations affecting any one chain result in defective assembly of the collagen network. Because type Roman 4 collagen chains are encoded on autosomes chromosomes 2 and 13 and the X chromosome, the inheritance pattern can be autosomal or X-linked. Instance and splice site mutations, insertions, and deletions have all been identified. Genetic analysis has shown that in patients with X-linked disease, large deletions in the collagen Roman 4 alpha-5 chain COL4A5 are associated with SID at an earlier age. Morphology. Fully developed Alport syndrome has characteristic electron microscopic findings. The GBM shows irregular foci of thickening alternating with attenuation thinning, and pronounced splitting and lamination of the lamina densa, often producing a distinctive. Figure 20.20 Hereditary nephritis Alport syndrome. Electron micrograph of the glomerular capillary with irregular thickening of the basement membrane, lamellation of the lamina densa, and foci of rarefaction. Such changes may be present in other diseases but are most pronounced and widespread in hereditary nephritis. CL, capillary lumen, epithelium, basket weave appearance Fig. 20.20. Similar alterations can be found in the tubular basement membranes. Immunohistochemistry can be helpful in cases with absent or borderline basement membrane lesions because antibodies to alpha-3, alpha-4, and alpha-5 collagen fail to stain both glomerular and tubular basement membranes in the classic X-linked form. There is also absence of alpha-5 staining in skin biopsy specimens from these patients. As the disease progresses, there is development of focal segmental and global glomerular sclerosis and other changes of progressive renal injury, including vascular sclerosis, tubular atrophy, interstitial fibrosis. 922. Clinical features. The most common presenting sign is gross or microscopic hematuria, frequently accompanied by red cell casts. Proteinuria may develop later, and rarely, the nephrotic syndrome develops. Symptoms appear at 5 to 20 years of age, and the onset of overt renal failure is between 20 and 50 years of age in men. The auditory defects may be subtle, requiring sensitive testing. Thin basement membrane nephropathy. Benign familial hematuria. This is a fairly common hereditary entity manifested clinically by familial asymptomatic hematuria, usually uncovered on routine urinalysis, and morphologically by diffuse thinning of the GBM to widths between 150 and 225 nm compared with 300 to 400 nm in healthy adults. Although mild or moderate proteinuria may also be present, renal function is normal and prognosis is excellent. The abnormality is estimated to affect 1% of the general population. The disorder should be distinguished from IgA nephropathy, another common cause of hematuria, and X-linked Alport syndrome. In contrast to Alport syndrome, hearing loss, ocular abnormalities, and a family history of renal failure are absent. The anomaly in thin basement membrane nephropathy has also been traced to mutations in genes encoding alpha-3 or diseases 923, alpha-4 chains of type Roman 4 collagen. The disease most often has an autosomal inheritance, and most patients are heterozygous for the defective gene. The disorder in homozygous resembles autosomal recessive Alport syndrome. Homozygous or compound heterozygous may progress to renal failure. Thus, these diseases illustrate a continuum of changes resulting from mutations in collagen type Roman 4 genes. Key concepts. Glomerular diseases with isolated hematuria. IgA nephropathy, characterized by mesangial deposits of IgA-containing immune complexes, is the most common cause of glomerulonephritis worldwide. It is a common cause of both isolated and frequently recurrent hematuria and of various degrees of proteinuria and sometimes of nephritic syndrome. It commonly affects children and young adults and has a variable course. Alport syndrome, a form of hereditary nephritis, is caused by mutations in genes encoding GBM type Roman 4 collagen. It manifests as hematuria and slowly progressing proteinuria and declining renal function. Glomeruli appear normal by light microscopy until late in the disease course. Thin basement membrane nephropathy has a benign clinical course and is also the result of mutations in genes coding for GBM type Roman 4 collagen and hence may be considered as part of a spectrum of diseases that includes hereditary nephritis. Glomerular lesions associated with systemic diseases. Many immunologically mediated, metabolic, or hereditary systemic disorders are associated with glomerular injury, and some, for example, SLE and diabetes. The glomerular involvement is a major clinical manifestation. Most of these diseases are discussed elsewhere in this book. Here we briefly recall some of the lesions and discuss only those not considered in other sections. Lupus nephritis. The various types of lupus nephritis are described in Chapter 6. As discussed, SLE gives rise to a wide variety of renal lesions and clinical presentations. Clinical manifestations can include recurrent microscopic or gross hematuria, nephritic syndrome, or PGN, nephrotic syndrome, acute and chronic renal failure, and hypertension. In Epstein-Barr purpura, this childhood syndrome consists of purpuric skin lesions, abdominal pain and intestinal bleeding, and arthralgias along with renal abnormalities. Skin lesions characteristically involve the extensor surfaces of arms and legs as well as buttocks. Abdominal manifestations include pain, vomiting, and intestinal bleeding. Renal manifestations occur in 1/3 of patients and include gross or microscopic hematuria, nephritic syndrome, nephrotic syndrome, or some combination of these. A small number of patients, mostly adults, develop a rapidly progressive form of glomerulonephritis with many crescents. Not all components of the syndrome need to be present for the diagnosis, and individual patients may have purpura, abdominal pain, or urinary abnormalities as the dominant feature. The disease is most common in children 3 to 8 years of age, but it also occurs in adults, in whom the renal manifestations are usually more severe. There is a strong background of atopy in about 1/3 of patients, and onset often follows an upper respiratory infection. IgA is deposited in the glomerular mesangium in a distribution similar to that of IgA nephropathy. This has led to the concept that IgA nephropathy and Hennach-Schönlein purpura are manifestations of the same disease. The finding of IgA and C3 deposits in glomeruli suggests that immune complexes are involved in the disease. Morphology. On histologic examination, the renal lesions vary from mild focal mesangial proliferation to diffuse mesangial proliferation and / or endocapillary proliferation to crescentic glomerulonephritis. Whatever the histologic lesions, the pathognomonic feature by fluorescence microscopy is the deposition of IgA, sometimes with Ig and C3, in the mesangial region, sometimes with deposits extending to the capillary loops. Skin lesions consist of subepidermal hemorrhages and a necrotizing vasculitis involving the small vessels of the dermis. Deposits of IgA, along with Ig and C3, are also present in such vessels. Vasculitis also occurs in other organs, such as the gastrointestinal tract, but is rare in the kidney. The course of the disease is variable, but recurrences of hematuria may persist for many years after onset. Most children have an excellent prognosis. Patients with the more diffuse lesions, crescents, or the nephrotic syndrome have a somewhat poorer prognosis. Diabetic nephropathy. Diabetes is a major cause of renal morbidity and mortality, and diabetic nephropathy is the leading cause of chronic kidney failure in the United States. Advanced or end-stage kidney disease occurs in as many as 40% of both type 1 diabetics and type 2 diabetics. The pathology and pathogenesis of this disorder are discussed in Chapter 24. Other systemic disorders: Goodpasture syndrome, Chapter 15, microscopic polyangiitis, and granulomatosis with polyangiitis, formerly called Wegener granulomatosis, Chapter 11, are commonly associated with glomerular lesions, as described in the discussion of these diseases. Suffice it to say here that the glomerular lesions in these three conditions can be histologically similar and are principally characterized by foci of glomerular necrosis and crescent formation. In the early or mild forms of renal involvement, there is focal and segmental, sometimes necrotizing, glomerulonephritis, and most of these patients will have hematuria with a mild decline in GFR. In the more severe cases, which may be associated with RPGN, there is more extensive necrosis, fibrin deposition, and extensive formation of epithelial cellular crescents, which can become organized to form fibrocellular and fibrous crescents if the glomerular injury evolves into segmental or global scarring sclerosis. Glomerular. 924, Chapter 20, the kidney. Essential mixed cryoglobulinemia is another systemic condition in which deposits of cryoglobulins composed principally of Ig-IgM complexes induce cutaneous vasculitis, synovitis, and a proliferative glomerulonephritis, typically MPGN. Most cases of essential mixed cryoglobulinemia have been associated with infection with hepatitis C virus, and this condition in particular is associated with glomerulonephritis, usually MPGN type I. Immunoglobulins secreted by plasma cell neoplasms may also induce glomerular lesions, including amyloidosis, tubular and interstitial diseases. Most forms of tubular injury involve the interstitium as well. Therefore, diseases affecting these two components are discussed together. Under this heading, we consider two major processes. 1. Ischemic or toxic tubular injury, and 2. Inflammation of the tubules and interstitium, tubulointerstitial nephritis. Acute tubular injury / necrosis. ATI is characterized by acute renal failure and often, but not invariably, morphologic evidence of tubular injury in the form of necrosis of tubular epithelial cells. Because necrosis is often not present, the term ATI is preferred by pathologists over the older name acute tubular necrosis, ATN. It is the most common cause of acute kidney injury. ATI can be caused by a variety of conditions, including the following. Ischemia, due to decreased or interrupted blood flow. Examples include diffuse involvement of the intrarenal blood vessels, such as in microscopic polyangiitis, microangiopathies, for example, hemolytic uremic syndrome, HUS, or thrombotic thrombocytopenic purpura, TTP, or decreased effective circulating blood volume, as occurs in hypovolemic shock, Chapter 4. Direct toxic injury to the tubules. This may be caused by endogenous agents, for example, myoglobin, hemoglobin, monoclonal light chains, bile/bilirubin, or exogenous agents, for example, drugs, radiocontrast dyes, heavy metals, organic solvents. ATI accounts for some 50% of cases of acute kidney injury in hospitalized patients. Other causes of acute renal failure are discussed elsewhere in this chapter. ATI is a reversible process that arises in a variety of clinical settings. Most of these, ranging from severe trauma to acute pancreatitis, have in common a period of inadequate blood flow to the peripheral organs, usually accompanied by marked hypotension and shock. This pattern is called ischemic ATI. The second pattern, called nephrotoxic ATI, is caused by a multitude of drugs, such as gentamicin, radiographic contrast agents, poisons, including heavy metals, for example, mercury, and organic solvents, for example, carbon tetrachloride. Combinations of ischemic and nephrotoxic ATI also can occur, exemplified by mismatched blood transfusions and other hemolytic crises causing hemoglobinuria and skeletal muscle injuries causing myoglobinuria. Such injuries result in characteristic intratubular hemoglobin or myoglobin casts, respectively. The toxic iron content of these globin molecules contributes to the ATI. In addition to its frequency, the potential reversibility of ATI adds to its clinical importance. Proper management can make the difference between recovery and death. Pathogenesis. The critical events in both ischemic and nephrotoxic ATI are 1. Tubular injury and 2. Persistent and severe disturbances in blood flow. Fig. 20.21. Tubular cell injury. Tubular epithelial cells, especially those of proximal tubules, are particularly sensitive to ischemia and are also vulnerable to toxins. Several factors predispose the tubules to toxic injury, including an increased surface area for tubular reabsorption, active transport systems for ions and organic acids, a high rate of metabolism and oxygen consumption that is required to perform these transport and reabsorption functions, and the capability for resorption and concentration of toxins. Ischemia causes numerous structural and functional. Toxic injury ischemia, tubular injury vasoconstriction, tubular backleak sloughed cells interstitial inflammation, decreased urine output obstruction, decreased GFR. Figure 20.21 postulated sequence in ischemic or toxic acute tubular injury, GFR, glomerular filtration rate. Tubular and interstitial disease is 925. Alterations in epithelial cells, as discussed in Chapter 2. One early reversible result of ischemia is loss of cell polarity due to redistribution of membrane proteins, for example, the enzyme NOD, K+ at pace from the basolateral to the luminal surface of the tubular cells, resulting in abnormal ion transport across the cells and increased sodium delivery to distal tubules, which incites vasoconstriction via tubular glomerular feedback. Initially, this response to the increased sodium lowers the GFR to maintain distal blood flow. In addition, ischemic tubular cells express cytokines and adhesion molecules, thus recruiting leukocytes that appear to participate in the subsequent injury. In time, injured cells detach from the basement membranes and cause luminal obstruction, increased intratubular pressure, and further decrease in GFR. In addition, glomerular filtrate in the lumen of the damaged tubules can leak back into the interstitium, resulting in interstitial edema, increased interstitial pressure, and further damage to the tubule. All of these effects, as shown in Fig. 20.21, contribute to the decreased GFR. Disturbances in blood flow. Ischemic renal injury is also characterized by hemodynamic alterations that cause reduced GFR. The major one is intrarenal vasoconstriction, which results in both reduced glomerular blood flow and reduced oxygen delivery to the functionally important tubules in the outer metallic ascending limb and straight segment of the proximal tubule. Several vasoconstrictor pathways have been implicated, including the renin-angiotensin system, stimulated by decreased sodium in the tubules as a result of decreased blood pressure, and suboptimal endothelial injury, leading to increased release of the vasoconstrictor endothelin and decreased production of the vasodilators nitric oxide and prostacyclin prostaglandin ITWA. There is also some evidence of a direct effect of ischemia or toxins on the glomerulus, causing a reduced glomerular ultrafiltration coefficient. The patchiness of tubular necrosis and maintenance of the integrity of the basement membrane along many segments allow repair of the injured foci and recovery of function if the precipitating cause is removed. This repair is dependent on the capacity of reversibly injured epithelial cells to proliferate and differentiate. Reepithelialization is mediated by a variety of growth factors and cytokines produced locally by the tubular cells themselves or by inflammatory cells in the vicinity of necrotic foci. CD, ischemic type, PCT, PST. Figure 20.22 patterns of tubular damage in ischemic and toxic acute tubular injury. In the ischemic type, tubular necrosis is patchy. Relatively short lengths of tubules are affected, and proximal straight tubule PST segments and ascending limbs of Henel's loop HL are most vulnerable. In toxic acute tubular injury, extensive necrosis is present along the proximal convoluted tubule PCT segments with many toxins, for example, mercury. But necrosis of the distal tubule, particularly ascending HL, also occurs. In both types, lumens of the distal convoluted tubules DCT and collecting duct CD contain casts. DCT, HL, CD, toxic type, PCT, PST, DCT, cast necrosis, HL. Morphology ATI is characterized by tubular epithelial injury at multiple points along the nephron, with large skip areas in between, often accompanied by rupture of basement membranes tubulorexis and occlusion of tubular lumens by cast figs. 20.22 and 20.23. The distinct patterns of tubular injury and ischemic and toxic ATI are shown in Fig. 20.22. The straight portion of the proximal tubule and the ascending thick limb in the renal medulla are especially vulnerable, but focal lesions may also occur in the distal tubule, often in conjunction with casts. It should be noted that the severity of the morphologic findings often does not correlate with the severity of clinical manifestations. Figure 20.23 acute tubular injury. Some tubular epithelial cells in the tubules are necrotic, and many have detached from their basement membranes and been sloughed into the tubular lumens. Other findings in ischemic ATI are interstitial edema and accumulations of leukocytes within dilated vasa. There is also evidence of epithelial regeneration in the form of flattened epithelial cells with hyperchromatic nuclei and mitotic figures. In time, this regeneration repopulates the tubules so that no residual evidence of damage is seen. 926 Chapter 20 The kidney. Toxic ATI is manifested by ATI, most obvious in the proximal convoluted tubules. On histologic examination, the tubular injury can be distinctive and poisoning with certain agents. With mercuric chloride, for example, Severely injured cells may contain large acidophilic inclusions. Later, these cells become necrotic, are disquamated into the lumen, and may undergo calcification. Ethylene glycopoisoning produces marked ballooning and hydropic or vacuolar degeneration of proximal convoluted tubules, and calcium oxalate crystals are often also found in the tubular lumens. Causes. Clinical features. The clinical course of ATI is highly variable, but the classic case may be divided into 3 stages. Initiation phase, lasting about 36 hours, is dominated by the inciting medical, surgical, or obstetric event. The only indication of renal involvement is a slight decline in urine output with a rise in BUN. At this point, oliguria could be explained by a transient decrease in blood flow and declining GFR. Maintenance phase is characterized by sustained decreases in urine output to between 40 and 400 ml/day. Oliguria, salt and water overload, rising BUN concentrations, hyperkalemia, metabolic acidosis, and other manifestations of uremia. With appropriate management, the patient can overcome this oliguric crisis. Recovery phase is ushered in by a steady increase in urine volume that may reach up to 3 L/day. The tubules are still damaged, so large amounts of water, sodium, and potassium are lost in the flood of urine. Hypokalemia, rather than hyperkalemia, becomes a clinical problem. There is a peculiar increased vulnerability to infection at this stage. Eventually, renal tubular function is restored and concentrating ability improves. At the same time, BUN and creatinine levels begin to return to normal. Subtle tubular functional impairment may persist for months, but most patients who reach this phase eventually recover completely. The prognosis of ATI depends on the magnitude and duration of injury. Recovery is expected with nephrotoxic ATI when the toxin has not caused serious damage to other organs, such as the liver or heart. For supportive care, 95% of those who do not succumb to the precipitating cause recover. Conversely, in shock related to sepsis, extensive burns, or other causes of multi-organ failure, the mortality rate can exceed 50%. Key concepts: acute tubular injury. ATI is the most common cause of acute kidney injury and attributed to ischemia and or toxicity from an endogenous or exogenous substance. Tubular epithelial cell injury and altered intrarenal hemodynamics are the primary contributors to ATI. The clinical outcome is determined by the magnitude and duration of ATI. Tubulointerstitial nephritis. This group of renal diseases involves inflammatory injuries of the tubules and interstitium that are often insidious in onset and are principally manifest by azotemia. Tubulointerstitial nephritis can be acute or chronic. Acute tubulointerstitial nephritis has a rapid clinical onset and is characterized histologically by interstitial edema, often accompanied by leukocytic infiltration of the interstitium and tubules, and tubular injury. In chronic interstitial nephritis, there is infiltration with predominantly mononuclear leukocytes, prominent interstitial fibrosis, and widespread tubular atrophy. Secondary tubulointerstitial nephritis is also present in a variety of vascular, cystic polycystic kidney disease, and metabolic diabetes renal disorders, in which it may also contribute to progressive damage. Here we discuss primary causes of tubulointerstitial injury. Table 28. Glomerular and vascular abnormalities may also be present in advanced stages of these diseases. Conversely, chronic tubulointerstitial damage is an important consequence of progression in diseases that primarily affect the glomerulus. Tubulointerstitial disorders are distinguished clinically from the glomerular diseases by the following hallmarks: absence of nephritic or nephrotic syndrome, presence of defects in tubular function. The latter may be subtle and include impaired ability to concentrate urine, evidenced clinically by polyuria or natriuria, salt wasting, diminished ability to excrete acids, metabolic acidosis, and isolated defects in tubular reabsorption or secretion. Advanced forms, however, may be difficult to distinguish clinically from other causes of renal insufficiency. Table 20.8 of tubulointerstitial nephritis. Infections: acute bacterial pyelonephritis, chronic pyelonephritis including reflux nephropathy, other infections, for example, viruses, parasites, toxins, drugs. Acute hypersensitivity interstitial nephritis, analgesics, heavy metals, lead, cadmium. Metabolic diseases: urate nephropathy, nephrocalcinosis, hypocalcemic nephropathy, oxalate nephropathy. Physical factors: chronic urinary tract obstruction, neoplasms, multiple myeloma, light chain cast nephropathy. Immunologic reactions: transplant rejection, Sjogren syndrome, sarcoidosis. Vascular diseases: miscellaneous, nephronophthisis, idiopathic interstitial nephritis. Tubular and interstitial diseases 927. Specific conditions are listed in Table 20.8 and are discussed elsewhere in this book. This section deals principally with pyelonephritis and drug-induced tubulointerstitial nephritis. Hematogenous infection: common agents: Staphylococcus E. coli, aorta, bacteremia, pyelonephritis, and urinary tract infection. Pyelonephritis is one of the most common diseases of the kidney and is defined as inflammation affecting the tubules, interstitium, and renal pelvis. It occurs in 2 forms. Acute pyelonephritis is generally caused by bacterial infection and is associated with urinary tract infection. Chronic pyelonephritis is a more complex disorder. Bacterial infection plays a dominant role, but other factors, vascular reflux, obstruction, predispose to repeat episodes of acute pyelonephritis. Pyelonephritis is a serious complication of urinary tract infections that affect the bladder, cystitis, the kidneys and their collecting systems, pyelonephritis, or both. Bacterial infections of the lower urinary tract may be asymptomatic bacteriuria and remain localized to the bladder, but lower urinary tract infection can potentially spread to the kidney. Pathogenesis. More than 85% of urinary tract infections are caused by the gram-negative bacilli that are normal inhabitants of the intestinal tract. By far the most common is Escherichia coli, followed by Proteus, Klebsiella, and Enterobacter. Streptococcus faecalis, also of enteric origin, Staphylococci, and virtually every other bacterial and fungal agent can also cause lower urinary tract and renal infection. Mycobacterial and fungal organisms induce caseating and non-caseating granulomatous inflammation, respectively. In immunocompromised persons, particularly those with transplanted organs, viruses such as polyomyvirus, cytomegalovirus, and adenovirus can also cause renal infection. There are two routes by which bacteria can reach the kidneys, one through the bloodstream hematogenous infection and two from the lower urinary tract ascending infection Fig. 20.24. The hematogenous route is less common and results from seeding of the kidneys by bacteria from distant foci in the course of septicemia or localized infections, such as infective endocarditis. Hematogenous infection is more likely to occur in the presence of ureteral obstruction and in debilitated patients. Typically, in patients receiving immunosuppressive therapy, non-enteric organisms, such as Staphylococci and certain fungi and viruses, are involved. Ascending infection is the most common cause of clinical pyelonephritis. Normal human bladder and bladder urine are sterile. Therefore, a number of steps must occur for renal infection to occur. The first step is colonization of the distal urethra and introitus in the female by coliform bacteria. This colonization is influenced by the degree of bacterial adherence to urethral mucosal epithelia, as discussed in Chapter 8, which involves adhesive molecules adhesins on the P. fimbriae pili of bacteria that interact with receptors on the surface of urothelial cells. From the urethra to the bladder, organisms gain entrance during urethral catheterization or other instrumentation. Long-term catheterization, in particular, carries a risk of ascending infection. Common agents: E. coli, Proteus, Enterobacter, intrarenal reflux, vesicurtal reflux, deranged vesicurtal junction, bacteria enter bladder. Bacterial colonization. Figure 20.24 schematic representation of pathways of renal infection. Hematogenous infection results from bacteremic spread. More common is ascending infection, which results from a combination of urinary bladder infection, vesicurtal reflux, and intrarenal reflux infection. In the absence of instrumentation, urinary infections are much more common in females, and this has been ascribed to the shorter urethra in females, the absence of antibacterial properties in prostatic fluid, hormonal changes affecting bacterial adherence to the mucosa, and urethral trauma during sexual intercourse, or any combination of these factors. Several conditions predispose to the movement of microbes from the bladder to the kidneys. Urinary tract obstruction and stasis of urine. Ordinarily, organisms introduced into the bladder are cleared by continual voiding and by antibacterial mechanisms. However, outflow obstruction or bladder dysfunction results in incomplete emptying and residual urine. In the presence of stasis, bacteria introduced into the bladder can multiply unhindered. Accordingly, urinary tract infection is frequent among patients with lower urinary tract obstruction, such as may occur with benign prostatic hypertrophy, tumors, calculi, or neurogenic bladder dysfunction caused by diabetes or spinal cord injury. Vesicurtal reflux. Although obstruction is an important predisposing factor in ascending infection, incompetence of the vesicurtal valve allows bacteria to ascend the ureter into the renal pelvis. The normal ureteral insertion. 928 Chapter 20 The kidney. In the absence of vesicurtal reflux, infection usually remains localized in the bladder. Thus, the majority of individuals with repeated or persistent bacterial colonization of the urinary tract suffer from cystitis and urethritis, lower urinary tract infection rather than pyelonephritis. Acute pyelonephritis. Acute pyelonephritis is a suppurative inflammation of the kidney caused by bacterial and sometimes viral, for example, polyomyvirus infection, which can reach the kidney by hematogenous spread or, more commonly, through the ureters in association with vesicurtal reflux. Morphology. Figure 20.25 vesicurtal reflux demonstrated by avoiding cystourethrogram. Dye injected into the bladder refluxes into both dilated ureters, filling the pelvis and calyces. Into the bladder is a one-way valve that prevents retrograde flow of urine when the intravesical pressure rises, as in micturition. An incompetent vesicurtal orifice allows the reflux of bladder urine into the ureters. Vesicurtal reflux. Fig. 20.25. Reflux is most often due to a congenital absence or shortening of the intravesical portion of the ureter, such that the ureter is not compressed during micturition. In addition, it may be acquired by bladder infection itself. It is postulated that bacteria themselves or the associated inflammation can promote reflux by affecting ureteral contractility, particularly in children. Vesicurtal reflux is estimated to affect 1% to 2% of otherwise normal children. Acquired vesicurtal reflux in adults can result from persistent bladder atony caused by spinal cord injury. Similar to that of an obstruction, the residual urine in the urinary tract after voiding favors bacterial growth. Intrarenal reflux. Vesicurtal reflux also affords a mechanism to propel infected bladder urine up to the renal pelvis and deep into the renal parenchyma through open ducts at the tips of the papillae. Intrarenal reflux. Intrarenal reflux is most common in the upper and lower poles of the kidney, where papillae tend to have flattened or concave tips rather than the convex pointed type present in the midzones of the kidney and depicted in most textbooks. Reflux can be demonstrated by voiding cystourethropy, in which the bladder is filled with a radiopaque dye and images are taken during micturition. Vesicular reflux can be demonstrated in about 30% of infants and children with urinary tract infection. See Fig. 20.25. The hallmarks of acute pyelonephritis are patchy interstitial suppurative inflammation, intratubular aggregates of neutrophils, neutrophilic tubulitis, and tubular injury. The suppuration may occur as discrete focal abscesses or large, wedge-like areas and can involve one or both kidneys. Fig. 20.26. In the early stages, the neutrophilic infiltration is limited to the tubules. The tubular lumens are a conduit for the extension of the infection, and the infection can extend to the interstitium and produces abscesses that destroy the involved tubules. Fig. 20.27. Characteristically, glomeruli are relatively resistant to the infection. Extensive disease, however, eventually also destroys the glomeruli. In fungal pyelonephritis, for example, candida often results in granulomatous interstitial inflammation. 3 complications may be superimposed on acute pyelonephritis. Papillary necrosis is seen mainly in diabetics, sickle cell disease, and in those with urinary tract obstruction. Papillary necrosis is usually bilateral but may be unilateral. One or all of the pyramids of the affected kidney may be involved. On cut section, the tips or distal 2/3 of the pyramids have areas of gray-white to yellow necrosis. Fig. 20.28. On microscopic examination, the necrotic tissue shows characteristic ischemic. Figure 20.26. Acute pyelonephritis. Cortical surface shows grayish-white areas of inflammation and abscess formation. Tubular and interstitial disease is 929. Figure 20.27. Acute pyelonephritis marked by a neutrophilic exudate within tubules and interstitial inflammation. Coagulative necrosis, with preservation of outlines of tubules. The leukocytic response is limited to the junctions between preserved and destroyed tissue. Pyelonphrosis is seen when there is total or almost complete obstruction, particularly when it is high in the urinary tract. The suppurative exudate is unable to drain and fills the renal, pelvis, calyces, and ureter with pus. Perinephric abscess is an extension of suppurative inflammation through the renal capsule into the perinephric tissue. After the acute phase of pyelonephritis, healing occurs. The neutrophilic infiltrate is replaced by one that is predominantly composed of macrophages, plasma cells, and lymphocytes. The inflammatory foci are eventually replaced by irregular scars that can be seen on the cortical surface as fibrous depressions. Such scars are characterized microscopically by tubular atrophy, interstitial fibrosis, and a lymphocytic infiltrate in a characteristic patchy jigsaw pattern with intervening preserved parenchyma. The pyelonephritic scar is almost always associated with inflammation, fibrosis, and deformation of the underlying calyx and pelvis, reflecting the role of ascending infection and vesicular reflux in the pathogenesis of the disease. Clinical features. Acute pyelonephritis is often associated with the following: urinary tract obstruction, either congenital or acquired; instrumentation of the urinary tract, most commonly catheterization; vesicular reflux; pregnancy. Between 4% and 6% of pregnant women develop bacteriuria sometime during pregnancy, and 20% to 40% of these eventually develop symptomatic urinary infection if not treated. Gender and age. After the first year of life, when congenital anomalies in males commonly become evident, and up to around 40 years of age, infections are much more frequent in females. With increasing age, the incidence in males rises as a result of prostatic hypertrophy and instrumentation, pre-existing renal lesions, causing intrarenal scarring and obstruction. Diabetes, in which increased susceptibility to infection, neurogenic bladder dysfunction, and more frequent instrumentation are predisposing factors. Immunosuppression and immunodeficiency. Acute pyelonephritis usually presents with a sudden onset of pain at the costovertebral angle and systemic evidence of infection, such as fever and malaise. There are often indications of bladder and urethral irritation, such as dysuria, frequency, and urgency. The urine contains many leukocytes. Puria derived from the inflammatory infiltrate, but puria does not differentiate upper from lower urinary tract infection. The finding of leukocyte casts, typically rich in neutrophils pus casts, indicates renal involvement because casts are formed only in tubules. The diagnosis of infection is established by quantitative urine culture. Uncomplicated acute pyelonephritis follows a benign course, and symptoms disappear within a few days after the institution of appropriate antibiotic therapy. Bacteria, however, may persist in the urine, or there may be recurrence of infection with new serologic types of E. coli or other. B. Figure 20.28. Papillary necrosis. Areas of pale gray hemorrhage and necrosis involve the papillary arrows. 930. Chapter 20. The kidney. Organisms. Such bacteriuria then either disappears or may persist, sometimes for years. In the presence of unrelieved urinary obstruction, diabetes mellitus, or immunodeficiency, acute pyelonephritis may be more serious, leading to repeated septicemic episodes. The superimposition of papillary necrosis may lead to acute renal failure. The viral pathogen causing pyelonephritis and kidney allografts is polyomyvirus. Latent infection with polyomyvirus is widespread in the general population, and immunosuppression of the allograft recipient can lead to reactivation of latent infection and the development of nephropathy, resulting in allograft failure in up to 5% of kidney transplant recipients. This form of pyelonephritis, now referred to as polyomyvirus nephropathy, is characterized by infection of tubular epithelial cell nuclei, leading to nuclear enlargement and intranuclear inclusions visible by light microscopy viral cytopathic effect. The inclusions are composed of virions arrayed in distinctive crystalline-like lattices when visualized by electron microscopy. Fig. 20.29. An interstitial inflammatory response is invariably present. Treatment consists of a reduction in immunosuppression. Chronic pyelonephritis and reflux nephropathy. Chronic pyelonephritis is a disorder in which chronic tubular interstitial inflammation and scarring involve the calluses and pelvis. Fig. 20.30. Although several diseases produce chronic tubular interstitial alterations, see Table 28, only chronic pyelonephritis and analgesic nephropathy affect the calluses, making pelvic callosal damage an important diagnostic clue. Chronic pyelonephritis at one time accounted for 10% to 20% of patients in renal transplant or dialysis units, until predisposing conditions, such as reflux, became better recognized. This condition remains an important cause of kidney destruction in children with severe lower urinary tract abnormalities. Blunted calyx. Figure 20.30. Typical core scars of chronic pyelonephritis associated with vesicular reflux. The scars are usually polar and are associated with underlying blunted calluses. Morphology. The characteristic changes of chronic pyelonephritis are seen on gross examination. Figs. 20.30 and 20.31a. The kidneys usually are regularly scarred. If bilateral, the involvement is asymmetric. In contrast, both kidneys in chronic glomerulonephritis are diffusely and symmetrically scarred. The hallmarks of chronic pyelonephritis are coarse, discrete, corticomedullary scars overlying dilated, blunted, or deformed calluses, and flattening of the papillae. The scars vary from one to several, and most are in the upper and lower poles, consistent with the frequency of reflux in these sites. Scar. A B. Figure 20.29. Polyomavirus nephropathy. The kidney shows enlarged tubular epithelial cells with nuclear inclusions, arrows, and interstitial inflammation, arrowheads. B. Intranuclear viral inclusions visualized by electron microscopy. Courtesy Dr. Gene Olson, Department of Pathology, University of California, San Francisco, Calif. An interstitial disease is 931. A B. Figure 20.31. A chronic pyelonephritis. The surface left is irregularly scarred. The cut section right reveals blunting and loss of several papillae. Below power view shows a corticomedullary renal scar with an underlying dilated deformed calyx. Note the thyroidization of tubules in the cortex. The microscopic changes involve predominantly tubules and interstitium. The tubules show atrophy in some areas and hypertrophy or dilation in others. Dilated tubules with flattened epithelium may be filled with casts resembling thyroid-colloid thyroidization. There are varying degrees of chronic interstitial inflammation and fibrosis in the cortex and medulla. There is often fibrosis around the callosal epithelium as well as a more chronic inflammatory infiltrate. Glomeruli may appear normal except for a variety of ischemic changes, including paraglomerular fibrosis, fibrous obliteration, and secondary changes related to hypertension. Individuals with chronic pyelonephritis and reflux nephropathy who develop proteinuria in advanced stages show secondary FSGS, as described later. Xanthogranulomatosis pyelonephritis is a rare form of chronic pyelonephritis characterized by accumulation of foamy macrophages intermingled with plasma cells, lymphocytes, polymorph nuclear leukocytes, and occasional giant cells. Often associated with Proteus infections and obstruction, the lesions sometimes produce large, yellowish-orange nodules that may be grossly confused with renal cell carcinoma. Clinical features: chronic obstructive pyelonephritis may have a silent onset or present with manifestations of acute recurrent pyelonephritis, such as back pain, fever, uria, and bacteriuria. These patients receive medical attention relatively late in their disease course because of the gradual onset of renal insufficiency and hypertension. Reflux nephropathy is often discovered in children when the cause of hypertension is investigated. Loss of tubular function, in particular of concentrating ability, gives rise to polyuria and nocturia. Radiographic studies show asymmetrically contracted kidneys with characteristic core scars and blunting and deformity of the callosal system. Significant bacteriuria may be present, but it is often absent in the late stages. Although proteinuria is usually mild, some individuals with pyelonephritic scars develop secondary FSGS with significant proteinuria, even in the nephrotic range, usually several years after the scarring has occurred and often in the absence of continued infection or persistent vesicular reflux. The onset of proteinuria is a poor prognostic sign since it increases the likelihood of progression to SID. Glomerulosclerosis, as discussed, is attributable to the adaptive glomerular alterations secondary to loss of renal mass caused by pyelonephritic scarring. Key concepts: pyelonephritis. Both acute and chronic pyelonephritis may be caused by infection via the ascending more common or hematogenous route. Obstructive lesions of the urinary tract are important predisposing factors. Bacteria are the most common infectious agent in acute pyelonephritis and induce a prominent neutrophilic inflammatory response. Granulomatous interstitial inflammation is characteristic. Fungal or mycobacterial infections. Chronic pyelonephritis ensues when anatomic anomalies result in urine reflux or urine outflow obstruction. Multiple episodes. This injury leads to irregular scarring of the kidney that is typically more prominent at the upper or lower poles where reflux is more common. Tubular interstitial nephritis induced by drugs and toxins. Drug and toxin-induced tubular interstitial nephritis is the second most common cause of acute kidney injury after pyelonephritis. Toxins and drugs can injure kidneys in at least 3 ways. One trigger an interstitial immunologic reaction, exemplified by the acute hypersensitivity nephritis induced by drugs such as methicillin. 2 cause ATI, as described earlier, and 3 cause subclinical but cumulative injury to tubules that takes years to result in chronic kidney disease. The last type of damage is especially worrisome, because it may be unrecognized until the renal damage is irreversible. Tubular. Chapter 20. The kidney. Acute drug-induced interstitial nephritis first reported after the use of sulfonamides. Acute tubular interstitial nephritis most frequently occurs with synthetic penicillins, methicillin, ampicillin, other synthetic antibiotics, rifampin, diuretics, thiazides, non-steroidal anti-inflammatory drugs, NSAIDs, and miscellaneous other drugs, allopurinol, cited, checkpoint inhibitors. Chronic tubular interstitial nephritis caused by phenacetin-containing analgesics, termed analgesic nephropathy, is of historical importance as its incidence has substantially diminished due to the withdrawal or restriction of phenacetin in most countries. Drug-induced acute interstitial nephritis begins 2 to 40 days after drug exposure and is characterized by fever, eosinophilia, which may be transient, rash in about 25% of patients, and renal abnormalities. The latter takes the form of hematuria, mild proteinuria, and leukocyturia, often including eosinophils. A rising serum creatinine or acute kidney injury with oliguria develops in about 50% of cases. Pathogenesis. Many features of the disease suggest an idiosyncratic immune mechanism. Clinical evidence of hypersensitivity includes the latent period, eosinophilia, and rash, the fact that the onset of nephropathy is not dose-related, and recurrence of clinical and pathologic manifestations after re-exposure to the same or chemically related drug. In some patients, serum IgE levels are increased, and IgE-containing plasma cells and basophils are present in the lesions, suggesting that the late-phase reaction of an IgE-mediated type of hypersensitivity may be involved in the pathogenesis. Chapter 6. In other cases, a mononuclear or granulomatous reaction, together with positive results of skin tests to drugs, suggests a T-cell-mediated type Roman IV delayed hypersensitivity reaction. The most likely sequence of events is that the drugs function as happens and covalently bind to some plasma membrane or extracellular component of tubular cells. These modified self-antigens then become immunogenic. The resultant injury is due to IgE or cell-mediated immune reactions directed against the tubular cells or their basement membranes. Morphology. The interstitium shows variable but frequently pronounced edema and infiltration by mononuclear cells, principally lymphocytes and macrophages. Eosinophils and neutrophils may be present. Fig. 2032. Often in clusters in large numbers and smaller numbers of plasma cells and mast cells are sometimes also present. Inflammation may be more prominent in the medulla where the inciting agent is concentrated. With some drugs, for example, methicillin, thiazides, interstitial non-necrotizing granulomas may be seen. When tubules rupture. Tubulitis. The infiltration of tubules by lymphocytes is common. Variable degrees of tubular injury and regeneration are present. Glomeruli are normal except in some cases caused by NSAID, when minimal change disease and the nephrotic syndrome develop concurrently. See below. 932. Figure 20.32. Drug-induced interstitial nephritis with prominent eosinophilic and mononuclear cell infiltrate. Courtesy Dr. H. Rank, Brigham and Women's Hospital, Boston, Mass. Clinical features. It is important to recognize drug-induced acute interstitial nephritis because withdrawal of the offending drug is followed by recovery, although it may take several months, and irreversible damage can occur. While drugs are the leading cause of acute interstitial nephritis, in many affected patients, approximately 30% to 40% an offending drug or mechanism cannot be identified. On occasion, necrotic papillae are excreted and may cause gross hematuria or renal colic due to ureteric obstruction. Papillary necrosis is not specific for analgesic nephropathy and is also seen in diabetes, as well as in urinary tract obstruction, sickle cell disease or trait described later, and focally in renal tuberculosis. In all cases, it is caused by ischemia resulting from compression or obstruction of small blood vessels in the medulla. Such compression may be caused by interstitial edema as in inflammatory reactions and urinary tract obstruction or microvascular disease as in diabetes. Table 20.9 lists the main features of papillary necrosis in these conditions. Nephropathy associated with NSAID, one of the most commonly used classes of drugs, produce several forms of renal injury. Although these complications are uncommon, they should be kept in mind because NSAID are frequently administered to patients with other potential causes of renal disease. Many NSAID are non-selective cyclooxygenase inhibitors, and their adverse renal effects are related to their ability to inhibit cyclooxygenase-dependent prostaglandin synthesis. Selective COX-2 inhibitors, while sparing the gastrointestinal tract, do affect the kidneys because COX-2 is expressed in human kidneys. NSAID-associated renal syndromes include the following. Acute kidney injury, due to the decreased synthesis of vasodilatory prostaglandins and resultant ischemia. This is particularly likely to occur in the setting of other renal diseases or conditions causing volume depletion. Acute hypersensitivity interstitial nephritis, resulting in renal failure, as described earlier. Acute interstitial nephritis and minimal change disease. This curious association of two diverse renal conditions. 1. An interstitial disease is 933. TL tubular 0 cases. Diabetes. 1, 3, 10 years. 80%. Rare. Several. All of same stage. The incidence of this disease has greatly decreased since the 1990 seconds because its main cause, phenicillin, has been withdrawn from the market in most countries, and combination analgesics are no longer available without prescription. Data from Session S. et al. Editors. Classification and Atlas of Tubular Interstitial and Vascular Diseases. Baltimore, 1999. Williams and Wilkins. Male to female ratio time course infection calcification number of papillary affected. Papillary pneumonitis. Asbestos. Analgesic nephropathy. 5 years of abuse. 25%. Frequent. Almost all. Different stages of necrosis. Sickle cell disease 1 variable plus or minus rare few. Obstruction 9. 1 variable 90% frequent variable, leading to renal failure and the other to nephrotic syndrome, suggests a hypersensitivity reaction affecting the interstitium and possibly the glomeruli, but also is consistent with injury to podocytes mediated by cytokines released as part of the inflammatory process. Membranous nephropathy, with the nephrotic syndrome, is a recently appreciated association, also of unclear pathogenesis. Key concepts: tubular interstitial nephritis induced by drugs and toxins. Drug-induced tubular interstitial nephritis is the second most common cause of acute kidney injury. Prominent interstitial inflammation with associated tubular injury, which may or may not be accompanied by eosinophils or granulomatous inflammation, can be induced by almost any pharmacologic agent. NSAID can cause tubular interstitial nephritis and / or glomerular injury, such as minimal change disease or membranous nephropathy. Other tubular interstitial diseases. Urate nephropathy. 3 types of nephropathy can occur in persons with hyperuricemic disorders. Acute uric acid nephropathy is caused by the precipitation of uric acid crystals in the renal tubules, principally in collecting ducts, leading to obstruction of nephrons and the development of acute renal failure. This is particularly likely to occur in individuals with leukemias or lymphomas who are undergoing chemotherapy. Tumor lysis syndrome. The drugs kill tumor cells, and uric acid is produced as released nucleic acids are broken down. Precipitation of uric acid is favored by the acidic pH in collecting tubules. Chronic urate nephropathy, or gouty nephropathy, occurs rarely in protracted forms of hyperuricemia. The monosodium urate crystals deposit in the acidic milieu of the distal tubules in collecting ducts, and form distinct birefringent needle-like crystals either in the tubular lumens or in the interstitium. Fig. 20.33. The urate deposits evoke a mononuclear response that contains foreign body giant cells. This lesion is called autophys. Chapter 26. Tubular obstruction by the urate causes cortical atrophy and scarring. Clinically, urate nephropathy is a subtle disease associated with tubular defects that may progress slowly. Some individuals with gout who develop a chronic nephropathy have evidence of increased exposure to lead. Nephrolithiasis. Uric acid stones are present in 22% of individuals with gout and 42% of those with secondary hyperuricemia. See later discussion of renal stones. Hypercalcemia and nephrocalcinosis disorders associated with hypercalcemia, such as hypoparathyroidism, multiple myeloma, vitamin D intoxication, metastatic cancer, or excess calcium intake milk alkali syndrome, may induce the formation of calcium stones and deposition of calcium in the kidney. Nephrocalcinosis. Extensive degrees of calcinosis, under certain conditions, may lead to chronic tubular interstitial disease and renal insufficiency. The earliest functional defect is an inability to concentrate the urine. Other tubular defects, such as tubular acidosis and salt-losing nephritis, may also occur. With further damage, a slowly progressive chronic kidney disease develops. This is usually due to nephrocalcinosis, but many of these patients also have calcium stones and secondary pyelonephritis. Figure 20.33. Granulomatous inflammation outlines the slender urate crystals in the renal medulla. 934. Chapter 20. The kidney. Autosomal dominant tubular interstitial kidney disease. Autosomal dominant tubular interstitial kidney disease ACT was previously known as medullary cystic kidney disease. Given the variable presence of cysts, which often are not located in the medulla, and the distinctive genetics, it is now recognized as ACT due to following genetic mutations. Mucone encodes mucin-1 expressed in distal nephrons. UMOD encodes uromodulin expressed in thick ascending limb of loop of Handel. REN encodes proporinin expressed by juxtaglomerular apparatus. HN-form beta encodes hepatocyte nuclear factor 1 beta, the transcription factor that regulates multiple genes, including UMOD. ACT is associated with nonspecific clinical and pathologic findings and causes progressive renal failure in adult life with an autosomal dominant pattern of transmission. Pathogenic mechanisms are unknown. Light chain cast nephropathy, myeloma, kidney, non-renal malignant tumors, particularly those of hematopoietic origin, affect the kidneys in several ways. Table 20.10. Most common involvements are tubular interstitial, caused by complications of the tumor: hypercalcemia, ureteral obstruction or therapy, irradiation, hyperuricemia, chemotherapy, hematopoietic cell transplantation, infections in immunosuppressed patients. We limit the discussion here to the tubular interstitial lesions in multiple myeloma patients. Overt renal insufficiency occurs in half of those with multiple myeloma and related lymphoplasmacytic disorders. Several factors contribute to renal damage. Benz-Jones proteinuria and cast nephropathy. The main cause of renal dysfunction is related to Benz-Jones light chain proteinuria and correlates with the degree of proteinuria. Two mechanisms seem to account for the renal toxicity of Benz-Jones proteins. First, some light chains are directly toxic to epithelial cells because of their intrinsic physicochemical properties. Second, Benz-Jones proteins combine with urinary glycoprotein TAM horseful Protein under acidic conditions to form large, histologically distinct tubular casts that obstruct the tubular lumens and induce a characteristic inflammatory reaction, light chain cast nephropathy. Amyloidosis of the AL type, formed from free light chains, usually of lambda type, occurs in 6% to 24% of individuals with myeloma, light chain deposition disease. In some patients, light chains usually of kappa type deposit in GBMs and mesangium and nonfibrillar forms, causing a glomerulopathy described earlier, and in tubular basement membranes, which may cause tubular interstitial nephritis. Hypercalcemia and hyperuricemia are often present in these patients. Morphology. The tubular interstitial changes in light chain cast nephropathy are characteristic. Benz-Jones tubular casts appear as pink to blue amorphous masses, sometimes concentrically laminated and often fractured, which fill and distend the tubular lumens. Some casts are surrounded by multinucleated giant cells that are derived from activated macrophages Fig. 20:34. The adjacent interstitial tissue usually shows an inflammatory response and fibrosis. On occasion, the casts rupture the tubules, evoking a granulomatous inflammatory reaction. Amyloidosis, light chain deposition disease, nephrocalcinosis, and infection may also be present. Clinical features. Clinically, the renal manifestations are of several types. In the most common form, chronic kidney disease develops insidiously and progresses slowly during a period of several months to years. Another form occurs suddenly and is manifested by acute kidney injury with oliguria. Precipitating factors include dehydration, hypercalcemia, acute infection, and treatment with nephrotoxic antibiotics. Benz-Jones proteinuria occurs in 70% of individuals with multiple myeloma. The presence of significant non-light chain proteinuria, for example, albuminuria, suggests AL amyloidosis or light chain deposition disease. Renal. Table 20.10 disease related to non-renal neoplasms. Direct or metastatic tumor invasion of renal parenchyma. Ureter's obstruction, artery, renovascular hypertension. Hypercalcemia, hyperuricemia, amyloidosis AL, light chain type. Expression of abnormal proteins, multiple myeloma, glomerulopathies, membranous nephropathy. Secondary carcinomas, minimal change disease, Hodgkin disease, membranoproliferative glomerulonephritis, leukemias, and lymphomas, monoclonal immunoglobulin / light chain deposition disease, multiple myeloma, effects of radiation therapy, chemotherapy, hematopoietic cell transplantation, secondary infection. Figure 20.34 light chain cast nephropathy. Alpha angulated and tubular casts, surrounded by macrophages, including multinucleated cells. Disease is 935. Biocast nephropathy, impairment of renal function, often occurs in patients with severe acute or advanced chronic liver disease. In this setting, serum bilirubin levels can be markedly elevated, particularly in jaundice patients with biocast formation, also known as chylemic nephrosis in distal nephron segments. The cast can extend to proximal tubules, resulting in both direct toxic effects on tubular epithelial cells and obstruction of the involved nephron. This mechanism of injury is analogous to that with monoclonal immunoglobulin and myoglobin casts. Tubular biocasts can range from yellowish-green to red-pink and contain variable degrees of slough cells or cellular debris. The reversibility of the renal injury depends on the severity and duration of the liver dysfunction. Vascular diseases. Nearly all diseases of the kidney involve the renal blood vessels secondarily. Systemic vascular diseases, such as various forms of vasculitis, also affect renal vessels, and their effects on the kidney are clinically important. Hypertension, as discussed in Chapter 11, is intimately linked with the kidney, because kidney disease can be both the cause and consequence of increased blood pressure. In this chapter, we discuss nephrosclerosis and renal artery stenosis, lesions associated with hypertension, and sundry lesions involving mostly smaller vessels of the kidney. Nephrosclerosis. Nephrosclerosis is the term used for the renal pathology associated with sclerosis of renal arterioles and small arteries. It is strongly associated with hypertension, which can be both the cause and a consequence of nephrosclerosis. Nephrosclerosis at autopsy is associated with advanced age, is more frequent in blacks than in whites, and may be seen in the absence of hypertension. Hypertension and diabetes, however, increase the incidence and severity of the lesions. Pathogenesis. Two processes participate in the arterial lesions: medial and intimal thickening, a response to hemodynamic changes, aging, genetic defects, or some combination of these. Hyalinization of arteriolar walls, caused by extravasation of plasma proteins through injured endothelium and by increased deposition of basement membrane matrix because of thickened walls. The affected vessels have narrow lumens, which results in focal parenchymal ischemia. Ischemia leads to glomerulosclerosis and chronic tubular interstitial injury, and it produces a reduction in functional renal mass. Figure 20.35 close-up of the gross appearance of the cortical surface in benign nephrosclerosis, illustrating the fine, leathery granularity of the surface. On histologic examination, there is narrowing of the lumens of arterioles and small arteries, caused by thickening and hyalinization of the walls. Hyaline arterial sclerosis. Fig. 20.36. Corresponding to the finely granular surface are microscopic subcapsular scars with sclerotic glomeruli and tubular dropout, alternating with better preserved parenchyma. In addition, the interlobular and arcuate arteries show medial hypertrophy, replica, tone of the internal elastic lamina, and increased myofibroblastic tissue in the intima, all of which narrow the lumen. This change, called fibroelastic hyperplasia, often accompanies hyaline arteriolosclerosis and increases in severity with age and in the presence of hypertension. Morphology: the kidneys are either normal or moderately reduced in size, with average weights between 110 and 130 g. The cortical surfaces have a fine, even granularity that resembles grain leather fig. 20.35. The loss of mass is due mainly to cortical scarring and shrinking. Figure 20.36. Hyaline arteriolosclerosis. High power view of two arterioles with hyaline deposition, marked thickening of the walls, and a narrow lumen. Courtesy Dr. M.A. Venkatachalam, Department of Pathology, University of Texas Health Sciences Center, San Antonio, Tex. Vascular. Chapter 20. The kidney. Consequent to the vascular narrowing, there is patchy ischemic atrophy, which consists of one foci of tubular atrophy and interstitial fibrosis, and two a variety of glomerular alterations. The latter include collapse of the GBM, deposition of collagen within the Bowman space, periglomerular fibrosis, and total sclerosis of glomeruli. 1. The ischemic changes are pronounced and affect large areas of parenchyma. They can produce wedge-shaped infarcts or regional scars with histologic alterations that may resemble those in renal ablation injury, mentioned earlier. 936. Clinical features: it is unusual for uncomplicated nephrosclerosis to cause renal insufficiency or uremia. However, 3 groups of hypertensive patients with nephrosclerosis are at increased risk of developing renal failure: people of African descent, people with severe blood pressure elevations, and persons with a second underlying disease, especially diabetes. In these groups, renal insufficiency may supervene after prolonged hypertension, but rapid renal failure may result from the development of the malignant or accelerated phase of hypertension. Small percentage of hypertensive persons, as many as 5%, show a rapidly rising blood pressure that, if untreated, leads to death within 1 to 2 years. This form of hypertension, called malignant hypertension, is characterized by severe pressure elevations, i.e., systolic pressure more than 200 mmHg, diastolic pressure more than 120 mmHg, renal failure, and retinal hemorrhages and exudates, with or without papillomatous swelling of the optic nerve that reflects increased intracranial pressures. Renal lesions associated with malignant hypertension have been referred to as malignant nephrosclerosis. It should be noted, however, that there is considerable clinical and morphologic overlap between the renal pathology of malignant hypertension and thrombotic myoangiopathies. About 30% of cases of malignant hypertension have myoangiopathic hemolytic anemia, discussed below, and conversely. Severe hypertension can occur in primary forms of hemolytic uremic syndrome. Endothelial injury is a common pathogenic factor in these disorders. Came from studies of experimental and human renal artery stenosis. Pathogenesis. Hypertension secondary to renal artery stenosis is caused by increased production of renin from the ischemic kidney. The classic experiments of Goldblatt and colleagues showed that constriction of one renal artery in dogs results in hypertension, and that the magnitude of the effect is proportional to the amount of narrowing. Elevation in blood pressure, at least initially, is due to stimulation of renin secretion by the juxtaglomerular apparatus and the subsequent production of the vasoconstrictor angiotensin Roman II. A large proportion of individuals with renovascular hypertension have elevated renin levels, and almost all show a reduction of blood pressure when given drugs that block angiotensin Roman II activity. Other factors, however, may contribute to the maintenance of renovascular hypertension after the renin-angiotensin system has initiated it, including sodium retention. Morphology. The most common cause of renal artery stenosis, 70% of cases, is narrowing at the origin of the renal artery by an atheromatous plaque. This occurs more frequently in men, and the incidence increases with advancing age and diabetes. The plaque is usually concentrically placed, and superimposed thrombosis often occurs. The second most frequent cause of stenosis is fibromuscular dysplasia of the renal artery. This heterogeneous entity is characterized by fibrous or fibromuscular thickening that may involve the intima, the media, or the adventitia of the artery fig. 2037. The stenosis, as a whole, are more common in women and tend to occur in younger age groups, i.e., in the 3rd and 4th decades. Key concepts: nephrosclerosis. Nephrosclerosis, which is commonly associated with hypertension, is defined by the presence of varying degrees of glomerulosclerosis, interstitial fibrosis and tubular atrophy, arteriosclerosis, and arteriolosclerosis. Luminal reduction of the renal vasculature, arteries, and arterioles contributes to glomerulosclerosis, both global and segmental, which can subsequently cause interstitial fibrosis and tubular atrophy. Renal artery stenosis. Unilateral renal artery stenosis is responsible for 2% to 5% of hypertension cases, and it is important to recognize because it is potentially curable by surgery. Furthermore, important insights into renal mechanisms of hypertension. Figure 20.37. Fibromuscular dysplasia of the renal artery, medial type elastic tissue stain. The median shows marked fibrous thickening, and the lumen is stenotic. Courtesy Dr. Seymour Rosen, Beth Israel Hospital, Boston, Mass. Vascular disease is 937. Ischemic kidney is reduced in size and shows signs of diffuse ischemic atrophy, with crowded glomeruli, atrophic tubules, interstitial fibrosis, and focal inflammatory infiltrates. The arterioles in the ischemic kidney are usually protected from the effects of high pressure, thus showing only mild arteriolosclerosis. In contrast, the contralateral non-ischemic kidney may show more severe arteriolosclerosis, depending on the severity of the hypertension. Primary clinical features. Few distinctive features suggest the presence of renal artery stenosis, and in general, these patients resemble those with essential hypertension. On occasion, a bruit can be heard on auscultation of the affected kidneys. Elevated plasma or renal vein renin response to angiotensin-converting enzyme inhibitor, renal scans, and intravenous pyelography may aid with diagnosis, but arteriography is required to localize the stenotic lesion. The cure rate after surgery is 70% to 80% in well-selected cases. Thrombotic myocardiopathies. The term thrombotic myocardiopathy encompasses a spectrum of clinical syndromes that includes thrombotic thrombocytopenic purpura TTP and hemolytic uremic syndrome HUS. As discussed in Chapter 14, HUS and TTP are caused by diverse insults that lead to thrombi in capillaries and or arterioles in various tissue beds, including those of the kidney. Fig. 20.38. The thrombi create flow abnormalities that shear red cells, producing a myocardiopathic hemolytic anemia. Of greater importance, the thrombi produce microvascular occlusions that cause tissue ischemia and organ dysfunction. Widespread consumption of platelets leads to thrombocytopenia. This group of disorders is classified according to the current understanding of their causes or associations. Table 20.11. Typical HUS synonyms: epidemic, classic. Diarrhea positive is most frequently associated with consumption of food contaminated by bacteria producing Shiga-like toxins. Figure 20.38. Fibrin stains showing thrombi red in the glomerular capillaries, characteristic of thrombotic myocardiopathic disorders. Table 20. Etiologic classification of thrombotic myocardiopathy. Forms: etiology. Shiga toxin, acquired Shiga toxin, producing E. coli. Mediated HUS Shigella dysentery serotype 1. Atypical HUS inherited complement dysregulation due to complement genetic abnormalities relatively. Mediated TMA common. Acquired complement dysregulation due to autoantibodies. TTP inherited genetic ADAM-S13 deficiency. Rare acquired ADAM-S13 deficiency due to autoantibodies relatively. Common ADAM-S13 von Willebrand factor cleaving protease. Whose hemolytic uremic syndrome TMA. Thrombotic myocardiopathy TTP. Thrombotic thrombocytopenic purpura. Major Fozunav. 1. Atypical HUS synonyms: non-epidemic. Diarrhea negative is associated with the following: inherited mutations of or autoantibodies targeting complement regulatory proteins. Adverse acquired cases of endothelial injury, including antiphospholipid antibodies, complications of pregnancy and oral contraceptives, vascular renal diseases such as scleroderma and malignant hypertension, chemotherapeutic and immunosuppressive drugs, and radiation. TTP is characterized by inherited or acquired deficiencies of ADAM-S13, a plasma metalloprotease that regulates the function of von Willebrand factor VWF. Pathogenesis within the thrombotic myocardiopathies. 2 pathogenetic triggers dominate: 1 endothelial injury and 2 excessive platelet activation and aggregation. As we will discuss, endothelial injury appears to be the primary cause of HUS, whereas platelet activation may be the inciting event in TTP. Endothelial injury. In typical epidemic, classic, diarrhea positive HUS, the trigger for endothelial injury and activation is usually a Shiga-like toxin, while for inherited forms of atypical HUS the cause of the endothelial injury appears to be excessive, inappropriate activation of complement. Many other exposures and conditions can occasionally precipitate a HUS-like picture, presumably also by injuring the endothelium. The endothelial injury in HUS appears to cause platelet activation and thrombosis within microvascular beds. There is evidence that reduced endothelial production of prostaglandin ITWO and nitric oxide, both inhibitors of platelet aggregation, contributes to thrombosis. A reduction in these 2 factors and increased production of endothelium-derived endothelin may also promote vasoconstriction, exacerbating the hypoperfusion of tissues. Platelet aggregation. In contrast to HUS and TTP, the initiating event appears to be platelet aggregation induced by very large multimers of VWF, which accumulate due to a deficiency of ADAM-S13, a plasma protease that cleaves VWF multimers into smaller sizes. The deficiency of ADAM-S13 is Chapter 20. The kidney. Most often caused by autoantibodies that inhibit ADAM-S13 function. Less commonly, a chronic relapsing and remitting form of TTP is associated with inherited deficiencies of ADAM-S13. Very large VWF multimers can bind platelet surface glycoproteins and activate platelets spontaneously, providing a pathophysiologic explanation for the microthrombi that are observed in vascular beds. With this as an introduction, we will now briefly delve into the various subtypes of HUS/TTP and then return to the morphologic features that are common to all. Typical epidemic, classic, diarrhea positive hemolytic uremic syndrome. This is the best characterized form of HUS. Most cases occur after intestinal infection with strains of E. coli, the most common being 157, H7 that produce Shiga-like toxins, so called because they resemble those made by Shigella dysentery. Chapter 17. Epidemics have been traced to various sources, most commonly the ingestion of contaminated ground meat as in hamburgers, but also drinking water, raw milk, and person-to-person transmission. However, most cases of typical HUS caused by E. coli are sporadic. Less commonly, infections by other agents, including S. dysentery, can give rise to a similar clinical picture. Typical HUS can occur at any age, but children and older adults are at highest risk. Following a prodrome of influenza-like or diarrheal symptoms, there is a sudden onset of bleeding manifestations, especially hematemesis and melena, severe oliguria, and hematuria, associated with microangiopathic hemolytic anemia, thrombocytopenia, and in some patients prominent neurologic changes. Hypertension is present in about half of patients. Precisely how Shiga-like toxin exposure causes HUS is not well understood. According to one model, the toxin activates endothelial cells, which respond by increasing their expression of leukocyte adhesion molecules in endothelin and decreasing nitric oxide production. In the presence of cytokines such as TNF, Shiga-like toxin may cause endothelial apoptosis. These alterations lead to platelet activation and induce vasoconstriction, resulting in the characteristic microangiopathy. But other possibilities remain. For example, there is some evidence that Shiga-like toxins may bind and activate platelets directly, or alternatively, may bind the regulatory complement protein factor H and inhibit its activity, causing hyperactivation of complement, an intriguing idea given the clear role of complement activation in some forms of atypical HUS described in the next section. In typical HUS, if the renal failure is managed properly with dialysis, most patients recover normal renal function in a matter of weeks. However, due to underlying renal damage, the long-term 15 to 25-year outlook is more guarded. In one study, only 10 of 25 patients with prior typical HUS had normal renal function, and 7 had chronic kidney disease. Atypical non-epidemic, diarrhea-negative hemolytic uremic syndrome. Atypical HUS occurs in a number of different settings. More than one-half of those affected have an inherited deficiency of complement regulatory proteins, most commonly factor H, which breaks down the alternative pathway C3 convertase and protects cells from damage by uncontrolled complement activation. Chapter 3. A number of patients have mutations in other proteins that regulate complement factor I and CD46 membrane cofactor protein. Having multiple genetic mutations in complement regulatory proteins may cause atypical HUS to manifest at a younger age. Autoantibodies against complement regulatory proteins also result in atypical HUS. The remaining cases of atypical HUS arise in association with a variety of miscellaneous conditions or exposures. These include the following: the antiphospholipid syndrome, either primary or secondary to SLE lupus anticoagulant. The syndrome is described in detail in Chapter 4. In this setting, the microangiopathy tends to follow a chronic course. Complications of pregnancy or the postpartum period. So-called postpartum renal failure is a form of HUS that usually occurs after an uneventful pregnancy, 1 day to several months after delivery. The condition has a grave prognosis, although recovery can occur in milder cases. Vascular diseases affecting the kidney, such as systemic sclerosis and malignant hypertension. Fig. 20.39. B. Figure 20.39. Thrombotic microangiopathy associated with malignant hypertension. A fibrinoid necrosis of afferent arterioperiodic acid. Skiff stain. E. Hypoplastic arteriolitis onion skin lesion. Courtesy Dr. H. Rank, Brigham and Women's Hospital, Boston, Mass. 938. Diseases 939. Chemotherapeutic and immune suppressive drugs, such as mitomycin, cyclosporine, cisplatin, gemcitabine, and antagonists of VEGF. Irradiation of the kidney. Patients with a typical HUS do not fare as well as those with typical HUS, in large part because the underlying conditions may be chronic and difficult to treat. As in typical HUS, some patients have neurologic symptoms. The disease in these patients can be distinguished from TTP by the presence of ADAM-S13 levels in the plasma of greater than % C later. Thrombotic thrombocytopenic purpura TTP is classically manifested by the pendant of fever, neurologic symptoms, microangiopathic hemolytic anemia, thrombocytopenia, and renal failure. The most common cause of deficient ADAM-S13 activity is inhibitory autoantibodies, and the majority of individuals with such antibodies are women. Regardless of the cause, most patients present as adults younger than 40 years of age. Less commonly, patients inherit an inactivating mutation in ADAM-S13. In those with hereditary ADAM-S13 deficiency, the onset is often delayed until adolescence, and the symptoms are episodic. Thus, factors other than ADAM-S13, for example, some superimposed vascular injury or prothrombotic state must be involved in triggering full-blown TTP. For unknown reasons, in TTP, central nervous system involvement is the dominant feature, whereas renal involvement is seen in about 50% of patients. The clinical findings are dictated by the distribution of the microthrombi, which are found in arterioles throughout the body. With plasma exchange, which removes autoantibodies and provides functional ADAM-S13, TTP, which once was uniformly fatal, can be treated successfully in more than 80% of patients. Figure 20.40. Diffuse cortical necrosis. The pale ischemic necrotic areas are confined to the cortex and columns of Burton. Key concepts: thrombotic microangiopathy. Thrombotic microangiopathy encompasses a diverse set of conditions that all lead to deposition of thrombi in the microvasculature, accompanied by red cell hemolysis, tissue ischemia and organ dysfunction, and a consumptive thrombocytopenia. In typical HUS, Shiga-like toxin produced by bacteria, most commonly E. coli strain 157, H7, is responsible for producing platelet activation and thrombosis. In most cases of atypical HUS, aberration activation of complement due to inherited mutations or acquired autoantibodies is the key pathogenic abnormality. In TTP, deficiencies of ADAM-S13, a negative regulator of VWF, permits the formation of abnormally large multimers of VWF that are capable of activating platelets. Vascular morphology. The morphologic findings in the various forms of HUS/TTP are indistinguishable and vary mainly in chronicity rather than cause. In acute, active disease, the kidney may show patchy or diffuse cortical necrosis and subcapsular petechiae. The glomerular capillaries are distended and occluded by thrombi. Disruption of the mesangial matrix and damage to the mesangial cells often results in mesangialysis. Interlobular arteries and arterioles often show occlusive thrombi. Chronic disease is common in patients with atypical HUS and has features that stem from continued injury and attempts at healing. The renal cortex reveals various degrees of scarring. By light microscopy, the glomeruli are mildly hypercellular and have marked thickening of the capillary walls associated with splitting or reduplication of the basement membrane, so-called double contours or tram tracks. The walls of arteries and arterioles often exhibit increased layers of cells. Cortex. Other vascular disorders. Atherosclerotic ischemic renal disease. We have seen that atherosclerotic unilateral renal artery stenosis can lead to hypertension. Bilateral renal artery disease, usually diagnosed definitively by arteriography, is a fairly common cause of chronic ischemia with renal insufficiency in older individuals, sometimes in the absence of hypertension. The importance of recognizing this condition is that surgical revascularization can prevent further decline in renal function. Atheroembolic renal disease. Embolization of fragments of atheromatous plaques from the aorta or renal artery into intrarenal vessels occurs in older adults with severe atherosclerosis, especially after surgery on the abdominal aorta, aortography, or intra-aortic canalization. These emboli can be recognized in the lumens of arcuate and interlobular arteries by their content of cholesterol crystals, which appear as rhomboid clefts. Fig. 20.41. The clinical consequences of atheroemboli vary according to the number of emboli and the pre-existing state of renal function. Frequently they are of no significance. However, acute renal injury or failure may develop in older adults in whom renal function is already compromised. Chapter 20. The kidney. The infarcts are wedge-shaped, with the base against the cortical surface and the apex pointing toward the medulla. In time, these acute areas of ischemic necrosis undergo progressive fibrous scarring, giving rise to depressed, pale, gray-white scars that assume a V-shape on section. The histologic changes in renal infarcts are those of ischemic coagulative necrosis, described in Chapter 2.940. Figure 20.41. Atheroembolus with typical cholesterol clefts in an interlobar artery. Sickle cell nephropathy. Sickle cell disease, homozygous or trait heterozygous, may lead to a variety of alterations in renal morphology and function, some of which produce clinically significant abnormalities. Various manifestations are grouped under sickle cell nephropathy. The most common abnormalities are hematuria and a diminished concentrating ability, hypostenuria. These are thought to be due to accelerated sickling in the hypertonic hypoxic milieu of the renal medulla. The hyperosmolarity dehydrates red cells and increases intracellular sickle hemoglobin HbS concentrations, which likely explains why even those with sickle cell trait are affected. Patchy papillary necrosis may occur in both homozygous and heterozygous. This is sometimes associated with cortical scarring. Proteinuria is also common in sickle cell disease, occurring in about 30% of patients. It is usually mild to moderate, but on occasion the overt nephrotic syndrome arises, associated with sclerosing glomerular lesions. Renal infarcts. The kidneys are common sites for the development of infarcts. Contributing to this predisposition is the extensive blood flow to the kidneys, 1/4 of the cardiac output. But probably more important is the limited collateral circulation from extrarenal sites. Small blood vessels penetrating from the renal capsule supply only the very outer rim of the cortex. Although thrombosis in advanced atherosclerosis and the acute vasculitis of polyarteritis nodosa may occlude arteries, most infarcts are due to embolism. A major source of such emboli is mural thrombosis in the left atrium and ventricle as a result of myocardial infarction. Vegetative endocarditis, aortic aneurysms, and aortic atherosclerosis are less frequent sources of emboli. Morphology. Because of the lack of a collateral blood supply, most renal infarcts are of the white anemic variety. Within 24 hours, infarcts become sharply demarcated, pale, yellow-white areas that may contain small irregular foci of hemorrhagic discoloration. They are usually ringed by a zone of intense hyperemia. Many renal infarcts are clinically silent. Sometimes, pain with tenderness localized to the costovertebral angle occurs, associated with showers of red cells in the urine. Large infarcts of one kidney are probably associated with narrowing of the renal artery or one of its major branches, which, in turn, may cause hypertension. Congenital and developmental anomalies. About 10% of people are born with significant malformations of the urinary system. Renal dysplasias and hypoplasias account for 20% of chronic kidney disease in children. Congenital renal disease can be hereditary but most often results from an acquired developmental defect during gestation. As discussed in Chapter 10, defects in genes involved in normal renal development, including the Wilms tumor, associated genes, understandably cause urogenital anomalies. As a rule, the resulting developmental abnormalities involve structural components of both the kidney and urinary tract. Other genetic defects primarily produce functional abnormalities in tubular transport, such as cystinuria and renal tubular acidosis. Here, we restrict the discussion to structural anomalies involving primarily the kidney. All except horseshoe kidney are uncommon. Anomalies of the lower urinary tract are discussed in Chapter 21. Agenesis of the kidney. Bilateral agenesis is incompatible with life and usually encountered in stillborn infants. It is often associated with other congenital disorders, for example, limb defects, hypoplastic lungs. Unilateral agenesis is uncommon and compatible with normal life if no other abnormalities exist. The solitary kidney enlarges as a result of compensatory hypertrophy. Some patients eventually develop progressive glomerular sclerosis in the remaining kidney as a result of the adaptive changes in hypertrophied nephrons, discussed earlier in the chapter. In time, chronic kidney disease ensues. Hypoplasia. Hypoplasia refers to failure of the kidneys to develop to a normal size. This anomaly may occur bilaterally, resulting in renal failure in early childhood, but it is more commonly encountered as a unilateral defect. True renal hypoplasia is observed in low birth weight infants and may contribute to their increased lifetime risk for chronic kidney disease. Differentiation between congenital and acquired atrophic kidneys may be impossible, but a truly hypoplastic kidney shows no scars and has a reduced number of renal lobes and pyramids, usually 6 or fewer. Ectopic kidneys. The development of the metanephros into the kidneys may occur in ectopic foci. These kidneys lie either just above the pelvic brim or sometimes within the pelvis. Cystic diseases of the kidney 941. They are usually normal or slightly small in size but otherwise are not remarkable. Because of their abnormal position, kinking or tortuosity of the ureters may cause obstruction to urinary flow, which predisposes to bacterial infections. Horseshoe kidneys. Fusion of Fuper 10% all pulls 90% of the kidneys produces a horseshoe-shaped structure that is continuous across the midline anterior to the great vessels. This anomaly is found in 1 in 500 to 1,000 autopsies. Cystic diseases of the kidney. Cystic diseases of the kidney are heterogeneous, comprising hereditary, developmental, and acquired disorders. They are important for several reasons. One, they are reasonably common and often represent diagnostic problems for clinicians, radiologists, and pathologists. Two, some forms, such as adult polycystic kidney disease, are major causes of chronic kidney disease. And 3, they can occasionally be confused with malignant tumors. The useful classification of renal cysts is summarized in Table 20.12. Autosomal dominant adult polycystic kidney disease. Autosomal dominant adult polycystic kidney disease is a hereditary disorder characterized by multiple expanding cysts of both kidneys that ultimately destroy the renal parenchyma and cause renal failure. It is a common condition affecting roughly 1 in 400 to 1,000 live births and accounting for about 5% to 10% of cases of ASID requiring transplantation or dialysis. The inheritance pattern is autosomal dominant with high penetrance. Although the susceptibility to develop this disease is inherited as an autosomal dominant trait, as with tumor suppressor genes, both alleles of the involved genes have to be non-functional for development of the disease. Thus, individuals prone to autosomal dominant polycystic kidney disease inherit one copy of a mutated AP gene, and mutation of the other allele is acquired in the somatic cells of the kidney. The disease is bilateral. Reported unilateral cases probably represent multicystic dysplasia. The cysts initially involve a minority of the nephrons, so renal function is retained until about the 4th or 5th decade of life. Genetics and pathogenesis. A wide range of different mutations in PKD1 and PKD12 has been described, and this allelic heterogeneity has complicated genetic diagnosis of this disorder. The PKD1 gene is located on chromosome 1613-3. It encodes a large 460 kD integral membrane protein named polycystin 1, which has a large extracellular region, multiple transmembrane domains, and a short cytoplasmic tail. Polycystin 1 is expressed in tubular epithelial cells, particularly those of the distal nephron. At present, its precise function is not known, but it contains domains that are usually involved in cell-cell and cell matrix interactions. Mutations in PKD1 account for about 85% of cases. In individuals with these mutations, the likelihood of developing renal failure is less than 5% by 40 years of age, rising to more than 35% by 50 years of age, more than 70% at 60 years of age, and more than 95% by 70 years of age. 20.2. Disease adult polycystic kidney disease. Childhood polycystic kidney disease. Familiar. Autosomal large multicystic, dominant kidneys, liver cysts, berry aneurysms, autosomal, recessive, enlarged, cystic, kidneys at birth, medullary cysts on excretory urography, none, autosomal, recessive, choriomedullary, cysts, shrunken, kidneys, irregular kidneys with cysts of variable size, cystic degeneration, and end-stage, kidney disease, single or multiple, cysts in normal-sized kidneys, none, clinical features or complications, hematuria, flank pain, urinary tract infection, renal stones, hypertension, hepatic fibrosis, hematuria, urinary tract infection, recurrent renal stones, salt wasting, polyuria, growth retardation, anemia, association with other renal anomalies, hemorrhage, erythrocytosis, neoplasia, microscopic hematuria. Typical outcome, chronic renal failure, beginning at 40, 60 years of age, variable, death in infancy or childhood, benign, progressive renal failure beginning in childhood. Renal failure is bilateral, surgically curable if unilateral. Dependence on dialysis. Benign tablet summary. Diagrammatic representation. Chapter 20. The kidney. The PKD12 gene, located on chromosome 421, accounts for most of the remaining cases of polycystic disease. Its product, Polycystin-2 is an integral membrane protein that is expressed in all segments of the renal tubules and in many extrarenal tissues. Polycystin-2 functions as a Cap1 plus permeable cation channel. Overall, the disease is less severe than that associated with PKD1 mutations. Renal failure occurs in less than 5% of patients with PKD1 mutations at 50 years of age, but this rises to 15% at 60 years of age and 45% at 70 years of age. The pathogenesis of polycystic disease is not established, but the currently favored hypothesis places the ciliate centrosome complex of tubular epithelial cells at the center of the disorder. Fig. 20.42. The tubular epithelial cells of the kidney contain a single non-motile primary cilium, a 2 to 3 mm long hair-like organelle that projects into the tubular lumen from the apical surface of the cells. The cilium is made up of microtubules, and it arises from and is attached to a basal body derived from the centriole. The cilia are part of a system of organelles and cellular structures that sense mechanical signals. The apical cilia function in the kidney tubule as a mechanosensor to monitor changes in fluid flow and shear stress, while intercellular junctional complexes monitor forces between cells, and focal adhesions sense attachment to extracellular matrices. In response to external signals, these sensors regulate ion flux. Cilia can induce Cap1 plus flux in cultured kidney epithelial cells and cellular behavior, including cell polarity and proliferation. The idea that defects in mechanosensing, Cap1 plus flux, and signal transduction underlies cyst formation is supported by several observations. Both polycystin-1 and polycystin-2 are localized to the primary cilium. Other genes that are mutated in cystic diseases, for example, the nephrocysteine genes, describe later encode proteins that are also localized to cilia and/or basal bodies. Mutations in polycystin-1, 2 or fibrocystin or nephrocystins, altered mechanosensation, bitubular cilia altered calcium flux, altered tubular epithelial growth and differentiation, abnormal extracellular matrix, cell proliferation, fluid secretion, interstitial inflammation/fibrosis, glomerular, vascular damage cyst. Figure 20.42 possible mechanisms of cyst formation and cystic kidney disease is see text. Knockout of the PKD1 gene in one model organism, the worm Chinorhabditis elegans, results in ciliary abnormalities and cyst formation. Tubular cells obtained from mice with the deletion of the PKD1 gene, which causes embryonic lethality in this species, retain normal architecture of cilia but lack the flow-induced Cap1 plus flux that occurs in normal tubular cells. Polycystin-1 and polycystin-2 appear to form a protein complex that regulates intracellular Cap1 plus in response to fluid flow, perhaps because fluid moving through the kidney tubules causes ciliary bending that opens Cap1 plus channels. Mutation of either of the PKD genes leads to loss of the polycystin complex or formation of anaberrin complex. The consequent disruption of normal polycystin activity results in alterations of intracellular Cap1+, which you will recall regulates many downstream signaling events, including pathways that directly or indirectly impact cellular proliferation, apoptosis, and secretory functions. The increase in calcium is thought to stimulate proliferation and secretion from epithelial cells lining the cysts, which together result in progressive cyst formation and enlargement. In addition, cyst fluids have been shown to harbor mediators derived from epithelial cells that enhance the fluid secretion and induce inflammation. Finally, the calcium-induced signals also alter the interaction of epithelial cells with ECM, and this too is thought to contribute to the cyst formation and interstitial fibrosis that are characteristic of progressive polycystic kidney disease. Morphology. In gross appearance, the kidneys are bilaterally enlarged and may achieve enormous sizes. Weights as much as 4 kg for each kidney have been reported. The external surface appears to be composed solely of a mass of cysts, up to 3 to 4 cm in diameter, with no intervening parenchyma. Fig. 20.43 and B. However, microscopic examination reveals functioning nephrons dispersed between the cysts. The cysts may be filled with a clear, serous fluid or with turbid, red to brown, sometimes hemorrhagic fluid. As these cysts enlarge, they may encroach on the calyces and pelvis to produce pressure defects. The cysts arise from the tubules throughout the nephron and therefore have variable lining epithelium. On occasion, papillary epithelial formations and polyps project into the lumen. Clinical features: many patients remain asymptomatic until renal insufficiency announces the presence of the disease. In others, hemorrhage or progressive dilation of cysts may produce pain. Excretion of blood clots causes renal colic. The enlarged kidneys, usually apparent on abdominal palpation, may induce a dragging sensation. The disease occasionally begins with the insidious onset of hematuria, followed by other features of progressive chronic kidney disease, such as proteinuria rarely more than 2 g/day, polyuria, and hypertension. Patients with PKD1 mutations tend to have an older age at onset and later development of renal failure. Both genetic and environmental factors influence disease severity. Progression is accelerated in blacks, particularly in those with sickle cell trait, and males, and in the presence of hypertension. 942. Diseases of the kidney. 943. BCD figure 20.43 and B. Autosomal dominant adult polycystic kidney disease app viewed from the external surface and bisected. The kidney is markedly enlarged and contains numerous dilated cysts. The autosomal recessive childhood PKD, showing smaller cysts and dilated channels at right angles to the cortical surface. The liver cysts in adult PKD. Individuals with polycystic kidney disease also tend to have extrarenal congenital anomalies. About 40% have one to several cysts in the liver, polycystic liver disease, that are usually asymptomatic. Cysts are derived from biliary epithelium. Cysts occur much less frequently in the spleen, pancreas, and lungs. Intracranial berry aneurysms, presumably from altered expression of polycystin and vascular smooth muscle, rise in the circle of Willis, and subarachnoid hemorrhages from these account for death in 4% to 10% of individuals. Mitral valve prolapse and other cardiac valvular anomalies occur in 20% to 25% of patients, but most are asymptomatic. The diagnosis is made by radiologic imaging techniques. This form of chronic kidney disease is remarkable in that patients may survive for many years with azotemia slowly progressing to uremia. Ultimately, about 40% of adult patients die of coronary or hypertensive heart disease, 25% of infection, 15% of a ruptured berry aneurysm or hypertensive intracerebral hemorrhage, and the rest of other causes. Autosomal recessive childhood polycystic kidney disease. Autosomal recessive childhood polycystic kidney disease is genetically distinct from adult polycystic kidney disease. Perinatal, neonatal, infantile, and juvenile subcategories have been defined, depending on the time of presentation and presence of associated hepatic lesions. The first two are the most common. Serious manifestations are usually present at birth, and the young infant might succumb rapidly to renal failure. Genetics and pathogenesis. In most cases, the disease is caused by mutations in the PKH-DUN gene, which maps to chromosome region 621, P23. The gene is highly expressed in adult and fetal kidney and also in liver and pancreas. The PKH-DUN gene encodes fibrocystin, a 447 kD integral membrane protein with a large extracellular region, a single transmembrane component, and a short cytoplasmic tail. The extracellular region contains multiple copies of a domain forming an egg-like fold. Like polycystins 1 and 2, fibrocystin also has been localized to the primary cilium of tubular cells. The function of fibrocystin is unknown, but its putative conformational structure indicates it may be a cell surface receptor with a role in collecting duct and biliary differentiation. Analysis of autosomal recessive polycystic disease patients has revealed a wide range of different mutations. The vast majority of cases are compound heterozygous, i.e., inherit a different mutant allele from each of the two parents. This complicates molecular diagnosis of the disorder. Morphology. The kidneys are enlarged and have a smooth external appearance. On cut section, numerous small cysts in the cortex and medulla give the kidney a sponge-like appearance. Dilated, elongated channels are present at right angles to the cortical surface, completely replacing the medulla and cortex. Fig. 2043c. On microscopic examination, there is cylindrical or, less commonly, saccular dilation of all collecting tubules. The cysts have a uniform lining of cuboidal cells, reflecting their origin from the collecting ducts. In almost all cases, the liver has cysts. Fig. 2043d associated with portal fibrosis and proliferation of portal bile ducts. Patients who survive infancy, infantile, and juvenile forms may develop a peculiar hepatic injury characterized by bland periportal fibrosis and proliferation of well-differentiated biliary ductules, now termed congenital hepatic fibrosis. In older children, hepatic disease is the predominant clinical concern. Such patients may develop portal hypertension with splenomegaly. Curiously, congenital hepatic fibrosis cystic. Chapter 20. The kidney sometimes occurs in the absence of polycystic kidneys or has been reported in the presence of adult polycystic kidney disease. Cystic diseases of the renal medulla. The two major types of medullary cystic disease are medullary sponge kidney, a relatively common and usually innocuous structural change, and nephronophthisis, which is almost always associated with renal dysfunction. Medullary sponge kidney. The term medullary sponge kidney is restricted to multiple cystic dilations of the collecting ducts in the medulla. The condition occurs in adults and is usually discovered radiographically. Renal function is usually normal. On gross inspection, the papillary ducts in the medulla are dilated, and small cysts may be present. The cysts are lined by cuboidal epithelium or occasionally by transitional epithelium. Unless there is superimposed pyelonephritis, cortical scarring is absent. The pathogenesis is unknown. Nephronophthisis. This group of progressive renal disorders is characterized by a variable number of cysts in the medulla, usually concentrated at the corticomedullary junction. Initial injury probably involves the distal tubules with tubular basement membrane disruption, followed by chronic and progressive tubular atrophy involving both medulla and cortex and interstitial fibrosis. Although the medullary cysts are important, the cortical tubular interstitial damage is the cause of the eventual renal insufficiency. 3 variants of the nephronophthisis disease complex are recognized: 1 sporadic, not familial, 2 familial juvenile nephronophthisis most common, and 3 renal retinal dysplasia 15% in which the kidney disease is accompanied by ocular lesions. The familial forms are inherited as autosomal recessive traits and usually become manifest in childhood or adolescence. As a group, the nephronophthisis complex is now the most common genetic cause of acid in children and young adults. Children affected with nephronophthisis present first with polyuria and polydipsia, which reflect a marked defect in the concentrating ability of renal tubules. Sodium wasting and tubular acidosis are also prominent. Some syndromic variants of nephronophthisis, for example, Senior-Loken syndrome, Joubert syndrome, Bardet-Biedl syndrome, June syndrome, Meckel-Gruber syndrome, Mainzer-Saldino syndrome, Sensenbrenner syndrome can have extrarenal associations, including ocular motor abnormalities, retinal dystrophy, liver fibrosis, and cerebellar abnormalities. The expected course is progression to SID in 5 to 10 years. Genetics and pathogenesis. 16 responsible gene loci. NPH prone to NPH-P11 that encode proteins called nephrocysteines, JBTS1, JBTS3, JBTS9, and JBTS11 are mutated in the juvenile forms of nephronophthises, and the list continually expands as additional loci that contribute to this ciliopathy are identified. These proteins are present in the primary cilia, basal bodies attached to these cilia, or the centrosome organelle from which the basal bodies originate. The NPHP12 gene product has been. Figure 20.44 Medullary cystic disease. Cut section of kidney showing cysts at the cord-cumedullary junction and in the medulla, identified as inversing, which mediates left-right patterning during embryogenesis. Morphology. In nephronophthises, the kidneys are small, have contracted granular surfaces, and show cysts in the medulla, most prominently at the cord-cumedullary junction. The cysts are similar to those in medullary cystic disease, a rare, usually autosomal dominant, disease. Fig. 20.44. Small cysts are also seen in the cortex. The cysts are lined by flattened or cuboidal epithelium and are usually surrounded by either inflammatory cells or fibrous tissue. In the cortex, there is widespread atrophy and thickening of the tubular basement membranes, together with interstitial fibrosis. In general, glomerular structure is preserved. There are few specific clues to diagnosis, because the medullary cysts might be too small to be visualized radiographically. The disease should be strongly considered in children or adolescents with otherwise unexplained chronic renal failure, a positive family history, and chronic tubular interstitial nephritis on biopsy. Multicystic renal dysplasia. Dysplasia is a sporadic disorder that can be unilateral or bilateral and is often cystic. The kidney is usually enlarged, extremely irregular, and multicystic. Fig. 20.45a. The cysts vary in size from several millimeters to centimeters in diameter. On histologic examination, they are lined by flattened epithelium. Although normal nephrons are present, the characteristic histologic feature is the presence of islands of undifferentiated mesenchyme, often with cartilage, and immature collecting ducts. Fig. 20.45b. Most cases are associated with ureteropelvic obstruction, ureteral agenesis or atresia, and other anomalies of the lower urinary tract. When unilateral, the dysplasia may mimic a neoplasm and lead to surgical exploration and nephrectomy. The opposite kidney functions normally, and such patients have an excellent prognosis after surgical removal of the affected kidney. In bilateral multicystic renal dysplasia, renal failure may ultimately result. 944. Tract obstruction, obstructive uropathy. 945. May cause sudden distension and pain, and calcification of the hemorrhage may give rise to bizarre radiographic shadows. The main importance of cysts lies in their differentiation from kidney tumors. Radiologic studies show that in contrast to renal tumors, renal cysts have smooth contours, are almost always avascular, and give fluid rather than solid signals on ultrasonography. A key concept: cystic diseases. Autosomal dominant polycystic kidney disease accounts for a small yet significant subset of SID. Ciliopathies or abnormalities of the cilium centrosome complex underlie the major cystic kidney diseases, including polycystic kidney disease, both autosomal dominant and autosomal recessive forms in nephronophthises. Dysfunction of the primary cilium of tubular epithelial cells results in alterations in ion flux and changes in cell proliferation and function, culminating in renal cyst formation. Urinary tract obstruction, obstructive uropathy. B. Figure 20.45 Multicystic renal dysplasia, a gross appearance. B. Histologic section showing Simple cysts are common post-mortem findings without clinical significance. On occasion, hemorrhage into them. Obstructive lesions of the urinary tract increase susceptibility to infection and stone formation, and unrelieved obstruction almost always leads to permanent renal atrophy, termed hydronephrosis or obstructive uropathy. Fortunately, many causes of obstruction are surgically correctable or medically treatable. Obstruction may be sudden or insidious, partial or complete, unilateral or bilateral. It may occur at any level of the urinary tract from the urethra to the renal pelvis. It can be caused by intrinsic lesions of the urinary tract or extrinsic lesions that compress the urine. The common causes are as follows. Fig. 20.46. Congenital anomalies: posterior urethral valves and urethral strictures, needle stenosis, bladder neck obstruction, ureteropleural junction narrowing or obstruction, severe vestibular reflex, urinary calculi, benign prostatic hypertrophy, tumors, carcinoma of the prostate, bladder tumors, contiguous malignant disease, retroperitoneal lymphoma, carcinoma of the cervix or uterus, inflammation, prostatitis, ureteritis, urethritis, retroperitoneal fibrosis, left papillary or blood clots, pregnancy, uterine prolapse and cystosol. Functional disorders: neurogenic spinal cord damage or diabetic nephropathy and other functional abnormalities of the urine or bladder, often termed dysfunctional obstruction. Hydronephrosis is the term used to describe dilation of the renal pelvis and calluses associated with progressive atrophy of the kidney due to obstruction to the outflow of urine. Even with complete obstruction, glomerular filtration urinary, chapter 20 of the kidney, pelvis, calculi tumors, ureteroplate, stricture, ureter, intrinsic, calculi tumors, clots, left papillary, inflammation, ureter, extrinsic, pregnancy tumors, for example, cervix retroperitoneal fibrosis, figure 20.47 hydronephrosis of the kidney, with marked dilation of pelvis and calluses and thinning of the renal parenchyma. Vesicular reflex, bladder, calculi tumors, functional, for example, neurogenic, urethra, posterior valve stricture tumors, rare, figure 20.46 obstructive lesions of the urinary tract. Persist for some time because the filtrate subsequently diffuses back into the renal interstitium and perianal spaces, from where it ultimately returns to the lymphatic and venous systems. Because of this continued filtration, the affected calluses and pelvis become dilated, often markedly so. The high pressure in the pelvis is transmitted back through the collecting ducts into the cortex, causing renal atrophy, but it also compresses the renal vasculature of the medulla, causing a diminution in the medullary blood flow. The medullary vascular defects are initially reversible, but lead to medullary functional disturbances. Accordingly, the initial functional alterations caused by obstruction are largely tubular, manifested primarily by impaired concentrating ability. Only later does the GFR begin to fall. Obstruction also triggers an interstitial inflammatory reaction, leading eventually to interstitial fibrosis, a mechanism similar to those discussed earlier. See Fig. 20.8. Morphology. When the obstruction is sudden and complete, it leads to mild dilation of the pelvis and calluses and sometimes to atrophy of the renal parenchyma. When the obstruction is subtotal or intermittent, progressive dilation ensues, giving rise to hydronephrosis fate. 2047, depending on the level of urinary block. Prostate, hyperplasia carcinoma prostatitis. Dilation may affect the bladder first, or the urine and then the kidney. The kidney may be slightly to massively enlarged, depending on the degree and the duration of the obstruction. The early features are those of simple dilation of the pelvis and calluses. In addition, there is often significant interstitial inflammation, even in the absence of infection. In chronic cases, the picture is one. A cortical tubular atrophy with marked diffuse interstitial fibrosis. Progressive blunting of the apices of the pyramids occurs. These eventually become cut. In far advanced cases, the kidney may become transformed into a thin-walled cystic structure having a diameter of up to 15 to 20 cm fig. 2047 with striking. Parenchymal atrophy, total obliteration of the pyramids, and thinning of the cortex. 946. Clinical features of acute obstruction may provoke pain attributed to distension of the collecting system or renal capsule. Most of the early symptoms are produced by the underlying cause of the hydronephrosis. Thus, calculi lodged in the ureters may give rise to renal colic, and prostatic enlargements may give rise to bladder symptoms. Unilateral complete or partial hydronephrosis may remain silent for long periods because the unaffected kidney can maintain adequate renal function. Sometimes its existence first becomes apparent in the course of imaging studies. In its early stages, perhaps the first few weeks, relief of obstruction leads to reversion to normal function. Ultrasonography is a useful non-invasive technique in the diagnosis of obstructive uropathy. Bilateral partial obstruction, the earliest manifestation is inability to concentrate urine, reflected by polyuria and natriuria. Some patients develop distal tubular acidosis, renal salt wasting, secondary renal calculi, and chronic tubular interstitial nephritis with scarring and atrophy of the papilla and medulla. Hypertension is common. Urolithiasis, renal calculi, stones 947. Complete bilateral obstruction of rapid onset results in oliguria or inuria and is incompatible with survival unless the obstruction is relieved. Curiously, after relief of complete urinary tract obstruction, post-obstructive diuresis occurs. This can often be massive, with the kidney excreting large amounts of urine that is rich in sodium chloride. Urolithiasis, renal calculi, stones. Urolithiasis affects 5% to 10% of people in the United States in their lifetime, and the stones may form anywhere in the urinary tract, but most arise in the kidney. Men are affected more often than women, and the peak age of onset is between 20 and 30 years. Familial and hereditary predisposition to stone formation has long been known. Many inborn errors of metabolism, such as cystinuria and primary hyperoxaluria, provide examples of hereditary disease characterized by excessive production and excretion of stone-forming substances. Pathology and pathogenesis, there are four main types of calculi. Table 20, 13. 1 calcium stones, about 70%, composed largely of calcium oxalate or calcium oxalate mixed with calcium phosphate. 2 another 15% are so-called triple stones or struvite stones, composed of magnesium ammonium phosphate. 3 5% to 10% are uric acid stones, and 4 1% to 2% are made up of cysteine. An organic mucoprotein matrix, making up 1% to 5% of the stone by weight, is present in all calculi. Although there are many causes for the initiation and propagation of stones, the most important determinant is an increase of various types of stones. Percentage of all stones setting 0, 2, 0, 1, 3 tablet renal, stone type, calcium oxalate and phosphate, idiopathic hypercalciuria 50%, hypercalciuria and hypocalcemia 10%. Hyperoxaluria 5%, enteric 4, 5%, primary 0, 5%, hyperuricasuria 20%, hypocytraturia, normal metabolic abnormality 15% to 20%, magnesium ammonium phosphate struvite. Uric acid, associated with hyperuricemia, associated with hyperuricasuria, idiopathic 50% of uric stones, cysteine, others are unknown, 5, 10, 5, 10, 1, 2 plus or minus 5 prevalence. Urinary concentration of the stone's constituents, such that exceeds their solubility, supersaturation. A low urine volume in some metabolically normal patients may also favor supersaturation. Calcium oxalate stones are associated in about 5% of patients with hypocalcemia and hypercalciuria, such as occurs with hypoparathyroidism, diffuse bone disease, sarcoidosis, and other hypocalcemic states. About 55% have hypercalciuria without hypocalcemia, which is caused by several factors, including hyperabsorption of calcium from the intestine absorptive hypercalciuria, and intrinsic impairment in renal tubular reabsorption of calcium renal hypercalciuria, or idiopathic fasting hypercalciuria with normal parathyroid function. As many as 20% of calcium oxalate stones are associated with increased uric acid secretion, hyperuricasuria calcium nephrolithiasis, with or without hypercalciuria. The mechanism of stone formation in this setting involves nucleation of calcium oxalate by uric acid crystals in collecting ducts. 5% are associated with hyperoxaluria, either hereditary primary oxaluria or, more commonly, acquired by intestinal overabsorption in patients with enteric diseases. Hypocytraturia, which can be idiopathic or associated with acidosis and chronic diarrhea of unknown cause, may produce calcium stones. In a variable proportion of individuals with calcium stones, no cause can be found in idiopathic calcium stone disease. Magnesium ammonium phosphate stones are formed largely after infections by urea splitting bacteria, for example, Proteus and some staphylococcus that convert urea to ammonia. The resultant alkaline urine causes the precipitation of magnesium ammonium phosphate salts. These form some of the largest stones, as the amount of urea excreted normally is very large. Indeed, so-called staghorn calculi occupying large portions of the renal pelvis are frequently a consequence of infection. Uric acid stones are common in individuals with hyperuricemia, such as patients with gout, and diseases involving rapid cell turnover, such as the leukemias. However, more than half of all patients with uric acid calculi have neither hyperuricemia nor increased urinary expression of uric acid. In this group, it is thought that a tendency to excrete urine at pH below 5.5 may predispose to uric acid stones because uric acid is insoluble in acidic urine. In contrast to the radiopaque calcium stones, uric acid stones are radiolucent. Cysteine stones are caused by genetic defects in the renal reabsorption of amino acids, including cysteine, leading to cystinuria. These stones also form at low urinary pH. It can therefore be appreciated that increased concentration of stone constituents, changes in urinary pH, decreased urine volume, and the presence of bacteria influence the formation of calculi. However, many calculi occur in the absence of these factors. Conversely, individuals with hypercalciuria, hyperoxaluria, and hyperuricasuria often do not form stones. It has been postulated that stone formation is enhanced by deficiency in inhibitors of crystal formation in urine. The list of such inhibitors is long, including pyrophosphate, glyphosate, citrate, glycosamine aldehydes, osteopotin, and a glycoprotein called nephrocalcin. Chapter 20, the kidney. Morphology. These small tumors are less than 1.5 cm in diameter. They are present invariably within the cortex and appear grossly as pale yellow-gray, discrete, well-circumscribed nodules. On microscopic examination, they are composed of complex, branching, papillomatic structures with numerous complex frontals. Cells may also grow as tubules, glands, cores, and sheets of cells. The cells are cuboidal to polygonal in shape and have regular, small central nuclei, scanty cytoplasm, and no atypia. By histologic criteria, these tumors do not differ from low-grade papillary renal cell carcinoma and share some immunohistochemical and cytogenetic features trisomy 7 and 17 with papillary cancers, to be discussed later. The tumor size is used as a prognostic feature, with a cutoff of 3 cm separating those that metastasize from those that rarely do. However, because of occasional reports, small tumors that have metastasized, some regard all adenomas, regardless of size, as potentially malignant. Figure 20.48 nephrolithiasis, a large stone impacted in the renal pelvis. Courtesy Dr. E. Musher, Brigham and Women's Hospital, Boston, Mass. Morphology stones are unilateral in about 80% of patients. The favorite sites for their formation are within the renal calluses and pelvis fig, 20, 48, and in the bladder. Formed in the renal pelvis, they tend to remain small, having an average diameter of 2 to 3 mm. These may have smooth contours or may take the form of an irregular, jagged mass of spicules. Often many stones are found within one kidney. On occasion, progressive accretion of salts leads to the development of branching structures known as staghorn calculi, which create a cast of the pelvic and callosal system. Clinical features of lithiasis may be asymptomatic, produce severe renal colic and abdominal pain, or may cause significant renal damage. Larger stones often manifest themselves by hematuria. Stones also predispose to superimposed infection, both by their obstructive nature and by the trauma they produce. Neoplasms of the kidney. Both benign and malignant neoplasms occur in the kidney. Malignant neoplasms are of great importance clinically. By far the most common malignant tumor is renal cell carcinoma, followed by Wilms tumor, which is found in children and described in chapter 10, and finally urothelial carcinoma of the calluses and pelvis. Benign neoplasms, renal papillary adenomas small, discrete adenomas arising from the renal tubular epithelium are found commonly 7% to 22% at autopsy. They are most frequently papillary and therefore called papillary adenomas. 948. Angiomyolipoma, this benign neoplasm consists of vessels, smooth muscle, and fat originating from perivascular epithelioid cells. Angiomyolipomas are present in 25% to 50% of patients with tuberous sclerosis, a disease caused by loss of function mutations in the TS-COMA TSC4 tumor suppressor genes. Tuberous sclerosis is characterized by lesions of the cerebral cortex that produce epilepsy and intellectual disability, a variety of skin abnormalities, and unusual benign tumors at other sites, such as the heart, chapters 12 and 28. The clinical importance of angiomyolipoma is due largely to their susceptibility to spontaneous hemorrhage. Oncocytoma, this is an epithelial neoplasm composed of large eosinophilic cells having small, round, benign appearing nuclei that have large nuclei. This is thought to arise from the intercalated cells of collecting ducts and accounts for approximately 5% to 15% of frontal neoplasms. Ultrastructurally, the eosinophilic cells have numerous mitochondria. In gross appearance, the tumors are tan or mahogany brown, relatively homogeneous, and usually well encapsulated with a central scar in 1/3 of cases. However, they may achieve a large size up to 12 cm in diameter. There are some familial cases in which these tumors are multicentric rather than solitary. Malignant neoplasms. Renal cell carcinomas represent about 3% of all newly diagnosed cancers in the United States and account for 85% of renal cancers in adults. There are approximately 65,000 new cases per year and 13,000 deaths from the disease. The tumors occur most often in older individuals, usually in the 6th and 7th decades of life, and show a 2-1 male preponderance. Epidemiology, tobacco is the most significant risk factor. Cigarette smokers have double the incidence of renal cell carcinoma, and pipe and cigar smokers are also more susceptible. In International, of the Kidney 949, study has identified additional risk factors, including obesity, particularly in women, hypertension, unopposed estrogen therapy, and exposure to asbestos, petroleum products, and heavy metals. There's also an increased risk in patients with acid, chronic kidney disease, acquired cystic disease, see earlier, and tuberous sclerosis. Most renal cancer is sporadic, but unusual forms of autosomal dominant familial cancers occur, usually in younger individuals. Although they account for only 4% of renal cancers, familial variants have been instructive in understanding renal carcinogenesis. Von Hippel of VHL syndrome. 1/2 to 2/3 of individuals with VHL, nearly all, if they live long enough, chapter 28 develop renal cysts and bilateral, often multiple, renal cell carcinomas. Current studies implicate the VHL gene in the development of both familial and sporadic clear cell carcinomas, hereditary lamellomatosis, and renal cell cancer syndrome. This autosomal dominant disease is caused by mutations of the FH gene, which expresses fumarate hydratase, and is characterized by cutaneous and uterine lamelloma and an aggressive type of papillary carcinoma with increased propensity for metastatic spread. Hereditary papillary carcinoma. This autosomal dominant form is manifested by multiple bilateral tumors with papillary histology. These tumors show a series of cytogenetic abnormalities and, as we will describe, mutations in the MET proto-oncogene. Bert-Hahn-Dubé syndrome. The autosomal dominant inheritance pattern of this disease is due to mutations involving the BHE gene, which expresses folliculin. The syndrome features a constellation of skin fibrofolliculomas, trichoscomas, and acrocordians, pulmonary cysts or blebs, and renal tumors with a wide range of histologic subtypes. Classification of renal cell carcinoma, histology, cytogenetics, and genetics. The classification of renal cell carcinoma is based on correlative cytogenetic, genetic, and histologic studies of both familial and sporadic tumors. Major types of tumor are as follows: Fig. 2049. Clear cell carcinoma. This is the most common type, accounting for 70% to 80% of renal cell cancers. Tumors are made up of cells with clear or granular cytoplasm and are non-papillary. They can be familial, but in most cases 95% are sporadic. And 98% of these tumors, whether familial, sporadic, or associated with VHL syndrome, there's loss of sequences on the short arm of chromosome 3. The deleted region harbors the VHL gene 3.5. 3. Second non-deleted allele of the VHL gene shows somatic mutations or hypermethylation induced in activation of up to 80% of clear cell cancers, indicating that the VHL gene acts as a tumor suppressor gene in both sporadic and familial cancers. Chapter 7. The VHL gene encodes a protein that is part of the ubiquitin ligase complex involved in targeting other proteins for degradation. Important among the targets of the VHL protein is the transcription factor hypoxia-inducible factor 1 HIF1. When VHL is inactive, HIF1 levels remain high, even under normoxic conditions, causing inappropriate expression of a number of genes that are turned on by HIF. These include genes that promote angiogenesis, such as VAGE, and genes that stimulate cell growth, such as insulin-like growth factor 1 IGF-1. In addition, HIF collaborates in complex ways with the oncogenic factor MyC to reprogram cellular metabolism in a way that favors growth. Each sequencing of renal carcinoma genomes has revealed frequent mutations in a number of genes that regulate histone modifications, indicating that dysregulation of sporadic papillary sporadic clear cell. Trisomy 7, 17 loss of Y mutated, activated MET. Hereditary papillary. Deletion of chromosome 3 loss of VHL and activated, mutated VHL hypermethylation of VHL. Hereditary clear cell. Trisomy 7 mutated, activated MET. Figure 20.49 cytogenetics blue and genetics red clear cell versus papillary renal cell carcinoma. Courtesy Dr. Keith Lagon, Brigham and Women's Hospital, Boston, Mass. Neoplasms. 950 chapter 20 kidney. The epigenome also has an important role in clear cell carcinoma. Papillary carcinoma accounts for 10% to 15% of renal cancers. It is characterized by a papillary growth pattern and also occurs in both familial and sporadic forms. These tumors are not associated with free deletions. The most common cytogenetic abnormalities are trisomy 7 and 17 and also by male patients in the sporadic form, and trisomy 7 in the familial form. The gene of chromosome 7 for the familial form has been mapped to MET, a proto-oncogene that encodes the tyrosine kinase receptor for hepatocyte growth factor. MET is also mutated in a small proportion of sporadic papillary carcinomas. Hepatocyte growth factor also causes scatterfactor mediates growth, cell mobility, invasion, and morphogenetic differentiation. Unlike clear cell carcinomas, papillary carcinomas are frequently multifocal in origin. Chromophore carcinoma represents 5% of renal cell cancers and is composed of cells with prominent cell membranes and pale eosinophilic cytoplasm, usually with a halo around the nucleus. On cytogenetic examination, these tumors show multiple chromosome losses and extreme haplotyploid. Like the benign oncocytoma, they are thought to grow from intercalated cells with collecting ducts and have an excellent prognosis compared with that of clear cell and papillary cancers. Histologic distinction from oncocytoma can be difficult. X-11 translocation carcinoma is a genetically distinct subtype of renal cell carcinoma. It often occurs in young patients and is defined by translocations of the TFF3 gene located at X-11. 2. With a number of partner genes, all of which result in overexpression of the TFF3 transcription factor. The neoplastic cells consist of clear cytoplasm with a papillary architecture. Collecting duct Bellini gut carcinoma represents approximately 1% or less of renal epithelial neoplasms. They arise from collecting duct cells in the medulla. Several chromosomal losses and deletions have been described, but a distinct pattern has not been identified. Histologically, these tumors are characterized by malignant cells forming glands and mesh within a prominent fibrotic stroma, typically in a medullary location. Medullary carcinoma is a morphologically similar neoplasm that is seen in patients with sickle cell trait morphology. Renal cell carcinomas may arise in any portion of the kidney, but more commonly affects the poles. Clear cell carcinomas most likely arise from proximal tubular epithelium and usually occur as solitary unilateral lesions. They are bright yellow, gray, white. Spherical masses of variable size that distort the renal outline. The yellow color is a consequence of the prominent lipid accumulations in tumor cells. There are commonly large areas of gray white necrosis and foci hemorrhagic discoloration. The margins are usually sharply defined and confined within the renal capsule. Fig. 20.50. Clear cell carcinoma. The growth pattern varies from solid to tracheal cord-like or tubular resembling tubules. The tumor cells have a rounded or polygonal shape and abundant clear or granular cytoplasm, which contains glycogen and lipids. Fig. 20.51a. The tumors have delicate branching vasculature and figure 20.50 renal cell carcinoma. Typical cross-section of yellowish, spherical neoplasm in one pole of the kidney. Both the tumor and the dilated thrombosed renal vein may show cystic as well as solid areas. Most tumors are well differentiated, but some show nuclear tibial with bizarre nuclear and giant cells. As tumors enlarge, they may bulge into the calyces and pelvis, and eventually fungate through the walls of the collecting system to extend into the ureter. One of the striking characteristics of renal cell carcinoma is its tendency to invade the renal vein. See Fig. 2050, in which it may grow as a solid column of cells that extends up the inferior vena cava, sometimes as far as the right side of the heart. Papillary carcinomas thought to arise from distal convoluted tubules can be multifocal and bilateral. They are typically hemorrhagic and cystic, especially when large. The tumor is composed of tubular or low columnar cells arranged in papillary formations. Interstitial form cells are common in the papillary core. See Fig. 2051b. Some of the bodies may be present. The stroma is usually skinny but highly vascularized. Chromophore renal carcinoma is made up of pale eosinophilic cells, often with a paranuclear halo, arranged in solid sheets with a concentration of the larger cells around blood vessels. See Fig. 2051c. Collecting duct carcinoma is a rare variant showing irregular channels lined by highly atypical epithelium with a hobile pattern. Sarcomeroid changes arise frequently in all types of renal cell carcinoma and are decidedly ominous feature. Clinical features. The classic clinical features of renal cell carcinoma are cause for vertebral pain, palpable mass, and hematuria, but all three are seen in only 10% of cases. Most reliable clue is hematuria, but it is usually intermittent and may be microscopic. Thus, the tumor may remain silent until it attains a large size, often greater than 10 cm. At this time, it is often associated with generalized constitutional symptoms such as fever, malaise, weakness, and weight loss. This pattern of asymptomatic growth occurs in many patients. So the neoplasms of the kidney 951. A figure 20.52 urothelial carcinoma of the renal pelvis. The pelvis has been opened to expose the nodular regular neoplasm just proximal to the ureter. B. See figure 20.51 renal cell carcinoma, a clear cell type. B. Papillary type. Note the papillary and foamy macrophages in the stalk. See chromophore type. Courtesy Dr. A. Rachel, Baptist Hospital, Miami, Florida. Tumor may have reached a diameter of more than 10 cm when it is discovered. Currently, an increasing number of tumors are being discovered in an asymptomatic state by incidental radiologic studies, for example, computed tomography or magnetic resonance imaging performed for other indications. Renal cell carcinoma is considered one of the great mimics in medicine because it tends to produce a diversity of systemic symptoms not related to the kidney. In addition to fever and constitutional symptoms mentioned earlier, renal cell carcinomas produce a number of syndromes described to abnormal hormone production, including polycythemia, hypoglycemia, hypertension, hepatic dysfunction, feminization or masculinization, Cushing's syndrome, eosinophilia, leukemoid reactions, and amyloidosis. A particularly troublesome feature of renal cell carcinoma is its tendency to metastasize widely before giving rise to any local symptoms or signs. In 15% of new patients with renal cell carcinoma, there is radiologic evidence of metastasis at the time of presentation. The most common locations of metastasis are the lungs more than 50% and bones 33%, followed in frequency by the regional lymph nodes, liver, adrenal glands, and brain. The average 5-year survival rate of persons with renal cell carcinoma is about 70% and as high as 100% in the absence of distant metastasis. With renal vein invasion or extension into the perinephric fat, the figure is reduced to approximately 60%. Hyponephrectomy has been the treatment of choice, but nephron-sparing surgery to preserve renal function is recommended for tonia tumors 4cm as well as larger tumors when technically feasible. Drugs that inhibit VAGE and various tyrosine kinases are used as an adjunct therapy for metastatic disease. Urothelial carcinoma of the renal pelvis, approximately 5% to 10% of primary renal tumors originate from urothelium of the renal pelvis. Fig. 20.52. These tumors range from apparently benign papillomas to invasive urothelial transitional cell carcinomas. Renal pelvic tumors usually become clinically apparent within a relatively short time because they lie within the pelvis and, by fragmentation, produce noticeable hematuria. They are almost invariably small when discovered. These tumors may block urinary outflow and lead to palpable hydronephrosis and flank pain. On histologic examination, pelvic tumors are the exact counterpart of those found in the urinary bladder. Further details are in chapter 21. Urothelial tumors may occasionally be multiple, involving the pelvis, ureters, and bladder. In 50% of renal pelvic tumors, there is a pre-existing or concomitant bladder urothelial. 952, chapter 20, the kidney tumor. On histologic examination, there are also foci of the tibia or carcinoma and cilium grossly normal urothelium remote from the pelvic tumor. There is an increased incidence of urothelial carcinomas of the renal pelvis in individuals with Lynch syndrome. Infiltration of the wall of the pelvis and calluses is common. For this reason, despite their apparently small, deceptively benign appearance, the prognosis for these tumors is not good. Reported 5-year survival rates vary from 50% to 100% for low-grade non-invasive lesions to 10% with high-grade infiltrating tumors. Key concepts: kidney neoplasms. Clear cell renal cell carcinoma is the most common subtype of malignant renal neoplasms, which often involve VHL, a tumor suppressor gene. Papillary renal cell carcinoma is the second most common subtype of malignant renal neoplasms, which may involve MET proto-oncogene. Hereditary forms of renal cell carcinoma have led to the discovery of important genes, for example, VHL, BHE, and renal carcinogenesis. Urothelial tumors resembling similar tumors in the urinary bladder can also originate in the renal pelvis. These tumors have a poor prognosis. Suggested readings: pathogenesis of immune-mediated glomerular injury, calcium WG. Basic and translational concepts of immune-mediated glomerular diseases. James Stock, Nephron 2338 tome.